Hope I am audible to all of you. Welcome back. So we'll spend around 4 hours revising the most important topics from medicine, the topics which had been the recurrent templates in last couple of years, from which questions are repeatedly being asked. Okay, now the marathon series has started long back, and I guess you have already covered some of the subjects. Today we will be dealing with medicine, and later part of the day Dr. Natisha will be covering radiology. Now, without wasting your time, let me start with the cardiology first. Now, from cardiology, what are the important topics? So, from CVS, I'm expecting questions to be asked on number 1, some physio-medicine integrated questions regarding pulse and JVP. As we know, almost one question is certain to come from JVP. After that, heart failure is an extremely important topic, mainly related to the pharmacological management of heart failure or diagnosis of heart failure. Then we do get questions regarding the AV blocks and other arrhythmias, tachyarrhythmias. And one question is likely to come either from cardiac tamponade or chronic constrictive pericarditis. So these are the topics that we will be paying attention to. First, let's start with the pulse. Now, there can be an image-based question asking you to identify different components of the pulse waveform. First of all, what is pulse? When our left ventricle, let us say this is left ventricle that we are looking at, and this is the aorta, this is left atrium. Sitting here is aortic valve. Now, during the ventricular systole, the left ventricle ejects the blood from the LV into the aorta. And whenever we eject the blood into the aorta, it triggers a pressure wave. That pressure wave is what we call as pulse. So pulse is a pressure wave. Pulse is a pressure wave. And when we plot it on a graph, where we are actually plotting on the x-axis the time, and on the y-axis the pressure recorded in the aorta. So on the y-axis, we are actually recording the pressure in the aorta, and we are documenting it on the graph. Then as soon as I eject blood into the aorta, it distends the aorta and increases the pressure in the aorta. That gives you a rapid rise in the pressure. This waveform that we see, the initial upstroke, this we are going to call it as percussion wave. So question they will ask is, what is responsible for percussion wave? The percussion wave is triggered by left ventricular ejection of blood into the aorta. So LV ejection is responsible for triggering the percussion wave. But after that, the aorta which was distended will recoil, because Newton has said there should be equivalent opposite reaction. So you distend the aorta by pushing blood into it, it will recoil. And when it recoils, the pressure inside the aorta further increases. So the graph now shows another upward stroke. This upward stroke, we will call this upward stroke graph, this one, as tidal wave. So they can also ask you what is responsible for tidal wave. The tidal wave is due to recoil of the aorta, due to aortic recoil. Collectively, we have reached the peak of your pulse waveform. Right now, we are at the top of the waveform. We ejected some blood, distended the aorta, increased the pressure, aorta recoiled and further increased the pressure, giving you two waves, a percussion wave and a tidal wave. Between the two, you do notice a small notch. Now, what should I call this notch as? The small notch that you notice here, we'll call it as anacrotic notch. It is called as anacrotic notch, the notch between percussion wave and tidal wave. Now, whatever is the peak of this waveform, that is a pressure, and this pressure corresponds to your systolic BP, systolic BP. And after that, as you are not further ejecting any more blood, the systole is over, the aortic valve closes, and after the aortic valve closes, you are not pushing any more blood, so the graph should start returning downwards. Okay, so you will notice the graph returning downwards after achieving the peak. Okay, but when it is returning downwards, you will notice that the graph again starts going up. Now, what is the reason for graph again starting to go up during the diastole? During systole, yes, I ejected the blood into the aorta, it was distended, it increased the pressure. And please note, we are noticing a notch here between the new wave that I created and the first wave that we had. This notch, we are going to call it as diacrotic notch. This is going to be your diacrotic notch. And they can ask you a question, diacrotic notch corresponds to what, right? Please remember, diacrotic notch corresponds to closure of the aortic valve. And if it is corresponding to closure of the aortic valve, what sound it corresponds to? It corresponds to second heart sound, corresponds to second heart sound. This is exactly where you have the closure of aortic valve resulting in S2 being heard. So what is responsible for this new waveform? This new waveform, I am going to call it as dicrotic wave. We will call this waveform as dicrotic wave. This is dicrotic wave. So we have three major components of the pulse waveform. The first one is your percussion wave or P, tidal wave and dicrotic wave. The dicrotic wave is because of the reflected waves coming from periphery. When you push the blood through the aorta, you sent a pressure wave. Aorta did react by recoiling, and that's why you got this tidal wave. Now the peripheral tissues and peripheral blood vessels will also react back, right? So they will also send a pressure wave back, and that leads to further constriction of the aorta, and you get another wave which we are calling as dicrotic wave. So what is responsible for the dicrotic wave? Dicrotic wave is due to reflected wave from periphery. Due to reflected wave from periphery, and when I say reflected wave from periphery, it means we are talking about peripheral vascular resistance. Peripheral vascular resistance, which is equal to peripheral vascular resistance. So 3 MCQs. What is responsible for percussion wave? Aortic, like ejection of the blood by left ventricle into aorta. Tidal wave is because of aortic recoil, and dicrotic wave is because of the peripheral vascular resistance. The peak of the first wave corresponds to your systolic BP, and the peak of the second wave, that is dicrotic wave, corresponds to your diastolic BP. And the difference between the two is what we call as pulse pressure. Pulse pressure is systolic BP minus diastolic BP. So sometimes you can get an IBQ where the pulse waveform is put there, and then they label one of the component, and then they will ask you which is responsible for it. So you should be able to answer that. Now beyond that, you also get MCQs on the abnormal pulses. Either there's a direct question asking you where do you get this kind of abnormal pulse, or it can be an image based question as well. I'm not listing all the abnormal pulses that are listed in a regular class, but the important ones we'll try to revise. The first one is pulsus bispherians. Now what do you mean by pulsus bispherians? I forgot to mention that this, before the S2 you have systole, and after the S2 you have diastole. So you have one major wave in systole and another in diastole. Okay, so can I say that in systole, though we have two waves, it is just a continuation of one over the other. You eject the blood, you distend the aorta, create a percussion wave, aorta recoils and increase pressure further, creating a tidal wave. So I don't feel them as two waves. When I'm percussing, when I'm palpating, I'll feel them only as a one wave. Dicrotic is felt, or like we are only feeling the systolic waveform. Dicrotic is as such not felt. But if I notice that the anacrotic wave becomes deeper and I feel two pulses in the systole itself, then we call it as pulsus bispherians. What is pulsus bispherians? Pulsus bispherians refers to two systolic peaks. Two systolic peaks. Now in what conditions I see it? It is seen in, first thing that should come to your mind is aortic regurgitation, or aortic regurgitation with aortic stenosis, or hypertrophic obstructive cardiomyopathy. In a lot of MCQs, they use pulsus bispherians as a clue for you to think about hypertrophic obstructive cardiomyopathy. It's like young patient having recurrent attacks of syncope or palpitations, and on examination, pulsus bispherians was noted. The question is about hypertrophic obstructive cardiomyopathy. Or another question where patient is having visible pulsations everywhere, and then there was pulsus bispherians noticed. Then the question is about aortic regurgitation. Okay. Next, can anybody tell me what is this pulsus paradoxus? Pulsus paradoxus. I'll give you an image of the pulsus bispherians so that if there is an image based question, you should be able to answer it. Meanwhile, comment and tell me what is pulsus paradoxus and where do you get it? So there will be two peaks in the systole and this is going to be corresponding to the second heart sound S2. That means this part is going to be systole and this part is going to be diastole. So there are two peaks in systole, 1, 2, two systolic peaks, then we call it as pulsus bispherians. As I've already told you, we see that in patients with HOCM, AR and AR with AS, predominant AR with mild to moderate AS. Yes, paradoxical, not paradoxical increase in the blood pressure, systolic BP during inspiration, rather decrease. Okay, so normally what happens, your systolic BP decreases in inspiration. Now, why does it actually decrease in inspiration? Because when we look at the ventricular filling, if you are talking about two ventricles, our BP is dependent on the left ventricular filling, because how much blood I eject from the LV decides how much is going to be my stroke volume. Stroke volume decides the blood pressure, because your systolic BP is directly proportionate to stroke volume. Okay, so during inspiration what happens? During inspiration, because of the negative intrathoracic pressure, more blood flows into the right atrium and thus more blood flows into the right ventricle. Right heart receives more blood during inspiration, and because more blood is flowing into the right side of the heart, this interventricular septum, to accommodate this extra inflow of the blood, the interventricular septum can slightly bulge into the left ventricle. So when I fill more into the RV, there is less space available for the LV filling. So if I am filling less into the left ventricle, of course I am going to eject less. So stroke volume decreases. So systolic BP decreases. So normally up to 10 millimeters of mercury drop in systolic BP occurs during inspiration. When it is more than 10 millimeters of mercury drop, we will call it as pulsus paradoxus. So pulsus paradoxus refers to more than 10 millimeters decrease in systolic BP. Pulsus paradoxus refers to more than 10 millimeter decrease in systolic BP during inspiration. During inspiration. Can you give me examples where we get it? Yes, in cardiac tamponade, asthma, COPD, pneumothorax. Awesome. Yes. Now, why are we getting it in cardiac tamponade? Because in cardiac tamponade, already there is so much fluid in the pericardial space that right ventricle is already collapsed. There is minimal space in the right ventricle to accommodate this extra inflowing blood. So when I try to bring a lot of blood into the RV, the bulge of the interventricular septum that we get here is going to be enormous. It bulges too much because there is no space. The fluid around here is trying to compress the ventricle, right ventricle. So right ventricle cannot expand. So in that case, the interventricular septum has to bulge a lot into the left ventricle to allow this extra inflowing blood. So LV filling becomes severely compromised. So instead of just up to 10 millimeters mercury drop in inspiratory BP, you will notice more than 10 millimeter drop in inspiratory BP, right? Apart from this, yes, you also get it in patients with asthma, COPD, and also even pneumothorax. So it is the first thing that should come to your mind is always cardiac tamponade. Okay. Beyond that, asthma, COPD and pneumothorax can be considered as causes. So it's not specific for cardiac tamponade. Okay. Now pulsus parvus. What do you mean by pulsus parvus? Parvus means small. So whenever the peak of the pulse becomes small instead of attaining the regular height. If the peak of the pulse achieved becomes smaller than usual, then we call it as pulsus parvus. I believe I have already told you that the peak is going to be dependent on the stroke volume. If I eject more blood into the aorta, I build more pressure in the aorta. If I eject less blood into the aorta, I build less pressure in the aorta. So peak of this pressure waveform is going to be directly proportionate to stroke volume. And we also know peak of this pressure waveform is nothing but your systolic BP. Okay. So if the peak is becoming smaller, that means the stroke volume is less. So any condition where the stroke volume is low, you can have pulsus parvus. Pulsus parvus refers to small peak, and that can be seen in any condition where you have low stroke volume. Low stroke volume can also be called as having low cardiac output. Okay, so what is the waveform appearing like if we are talking about pulsus parvus? So in pulsus parvus, if this is the normal waveform, you have a percussion wave, anacrotic notch, and a tidal wave, and after that you have a dicrotic wave. This is the, if this is the normal waveform, then in case of pulsus parvus, the peak of the waveform is going to be smaller than usual. So this is the small peak that we are talking about. Lower the stroke volume, smaller the peak. Then we have one more entity called as pulsus et tardus. Pulsus et tardus. Now what do I mean by pulsus et tardus? Tardive means slow. So when the pulse rises slow and the peak appears late, we call it as pulsus et tardus. Pulsus et tardus. So if the graph has to be represented, if this is what the normal waveform looks like, then on the x-axis we are actually plotting time. So here at this point of time I am expecting to reach the peak, but what happens in pulsus et tardus? The pulse rises slowly, so peak appears late. Peak appears late. This is your late peaking pulse. Now can anybody tell me in what condition I get late appearance of the pulse peak? The classical example we quote for pulsus et tardus is going to be left bundle branch block. Left bundle branch block. This is classically seen in LBBB. Can anybody tell me why in LBBB we are getting this kind of late peaking pulse? Because what is happening in LBBB is, if this is the heart that we are looking at, then somewhere sitting here we have the AV node from which we have the His bundle, which branches into two bundle branches, which are eventually converting into Purkinje fibers to penetrate into the ventricles. And whenever AV node sends a signal, it is sending the signal to both the bundle branches, and both the ventricles almost simultaneously get depolarized. But when I have block, let us say in the left bundle branch, if LBBB is there, this bundle branch is blocked. So in that case, whenever AV node sends an electrical impulse to cause depolarization of both the ventricles, I will not be able to achieve depolarization of the left ventricle. But the electricity definitely makes its way into the right ventricle. Right ventricle gets depolarized, it contracts. And because of the potential difference, because right ventricle has now reached higher voltage, left ventricle is sitting at the lower voltage, because of the potential difference, the electricity also flows from right ventricle to left ventricle, and that causes the depolarization of LV. So normally both ventricles get simultaneously depolarized, but in case of left bundle branch block, RV is getting depolarized first, and then from the RV, LV is getting the electricity, and then it is getting depolarized. So its contraction is delayed. Second, the voltage that goes to the RV is not as strong as the voltage that generally gets into the LV. So LV is now getting lower voltage impulse. Voltage is low and it is reaching late. So that's why its force of contraction gets delayed and becomes less. That's why we see the peak appearing late. Okay, so we call this as pulses et tardus. And then we have one combination which is called as pulses parvus et tardus. MCQs have been asked on this in the past. Pulses parvus et tardus. Now, what do you mean by pulses parvus et tardus? Parvus means small peak. So that is seen in any condition with low cardiac output or stroke volume. Right? It is seen in any condition with low cardiac output or low stroke volume. But what if the peak is small and it also appears late like this? Small peak and peak is appearing late. Then we will call it as pulsus parvus because of the peak being small, and et tardus because it is appearing late. Often described in regular conversations as the slow rising late peaking pulse, which is called as pulsus parvus et tardus. So if the normal graph kind of looks like this, if this is black is taken as normal, then pulsus parvus et tardus, where it will be rising slow, peak is small and it appears late. So here you have small and late peak. This is typically encountered in patients with severe aortic stenosis. Severe aortic stenosis. But why in severe aortic stenosis? Because in patients with severe aortic stenosis, let us say this is left ventricle that I am looking at, and this is going to be aorta. This is going to be my left atrium, and sitting here is the aortic valve, and the opening is narrow. It is so narrow, critically narrow, maybe less than 1 centimeter square or less than 0.7 centimeter square is the opening. So in that case, when I try to eject the blood from left ventricle to the aorta, the small opening limits how much blood I can eject. So if I am ejecting less blood, the stroke volume is decreased, and once we know the stroke volume is decreased, the peak of the pulse will become small, because peak of the pulse is directly proportionate to stroke volume, as we have already discussed. So peak becomes small. And then if I have a small opening, do you think I can eject the blood rapidly? No, the opening decides how much blood can come out of the LV into the aorta at each point of time. Smaller the opening, less blood gets ejected. So slowly ejection progresses, and thus the peak also appears late. And this is what we call as pulsus parvus et tardus. Pulsus parvus et tardus. This is actually a clinical marker of severity of aortic stenosis. So if you have a patient with AS murmur and you notice that the pulse is very small or feeble and it is rising slowly, then you know you're dealing with severe aortic stenosis, and the condition is called as pulsus parvus et tardus. So pulsus et tardus is late peak, typically encountered in left bundle branch block, and pulsus parvus et tardus is about small and late peak, typically encountered in severe aortic stenosis. Okay, so this is about what questions we can expect from the pulse. Now let's go into the jugular venous pressure. Now JVP based questions can be image based. They can be clinical vignette types, or maybe flat straight one liners asking you where do you get this kind of JVP abnormality, or which event in cardiac cycle is responsible for a particular JVP waveform. I hope the pulse is clear. LV during systole contracts and ejects the blood into the aorta. Whenever we push the blood into the aorta, pressure inside the aorta increases, it triggers a pressure wave which travels across the arteries. And because aorta will have an equal and opposite reaction, it recoils, which further increases the pressure, giving you two systolic waves. The one is percussion wave, the other one is tidal wave. There's a small notch between the two called anacrotic notch, and it is barely recognizable on palpation. When the notch becomes deeper and easily recognizable, you call it as pulsus bispherians. You will have two peaks in the systole easily felt, typically seen in HOCM. The dicrotic wave is because of the reflected periphery waves, which is also called as peripheral vascular resistance. Now let's talk about the JVP. So what are we doing in JVP? In JVP, basically we are looking at the right atrial pressure changes. because our jugular vein, the internal jugular vein we are referring to, that too on the right side, its pressure directly correlates with the pressure in the right atrium. So jugular venous pressure directly correlates with the right atrial pressure. So now think about it. This is going to be your internal jugular vein on the right side. It joins with the subclavian vein to form your superior vena cava. This is your right atrium, and this is your right ventricle. This is your pulmonary artery. Now sitting between right atrium and right ventricle, we have tricuspid valve, and sitting between right ventricle and pulmonary artery, we have pulmonic valve. Because of its anatomical alignment, the right atrial pressure and internal jugular vein pressure on the right side will be proportionate. So can I say that IJV on the right side is proportionate to right atrial pressure? So I'm using JVP as a window to see what is happening in the right atrium without putting a catheter into the right atrium. So now let us look at the cardiac cycle. First thing that we do in cardiac cycle is to fill the ventricles and then eject the blood from the ventricles. So when we fill the blood into the ventricle, that phase is called as diastole, and when we eject the blood from the ventricle into respective arteries, right ventricle to pulmonary artery or left ventricle to aorta, we call that as systole. Systole is about ejection, diastole is about filling. Okay. Now in the diastole, if I'm looking at right atrial pressure, imagine that I have put a catheter into the right atrium and recording the pressures during the diastole. What is the first phase of the diastole? Can anybody tell me? What is the first phase of diastole? Let me take an example. Let us say I have a bottle in my hand or a container, okay, and I have squeezed it to eject the water out of that bottle. That's your systole. Once the ejection is over, the bottle is in a squeezed shape. And please remember, there is this law called Boyle's law, which states that pressure will have an inverse relationship with the volume of a container. So when I squeeze the bottle to eject, pressure increased. That increased pressure itself helped me to eject. But after completing the squeezing, the pressure in that bottle is very high. So can I fill fluid into that compressed chamber? So to fill that, I have to push with more pressure. So ideally that's not the situation. So what should I do? I should first dilate that bottle so that its pressure decreases, and then I can easily fill. So during the systole, the ventricle was contracted to eject the blood. So before I start filling the blood, ventricle is in contracted state, right? So first I have to relax it. So the first phase of diastole is going to be relaxation of the contracted ventricle, and we call that as isovolumetric relaxation. Once we relax the ventricle, the pressure in the ventricle drops below than that of the right atrium. And because of the pressure difference, the tricuspid valve opens and the blood from right atrium starts flowing into the RV. This phase we will call it as passive filling, because right atrium is not pushing the blood. RV has relaxed and created a pressure difference, and because of that blood is flowing. We will call it as passive filling. 70% of blood transfer from RA to RV occurs during passive filling. But as I am transferring the blood from RA to RV, RV is getting filled, so its pressure is increasing. RA is losing blood, so its pressure is decreasing. So somewhere down the line, you reach a point where pressure in right atrium and right ventricle are almost equalized. So further passive filling is not possible because fluid always moves from high pressure to low pressure zone. I may still have 20 to 30% blood remaining in the RA. So if I want to transfer this, what should I do? I have to contract the right atrium. When I contract, according to Boyle's law, the right atrial volume decreased, pressure increases. So pressure of the RA becomes more than that of the RV, and remaining blood can be pushed in. So now let's talk about this phase. We will call this as active filling phase of the cardiac cycle, where right atrium is contracting to push the 30% or 20% blood that is remaining in it after passive filling. At this point of time, if there is a catheter here and I'm checking the right atrial pressure, what will I see? Right atrium is contracting. There is a catheter inside it. Will it record a rising pressure or a decreasing pressure? When right atrium is contracting, its volume is decreasing, pressure is rising, right? So if I put a graph now, with the x-axis representing time and y-axis representing the right atrial pressure, and we are talking about the active filling phase of the cardiac cycle, the pressure in the right atrium will be increasing. So if I plot a graph, the graph will show an upgoing wave, and this is what we are going to call as A wave. A wave is due to atrial contraction or active filling phase of cardiac cycle. Okay, so they can ask you questions. A wave is due to what? A wave is due to atrial contraction, and with respect to cardiac cycle, this actually occurs during active filling phase of cardiac cycle. This is pretty easy to remember. A for A. A for A. A wave is due to atrial contraction. Which phase of cardiac cycle it corresponds to? It corresponds to the active filling phase of diastole. Okay. So once the active filling is done, already we have done passive filling, 70% blood transfer is done. During active filling, another 30% blood transfer done. So all that I had to transfer from right atrium is done. At the end of active filling, the right atrium is in a contracted state. It is in a contracted state. The tricuspid valve was already open because we were transferring the blood. This is the status now at the end of the active filling. Filling is over, diastole is over. Now whatever blood that I have transferred to the ventricle, we will call that as end diastolic volume, and the ventricle will start contracting to eject this blood to the pulmonary artery. So ventricle is now entering the systole. If ventricle is going into the systole, what atria should be doing? Atria should go into its diastole, where it actually receives the blood from the superior and inferior vena cava. But to be able to receive the blood, first it has to relax itself because it was doing active filling. So it was contracting. Now it is contracted, its pressure is high. We can see it on the graph itself. The pressure has reached the peak. So with such high pressure inside the atrium, it cannot receive the blood. The first thing it has to do is it has to start relaxing. The contracted atria starts relaxing. And as it starts relaxing, the pressure graph starts going down because with the relaxation, the volume of the atria is increasing. As volume increases, pressure decreases. So the new direction for my graph will be downwards. Okay, and this downward graph is what we are going to call as, we will call it as X descent. Okay, this is what the graph should actually look like, and we are going to call it as X descent. But please remember, when atria is relaxing, the ventricle is on the other side contracting. It is getting into isovolumetric contraction phase of systole. The pressure inside the ventricle is building up, and that pressure is channelized everywhere towards the pulmonary artery as well as towards the right ventricle, towards the right atrium. And this pressure wants to push and open the pulmonary valve so that the ejection can start. But the same pressure will also be exerted on the tricuspid valve. So because of that, the tricuspid valve slightly bulges into the right atrium. When is this happening? When the right ventricle is in isovolumetric contraction, and this bulge of the tricuspid valve into the right atrium reduces the volume of the right atrium, and when volume reduces, the pressure in the right atrium increases. So when right atrium was relaxing, you are noticing a downward graph, but then suddenly tricuspid valve bulges inwards and then pressure increases further. So the resultant wave is not going to look like what I have shown here because the pressure will increase because of the tricuspid bulge. And this wave is what we are calling as C wave. C wave. So what is responsible for C wave? A wave was due to atrial contraction. Then X descent was due to atrial relaxation. Atrial relaxation. Just for remembering, you can put more stress on X so that you remember. X descent is because of atrial relaxation. But in between the X descent, we got a C wave because of the tricuspid bulging into the right atrium. So C wave is due to tricuspid valve bulge, or simply you can say cusp bulge into right atrium. Easy to remember again. C for C. The cusp bulge is responsible for C wave. But this bulge will not remain bulged into the right atrium throughout the ventricular system, because after isovolumetric contraction, the pulmonic valve opens and the blood starts going into the pulmonary artery. So inside the ventricle, pressure starts rapidly dropping down. So the valve that was bulged because of pressure will come back. Once it comes back, the pressure in the atria will decrease, and atria was anyway continuing to dilate. So your graph will again show a downwards trend. So only transiently, when the cusp was bulged into the right atrium, you get this small spike, which we are calling as C wave, essentially splitting the X descent into two components, one before the C wave, one after the C wave, right? So you can label that as X1, X2, or X and X dash descents. So at the end of the atrial relaxation, atria is completely relaxed. Pressure in the atria is very low now. Look at the graph, pressure is here. At the end of active filling, the pressure was here at the peak. Now pressure is at the bottom. So it is a very low pressure chamber now. And because of this low pressure, blood starts flowing from superior and inferior vena cava. So as blood starts flowing into the right atrium, the right atrium is getting filled. And because we are filling the right atrium, the pressure in the right atrium starts increasing again. So my graph now takes an upward trend. This upward trend, we will call this wave as V wave. Now what is responsible for this V wave? The blood coming from superior and inferior vena cava. So can I call this as venous filling? Because blood coming from veins is filling the right atrium. And we are going to call this wave as V wave. So V wave is due to venous filling. Venous filling. Why am I able to fill the blood from the veins? Because I have relaxed the atria and lowered the atrial pressure. Easy to remember again, V for V. In normal JVP, A wave is always taller than V wave. Please remember this point. Because if a waveform is given and there is no labeling, which one is A, which one is X descent, which one is V, then it's in a normal JVP, the tallest wave will always be A. V is always smaller than the A wave, because during A wave, atria was actively contracting, building too high pressure. That's why we reached such peak pressure. Okay. So once I have filled the blood into the right atrium, this side ventricle finishes its ejection. So it is ready for receiving the blood again. So as usual, it goes into isovolumetric relaxation, okay, and lowers the pressure. And once the pressure is lowered, the tricuspid valve opens. So somewhere after the V wave, there is opening of tricuspid valve. And once the tricuspid valve opens, whatever blood we have in the right atrium, because of the pressure difference, it starts moving into the right ventricle, which we call as passive filling. And if blood is leaving from RA to RV, what will happen to the right atrial pressure? Blood is leaving, so right atrial pressure starts decreasing. So my graph starts going down again. And this downward trend of the graph, we are going to call this as Y descent. Y descent. Now what is responsible for Y descent? Y descent is due to atrial emptying. Atria is emptying itself into right ventricle. Easy to remember again. Give more stress on emptying, the Y component of emptying. So Y descent is for atrial emptying. To be more precise, if I have to map it to the cardiac cycle, Y descent actually corresponds to the passive filling. A wave was corresponding to active filling, Y descent is corresponding to passive filling. And this tricuspid bulge was occurring during isovolumetric contraction, when the ventricle was contracting, trying to open the pulmonic valve. Same pressure was also exerted on the tricuspid valve. That's why the tricuspid valve was bulging into the right atrium. So there are three waves that can be mapped on the cardiac cycle: active filling, A wave; passive filling, Y descent; and isovolumetric contraction, C wave. All of these have been asked as MCQs. And many a times they just give a JVP waveform and then label one part and then ask you which cardiac cycle corresponds to it. Okay, clear? So this is the basic JVP waveform. Now let's talk about the abnormalities. First, and a common question, where do we get absent A wave? A wave is due to atrial contraction. What if atria doesn't contract? If it contracts, pressure builds and A wave appears. If it does not contract, pressure does not build, A wave doesn't appear. When atria doesn't contract, when it is in fibrillation. So atrial fibrillation is the condition where you will notice atria not contracting. So you will have absent A waves. Okay. Then when do I get tall A wave? Whenever, very good. Vayu and Javier, very good. So whenever right atrium encounters more resistance when it is doing active filling, when it wants to squeeze the blood into the RV, if it encounters resistance, then it has to put more pressure to overcome the resistance. So A wave becomes taller. So when right atrium has to put more effort, when you have either tricuspid stenosis, opening is narrow, so to pass the blood through narrow opening, right atrium has to contract with more force. So A wave becomes tall. Or instead, if I have concentric right ventricular hypertrophy, where there is too much of muscle mass added into the ventricular cavity, making the ventricle thicker, but the cavity becomes smaller. And please remember, whenever a chamber becomes smaller, by default, its pressure increases. So if I have to fill blood from right atrium to a high pressure right ventricle, fluid always moves from high pressure to low pressure. So if RV is already at higher pressure, then RA pressure has to go further high. And when RA pressure goes further high, A wave becomes more taller. So can I say we can get tall A waves in patients with tricuspid stenosis or concentric right ventricular hypertrophy, and we get concentric right ventricular hypertrophy because of pulmonary hypertension. Pulmonary hypertension. And what if the right ventricle is collapsed? Like if there is too much fluid around, and this fluid has made the right ventricle collapse, and in that case, when I have to push the blood from RA to RV, I have to push the blood in a collapsed chamber. Collapsed chamber already has high pressure, so I have to increase my pressure even higher than that. And tell me now, when do I get this collapsed right ventricle? Whenever there is massive fluid around it, and we call that condition as cardiac tamponade. So in patients with cardiac tamponade also, we can get tall A waves. Okay. And then in patients with chronic constrictive pericarditis, we can get tall A waves. One more important point to note here is, whenever you get a tall A wave, the height of the A wave is taller. So in that case, by default, the X descent appears steep. The more peak I reach for A wave, the descent for X becomes even more steeper. The more you reach the peak, the descent becomes more steeper. So if you ask me, where do you get prominent X descent? You get prominent X descent in any condition with tall A waves. Any condition with tall A waves. So whatever we listed here for tall A waves can also be listed as causes for prominent X descent. So we get prominent X descent in TS, concentric RVH, pulmonary hypertension, as well as cardiac tamponade and chronic constrictive pericarditis. Okay. Then comes the question, what is Cannon A waves? Cannon A waves are also tall A waves. Then what's the difference between your regular tall A waves and Cannon A waves? So if I get, let us say, this is the normal JVP waveform, A, X descent, C wave, and then V wave and Y descent, right? Let us say this is a normal JVP waveform. This is A, this is X and X dash, between that we have C wave, this is V wave, and this is Y descent, right? Let us call this as normal JVP waveform. Now in patients with tall A waves, you will notice the graph looking somewhat like this. The A becomes taller than usual, and whenever A becomes taller, by default the X descent appears steeper. This is your tall A wave. You can also call it as giant A wave, right? So the A is tall here. This is X dash descent, this is C wave, this is V wave, and this is Y descent. Now in these patients, like in patients with tricuspid stenosis or concentric RVH, or patients with pulmonary hypertension or constrictive pericarditis or cardiac tamponade, in all these cases, every JVP waveform you see will have a tall A wave. Every JVP waveform. If I trace it for, let us say, 10 cycles, each A wave in the 10 cycles will show tall A wave. So every A is going to be tall. But if the tall A wave appears intermittently, not always, selectively, then we will call it as Canon A waves. So the waveform is somewhat going to look like this. You have one A wave which appears normal, one A wave which appears normal. Okay, this is one normal JV waveform. The next one, the A is quite tall. The next one again may be normal. The next one again may be normal. But then the next one is tall again. So whenever you get this intermittently tall A waves, then we will call it as Canon A wave. So this is A which is normal. This is A which is tall. This is A which is normal. This is A which is normal. This is A which is again tall. So basically you get intermittent tall A waves. Whenever you have intermittent tall A waves, you are going to call it as Canon A waves. That will be called as Canon A waves. So where do I get it? So basically when right atrium is contracting in the active filling to push the blood into the right ventricle, if I have narrow tricuspid opening, every time right atrium contract, it gives the same resistance. If I have concentric RVH, every time right atrium contracts, it gives the same resistance. But what if I have AV dissociation? Means atrial rate and ventricular rate are totally different. Normally, atrial rate and ventricular rate is same. One time atria contracts, next ventricle contracts. Atria contracts, next ventricle contracts. But what if, let us say atria is contracting with more speed. Instead of 60 per minute, atria is contracting at 150, but the ventricle is contracting at only 60. So in that case, there will be a lot of contractions where atria and ventricle both contract simultaneously. So in that case, right atrium is contracting, but it will not be able to push the blood into the RV because RV is also contracting. That time, the pressure in the RA increases staggeringly and you get a tall A wave. But the next cycle, if RA contracts first, where ventricle is relaxing and receiving the blood, you don't get the tall A wave. So whenever you separate atrial and ventricular rate, many contractions are those where atria and ventricular are fighting against each other. Only during those contractions where both are contracting simultaneously, you get a tall A wave. But when atria contracts first and then ventricle, you will be able to transfer the blood easily and you will not get tall A wave. So when atrial and ventricular rate gets separated, whenever ventricular or atrial rate gets separated, we call that condition as AV dissociation. AV dissociation is possible either by increasing atrial rate or by decreasing ventricular rate or keeping the atrial rate same and increasing ventricular rate. You have to just create an imbalance. So in what conditions I can have increased atrial rate? If you have supraventricular arrhythmias like AV nodal reentrant tachycardia, AVNRT. Yes, in AVNRT, you have supraventricular tachycardia, means atria is contracting faster than ventricle. Okay. Second, tell me condition where ventricles can contract faster than atria. That is ventricular tachycardia or ventricular fibrillation, where atria is contracting regularly at 60 to 100 per minute, but ventricles are contracting at 200 to 50 per minute. Third, atrial rate is normal, but ventricular rate is decreased. That's your third degree AV block. Third degree AV block, which is also called as complete heart block, where SA node, whatever signal it is sending, it's not able to reach the ventricle. So you have a new pacemaker in the ventricle. So basically what happens in AV blocks is, in the third degree AV block, let us say this is the ventricle we are looking at. Here is the SA node. Here is the SA node, here is the AV node. SA node sends the signal to AV node. AV node picks it up, delivers to his bundle. His bundle branches into two bundle branches and then Purkinje fibers deliver that signal to the ventricle. So whenever SA node sends one signal, AV node gets one, bundle branches get one signal, Purkinje fibers get one signal. So atrial rate and ventricular rate is always same. But when you have developed complete AV block, the AV node is not able to send any signal coming from the SA node down. So SA node is constantly sending signals at 60 to 100 per minute, and that is going to be your atrial rate. But ventricle is not receiving that signal. So either His bundle or bundle branches or Purkinje fibers now become the pacemaker for ventricle. But the only problem here is the His bundle branches or Purkinje fibers, though they are capable of being the pacemakers, their rate of firing is not as much as the SA node. SA node's rate of firing is 60 to 100. That's why our normal heart rate is 60 to 100. But let us say now His bundle has become the new pacemaker for the ventricle. Its usual rate of firing is around 25 to 40 per minute. So in that case, atrial rate will be 60 to 100. Let us even take the lower limits of normal. So atrial rate is 60, ventricular rate is going to be 25. Don't you think there is a clear rate difference between atria and ventricle? Atria is contracting more faster, ventricle is relatively slower. So during this rate difference, many times atria and ventricle end up contracting simultaneously. Those are the times where you get tall A wave. Clear? Now you should also remember, whenever atria and ventricle contract simultaneously, this tall A wave is clearly visible on the patient's neck. And when you see them on the patient's neck, what do we call it as? The Canon A waves when they are visible on patient's neck. When they are visible on patient's neck, we call it as frog sign. Visible on patient's neck, we call it as frog sign. Because not every JVP is, every waveform is showing a tall A wave, right? Only intermittently, suddenly the JVP becomes prominent. Again disappears. Later when again atrioventricle contract, it becomes prominent. Just like the frog's neck showing that pulsatile behavior. Classically, frog sign was described in AV anatomy, but now Canon A waves, we know the concept. So we can say frog sign is seen in any condition where there is Canon A wave present. Okay, very good. So I hope you can differentiate between the regular tall A waves and intermittent tall A waves called Canon A waves. Now what else I need to know from JVP? So we now learned that Canon A waves are seen in AV dissociation. AV dissociation. Okay. The next question is prominent Y descent. Where do we get prominent Y descent? Okay. Remember, prominent Y descent is seen in patients with constrictive pericarditis. And now I'm not getting into the detailed discussion of the mechanism because it will take a lot of time, but just be aware that prominent Y descent is seen in constrictive pericarditis. This is an extremely important point. Why? Because patients with cardiac tamponade and constrictive pericarditis have a lot of similar clinical features, but if the JVP details are given, in cardiac tamponade, Y descent is absent. Remember, you can get absent Y descent in cardiac tamponade. In cardiac tamponade, while you have Y descent present and it becomes prominent in patients with constrictive pericarditis. Last 3 years, there were 3 questions asking you to differentiate between cardiac tamponade and constrictive pericarditis merely based on the Y descent, whether it is present or absent. If it is absent, think about cardiac tamponade. Okay. Then you can have fused CV wave and also prominent V wave. The answer for both of them is same. In patients with tricuspid regurgitation. Tricuspid regurgitation. What do you mean by fused CV wave and prominent V wave? I told you in the beginning that the tallest wave on the JVP in normal circumstances is going to be A. V is always shorter than A. But in some conditions, V wave becomes taller than A. In that case, you can say V is prominent. And then, as you see the graph, after the C wave, you have continuation of X descent, which is called as X dash. But sometimes there is no continuation. From C directly you go to V wave, and then you only have Y descent. Such wave is called as fused C and V wave, fused CV wave. I'll give you an image because this is a potential image based question. Fused CV wave. So let us say this is the normal JVP, A wave here, X descent, C wave, X dash descent, venous filling V wave, and then atrial emptying Y descent, right? Let us say this is normal. This is A, X and X dash descent, This is going to be your C wave. This is V. This is Y. Okay. Now, if I get a patient where your A is same, X descent occurs, C is there, and after C, now let us think about tricuspid regurgitation. What is happening in tricuspid regurgitation? So during the passive filling, I transferred 70% of the blood from atria to the ventricle, and then during active filling, another 30% transferred. So whatever blood now I have in the ventricle, I will call that as end diastolic volume, right? That is the end diastolic volume. End diastolic volume is present in the ventricle. Now I am ready for ejection, right? So when I start ejection, the tricuspid valve is closed, pulmonic valve is closed, and I get into what we call as isovolumetric contraction. The ventricle starts contracting to build the pressure. So during this time, as we know, pressure is directed on tricuspid as well as pulmonic valve. We want only pulmonic valve to open, not the tricuspid valve. Thankfully, we have papillary muscles and chordae tendineae which hold the tricuspid valve from opening. All that can happen is the tricuspid valve may slightly bulge into the right atrium, giving you a C wave. But if I have tricuspid regurgitation, it fails to hold its position. It opens up. Ideally, it should not, but here it opens up. So if it opens up, even before the pulmonic valve is open, the blood starts entering into the right atrium. Okay. Regurgitation started. So as the regurgitation started and blood started entering into the right atrium, the right atrial pressure starts increasing. That's why after C wave, instead of getting the X dash descent, you start noticing the waveform going up. Okay. Now, after the atrial relaxation, eventually blood will also start flowing from the veins through venous filling. So when I start venous filling, I start adding more blood to the right atrium, so pressure increases further. And at the end of venous filling, I've reached this point. Earlier I would have reached here, but now I have reached here. And this waveform is what we are going to call as fusion of, this is C, this is V, both are fused CV wave. And you can clearly notice the V wave is now taller than A wave, prominent V wave and fused CV wave. And this condition is what we call as Lances sign. Fused CV wave is called as Lances sign. Lances sign. And here we also have prominent or tall V wave. Prominent or tall V wave. Simple. The concept is pretty simple. Normally, from where right atrium receives the blood, it gets only blood from superior and inferior vena cava, giving you the V wave. Venous filling gives V wave. But in tricuspid regurgitation, in addition to the blood that is coming from veins, I am also adding regurgitant volume. So right atrium is receiving extra blood, and because it is receiving extra blood, the pressure increases further, and that's why the V wave becomes taller. It's pretty simple, right? Normally only venous filling is responsible for V wave. Here venous filling plus the regurgitant blood, both put together, you are getting V wave. That's why it becomes taller. So we have heard about two main named signs today. One is Lances sign, the other one is frog sign. Okay, and let us put a small comparison between the cardiac tamponade and constrictive pericarditis, because we are expecting questions around it. Chronic constrictive pericarditis. First is with respect to clinical features. Both of them may have raised JVP. Both of them can have raised JVP. Both of them may have hypotension. Both of them may have hypotension. But what differences we notice in patients with cardiac tamponade? There is so much fluid around the right ventricle that right ventricle is collapsed. It can't do isovolumetric relaxation, so there is no passive filling occurring. And because there is no passive filling, you will not have Y descent. Remember, Y descent is the wave of passive filling. Passive filling is represented on the JVP by Y descent. So if there is no passive filling, no Y descent. While passive filling does occur to some extent in constrictive pericarditis, that's why you get Y descent, which is in fact become more prominent. So if you look at the waveforms, JVP waveforms, both will have tall A waves both will have tall A waves, and whenever A wave is tall, by default the X descent will be prominent. So both have prominent X descent. Prominent X descent. But when it comes to the Y descent, here you will have absent Y descent. Absent Y descent. While in case of constrictive pericarditis, you have that also prominent Y descent. You will have prominent Y descent. Then we also have differences on auscultation. When I auscultate, fluid is not a good conductor of sound, so heart sounds get muffled in cardiac tamponade. You will have muffled heart sounds. While in case of constrictive pericarditis, the pericardium is thick, and when we are trying to fill the blood into the ventricle starts expanding and it stretches the thick pericardium. I can only allow the pericardium to stretch as much as its limit allows me, and because here it is thick, suddenly its limit of stretch is reached, and when limit of stretch is reached, the ventricular expansion is halted, and when we halt the ventricular expansion, ventricle vibrates vigorously, producing a sound which is called as pericardial knock. Pericardial knock. So you get a knocking sound in the diastole. It's a diastolic sound. We call it as pericardial knock. So these points help us to differentiate between cardiac tamponade and constrictive pericarditis. Okay, so I think the JVP, whatever one question we are expecting, hopefully we have covered the key points that we need to know. Most of the times it's about the absent A wave, or cardiac tamponade versus constrictive pericarditis, or the Lancisi sign in case of tricuspid regurgitation. Okay, so after covering the pulse and JVP, let's get into a core cardiology topic. We are expecting one question around it, which is valvular heart diseases. Majority of the questions are about diagnosing which valvular heart disease this particular patient is suffering from. Okay, and for that I'll give you an approach. So even if you have not done valvular heart diseases, you should be able to answer most questions. Okay, so let us say we have a patient here who is 40-year-old male. Okay, he has presented with raised JVP, ascites, hepatomegaly. These are his main complaints, and also edema. And when we examined him, we noticed that there was a mid-diastolic murmur. Mid-diastolic murmur in left lower sternal border, which is also described as parasternal region, lower sternal border. Now they are asking you what is the diagnosis. First option is mitral stenosis, second option is mitral regurgitation, third option is tricuspid stenosis, fourth option is pulmonic regurgitation. So these are the first kind of questions that we get from valvular heart disease. And sometimes the same question, but instead of ending with what is the diagnosis, they might ask what is the most common cause for this condition. So if we know the most common causes for all the 4 valvular heart diseases and we are able to clinically recognize them, then our valvular heart disease questions are sorted. So can anybody tell me what should be the answer here? Okay, so some are saying MS and some are saying AS. So the approach is, first thing you should see in any valvular heart disease case, MCQ, is which side of the heart the symptoms are pointing at. Because whenever I have right-sided pathology, if I have right heart pathology, eventually right atrial pressure will increase. And whenever right atrial pressure increases, I will have increase in jugular venous pressure, and also I will have increase in hepatic venous pressure. So hepatomegaly, ascites, they will develop. Okay. Now if I have to represent the circulation, this is the right side of the heart. You have right atrium sitting here, you have right ventricle here, you have pulmonary artery here, and right here you have tricuspid valve, here you have pulmonic valve. Now the pulmonary artery eventually enters the lungs, okay, where the arteries will become capillaries around the alveoli. Alveoli will bring the gas, and then once the blood gets oxygenated, this oxygenated blood will reach the left side of the heart through pulmonary veins, right? These are pulmonary veins. They reach the left atrium. From the left atrium, the blood will get into the left ventricle, and from the left ventricle, we are going to eject the blood into aorta. So sitting here, we have mitral valve. Sitting here, we have aortic valve. This is going to be your aorta, this is going to be your LV, and this is going to be your LA. Now remember, whenever you have a right heart pathology, the right atrial pressure increases. That will show up in the form of raised JVP, increase inferior vena cava pressure, resulting in, sitting here is liver, which is draining through hepatic veins. So hepatic vein pressure increases, that leads to liver congestion. Eventually portal vein pressure increases and you develop ascites. And if I have left heart pathology, left atrial pressure increases, that will result in pulmonary vein pressure going up, pulmonary capillary pressure going up, causing the congestion of the lung. Lung congestion will present with dyspnea as a symptom. So whenever we are reading a valvular heart disease question, first thing we should see is whether we are talking about left heart pathology here or right heart pathology here. Like when I see this question, it is about raised JVP, ascites, hepatomegaly and pedal edema. So it is pointing towards right heart pathology. So I can kind of rule out left heart diseases. So what options can be ruled out in that case? I can rule out mitral stenosis, mitral regurgitation. If I had MS or MR, there should be LA pressure increasing, pulmonary vein pressure increasing, and patient should have dyspnea as a symptom. It's not there. So left heart pathology is ruled out. That is step number 1. Step number 2, look at the area of auscultation from which the murmur is best heard. Because all the valvular heart diseases will cause murmurs, but those murmurs are best heard in a particular area. So if you can recognize this area is representing which valve, then your diagnosis is most often sorted there itself, right? That's why first we'll talk about the areas of auscultation, and then we will come back to the further approach. So there are 4 valves, so there will be 4 major areas for auscultation. So the first major area of auscultation is on the right side of the chest. The right second intercostal space is one major area of auscultation. On the left side, we have plenty. Left second intercostal space, left third intercostal space, and left lower sternal border. And there is one more area medial to the mid-clavicular line on the fifth intercostal space. So these are going to be our areas of auscultation. So on the right side, what we have is aortic area. Aortic area is on the right second intercostal space. So if the question is talking about a murmur being heard in the right second intercostal space, it is mostly pointing towards aortic valve pathology. Okay. On the left side, the left second intercostal space is your pulmonic area. Pulmonic area. So if the question is talking about a murmur being best heard in the left second intercostal space, it is coming from pulmonic valve. So in that case, you should think about PS or PR. Okay. And if it is left third intercostal space, which is called as Erb's area, or it is also called as neo-aortic area. It is an additional area for the aortic valve where the murmur of AR is better heard. This is your left third intercostal space. Okay. And just beneath the sternum, let us say here I have the manubrium, and then the lower end of the sternum spread over 2-3 spaces. We have left lower sternal border, left lower sternal border, lower sternal border, also called left parasternal region. This is your tricuspid area. This is your tricuspid area. So if the murmur is heard over left lower sternal border, it is coming from tricuspid valve. So in that case, you are only thinking about TS or TR. You are not thinking about AS, AR, PS, PR, MS, MR. No. If the murmur is heard in this area, it must be coming from tricuspid valve. Okay. So I think you have already understood the approach. Look at the area, and that already tells you which valve we are thinking about. Other options are by default ruled out. Okay. And then here, this one, where you get the apex beat, wherever you feel the apex beat, that is your mitral area. Mitral area. Normally it is in the fifth intercostal space, medial to midclavicular line. But if the apex beat is displaced, then even the mitral area gets displaced. It's a floating area, it's not a fixed area. So now let us go through the question, and you should tell me which valve you are thinking of that this patient may be having a pathology in. Already from the symptoms, we have concluded that this has a right heart pathology, and we have already ruled out MS and MR as choices. There are 2 right heart valve pathologies remaining in the option. And when I get to know that the murmur is heard from the left lower sternal border, now this is the tricuspid area. That means the murmur must be coming from tricuspid valve. Murmur must be coming from tricuspid valve. So then there's only one tricuspid option available, right? Then the diagnosis becomes tricuspid stenosis. Tricuspid stenosis, right? So symptoms are because of the narrow tricuspid valve. Once the tricuspid valve becomes narrow, you will have difficulty to transfer blood from RA to RV. So RA pressure increases. That's why you are getting tall A wave. Increased RA pressure will result in raised JVP. Increased RA pressure will also result in increased inferior vena cava pressure. Increased inferior vena cava pressure will result in increased hepatic vein pressure. So liver congestion, portal hypertension, ascites, edema, these all will ensue. Yeah, if you want, you can call it as tricuspid stenosis leading to right heart failure. Okay. So then here the diagnosis becomes pretty apparent that we are dealing with tricuspid stenosis. But then some of you might say, sir, what if there was also tricuspid regurgitation as an option? In that case, how will I answer it? In that case, if you have the idea of murmurs, which murmur is heard in which valvular heart disease, then that is also sorted. I guess most of you know that in tricuspid stenosis, you get mid-diastolic murmur. And in case of tricuspid regurgitation, you get pansystolic. And because this question is talking about mid-diastolic murmur, answer is sorted, right? So what we will do now is, we will just make a list of murmurs for different valvular heart diseases. Now remember, the aortic valve and pulmonic valve open simultaneously, right, during the systole. The murmur of aortic stenosis and pulmonic stenosis will be same. Only thing is, it will be heard in different areas. If I have AS, it will be heard in aortic area. If I have PS, it will be heard in pulmonic area. Same applies to AR and PR. Both will have same murmur. But if I have AR, it will be heard in the herbs area or neo-aortic area. And if I have PR, it will be heard in pulmonic area. Murmur of mitral and tricuspid stenosis will be same, but heard in their respective areas. And so is the murmur of MR and TR. Same murmurs, but heard in their respective areas. So what is the murmur of aortic stenosis and pulmonic stenosis? The murmur of aortic and pulmonic stenosis is going to be an ejection systolic crescendo decrescendo murmur. Now why am I getting ejection systolic crescendo decrescendo murmur in case of AS and PS? Because we eject the blood from the ventricles into the aorta first during systole, right? So if there is a narrow opening, when the blood passes across these valves, it creates turbulence, and the sound that turbulence is creating is what we are calling as murmur. The blood is passing during systole, so murmur will be systolic. Second, the ejection happens in 2 phases. Initial rapid ejection followed by slow or delayed ejection. So in the rapid ejection, the flow velocity is very high. So turbulence will be high, murmur intensity will be high. While in the delayed ejection or slow ejection, the flow velocity is slow, turbulence will be less, murmur intensity will go on decreasing. So that's why in the rapid ejection, the murmur becomes louder, and then in slow ejection, it starts decreasing before it ceases. That's why we are going to call it as ejection systolic crescendo decrescendo murmur. So even if you don't remember the table of valvular heart disease, if you can relate to cardiac cycle, like across this valve, when does blood flow? Across the mitral valve, blood flows during diastole when we fill the ventricle. So murmur of MS will be diastolic murmur. Across the aortic valve, blood flows during systole. So murmur of AS will be systolic murmur. Same applies to the right side. Blood flows from RA to RV during diastole. So if I have stenosis of the tricuspid valve, I will have diastolic murmur. And if I have stenosis of pulmonic valve, I will have systolic murmur. Okay, so how does it look if I put it on a phonocardiographic tracing? we will have the murmur between S1 and S2, because between S1 and S2 we have systole. The first phase of systole is isovolumetric contraction. During isovolumetric contraction, ventricles are contracting, but the aortic valve is not open yet. If the valve is not open, blood is not flowing. If blood is not flowing, no turbulence, no murmur. But after isovolumetric contraction, the aortic valve opens. A stiff valve, when it opens, it can make a noise. Normally, valves when they open, they don't make noise. But a stiff valve while opening may make a noise, and we call that noise as, in case of AS and PS, we call it as click or ejection click. And after the click, the valve is open and the blood starts moving from the ventricle to respective arteries, initially through rapid ejection and then through delayed ejection or slow ejection. So during rapid ejection, the murmur intensity goes on increasing in loudness, and then it goes on decreasing, giving you a diamond shaped or crescendo decrescendo murmur. Okay. Now the question wise, what they will ask you, what is the most common cause for aortic stenosis. The most common cause for aortic stenosis is age related degeneration, age related calcific degeneration. They will also ask you what is the most common cause for AS in young individuals. Most common cause for AS in young individuals, because aging is the most common cause where you are developing the atherosclerosis of the aortic valve. It is getting calcified and becoming stiff and difficult to open. In young individuals, the most common cause is going to be congenital bicuspid aortic valve. Normally, aortic valve has 3 cusps, but some people are born with only 2. So in them, the degeneration occurs much early. So in the young age itself, they can develop aortic stenosis. Okay. Another question they will ask you is, on clinical grounds, by just looking at the murmur, can you tell whether the aortic stenosis is severe or non-severe? Okay. So we will be able to detect that by looking at, yes, dystrophic calcification or age-related calcification or calcific degeneration. All the terms mean same thing. Narrower the opening of the aortic valve, the peak of the murmur will be achieved late. More the narrow, peak will appear here. So the shape of this diamond keeps shifting, the peak keeps shifting distally. So you can remember here that late peak of murmur is suggestive of severe aortic stenosis. The same concept we have already applied in pulsus parvus et tardas. The more slower you eject, you reach the peak late. That's why in the pulsus parvus et tardas, the peak of the pulse was felt late. Same peak, when you auscultate, the peak of the murmur will also be felt late. The more severe it is, more late the peak. In fact, there was an image-based question where 2 images were given of aortic stenosis patient, and then they had asked you to identify which one of them is actually having severe aortic stenosis. So both of them have a murmur heard between S1 and S2. Let us say this is patient A and this is patient B. Okay. So in patient A, here we heard a click followed by the beginning of the murmur, and the murmur looked like this. And in patient B, here we heard the click followed by the opening click. The murmur showed somewhat like this. This was the appearance. So which one is severe aortic stenosis? Here peak appeared early in first half of the murmur itself. Here the peak has appeared late, almost after 2/3 of the murmur is already heard, we reach the peak. The more late the peak appears, more severe is the aortic stenosis. So I can say this is non-severe aortic stenosis, while this is going to be severe aortic stenosis. And this is the patient. This patient is the one which will also show on examination pulsus parvus et tardas. Okay. So this is about our aortic stenosis. Very good. B, of course, is a severe AS case. Now coming to the aortic regurgitation and pulmonic regurgitation. After we eject the blood to the pulmonary artery and aorta during systole, the valve should shut down so that whatever blood we have ejected into the aorta or pulmonary artery do not regurgitate back. You push the blood to the pulmonary artery and aorta during systole, and then you close the valves that were open during systole, so that the ejected blood only goes towards their target tissues and doesn't drop back. But if these valves fail to close, then the blood will start dropping back, and this phenomenon is what we call as regurgitation. So when is it happening? It is happening during diastole. Systole we have ejected, during diastole it is dropping back, and when this blood is dropping back, it is going to create a murmur. So murmur of AR and PR are going to be diastolic. But these murmurs are not running throughout the diastole. It will only run in the early part of the diastole. So we will describe them as decrescendo, early diastolic murmur. Early diastolic murmur. So on phonocardiogram, the murmur will be heard between S2 and S1 because diastole occurs between S2 and S1. So the first part of the diastole is isovolumetric relaxation. After that, there will be opening of tricuspid and mitral valve on the respective sides. So passive filling occurs. After passive filling, we will have atrial contraction giving active filling. Now where do I hear the murmur? Murmur begins right after the second heart sound, and then will have a decreasing intensity, and somewhere in the early part or mid part of the passive filling, the murmur stops. Why? Because when we are causing regurgitation, right, when the blood is dropping from the respective arteries to the ventricles, what is happening to the ventricle? Ventricles are getting filled, so ventricular pressure starts increasing, and whatever blood I had pushed into the arteries, some of it is going forward to the tissues and some of it is dropping back. So that means at the level of aorta or pulmonary artery, pressure is decreasing as the regurgitation continues, and because the ventricles are getting filled, their pressure is increasing. So pretty soon you will reach a point where ventricles, by filling some blood, their pressure is increased, and aorta, by losing its blood, its pressure is decreased, so they become equipressure. And once they reach equipressure, even if the orifice is open, no further regurgitation is not possible, because physics says fluid can only move from high pressure to low pressure. If both the chambers, aorta and ventricle, are sitting at the same pressure, there will be no regurgitation anymore. That's why regurgitation occurs only in the early part of diastole, not throughout the diastole. Okay, so they have asked one question: which phase of cardiac cycle the murmur of AR is heard? I think last INICET. If they are asking which phase of cardiac cycle the murmur is heard, it is isovolumetric relaxation mainly. If they ask which phase of cardiac cycle the murmur of AS or PS is heard, it's mainly ejection phase, which includes rapid as well as delayed ejection. Okay, what else they can ask me about AR? Mostly with respect to AR, they will ask you peripheral signs of AR. Peripheral signs of AR. Jeff, you're absolutely right. Yes. What are peripheral signs of AR? Most of the peripheral signs of AR are because of the wide pulse pressure. So in aortic regurgitation, what happens? Two things happen here in aortic regurgitation. First one, let us say I created some regurgitation. So some blood that had pushed to the aorta has dropped back. So during diastole, I should only receive the blood from LA, but I'm also getting blood from aorta. So my end diastolic volume that I get increases because regurgitant volume plus the regular filling, both put together, my end diastolic volume is increased. So for next cycle, I have more blood to eject. So I eject larger amount of blood in the next cycle. And when I eject larger amount of blood, that means my stroke volume is high. And if stroke volume increases, that means your peak of the pulse increases. And if the peak of the pulse increases, systolic BP increases, because systolic BP is directly proportional to stroke volume. So you have high systolic BP in aortic regurgitation. Okay, but once I ejected the blood, some of it drops back in the diastole. So diastolic pressure decreases. So you have increased systolic BP and decreased diastolic BP, creating a wide pulse pressure. And this wide pulse pressure becomes the reason for the pulses to become visible. And these visible pulsations is what we call as peripheral signs of AR. So they can ask what is the mechanism behind the peripheral signs of AR. It is they are due to wide pulse pressure. Okay, I think we can list few important peripheral signs of AR before we move forward. Okay, so let's also look at the peripheral signs of AR. We will see from the head to toe peripheral signs of aortic regurgitation. First, because in systole you're pushing a larger amount of blood into the aorta, larger amount of blood is also likely to reach the tissues. So there will be increased blood flow to tissues causing flushing of tissues, and when it appears on the face, right, face becomes red during systole, but then during diastole all this blood is dropping towards the ventricle, so face becomes pale. So when you see the patient's forehead region, you will notice that there is alternate blanching and pallor, or redness and pallor. Redness during systole because of increased flow, and then regurgitation during diastole, so decreased flow, it becomes pale. We call this as lighthouse sign. It's called as lighthouse sign. That is alternate blanching and flushing of forehead. It looks like the blinking of the lighthouses. That's why it is called as lighthouse sign. Okay. Second, when too much of blood gushes into the head and neck region during systole, because of this gush of blood, the head can slightly pop forward, and then during diastole all this blood is going back towards the left ventricle, so it goes back. So patients might have slight head bobbing, and this head bobbing we call it as de Musset's sign. What is de Musset's sign? Head bobbing. Head bobbing. Okay. Then third, normally carotid artery pulsations are not visible, but now that systolic flow is too much, so you will see a carotid literally bouncing out from the neck and then collapsing back during the diastole because the blood is going back to the ventricle. So we call this as dancing carotids, or dancing carotids is also called as Corrigan's sign. It's also called as Corrigan's sign, which is nothing but visible carotid artery pulsations. Visible carotid artery pulsations. Similarly, you can have visible brachial artery pulsations, and when you have visible brachial artery pulsation, we call it as locomotor brachialis. Locomotor brachialis. Locomotor brachialis refers to visible brachial artery pulsations. Visible brachial artery pulsations. And then because of this wide pulse pressure, even the nail bed capillary pulsations become visible. What do we call it as? We call it as Quincke's sign. Quincke's sign, which refers to visible nail bed capillary pulsations. Capillary pulsations. So these are major peripheral signs of AR from the upper limb. If you look at the lower limb, I want you to remember two major peripheral signs of AR in the lower limb. The first one is called as Hill sign. Okay. The second one is pistil short femoralis, which is also called as Traub's sign. What is Hill sign? Normally, there is a difference between systolic BP recorded on the upper limb and on the lower limb. Which one is going to be higher? Will I have more systolic BP of the lower limb or more systolic BP of the upper limb? Because when left ventricle ejects the blood into the aorta, whatever quantity we ejected is stroke volume. Do you think it will be equally distributed between the upper limbs and lower limbs? No, because gravity is likely to pull more blood towards the lower limb. The distribution of stroke volume between upper and lower limb is not equal. Lower limb receives more stroke volume, so thus the systolic BP in the lower limb will be more. Okay, how much more? Up to 20 millimeters of mercury more. But in case of AR, this unusual distribution becomes even more accentuated, and you will have more than 20 millimeter difference between systolic BP of lower limb and upper limb. So systolic BP of lower limb greater than upper limb by more than 20 millimeters of mercury. Remember, less than 20 millimeters of mercury is normal, but if it is more than 20 millimeters of mercury difference you are noticing, then it is Hill sign. To give you an example, let us say I recorded the systolic BP in the upper limb as 110. This is systolic BP in the upper limb. In that case, in normal physiological state, How much max lower limb systolic BP can be encountered? Max you can see 130 in the lower limb. This difference is because of the gravitational difference in distribution of blood. Okay, but if I get upper limb 110 but lower limb 140, the difference is clearly 30, more than 20 millimeters of mercury. In that case, you are dealing with Hill sign. Patient may be having aortic regurgitation. Okay, the second one is pistol shot femoralis, which is basically systolic booming sounds heard over femoral artery. Because you're ejecting larger volume into the aorta, it creates a strong pulse pressure wave, and when it travels through the femoral artery, you can hear a booming sound. It feels like someone is shooting the bullets through the femoral artery. That's why it is called as pistol shot femoralis or Traub's sign. The last one to remember is your Duroger's murmur. Duroger's murmur. Now, what is murmur? Murmur is the sound produced by turbulent flow of blood. So, in case of valves, when you narrow the valve or in unusual parts of the cardiac cycle, you make the blood flow through the valve, you are creating the turbulence. But I can also create the turbulence by increasing the flow through any blood vessel. So, whatever normal femoral artery flow is there, if I increase it, there is turbulence. That turbulent flow will be heard as a murmur, because in case of the aortic regurgitation, the stroke volume generated is going to be higher than usual. You will experience that turbulent flow in the femoral artery, creating the murmur, which is called as Duroger's murmur. It's a to and fro murmur over femoral artery. So this large volume blood, when it flows across the femoral artery during systole, it produces a murmur. But then during diastole, when the blood is flowing back, the flow reversal occurs, then also it will create a murmur. So you get a murmur during systole, then again the murmur returns during diastole. This is what we call as to and fro murmur. To and fro murmur. Okay. So these are the important signs of peripheral signs of AR that you should be aware about. Okay. So I think AR and PR are sorted. Now let's talk about the mitral stenosis and tricuspid stenosis. Okay. Now mitral valve opens during diastole, so is tricuspid valve. So if they are narrow, they will affect the diastolic transfer of blood from atria to ventricle, creating murmur. So what kind of murmur we are getting? We are getting a mid-diastolic murmur. Mid-diastolic murmur with pre-systolic accentuation. With pre-systolic accentuation. So phonocardiography wise, it looks like this. You have this S2 because diastole is between S2 and S1. The first phase of diastole is isovolumetric relaxation. At this point of time, the ventricles are relaxing so that they can lower their pressure in comparison to atria. The valves are not open yet. After isovolumetric relaxation, the ventricular pressure becomes lower than that of atrial pressure, and that pressure difference opens the valves. Normally, when valves open, they don't make noise, but here they are stenosed, so they can make a noise, and this noise in this case will be called as snap. If I have ASPS, the valve opening produces much louder noise. That's why we call it as click. These valves are opening in diastole, low pressure systems. So they produce less loud noise. So we call it as snap. After you open the valve, the blood starts moving through these narrow valves. First is through passive filling. That is where you are experiencing the turbulence. So you start noticing murmur appearing. But towards the end of passive filling, the pressure between atria and ventricle are normalized, and to push the remaining blood, the atria contracts more forcefully to give you what you call as active filling. And when I am doing active filling, I am generating much more forced transfer of blood from atria to ventricle through narrow orifice, so the murmur intensity even increases. And this is what we call as pre-systolic accentuation, right? This part is what we are calling as pre-systolic accentuation. And this pre-systolic accentuation is due to active filling, and it can be absent in. When it will be absent? If atria contracts forcefully during the active filling, it is pushing the blood through narrow orifice, producing loud murmur. But if atria doesn't contract, Atrial doesn't contract, then there is no active filling and no pre-systolic accentuation of the murmur. And when atrial doesn't contract, atrial fibrillation. And remember, mitral stenosis is a risk factor for atrial fibrillation. So if you have MS, you may develop AFib, and if you develop AFib, the pre-systolic accentuation part of the murmur disappears. So that can be taken as a sign of development of AFib. It can be absent in atrial fibrillation. Very good. Okay, the other question they may ask you about the MS and TS is, they can ask you what is the most common cause for mitral stenosis, and that's simple. That is going to be your rheumatic heart disease. RHD is the most common cause for mitral stenosis. Okay. Now talking about the mitral regurgitation and tricuspid regurgitation. Ignoring the acute MR and TR, let's talk about chronic MR and TR, which are more common. So in both chronic MR and TR, you have pan-systolic murmur. You have pan-systolic murmur. So the murmur runs from S1 all the way through to S2. This is what we call as pan-systolic murmur. Where is it best heard? It will be best heard in case of mitral regurgitation in the mitral area, in case of the tricuspid regurgitation in the tricuspid area, which is the left lower sternal border. Okay. Beyond that, you should also remember, if there is a combination of mitral stenosis plus mitral click, okay, plus the question is talking about young female, plus palpitations as a complaint. What is the diagnosis I should be thinking of? Not mitral stenosis, sorry, mitral regurgitation. Mitral regurgitation. Yes, in case of acute MR and acute TR, you will have an early systolic murmur, but as the condition becomes chronic, the duration goes on increasing and you eventually end up with pan-systolic in case of chronic. Good. So if you get this combination, I want you to think about mitral valve prolapse. So when mitral valve prolapses into the RA, it produces a click. So if you are having MR plus click, you are dealing with mitral valve prolapse. And because mitral valve prolapse is more common in females and the usual presentation is with palpitations, the question goes like this: a young female presented with palpitation. On auscultation, mitral valve click followed by a systolic murmur was heard. So in the mitral area, indicating that you have MR and click. So that means we are dealing with mitral valve prolapse as the question. Okay. So this is about the valvular heart diseases. So whenever you get a valvular heart disease question, what is our approach? Our approach is to see from which area the murmur is coming, whether we have right-sided symptoms or left-sided symptoms, and whether it is systolic or diastolic murmur. And if you have kind of memorized this table, then with the 3 levels of information, any 2 levels of information will usually take you to the diagnosis among the given options. Okay. So after completing the valvular heart diseases, let's get into some questions related to abnormal heart sounds. Okay. Now we know S1 is due to closure of mitral tricuspid and S2 is due to closure of your aortic and pulmonic valves. But there can be additional sounds called S3 and S4, and they do ask questions about it. Now what is this S3? S3 is the sound produced, both are diastolic sound. S3 is the sound produced by passive filling. Normally passive filling or active filling does not produce sound, only valve closure produces sound, nor opening produces, nor the transfer of blood produces. But in some individuals, passive filling can produce the sound. When does it produce a sound? When I do passive filling into the normal sized left ventricle, I don't make any noise. But if I dilate the left ventricle, it becomes more compliant. And when I do passive filling in the dilated LV, this first jet of passive filling coming and hitting the wall of the LV produces a sound. That sound is what we call as S3. So S3 is the sound produced by passive filling. And to produce that sound, I had to change the ventricle. What change I had to do? I had to create dilatation of the ventricle. So passive filling plus dilated compliant LV produces S3. Now, when LV gets dilated, LV can get dilated whenever there is volume overload on the left ventricle or there is atrophy of the LV muscle mass. When do I have volume overload on the left ventricle? In case of MR and AR. In MR, whatever blood that regurgitated into the atria is coming back, adding volume burden on the ventricle, or in AR, the blood regurgitating from the aorta is creating the volume burden. So, to accumulate this volume burden, the ventricle dilates. Okay, or if there is ischemia of the ventricular wall, it becomes atrophied and it dilates. You get this S3 in patients with AR, MR and ischemic heart disease, particularly systolic dysfunction, when you have systolic dysfunction. Okay, beyond that, it can be physiological as well. So, S3 can be physiological or pathological. It can be physiological in children, athletes and pregnant women. Children, athletes and pregnant women. But in adults who are not into athletics and who are not pregnant, if you get S3, it is pathological. You should be thinking about volume overload and dilated LV in that case. Okay. Now, S4 is the sound produced by active filling. Normally, active filling doesn't produce the sound. So, this is the story of S3. What happens in S4? In S4, when we are doing active filling, if I make the ventricle small, now how do I make the ventricular cavity small? By creating concentric LVH. So, if I add more muscle mass inwards, the ventricle becomes small, and when I forcefully push the blood into a small ventricle, the noise that it produces is what we are calling as S4. So, S4 is produced by active filling, and to do that I need small non-compliant LV, as in case of LV, as in case of concentric LVH. So, we are doing active filling. So, this jet is the jet of active filling. Active filling into a concentrically hypertrophied LV is responsible for production of S4. Point to note about S4, S4 is always pathological. It's always pathological. So, one of the MCQ they ask you is, which one is early diastolic sound and which one is late? Now, tell me, is S3 early diastolic sound or is S4 early diastolic sound? Is S3 early diastolic sound or S4 early diastolic sound? Yes, hypertrophic obstructive cardiomyopathy is also a form of asymmetric but concentric type of hypertrophy. The muscle mass is added inwards, not outside of the ventricle. It's a concentric hypertrophy. So, there also ventricle cavity becomes smaller. You can have S4. Okay. So, if I have to put it on a graph, let us say this is my S1, this is my S2, this is my S1 again. Okay. So, first phase of systole will be isovolumetric contraction followed by opening of the valves. Then we will have rapid ejection followed by delayed ejection. Once the ejection is over, we get into the diastole. The first phase of diastole is isovolumetric relaxation followed by passive filling followed by active filling. So, S3 is the sound produced by passive filling into a dilated compliant LV, right? So, it is relatively early in the diastole in comparison to S4. S3 is early diastolic sound, while S4 is the sound produced by active filling. So, S4 is a late diastolic sound. S3 can be physiological, S4 is always pathological. Okay. Beyond that, what other additional sounds we should be familiar with? We should be familiar with clicks and opening snaps, which we already know. Clicks we get in patients with aortic stenosis, in patients with pulmonic stenosis, and we just discussed about one condition where the prolapse of the valve is producing a clicking noise, that is mitral valve prolapse. Young female palpitations, mitral valve prolapse click, and MR murmur, that's typical of MVP. Opening snap we get in mitral stenosis and tricuspid stenosis. Now, where do I hear them? It is the sound produced by opening of the valves. So, the clicks will be heard in systole. Okay, and here I'll be hearing the snaps in mitral stenosis and tricuspid stenosis, the snap will be heard after the isovolumetric relaxation. In fact, you can say that click indicates that isovolumetric contraction got over and you start ejection now, and if you get snap, it indicates that the isovolumetric relaxation is over, the valve is open, and you start passive and eventually active filling now. Okay, so that's about our heart sounds. Again, I'm reiterating the key point to remember: S4 is always pathological, S3 can be physiological. Now let's get into a core cardiology topic, which is heart failure. Okay, now what is heart failure? Your heart has two functions. First one is to eject the blood or pump the blood. If it fails to properly eject the blood, there is failure. But to be able to eject the blood, it has to first do isovolumetric relaxation and receive the blood. Ventricles have to fill first. So if I have problems in ventricular filling, that is also heart failure. So by definition, heart failure is impaired left ventricular ejection or filling. Okay, so if there is ejection problem, then we call that as systolic heart failure. We will call it as systolic heart failure. And if you have difficulty in filling, we will call it as diastolic heart failure. If you fill during diastole but you are not able to fill it properly, you will have diastolic heart failure. Now, why I will not be able to eject the blood well from the heart? Most commonly it's because of ischemic heart disease. The ventricles muscle mass is infarcted, so it is not able to contract. That's why you're not able to eject well, right? So the most common cause for systolic heart failure is going to be IHD. But why will I not be able to fill properly in diastolic heart failure? Now let us think about it. This is my left ventricle. Okay, now from left atrium I fill the blood into it during diastole. But what if I have developed concentric LVH? The LV cavity has become small, and smaller the LV cavity, less the filling. I add more muscle mass, cavity becomes even more smaller, less filling. So concentric LVH can lead to impaired diastolic filling. And what is the most common cause for concentric LVH? It is hypertension. And thus hypertension is the most common cause for diastolic heart failure. It is the most common cause for diastolic heart failure. Now these patients will present with symptoms of heart failure. Okay, so what are the signs and symptoms of heart failure we are talking about? If you talk about right heart failure, the patients will have raised right atrial pressure presenting in the form of raised JVP, ascites, hepatomegaly, and edema. While if the patient has left heart failure, left atrial pressure will be increased, so there will be congestion of the lungs, so patients will present with dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. So whenever I have these signs and symptoms, they need not always say that patient has got heart failure. You can have these signs and symptoms because of various other causes. But if I can prove that these signs and symptoms are because of impaired cardiac function in the form of a marker which is going to be N-terminal pro-BNP or BNP levels, increased BNP, brain type or B type natriuretic peptide, or N-terminal pro-BNP levels, that proves that these symptoms are arising because of impaired cardiac function, and then you can consider that you have heart failure. So if they ask you what is the biomarker of choice for diagnosis of heart failure, it is going to be N-terminal pro-BNP, if not BNP. Okay, so once you recognize that these patients with these symptoms have heart failure based on the biomarker, next is classification. The classification is based on the ejection fraction. Ejection fraction. Yes, so in hypertension you have increased peripheral vascular resistance. So to overcome that resistance, the ventricles start doing more work, and whenever a muscle does more work, it develops hypertrophy. And whenever afterload is increased, you develop concentric hypertrophy. That's why hypertension is the most common cause for concentric hypertrophy, and thus it becomes the most common reason for a diastolic heart failure. Okay, now the classification is based on ejection fraction. Now what is ejection fraction? Ejection fraction is basically what percentage of end diastolic volume that you had in the ventricle is ejected by the heart as stroke volume, and because we are expressing it in terms of percentage, I have to multiply it with 100. This is the formula for ejection fraction. Percentage of end diastolic volume, like if this is the left ventricle we are looking at, left atrium is here, and this is the aorta. This is the aortic valve, mitral valve. So I have filled some blood into the left ventricle. This blood is what I am going to call as end diastolic volume. So every time I contract, I will not be able to eject all the blood from the LV into the aorta. I eject some amount of blood into the aorta, and whatever I eject, that quantity of blood will be called as stroke volume. That will be called as stroke volume. And if I express what percentage of end diastolic volume got ejected as stroke volume, then we call it as ejection fraction. And what is the main determinant of this ejection fraction? The more forcefully ventricle contracts, you will be able to eject more blood as stroke volume. Less forcefully it contracts, you will be able to eject less blood. So indirectly, ejection fraction tells you the force of left ventricular contraction, and the force of left ventricular contraction depends on the health of the muscle. If the muscle is infarcted, it will not be participating in the contraction. So by that, force of contraction comes down, ejection fraction comes down. So that means whenever you have problems in systole, you're not able to eject properly, EF comes down. But if you have heart failure but EF is normal, then you have diastolic problem. You're not able to fill well, that's why you're getting low stroke volume. But otherwise your ventricle is able to contract. So ejection fraction can help me to identify whether I'm having systolic dysfunction or diastolic dysfunction. So once you have heart failure, the first thing I should reach out for is echo to see what is the ejection fraction. If ejection fraction is, remember, normal ejection fraction is in the range of 60 to 70%. Means if I have, let us say 100 ml as my end diastolic volume, then 60 to 70 ml will be ejected as stroke volume. Okay. But if it is less than 40%, then we will call it as heart failure with reduced ejection fraction, and that is nothing but your systolic heart failure. I have symptoms of heart failure, but EF is more than or equal to 50%. Then it is fairly close to normal, right? Normal is 60 to 70%. It is fairly close to normal. In that case, we'll call it as heart failure with preserved ejection fraction, which indicates you have diastolic heart failure. So if I have a patient with heart failure and I get EF 50% or more, I would rather think of hypertension as the cause, or maybe other conditions like hypertrophic cardiomyopathy or constrictive pericarditis where diastolic dysfunction can occur. But if I have heart failure and EF turns out to be less than 40%, I should think about systolic heart failure, and in that case, I am probably having ischemic heart disease, right? Okay, so this is about your basic classification of heart failure. Some of you may be wondering, sir, what about 40 to 49% EF? These patients are called as having heart failure with mid-range ejection fraction. If EF is between 40 to 49%, you call them as having heart failure with mid-range ejection fraction. We are not sure whether it is systolic dysfunction or diastolic dysfunction. Okay. Now, when we talk about the management of heart failure, we know the diagnosis. You'll have signs and symptoms of right or left heart failure. You get the BNP or pro-BNP levels and they're elevated, means you're dealing with heart failure. By looking at EF, you may be able to gauge whether you are dealing with hypertensive heart failure or IHD as the cause for heart failure. So of course, you will treat the underlying cause. But then because your heart is failed, you are having two changes. One, your stroke volume is decreased. Second, your atrial pressures will be high. That's why you are getting all these symptoms, right? Orthopnea, dyspnea, PND, raised JVP, ascites and all. So when I have to treat these patients, I have to ensure the atrial pressures get lowered. But when I try to lower the atrial pressures by giving diuretics, I can induce reduction in end diastolic volume, the stroke volume gets reduced. So then how will I manage? Well, I'll just tell you what is the pathophysiology of heart failure. Two things are happening when heart fails. The first thing is your atrial pressures are increased. Second thing, your stroke volume is decreased, and because of the decreased stroke volume, you will have decreased systolic BP. And when the systolic BP decreases, to counter that, two systems get activated. One of them is going to be sympathetic nervous system, The other one is going to be your RAS. So what sympathetic nervous system does? Sympathetic nervous system through adrenaline, noradrenaline, dopamine will cause vasoconstriction. This vasoconstriction will help you to normalize the blood pressure that was already low. Okay. RAS will also help you to normalize the blood pressure which was getting low because of low stroke volume, because RAS has angiotensin 2. Angiotensin 2 is a very potent vasoconstrictor. Second, RAS has aldosterone. Aldosterone will increase your sodium and water reabsorption in the kidney, and by doing so you will have more sodium and water now, so your effective blood volume increases, and increased blood volume also helps you to normalize the blood pressure. But the problem here is the vasoconstriction increases after load. The more constricted the blood vessels are, to push blood into the constricted blood vessels, ventricles have to put more effort. So indirectly you are increasing the work that ventricles need to do. There will be increased afterload. It is already failing, not able to do its job, and now you're asking it to do more job. Just like how if you're an intern, your HODs are asking you to do more work and making you fail more. Same way, if I ask the ventricles to do more work, it fails more. And increased blood volume also means you will have increased end diastolic volume, which is nothing but increased preload. So whether I increase preload or increase afterload, it is going to be harmful for the heart, harmful for heart failure, because you are putting more burden on the heart. So what do you think? Should I stimulate the sympathetic nervous system and RAS to treat heart failure, or block them? We should block, right? By blocking, we will be able to reduce the afterload and preload. That's why in the management of heart failure, we use beta blockers, use ACE inhibitors or ARBs, and spironolactone. The other change that is happening here is atrial pressures are increasing. So in response, there will be release of natriuretic peptides. Natriuretic peptides like ANP and BNP. They do exactly opposite of what RAS does, because these natriuretic peptides cause vasodilatation, and by causing vasodilatation, they will decrease afterload, and reducing the load on a failing heart is beneficial. Second, on the kidney, exactly opposite of what aldosterone does. Aldosterone increases sodium and water reabsorption. These increase sodium and water excretion. It is there in the name, right? Natriuretic peptide. Sodium urases, losing the sodium in urine. Along with sodium, you always lose water. So there is increased sodium and water excretion that will result in decreased end diastolic volume, that will result in decreased preload. So this natriuretic peptides are beneficial. So then tell me, what should I do? Natriuretic peptides should be supported, while the RAS and sympathetic nervous system should be blocked. How do I block these? We already know, but how do I support the natriuretic peptides? Remember, these natriuretic peptides, when they complete their action, they get converted to inactive peptides by an enzyme called neprilysin. The name of the enzyme is neprilysin. So what if I can block the neprilysin? If I block neprilysin, then ANP, BNP will not be broken down to inactive peptides, so they will be active for a longer period of time, and I get more benefit, right? So these are the classes of drugs that we have that can be used. So we are blocking the RAS with the help of ACE inhibitors or ARBs, plus I am blocking the sympathetic nervous system with the help of beta blockers. Can anybody tell me which beta blockers are approved by the FDA for particular use in heart failure, where studies have clearly shown that use of them reduces mortality? Yes, sacubitril is the neprilysin inhibitor. In India, we have sacubitril available in combination with valsartan, which is an ARB. Collectively, the combination is called as ARNI. Okay. Which beta blockers are approved for use in heart failure, where there is clearly documented mortality benefit in the trials? There are 3 beta blockers that you need to remember. You can remember them with the Melbourne Cricket board? Melbourne Cricket Board. Absolutely right. So one of them is going to be metoprolol. If you want, you can also remember it as Mumbai Cricket Board. Second is carvedilol. The third one is bisoprolol. The other beta blockers either have failed the clinical trials to show that they reduce mortality, or trials are not yet done. So of course we should use the one that has proven benefit in the trials. Okay. Then third, we are using spironolactone because RAS also had aldosterone. We want to block that, so we are using spironolactone. And fourth, we can consider neprilysin inhibitor, which is going to be sacubitril. Okay. Apart from that, recent studies have shown that SGLT2 inhibitors reduce the death risk in patients with heart failure, regardless of presence or absence of diabetes. Because when you give SGLT2 inhibitors, they block sodium reabsorption and glucose reabsorption. So there will be mild natriuresis, that's water loss, glucose loss, along with that water loss. So you are reducing the circulating blood volume, thus you are reducing the preload and you are helping the heart. We can use SGLT2 inhibitors regardless of the diabetes status. SGLT2 inhibitors do not cause hypoglycemia. Okay. So now these are the class of drugs we have. And please note, if you have the combination of sacubitril, which is neprilysin inhibitor, plus valsartan, this combination is called as ARNI. This combination is called as ARNI. Okay. And you should be aware that in the treatment of heart failure, there is something called as golden 4 pillars of heart failure treatment. So what are these 4 pillars? The first one is going to be ACE inhibitors or ARBs or ARNI combination with neprilysin inhibitor. Second one is beta blockers. The third pillar is going to be your spironolactone, the aldosterone receptor blocker. And the fourth pillar is going to be your SGLT2 inhibitors. Okay. So this is about the management of heart failure. What about the inotropic agents like, let us say, digoxin, or newer inotropic agents like levosimendan? Their use is not beneficial in chronic heart failure. In fact, their use is associated with increased mortality. In acute heart failure, for a temporary improvement in stroke volume, you can use them, but not for long-term use in chronic heart failure patients. Okay. So studies have shown that use of digoxin in heart failure is associated with increased mortality. This is also an MCQ that has been repeatedly asked. Okay. So that completes our heart failure as well. We have discussed about pulse, JVP, valvular heart diseases, added heart sounds S3, S4, snaps, clicks, and heart failure. Okay. Now let's talk about the next important topic from cardiology, which is going to be constrictive pericarditis. Right? Chronic constrictive pericarditis. So what is this constrictive pericarditis? Basically, when you have either chronic pericarditis, which is very often caused by tuberculosis, or you have recurrent acute pericarditis. Recurrent acute pericarditis, which can be idiopathic or viral. Which can be idiopathic or viral. It will lead to scarring and thickening of the pericardium. And once there is scarring and thickening of the pericardium, the pericardial stretch limit is now reduced. This will result in decreased pericardial limit of stretch. So now pericardium can stretch only as much as the scarring allows it to stretch. So normally what happens, if I'm looking at the heart, let us say this is the heart that we are looking at. This is my right ventricle, this is my left ventricle, and we transfer the blood from atria to ventricle during diastole. So when I want to fill the blood into the ventricle during diastole, the ventricle has to expand. Okay. Normally the pericardium around it never limits it how much ever the ventricle wants to expand, pericardium allows. It is highly stretchable tissue. But now that you have scarred pericardium, it can stretch only to some extent. Let us say during the diastole, the ventricle wants to expand till here. So then the expanded ventricle should be of this size. Okay. But the pericardium has set a limit and says, I cannot allow you to expand that much. My limit of stretch is only this much. So in that case, during the filling, the ventricle can only expand till that pericardial limit of stretch is reached. Once I reach this point, further ventricular expansion doesn't happen. So whatever filling I am doing has to be halted once I reach the pericardial limit of stretch. So this results in sudden or abrupt cessation of passive filling. Yes, TB is the most common cause for constrictive pericarditis in India, and in the rest of the world, the Western world, it is the recurrent acute pericarditis. Sudden cessation of passive filling. And when you abruptly stop the passive filling, two things happen. First thing, we know normally we fill 70% of the blood into the ventricle during passive filling, but you stopped it before that only. So instead of 70%, you might have filled 50% or 40%, depending on how stiff the pericardium has become. So thus, there will be decreased passive filling. There will be decreased passive filling. And if the passive filling is less, then there is more burden for the active filling. Normally 70% is filled in passive and then remaining 30 is filled during active. But now if I only filled 40% in passive filling, then I have to try to fill 60% during active filling. So during active filling, the atrial pressure increases, right? So this decreased passive filling will result in increased active filling burden, and increased active filling burden will result in taller A waves. This will result in tall A waves, and whenever we get tall A waves, we will have steep or prominent X descent as well. This we know. So these changes we are already familiar from our earlier discussion on the JVP. Second, this sudden cessation of passive filling also becomes the reason for steep or prominent Y descent. Steep or prominent Y descent. This is something that is different from the cardiac tamponade, where there is no passive filling occurring, so you don't have Y descent. Okay. And then suddenly, when the expanding ventricle gets halted by reaching the pericardial limit of stretch, Newton's laws come into picture. Newton says, if an object is in motion, it will continue to remain in motion, and if an object is inert, not moving, it will continue to remain in inert state until and unless an external force is applied. So now the ventricle was in motion because the blood was coming into it, it was expanding, it was in motion, and suddenly you applied an external force. So you are halting it, but it wants to continue to move. Something similar to what we experience in our life. If I am driving a car and if I suddenly apply the brake, vehicle stops, but because my body was also in the inertia of motion, it continues to move. That's why we jerk forward before we regain the composure. So similarly, when abruptly ventricle gets halted, which was expanding, that also jerks, just like how we jerk when we brake. And that jerking of the ventricle produces a noise, which we are calling as pericardial knock. So this sudden cessation of passive filling itself is the reason why we are getting pericardial knock. Pericardial knock. So in case of the cardiac tamponade, we were getting muffled heart sound. Here we are getting pericardial knock. Okay. As someone pointed out, this is the most common cause in India. TB is the most common cause in India, while recurrent acute pericarditis is the most common cause in rest of the world. Now, because there is less passive filling, this will also result in other changes. If you're not doing full passive filling, overall RV filling is going to be reduced. And if the RV filling is less blood is coming to the RV, that will result in decreased right ventricular stroke volume, If RV is sending less blood to the lungs, less blood goes to the left side of the heart, so there will be decreased LV filling, and decreased LV filling can lead to decreased LV stroke volume, and if the LV stroke volume is decreased, it can lead to hypotension. Okay, and because you are having burden on the active filling, you are getting tall A waves and steep X descent, which is nothing but your tall JVP waves. So you have raised JVP, you will have hypotension, which are similar to cardiac tamponade, the Beck's triad components. But what is the change? There you get muffled heart sound, here you get pericardial knock. Now, once I have recognized that this is a case of constrictive pericarditis, how am I going to manage it? So please remember, for diagnosis, yes, we can get some clue on the echocardiography. Okay. Second, the gold standard for diagnosis or investigation of choice is going to be right heart catheterization. In the echocardiography, this sudden halting of the ventricular expansion, the ventricle vigorously vibrates, something that is producing the pericardial knock. That vigorous vibration or shuddering can be seen on the echocardiography, and we call it as right ventricular shudder. In my regular video lectures, I have added a video where we can literally see the ventricle shuddering. When we do right heart catheterization, we get something called as square root sign. Square root sign. Now, I am not getting into the detailed discussion how the square root sign is produced. Just remember that you get square root sign on right heart catheterization. Basically, when you are trying to check the right ventricular pressure. So, when you are doing the passive filling, the blood is coming to the ventricle, so ventricular pressure will be going high. That is the reason to see this upward trend. But after that, once you suddenly halt the passive filling, till active filling occurs, the ventricle is not doing anything, so pressure remains same. Normally what happens? Passive filling increases the ventricular pressure. After that, active filling further increases the ventricular pressure. So you see a upward graph. But here, after sudden halting of the passive filling, the ventricle is waiting for the active filling to start. Once active filling starts, the pressure starts going up again. But till that time, it is plateaued. This creates the appearance of square root sign, right? The square root sign is also called as dip. We're getting a dip, then rising pressure, and then plateau. So it's called as dip and plateau sign. Okay. Now for management, simple solution is your pericardium is the reason why you are not able to do proper passive filling. It is limiting the passive filling. So remove the limit, problem solved. So in terms of management, we treat them with pericardiectomy. Remove the pericardium, no more restriction of the passive filling. In case of TB, of course, you can try ATT for, generally we give for 1 year, but if you're not getting response in first 2 to 3 months, again you have to go for pericardiectomy, removal of the pericardium. Yes, so there are various conditions where there is cessation of diastolic filling. You can have the square root sign, but the typical square root sign where you can see a long sustained plateau is encountered in the constrictive pericarditis itself. So though you can say square root sign per se is not specific, but getting a clearly halted passive filling and then a long sustained plateau before active filling starts, that's something that we only get in case of constrictive pericarditis. Okay, now let's talk about the cardiac tamponade. Cardiac tamponade. What is cardiac tamponade? So when I have collection of fluid in the pericardial cavity, let us say this is the right side of the heart, this is the left side of the heart, and surrounding that I have the pericardium. When I start accumulating fluid in the pericardial cavity, we'll call that condition as pericardial effusion. This is not cardiac tamponade, this is pericardial effusion. But when this pericardial effusion results in, of course, when fluid is collecting in the pericardial space, this will be exerting pressures on the ventricles. And this effusion, if leads to collapse of the ventricles, then we will call it as cardiac tamponade. Which ventricle is going to collapse first? It's always right ventricle, because left ventricle is more muscular. To make it collapse, the fluid has to be more, it has to put more pressure. RV is thin, so it collapses first. So once the RV collapses, under the pressure from the pericardial fluid, then we will call it as cardiac tamponade. So before the RV collapse, we will simply call it as pericardial effusion. So here you have pericardial effusion and collapsed right ventricle. And because the RV is collapsed, doing a passive filling into RV becomes very difficult, because for me to do passive filling, I have to first relax this ventricle. Isovolumetric relaxation should occur. But here, isovolumetric relaxation is not possible because fluid is pushing it on the opposite direction, and you can't do isovolumetric relaxation. So if I can't do isovolumetric relaxation, I can't do passive filling. So this collapsed RV is the reason why there is no passive filling in patients with cardiac tamponade. And if there is no passive filling, there will be, number one, no Y descent, right? Because Y descent is produced by passive filling, and you're not doing passive filling, so you're not getting Y descent. Okay. Number two, if you're losing out on passive filling, you're literally losing out on 70% of the filling of the ventricle. In the active filling, you will be able to push the remaining 30% forcefully into this ventricle, right? So thus, can I say that there will be decreased RV filling? By having no passive filling, there will be decreased right ventricular filling. And if there is decreased RV filling, there will be decreased LV filling. And if there is decreased LV filling, there will be decreased LV stroke volume, and you end up with hypotension. You will end up with hypotension. So one of the component of what we call as Beck's triad is here. Hypotension because of decreased RV filling result in decreased LV filling. Okay. Then we are already aware about Y descent being absent here. And if I'm not able to transfer blood efficiently from RA to a collapsed RV, more and more blood is staying in RA itself. So right atrial pressure increases, right? So there will be increased right atrial pressure. Increased right atrial pressure will result in raised JVP. Increased right atrial pressure will result in raised JVP. Another component of Beck's triad. And now we know fluid is not a good conductor of sound. So if I keep my stethoscope here and try to auscultate, I will not be able to pick up the sounds produced by the closure of the valve, because fluid is not a good conductor of sound, ending up with muffled heart sound, muffled heart sounds. And these three features collectively we call it as Beck's triad, a classical triad described in patients with cardiac tamponade. Yes. So this hypotension is nothing but a form of obstructive shock itself. Okay. Now what can get me into this situation? For me to collapse the right ventricle, either I should have massive collection of fluid or too rapid collection of fluid. If I am slowly accumulating fluid, then the pericardial compliance improves. So it will not help you build more pressure inside the cavity. But if I add too much fluid or too rapidly, I can end up in a situation where the RV can be collapsed. Too much fluid too rapidly can be added by bleeding into the pericardial cavity. So the most common cause for cardiac tamponade is indeed hemopericardium. The most common cause is going to be hemopericardium. And what is the most common cause for hemopericardium? The most common cause for hemopericardium is going to be trauma. The trauma can be because of road traffic accident or iatrogenic, like when you're trying to do thoracic surgeries or cardiac surgeries or even angioplasty, you can rupture a vessel, coronary artery, and then you can bleed into the pericardial space. So it can be iatrogenic, but overall, road traffic accidents are the leading causes for cardiac tamponade. Most of your MCQ story goes like this. A patient had a road traffic accident and then he was brought to the emergency room. When he was brought to the emergency room, BP non-recordable, heart sounds faintly heard or heard distantly or not heard, and the neck veins were distended. That is what we call as Beck's triad. Once you get this picture, road traffic accident and Beck's triad, you know you're dealing with cardiac tamponade, right? So what are the components of Beck's triad in that case? So there are a lot of triads that we need to be aware in case of cardiac tamponade. The first one is clinical triad. The clinical triad is called as Beck's triad. So in Beck's triad, we have raised JVP with absent Y descent, of course. Then we will have muffled heart sounds and hypotension. Muffled heart sounds and hypotension. We also have a ECG triad. Now, what is the ECG triad of cardiac tamponade? First thing is you're getting into hypotension. Whenever BP drops, sympathetic nervous system gets activated. Adrenaline, noradrenaline will stimulate the heart to beat with higher rate. So you'll have sinus tachycardia. So sinus tachycardia can be seen on the patient's ECG. Second, the fluid is not only impairing the sound conduction to the surface, but it is also going to impair the electrical impulse conduction to the surface electrodes. So when you record the ECG, the QRS voltages will be smaller than usual because fluid is impairing the conduction, resulting in low QRS voltage. Low QRS voltage. Third, this heart can now float in the pericardial fluid like a pendulum, sometimes coming closer to the surface of the chest, sometimes going away. So whenever it comes closer to the surface of the chest, the ECG electrodes record a larger QRS voltage, and when it goes away, there's a lot of fluid between the heart and the surface of the chest. So in that case, the ECG records lower QRS voltage. So you might have alternate high and low QRS voltage. And that condition is called as electrical alternance. Electrical alternance. This had been an image-based question in the past, electrical alternance. So let's see that image as well. If you look closely, let us say we are looking at lead 2, then this is one QRS which is small, while the next QRS is tall. The next QRS is again small, the next QRS is tall. That means the heart was away from the surface electrodes here, while it had come closer to the surface electrodes here. Again it moved away, giving a low QRS voltage, then it moved closer to the surface, giving a taller QRS voltage. So this alternating tall and low QRS voltage is what we call as electrical alternance. These three things put together we call it as ECG triad of cardiac tamponade. Okay. Then we also have an echo triad. An echo triad of cardiac tamponade. Now what is the echo triad? When you do echo, first thing you will notice is there is pericardial fluid, that may be blood or other fluid. Second, this fluid has resulted in collapse of right ventricle. So you will have collapsed RV. Third thing, you will also notice that if the RV is collapsed, RA pressure will be high. That will result in raised JVP, but similarly there will be increased inferior vena cava pressure, which I cannot see from the surface, but echocardiography can tell me in the form of dilated inferior vena cava. Dilated inferior vena cava. These three things put together we call it as echo triad. Echo is right now considered as the investigation of choice for diagnosis of cardiac tamponade. It can clearly tell you that there is fluid, RV is collapsed, and thus you have cardiac tamponade. Once we have recognized that we are dealing with cardiac tamponade, how are we going to manage it? Okay, so if it is traumatic cardiac tamponade, which is due to hemopericardium, in that case, the mainstay of management should be surgical. You have to go for explorative thoracotomy, right? Open the chest, remove all the blood that is accumulated in the pericardial space. The reason we are jumping for surgery is because if it is hemopericardium, the blood often gets clotted. So when you put a needle and try to drain, you may not be able to drain all the blood. The clots will still remain. They will still compress the ventricle, right? So that's why opening and clearing the clot becomes necessary. Second, you need to identify from where the patient is bleeding. If you put a needle and remove, after 1 hour again the fluid or the blood might accumulate if there is an injured artery. So that's why identifying the site of bleed and sealing it is also important. But if it is non-traumatic, like let us say mixed edema coma or patients with nephrotic syndrome or heart failure, there is pericardial effusion and it is resulted in the tamponade, in that case we will go for needle pericardiocentesis. You don't need to go for explorative thoracotomy. Needle pericardiocentesis. They will ask what is the preferred site for needle insertion. That will be substernal or subxipoid. From below the xipoid process, you put a needle towards the heart, and once you reach the pericardial space, the fluid will be gushing out and you will drain it. Substernal or you can also call the same approach as subxiphoid approach, substernal or subxiphoid approach. So there are some students confused about whether we should answer needle pericardiocentesis or surgical, because generally when books talk about cardiac tamponade, some books mention needle, some books mention surgical. So let's be specific about it. If it is traumatic, we always prefer surgical, and if it is non-traumatic, we begin with needle. Okay. Now the next question is, what if, sir, they're asking that it is, they're telling that it is a traumatic case, road traffic accident, rib fractures are there, cardiac tamponade is there, but then thoracic surgeon is not available or OT is not available. In that case, what should be my answer? In that case, of course, something is better than nothing. So put a needle, drain as much blood as you can. After that, you have to refer the patient to a place where thoracic surgery is possible, so that all the issues, bleeding artery is identified and sorted. But if the patient has landed up in a place where thoracic surgery is possible, then take the surgical approach. So that completes our cardiac tamponade. We have already discussed the cardiac tamponade versus constrictive pericarditis. Same thing is there in the workbook table. Okay. Javier, okay, see, high index of suspicion is required for diagnosis of cardiac tamponade, but you will have a lot of conditions where you can have raised JVP and hypotension and even muffled heart sounds. Like for example, a patient with tension pneumothorax can also have raised JVP. They can also have muffled heart sounds because this massive hemithorax is literally squeezing the heart, and the sounds coming from the heart may not be heard well, right? There also you can end up with hypotension. So Beck's triad is a pointer towards cardiac tamponade, but I cannot exclusively rely on Beck's triad for diagnosis of cardiac tamponade. For confirmation, echo is the best investigation. Okay, so next topic we have is acute rheumatic fever. Okay, what is acute rheumatic fever? It is an autoimmune, it's an infection triggered autoimmune polysystem disorder, right? So what is it? It is an infection triggered multi-system autoimmune disorder, multi-system autoimmune or autoinflammatory disorder, just like your post-streptococcal glomerulonephritis. Usually which infection is responsible? It is the group A beta hemolytic streptococcal infection, group A beta hemolytic streptococcal infection. And whenever we have group A beta hemolytic streptococcal infection, two possible autoimmune reactions can occur. One is development of post-streptococcal glomerulonephritis, the other one is acute rheumatic fever. Okay, now how do I get to know that a person who had sore throat a week ago or so has developed rheumatic fever? They will present with some clinical features which will be dividing into major and minor criteria. The major criteria can be easily remembered with the mnemonic cases where C stands for carditis. If there is inflammation of the heart, A stands for arthritis, usually polyarthritis. S stands for Sydenham's chorea. E stands for erythema marginatum, and another S stands for subcutaneous nodules. So basically, when you think about rheumatic fever, all you have to think about is you had a group A beta hemolytic streptococcal infection. Body produced antibodies against the group A beta hemolytic streptococci. But because of molecular mimicry, these antibodies are going to target your own tissues. Wherever they find similarly structured proteins, they are going to target. We find similarly structured proteins in the heart, so heart gets targeted. You get similar proteins in the joints, so joints get targeted. Even in the caudate lobe of the brain, you have similarly structured proteins, so even the caudate lobe gets targeted. The caudate nucleus gets targeted. And then in the skin and subcutaneous plane also, you have proteins which are similar in structure to the group A beta hemolytic streptococcal antigens, so they also become targeted, resulting in multiple systems being affected. In terms of MCQ, they will ask you what is the most commonly affected organ. So in the today's world of echocardiography, the most commonly affected organ is heart itself. So carditis is the most common manifestation of rheumatic fever. Once upon a time, we used to say the arthritis is the most common manifestation of rheumatic fever, because back then we could only recognize clinically apparent carditis. Subclinical carditis could not be recognized. But when echo became readily available, we recognize subclinical involvement of heart as well, and that's why now we know carditis is the most common manifestation. Now, what all can happen in carditis? In case of carditis, you can have generally pancarditis, means you can have involvement of endocardium, myocardium as well as pericardium. You can also have valvulitis. And when we are talking about valvulitis, the most commonly affected valve is going to be mitral valve, followed by aortic valve. Mitral valvulitis is the most common valvular lesion in case of rheumatic fever. Yeah, traditionally we make this statement saying that rheumatic fever licks the joints, because patients usually present with arthritis as their initial presenting complaint. But then we say after that it bites the heart. Rheumatic fever licks the joints and then bites the heart. Okay. Now, with respect to arthritis, generally it is polyarthritis but migratory type, means at the time of presentation, migratory polyarthritis. At the time of presentation, patient may have evidence of only one joint involvement, because though multiple joints get affected, there is jumping of involvement of one joint to the next, So at the time of presentation, the previously affected joints might have resolved. So patient might only have one joint involvement as the evidence. Okay. Sydenham's chorea is due to involvement of caudate nucleus of the basal ganglia. Erythema marginatum, I guess you can recognize from your dermat knowledge, where you will have a rash with advancing erythematous edge with the central clearance. Subcutaneous nodules are nodules that are usually seen on the extensor surfaces, not on the flexor surface like elbow or bony prominences and extensor surfaces is where you see subcutaneous nodules. So if there is a question which says a patient had sore throat, followed by that he developed, let us say, mitral valvulitis or pericarditis or migratory polyarthritis or Sydenham's chorea, it is pointing towards acute rheumatic fever. Okay. So these cases are major criteria. What are the minor criteria that I should be aware about from the Indian perspective? Single joint arthralgia, monoarthralgia, okay, then fever, okay, then your raised ESR or CRP, and then prolonged PR interval. These are considered as minor criteria. Cases are your major criteria. So for me to diagnose how many major or minor criteria I need according to revised Jones criteria, according to the revised Jones criteria, I would require either two major or one major plus two minor. That is going to be equal to your acute rheumatic fever case. So I need two major or one major and two minor criteria. Now tell me, can I diagnose rheumatic fever without involvement of heart? Yes, it's not compulsory to have carditis. If I have migratory polyarthritis plus erythema marginatum, two major criteria is done. So according to the revised Jones criteria, it is a case of rheumatic fever if I have the evidence of preceding group A beta hemolytic streptococcal infection. Okay. Or if I have, let us say, prolonged PR interval and fever, two minor criteria, and then I have Sydenham's chorea, one major, two minor done, then also you can label it as a case of rheumatic fever. Please note, in presence of, you need, or you can say with evidence of preceding Group A, beta hemolytic streptococcal infection. This evidence can be also in the form of antibodies like raised ASLO titers. Now, when it comes to the management of rheumatic fever, first thing is patients would be given benzathine penicillin G for the eradication of the currently existing beta hemolytic streptococci as well as for further prevention. So, we would require benzathine penicillin G once in 2 to 3 weeks. Only point I want you to note here is if there is carditis, and from the Indian perspective, then we have to give them lifelong benzathine penicillin prophylaxis. Second, we will also offer them symptomatic care because they are having various organ manifestations. For example, arthritis can be treated with NSAIDs, and then if they have Sydenham's chorea, that can be treated with sodium valproate. Okay, so this is about the basic management of our rheumatic fever. What kind of questions are we expecting? Mostly asking you either diagnose rheumatic fever based on the revised Jones criteria, or they will give the story, features are mentioned, and then they will ask how many more minor are required or how many more major are required to make sure that this patient is having rheumatic fever. Okay, so it's all about the diagnostic criteria there. Recently, video-based questions have started appearing. We had some video-based questions in the FMG exam. You may get a video-based question here, and if they are giving a video-based question, it's most likely it's like patient had sore throat, followed by there will be a video where patient will be having some dance-like coriform movements. So then you know sore throat plus coriform movement, it is Sydenham's chorea. You're talking about rheumatic fever. So now from cardio, let's move to neuro. Okay, so from the neuro, what are the important topics? From the neuro, mostly questions are coming from myasthenia gravis, GB syndrome, multiple sclerosis, and stroke management. Okay, so we'll concentrate on these topics. But before that, just a quick recap of differentiating between upper motor and lower motor neuron lesions. So whenever we have upper motor neuron lesion, remember upper motor neuron is playing a suppressive role when it comes to tone and reflexes, while lower motor neuron is responsible for maintaining the muscle tone and spinal reflex arc. So if there is upper motor neuron lesion, if you look at tone, the tone will be increased because the suppression of tone is taken away. We will call it as hypertonia, more precisely spastic type of hypertonia, spasticity. And in case of lower motor neuron lesion, the tone will be decreased. We call it as hypotonia or flaccidity. Spasticity indicates UMN lesion, flaccidity indicates LMN lesion. And if you talk about deep tendon reflexes, the spinal reflex arc is maintained by lower motor neuron, and if it is damaged, the deep tendon reflexes will be diminished. You can call it as hypo, or if it is totally absent, you can call it as areflexia. But if the upper motor neurons are damaged, UMN is actually suppressing the reflexes, and if the suppression is removed, you will have exaggerated reflexes. You can call it as hyperreflexia. The normal plantar response, which is a superficial reflex, normal response is flexion of great toe and crowding of other toes. In adults, we call it as the normal flexor response or downgoing. So in case of LMN lesion, you can have the normal response preserved, or you can have mute response. But if UMN is damaged, it becomes extensor. You will have an upgoing plantar or extensor plantar reflex, which is also called as Babinski sign. Babinski sign involves extension of great toe and fanning of other toes. Extension of great toe and fanning of other toes. So basically, when we do plantar reflex, let us say I'm trying to do the plantar reflex on this patient's foot. This is my great toe and these are other toes. So then plantar reflex examination begins with stroking the posterior lateral edge of the feet, and then we ascend up and move medially, right? This is the stroke direction. So when we do that, this great toe goes into extension and the other toes open out. Great toes extends, other toes open out. This is what we call as fanning of other toes and extension of great toe. This is the response that we get in newborn, which is normal there. It's a primitive reflex. But if I get this response in adult, it indicates there is upper motor neuron lesion, because in adults we are supposed to get flexion of great toe and crowding of other toes, or no response. No response is mute response, which can be seen in LMN lesion, or you get the flexor but not the extensor. Okay, so this is something that I want all of us to know before we discuss about individual disorders, because I will be randomly saying UMN lesion and LMN lesion, and if you don't know the basics, we may be lost there. So with that basics in place, let's talk about the first neuro disease, which is myasthenia gravis. So what is myasthenia gravis? Myasthenia gravis is a disorder of neuromuscular junction. Which neuromuscular junction? Because when we talk about neuromuscular junction, there will be a nerve terminal, and on the other side of the nerve terminal you will have the muscle. So neuromuscular junction has two ends, a nerve end and a muscle end. The nerve end membrane is called as presynaptic membrane, and the muscle end membrane is called as postsynaptic membrane. So normally what happens, whenever we want to contract a muscle, an electrical impulse travels from the brain through UMN, then handed over to LMN, and LMN brings that electrical impulse to the nerve terminal. And whenever that electrical impulse arrives at the nerve terminal, there are dedicated channels which sense this rise in voltage. We call them as voltage gated calcium channels. They open. Whenever an electrical impulse arrives here, the voltage gated calcium channels open, allowing the influx of calcium ions from the extracellular compartment to the nerve terminal. And once these calcium ions enter the nerve terminal, within the nerve terminal we have so many secretory vesicles which contain acetylcholine. The calcium ions help us to break these acetylcholine containing vesicles and release the acetylcholine into the synaptic cleft. So we release these acetylcholine molecules out in response to an electrical impulse coming from the nerve terminal. So these are going to be my acetylcholine molecules. These acetylcholine molecules will bind to their receptors on the muscle membrane, resulting in activation of second messenger system and contraction of the muscle. So we are talking about acetylcholine receptors here, and these are basically nicotinic type of acetylcholine receptors. So whenever we want to contract a muscle, brain has to send a signal has to arrive at the nerve terminal. Voltage gated calcium channels open because voltage of the membrane has increased. Calcium comes in, facilitates rupture and release of acetylcholine. Acetylcholine now binds to its nicotinic receptors and causes the muscle to contract. And once the acetylcholine is done its job, it will be broken down to choline and acetate by enzyme acetylcholine esterase. That is how the muscle contraction ceases. This is basic nerve muscle physiology. Myasthenia gravis is affecting this physiology. In what way? Most likely you are producing antibodies and blocking these acetylcholine receptors. So which side I am affecting? The postsynaptic membrane or presynaptic membrane? Nerve side is presynaptic, muscle side is postsynaptic. So I am affecting the muscle side. That's why myasthenia gravis is considered as a postsynaptic NMJ disorder. It's a postsynaptic neuromuscular junction disorder. Okay. And the nature, why are we developing the postsynaptic NMJ dysfunction here? Because of the antibody production. So you can say it is an autoimmune disorder. It is an autoimmune disorder. And being an autoimmune disorder, you can tell me which gender it is going to be more common. It is more common in females than males. Females than males. Okay. Now if it is an autoimmune disorder, which antibodies we get in these patients? the most common antibody that we get in myasthenia gravis patient is going to be anti-acetylcholine receptor antibody. Okay, this is the most common antibody responsible for more than 85% patients of myasthenia gravis. That's why generally when we say myasthenia gravis, we talk about acetylcholine receptor antibody only. But some patients may have other antibodies instead of acetylcholine receptor antibody. The second most common antibody that we get here is going to be anti-muscle specific kinase or anti-MuSK antibody, encountered in around 10% of patients. 10% of patients. Some patients have even rarer, or as of now you can say least common antibody, which is going to be antibody against lipoprotein 4 receptor like protein, or anti-LRP4 antibodies. They are rare. They account for less than 5% of patients. Now, why should I know the antibody status? Please remember, if you have myasthenia gravis because of anti-acetylcholine receptor antibody, then thymectomy can be curative. Thymectomy is useful. But if you have these antibodies, removing the thymus is of no use. So the thymectomy is reserved for acetylcholine receptor antibody positive myasthenia gravis, right? So please note it down. There is no role of thymectomy when it comes to MuSK or LRP4 antibody myasthenia gravis. But if you have the most common antibody present, then thymectomy has a role. Why thymectomy has a role? Because here the autoimmunity is not actually targeted as at the acetylcholine receptor. The main target is another receptor similar to acetylcholine receptor in structure, which is present on the myoepithelial cells of thymus gland. Myoepithelial cells of the thymus gland. Those are the cells which have shared characteristics of epithelial cell and muscle cell. That's why we call them as myoepithelial cells. They express acetylcholine receptor like proteins, and your autoimmune process is actually targeting those proteins. But because acetylcholine receptor also has structural similarity, it also becomes targeted. But what if I remove the thymus gland? The source of antigen is gone, antibody production declines, and myasthenia gravis can be cured, right? So that's why it's important that we know in these patients thymectomy is useful, and in these two patients no role of thymectomy. There is no role of thymectomy. Now, what symptoms I get in myasthenia gravis? It depends on the sequence of involvement of the muscles. In myasthenia gravis, the most used muscle loses the acetylcholine first and gets affected first. And levator palpebrae superioris, because we are constantly blinking, is the most used muscle. So the first affected muscle is going to be levator palpebrae superioris, and that results in ptosis, making the ptosis as the earliest symptom of myasthenia gravis. After levator palpebrae superioris, you start noticing the involvement of extraocular muscles. The other extraocular muscles means your lateral recti, superior oblique, inferior oblique, they also get affected. And once they get involved, you develop ptosis, because we are constantly moving eyeballs, so they are also being used. The more I use the muscle, more acetylcholine gets pent up, so we lose that muscle's action first. Okay. After the extraocular muscle involvement, you can also have the involvement of bulbar muscles. What do you mean by bulbar muscles? Basically, we are talking about head and neck region muscles, and that can result in difficulty in swallowing, difficulty in speaking, so dysphagia, dysphonia, and dysarthria. After the involvement of bulbar muscles, you may have involvement of proximal muscles, means large muscles in your shoulder and hip region. They become weak. Patients will have difficulty to comb hair, difficulty to shrug the shoulders or lift objects, difficulty to climb stairs. They can develop proximal muscle weakness. After that, there will be involvement of facial muscles, because we regularly use facial muscles for expression, for chewing, right? So because of that, acetylcholine gets used up there and they get affected. And the facial muscle involvement results in drooping of face. And when these patients are asked to give a smile, the face is bilaterally showing drooping, right? It's all drooped. And when you ask them to smile, normally when we smile, the lateral edges of the lip go up. That's a bright smile. But these people will not be able to lift the lateral edges of the lips. Only the philtrum gets lifted, showing the teeth only, right? And that appearance where you are trying to show only teeth, we call it as snarling face or myasthenic smile. Snarling face or myasthenic smile. Snarling is the expression of a dog where it is trying to show the teeth to scare its opponent or enemy. But then today we consider using that word is derogatory. So we have replaced that with myasthenic smile. Okay. After that, the disease may progress to involve respiratory muscles. May progress to involve respiratory muscles, and the respiratory muscle involvement can lead to respiratory paralysis or respiratory failure. And it is one of the causes for death in patients with myasthenia gravis. Now, if the patient presents at a stage where there is only involvement of eye muscles and maybe some degree of bulbar muscles, what should I call it as? We will call that patient as having ocular myasthenia gravis. Ocular myasthenia gravis. But if there is involvement of proximal muscles as well, then I will call that patient as having generalized myasthenia gravis. If the involvement is restricted to eyes, it is ocular myasthenia gravis. But if there is involvement of proximal muscles and other muscles, then it is generalized myasthenia gravis. That is an extremely important point. So all the weaknesses that we are seeing here, right? The ptosis, diplopia, and then the bulbar weakness symptoms, drooping of face, all of these show diurnal variation, because in myasthenia gravis, the repetitive use of the muscle makes you lose acetylcholine and become more weak. Okay. So they will be worsening at the evening. So they show with diurnal variation. Diurnal variation. And when I say diurnal variation, I refer to worsening with advancing day. As the day advances, the weakness goes on worsening. So they have worse evening but relatively better mornings, as opposed to Lambert-Eaton, where the weakness is profound in the morning and it worsens in the evening. So if I have facial weakness because of stroke, or even for that matter Bell's palsy, it will not show diurnal variation. The drooping will stay same in the morning or afternoon or evening. But in case of myasthenia gravis, morning the drooping may not be much noticeable. But as the day progresses, by evening the drooping is much apparent. Morning ptosis may not be noticeable, but by evening ptosis is apparent. Morning they may be able to handle the proximal muscles well. They may be able to lift, take bath, brush, everything. But by evening, even lifting the spoon to eat might become difficult. This diurnal variation is the hallmark of neuromuscular junction disorders. Okay. Now, if on the basis of diurnal variation, ptosis, diplopia, I am suspecting that patient may be having myasthenia gravis, how do I confirm it? For diagnosis, we have sensitive investigations, we have screening tests, and we have specific investigation. The most sensitive investigation is going to be single fiber electromyography. This is an MCQ that has been asked multiple times. What is the most sensitive investigation for diagnosis of myasthenia gravis? It is sensitive but not specific. So you are not going to use it as a confirmatory test. It is more of for initial detection. The most specific investigation is going to be getting the antibody itself, that is anti-acetylcholine receptor antibody. That's the most specific investigation. If they ask you what can be used as a bedside screening test, like if I'm in a remote village and I can't get the single fiber electromyography done or anti-acetylcholine receptor antibodies done, then what can I do? Ice pack test. Ice pack test. So what we do in ice pack test, we apply ice pack to one of the eye which is showing ptosis. And after removing the ice pack after 15 minutes, if the ptosis improves, it indicates that you're dealing with myasthenia gravis. If I had ptosis because of stroke or third cranial nerve palsy, it will not improve. It will stay like that even if you apply ice pack. But if it is due to myasthenia gravis, it improves. So improvement in ptosis after ice pack application indicates that you are having fatigable weakness. So in that case, you think about myasthenia gravis. We should be aware about one more test, which is tensilon test or edrophonium test. Tensilon test or edrophonium test. So what we do in tensilon test or edrophonium test? So in tensilon or edrophonium test, we administer tensilon or edrophonium. What is it? It's an acetylcholine esterase inhibitor. So whenever we inhibit acetylcholine esterase, the acetylcholine concentration in the nerve terminal increases. So whatever little receptors which are unbound by the antibodies, you will be able to recruit them with increasing acetylcholine. Thus you will be able to achieve the muscle contraction. Right. So by increasing acetylcholine, if the ptosis improves, that means the problem was myasthenia gravis. But if stroke or cranial palsies are reason for the ptosis, then it will not improve upon administration of edrophonium, right? So if ptosis improves, it indicates that you have myasthenia gravis, but it is not routinely performed. Why is it not routinely performed? The reason is increased risk of due to increased risk of cholinergic crisis, because we are trying to increase the acetylcholine, and acetylcholine, when we give this edrophonium or tensilon, it's not selectively increasing the acetylcholine in the neuromuscular junction. It is going to increase in every other location. So you can end up with cholinergic crisis, and I don't want the patients to experience that. That's why, because we have much safer tests like single fiber electromyography, antibody test, ice pack and all, we avoid doing this tensilon test or edrophonium test. Yes, if you have myasthenia gravis patients, we should also think about doing a CT chest, especially if it is anti-acetylcholine receptor antibody positive cases, because invariably they will have some thymic abnormalities, and to plan for and to think about thymectomy, you have to go for understanding the status of the thymus gland. So we have to go for a CT chest, mainly focused on the mediastinum. So this is about the investigation. Extra point, what do I get in case of myasthenia gravis if I do single fiber electromyography or repetitive nerve stimulation test? So in case of myasthenia gravis, you will get something called as decremental response, because the more you stimulate the muscle, its force of contraction goes on decreasing. Decremental response, or it can also be called as increasing jitter, because the contractions start becoming less and less stronger the more you keep stimulating it. So it becomes jittery rather than a proper contraction. Increasing jitter or decremental response. But in case of Lambert-Eaton syndrome, the more I use the muscle, the more stronger it becomes. So you get increasing force of contraction. So you call it as incremental response. Incremental response, or indirectly you can say the first stimulus you gave did not cause the contraction, it was a jitter, but the second it will start contracting, next it will give a better contraction, next it will give better contraction. So you can say decreasing jitter or incremental response. So they have asked questions about interpretation of the single fiber electromyography or repetitive nerve stimulation test in myasthenia gravis and Lambert-Eaton, so just be aware about. Now coming to the management of myasthenia gravis. First thing I have to understand is, yeah, we'll add a small note on the Lambert-Eaton syndrome. When I'm dealing with myasthenia gravis patient, I should see whether I am in crisis situation or whether I'm having a stable myasthenia gravis or stable myasthenia gravis. If when do I say you are in crisis? If the myasthenia gravis has involved the respiratory muscles. So myasthenia gravis with respiratory failure is called as myasthenic crisis. All other cases will be called as stable myasthenia gravis. So if I'm having stable myasthenia gravis, my goal is to increase the acetylcholine and decrease the antibodies. So how will I increase the acetylcholine? Acetylcholine can be increased by using acetylcholine esterase inhibitors, and the drug of choice here is going to be pyridostigmine, because it is long acting, so I don't have to give an acetylcholine esterase inhibitor every 10-15 minutes. I would prefer using pyridostigmine. and to decrease antibody production. What all I can do? To decrease antibody production, one thing I can do is I can think about thymectomy, because the source of antigen in many patients is going to be thymus gland. Second, I can think about steroids and immunosuppressants, which reduce beta cell activity, and thus antibody production can come down. Now, thymectomy is not for everyone. As I've already told you, only those who have acetylcholine receptor antibody positivity, they will be benefited, right? So thymectomy is done under two circumstances. One, if there is thymoma. Now, if there is thymoma, whether they have myasthenia gravis or not doesn't matter. It's a malignant tumor most often, and it is aggressive. It is there in the mediastinum. It can compress vital structures, so it has to be removed. Second, anti-acetylcholine receptor positive myasthenia gravis, aged less than 55 years. Because this is a major surgery and the mortality rates associated with surgery are high, so we are choosing those who are reasonably fit to undergo the surgery. If they are 55 plus, then instead of pushing them through surgery and running the risk of losing the patient on the table itself, we'll try to manage by giving steroids and immunosuppressants. Okay, so please be aware about the indications for thymectomy. Any patient with thymoma, with or without myasthenia gravis, and patients with myasthenia gravis who are having anti-acetylcholine receptor antibody positive and they are aged less than 55 years. This is management of stable myasthenia gravis. For those who are in crisis, the first step is they are not able to breathe well because their respiratory muscles are weak. If I let them be like that, they will die soon. So first thing is put them on mechanical ventilator. They need a ventilatory support. Second, I want to bring down the antibodies as quick as possible, and that is possible by doing either plasma exchange or giving IV immunoglobulins. Plasma exchange will remove the antibodies, or IV immunoglobulins will neutralize the antibodies. This is going to be the management for the myasthenic crisis. Okay. Now a short note on the Lambert-Eaton syndrome. Unlike the myasthenia gravis, Lambert-Eaton syndrome is not an autoimmune disorder. It is more of a paraneoplastic syndrome. Means here the source of antibodies need not be your immune system, but rather the cancer cells. That's why we call it as a paraneoplastic syndrome. Now, if it is a paraneoplastic syndrome, which cancer is most commonly responsible? The most common cancer associated with Lambert-Eaton syndrome is going to be small cell lung cancer. Small cell lung cancer. Okay. Then third, which antibody we get here? We get antibodies targeted at voltage gated calcium channels. So making this a presynaptic NMJ disorder, presynaptic neuromuscular junction disorder. Okay. Now here for a diagnosis, if I do single fiber electromyography or repetitive nerve stimulation test, I will notice incremental response or a decreasing jitter. Because in Lambert-Eaton syndrome, the more I use the muscle, more stronger it becomes. So morning they are very weak, but by evening, because they are repetitively using the muscles, they feel more energetic or more comfortable in the evening. Okay, when it comes to management, the mainstay of treatment is going to be treat the underlying cause, which is mostly a cancer. Okay, apart from that, use of a drug called aminopyridine. Aminopyridine can be useful. It increases the it is a potassium blocker which increases the voltage of the nerve terminal, and by increasing the voltage of the nerve terminal, you will be able to keep the voltage gated calcium channels open so that more calcium can come in and you can release more acetylcholine. Okay, so this is about your basic myasthenia gravis and Lambert-Eaton syndrome. Next up we have GB syndrome. Okay, now what is GB syndrome? GB syndrome is similar to rheumatic fever. It's an infection triggered autoimmune disorder. Okay, it's an infection triggered autoimmune disorder. But what is it targeting? The rheumatic fever was targeting multiple organs. It was affecting heart, causing pancarditis and valvulitis. It was affecting the brain, mainly the caudate nucleus, producing Sydenham's chorea. It was also affecting joints, producing migratory polyarthritis. But this GB syndrome is primarily a single organ disease. It's an infection triggered autoimmune disorder affecting the peripheral nerves. So it is an autoimmune polyneuropathy state. Polyneuropathy. And when we talk about polyneuropathy, means we are talking about peripheral nerves. Peripheral nerves contain, remember, lower motor neurons. So when we talk about GB syndrome, we are talking about lower motor neuron lesion. Okay. So the first question is, which infection is usually responsible? Generally, GIT infections are more commonly responsible than respiratory infections. Okay. And when we are talking about GIT infections, again, the most common GIT infection that has been implicated in causing GB syndrome is going to be Campylobacter jejuni dysentery. Campylobacter jejuni dysentery. So basically what happens is you get this Campylobacter jejuni infection. It causes dysentery generally. So it invades the intestinal epithelium and tissues. Body recognizes it and produces antibodies against Campylobacter jejuni cell components. And similar to rheumatic fever, because of the molecular mimicry, these antibodies start targeting various components in your peripheral nerves. That's how the peripheral nerves become affected. Okay. And when peripheral nerves, multiple of them get affected, usually the longest neurons, means the neurons which are having the longest journey, get affected first, then the next longest, then the next longest. And because the longest neurons are traveling from the spinal cord to distal body parts like hands and feet, distal parts get affected first, followed by next distal, creating a perception of ascending paralysis. The patients present with rapidly progressing ascending paralysis after acute GE. Okay. And because in the peripheral nerves, you are mainly targeting lower motor neurons. When you check their muscle tone and reflexes, what do you expect? All the affected muscles will show decreased tone or flaccidity because LMN is affected. Plus, they will also show decreased or absent reflexes, hypo or areflexia. So any MCQ which talks about rapidly progressing ascending paralysis with flaccidity and hypo or areflexia is talking about GB syndrome in all probability. Okay. Few extra points to note here from which MCQs are being asked repeatedly. Yeah, I'll talk about the Aman and the brainstem encephalitis as well. So ascending paralysis that we are getting here, generally the progression of the disease lasts less than 4 weeks. Means once I had, let us say, the Campylobacter jejuni dysentery, and after that 2 weeks later I start noticing weakness in my feet. I'm not able to move the feet muscles. Then leg muscles become weak. Then I might start noticing thigh muscles becoming weak, maybe distal upper limb muscles, hand muscles and forearm muscles becoming weak. I'll have difficulty to grip things. So there is an ascending paralysis evolving. If I noticed weakness in the feet muscles in week 1, maybe week 2 I might notice in the leg muscles, maybe week 3 in the thigh muscles, maybe week 4 somewhere in the abdominal muscles. But after 4 weeks, the new areas will not become weak. The progression won't last beyond 4 weeks if it is a typical case of GB syndrome. The point to note here is, if progression lasts more than 4 weeks, think about another polyneuropathy condition called as chronic inflammatory demyelinating polyneuropathy or CIDP. And if it is more than 8 weeks, progression lasting more than 8 weeks, you're not only thinking about, you are almost making the diagnosis, right? It is highly suggestive of CIDP. So if I noticed weakness 2 months ago and after 2 months also new areas are being affected by weakness, right? Every week I'm getting new areas being affected, the weakness is progressing, then it is not GB syndrome. You're dealing with CIDP, right? They've asked this MCQ, so please remember this. Okay. Now, if I have to diagnose the GB syndrome, clinically, we are dealing with this rapidly progressing ascending paralysis, flaccidity and hyporeflexia. I need a little bit of support from laboratory. So, two investigations are helpful here. The first one is going to be CSF analysis, and the second one is going to be nerve conduction studies. Nerve conduction studies. So, when you do CSF analysis, in the typical cases of GB syndrome, because you're producing antibodies which are causing the damage to the peripheral nerves, these antibodies also find their way into the CSF. So, antibodies are what chemically? Antibodies are immunoglobulins, they are proteins. To be very frank, they are IgG class proteins. So, in the CSF, proteins increase, but because there is no major role of cell mediated immunity here, the cell count doesn't increase. Normally, if I have meningitis or encephalitis or meningoencephalitis, protein and cell count both increase. Now, depending on the cause for meningitis or meningoencephalitis, if it is bacterial, neutrophils increase predominantly. If it is fungal, viral or tubercular, lymphocytes increase predominantly, but cell count and protein both increase. But here I am seeing only increase in protein and not much of increase in CSF cell count, minimal or no increase. And collectively these changes, we will call them as albumino. Albumin here refers to protein. Cytology refers to cell count. Albuminocytological dissociation. They are divorced. Normally protein and cell count go hand in hand, but here they are divorced. Only protein is increasing, cell count is not increasing. Okay. And when you do nerve conduction studies, you will clearly see the evidence of either demyelination or injury to the axons. Either you get demyelination or axonal injury. And in fact, based on the nerve conduction study itself, we have classified the GB syndrome into different types. So, what are the subtypes of GB syndrome that we need to be aware about? The basis for this classification is the nerve conduction study results. So, when you do nerve conduction study, you will notice some patients of GB syndrome have purely demyelinating injury to the nerves, because whatever antibody their body is producing, the target antigens are there on the myelin sheath. So, that's why you're targeting myelin sheath, you're causing demyelination, and we call that type as AIDP, acute inflammatory demyelinating polyneuropathy. And this AIDP is the most common type. This is the most common type. How common it is? It accounts for more than 85%. And what type of nerve injury is there? It is there in the name itself, demyelinating type of polyneuropathy. Is demyelinating type of polyneuropathy. In these patients, you will have both motor plus sensory symptoms. You are not only developing ascending paralysis, you might also have mild ascending sensory loss. Okay. And what is the most common antibody that is actually responsible for demyelination? It is going to be anti-ganglioside M1 antibodies. Okay. Then some patients of GB syndrome will develop axonal injury. We call that as acute motor axonal neuropathy. And some will have not just the motor but also sensory. So, in that case, we will call it as AMSAN, acute motor and sensory axonal neuropathy. So, the nature of injury is there in the name of the disease itself, axonal injury. You are not causing the injury to the myelin, you are causing the injury to the axons. Okay. So, this is not as common as AIDP. You can say these are second most common in comparison to AIDP, where you have axonal injury. Axonal injury. Now, which antibody we get in these patients? The antibody that we get in these patients is anti-ganglioside D1A, anti-GD1A antibodies. Anti-GD1A antibodies. How do I get to know that these patients have axonal injury? By doing the nerve conduction study. Okay. There can be an MCQ asking you which of this GB syndrome variant is a pure motor variant. In AIDP, motor and sensory both nerves are getting affected in the peripheral nerves. But in case of AMAN, it's only motor neurons which are being affected. In AMSAN, motor plus sensory both are affected. If they ask you which is a pure motor variant of GB syndrome, then your answer is going to be Aman. Aman is the pure motor variant. This is an important MCQ point. Okay. Now, in terms of prognosis, which one carries poor prognosis? When you cause demyelination, remyelination is easier. So prognosis is reasonably better. But when you cause axonal injury, regeneration of injured axons is difficult. So prognosis is poor in case of Aman and Amsan. So these carry poor prognosis, while AIDP patients carry reasonably good prognosis in comparison to Aman and Amsan. Okay. Last year we had a localized outbreak of GB syndrome reported from Pune, and in that outbreak, most patients were Aman variants rather than AIDP. Otherwise, overall most common is AIDP, but in the last Pune outbreak, the common cases were Aman rather than AIDP. Okay, then we should also be aware about a third variant, which is peculiar, which is called as Miller-Fisher syndrome. What is it called? Miller-Fisher syndrome, or MFS. Now, the peculiarity of Miller-Fisher syndrome is that here the antibodies produced, this is also predominantly demyelination variant, some degree of axonal injury can occur, but clinically as a phenotype it is totally different. Here the antibodies that we are producing are anti-ganglioside Q1, GQ1 antibodies, anti-GQ1 antibodies, and these antibodies target mainly sensory neurons because the ganglioside Q1 is expressed predominantly over the sensory neurons. So here you have sensory predominant GB syndrome. AIDP is affecting both motor and sensory. Aman is pure motor. Amsan again sensory and motor. But here predominantly sensory, barely any motor involvement. And being predominantly sensory, you're losing the sensations. And when you lose sensations, what symptoms it can lead to? It can lead to sensory ataxia. Because the proprioception is required for our brain to sense the position and help you maintain the balance. Apart from your vision, cerebellum, proprioception is important. And when I lose the sensation, proprioceptive information is not coming to the brain, so I start developing ataxia. Okay. Apart from ataxia, these patients will also have ophthalmoplegia. Ophthalmoplegia. Okay. There will be minimal or no motor weakness. Now tell me, what will be the prognosis of these patients? I would rate them as having good prognosis. Why? Because patients of GB syndrome die when the respiratory muscles become paralyzed. When there is no major motor involvement, then my death risk is less. So patients with Miller-Fisher syndrome carry good prognosis. Okay, so this is about the subtypes of GB syndrome. There is a very rare subtype called as Bickerstaff encephalomyelitis. What is it called as? Shashikiran, yes, absolutely right. Because in AIDP and Amsan, there is involvement of sensory as well as motor. Okay, and in case of the AIDP, there is predominantly motor. In case of Aman, there is pure motor. In all those cases where there is motor involvement, the motor control of the external sphincters of your bowel and bladder will also be affected. So they can have incontinence, but because in all these polyneuropathy conditions, the longest neurons get affected first, and the nerves supplying the external sphincters are having a very short journey from the sacral plexus to the sphincters, so they get affected quite late. So yes, there can be involvement of bowel and bladder, but it is a late manifestation. Okay, so I was talking about this rare variant which is called as Bickerstaff encephalomyelitis. Bickerstaff encephalomyelitis. Where there is involvement of even CNS. So apart from the peripheral nervous system, GB syndrome is purely a peripheral nervous system disorder, but there is CNS involvement also present. It is there in the name, right? Encephalomyelitis. Myel means spinal cord, encephal means cerebrum. Both are part of CNS. If there is CNS involvement, it is called as Bickerstaff encephalomyelitis, and this carries the worst prognosis of all. It carries worst prognosis of all. Okay, this is about the basic classification of different types of GB syndrome. Now let's try to understand, once I have diagnosed, how do I manage? I forgot to mention the name of the diagnostic criteria that we are following here, which is called as Brigden's criteria. Called as Brigden's criteria. So 5 criteria is listed here. Depending on how many are present in a patient, you can have various levels of diagnosis. But for an undergraduate student, all of that is not required. Just be aware that what all we need. We need to have rapidly progressing ascending paralysis, hypotonia or flaccidity, and hyporeflexia. CSF should show albuminocytological dissociation, or nerve conduction study should show demyelination or axonal injury. If it is showing demyelination, we are mainly thinking about AIDP. It is showing axonal injury, you are thinking about AMAN or AMSAN. If there is ataxia also, you think about Miller-Fisher syndrome, and not much of motor weakness, you strongly think about Miller-Fisher syndrome. And if patient has seizures or coma, then you think about Bickerstaff encephalomyelitis. Now when it comes to management, what is causing the damage to the nerves? All these antibodies, anti-GM1, anti-GD1, anti-GQ1, these antibodies. If I remove the antibodies from the patient's body, then further ongoing injury will stop. And whatever injury we have caused, slowly there will be recovery from it. So my goal is to remove the antibodies from the patient's body. So how do I remove? We can remove it by either going ahead with plasma exchange or IV immunoglobulins Yeah, see, cranial nerves are also part of the peripheral nervous system, so they can also be affected. You can have the involvement of 7th as well as 3rd, sometimes even the 6th cranial nerve in case of GB syndrome. The most commonly affected is, yes, 7th cranial nerve. So that completes our discussion on GB syndrome. Now let's talk about the stroke. Okay, so what is stroke? Stroke is actually a focal or global neurological deficit which is arising out of a vascular pathology, right? Stroke is neurodeficits due to vascular pathology. And when I say vascular pathology, what can go wrong with the blood vessel? Either you can have a blocked blood vessel resulting in reduced blood supply. In that case, whatever stroke results, we'll call it as ischemic stroke. Or a blood vessel can rupture and bleed. In that case, we will call it as hemorrhagic stroke. Hemorrhagic stroke. Okay, but you will, by older definition, you will label it as stroke when the neurodeficits persist for 24 hours. Okay, that's an older definition, and I have seen the trend that the examiner still asks questions based on the older definition. So we should be fairly aware that the traditional definition of stroke is where you have neurodeficits persisting for more than or equal to for more than 24 hours or till death of the patient. The modern definitions have foregone that definition, because in the modern definition, if you find infarct, even if the symptoms do not last for 24 hours, we will still call it as stroke. We don't label it as not a stroke anymore. Okay. Now, in the hemorrhagic stroke, we include subarachnoid hemorrhage. Okay. But we do not consider, we also include intraparenchymal hemorrhage, bleeding into the brain tissue or subarachnoid space. But your subdural hemorrhage and epidural hemorrhage are not considered as stroke, because the cause for subarachnoid hemorrhage, most commonly non-traumatic we are talking about, is because of the rupture of berry aneurysms, which is a pathology of the blood vessel, and intraparenchymal hemorrhage is most commonly because of hypertensive rupture of the blood vessel, which is again a pathology of the blood vessel. So it satisfies the traditional definition of stroke. But subdural and epidural are usually because of trauma. So vascular pathology is not there. That's why we don't count them as stroke. Okay. Now there comes the concept of transient ischemic attack. So what is TIA? TIA refers to neurodeficits lasting for less than 24 hours. with no evidence of infarct. No evidence of infarct. If there is an evidence of an infarct present, even if the symptoms last for less than 24 hours, we will count it as stroke. Okay, so even if symptoms resolve within 24 hours, it is a case of stroke. It is not TIA. To call it as TIA, two things should be there. Patient should develop some neurological deficits, like he's not able to move one limb or one side of the face or one side of the body, whatever. Those neurodeficits should resolve within 24 hours. And when you image, do CT or MRI, you don't find an infarct. To find an infarct, even if symptoms have completely resolved within 24 hours, it is still a case of stroke. Okay. Now, if you have TIA, that means you already have high risk of developing stroke, because randomly someone does not develop neurodeficits, right? So if you had TIA, it means you have high risk of frank or overt stroke occurring in near future. In fact, today's understanding of the stroke pathophysiology is like transient ischemic attack is nothing but a stroke which is still evolving. A lot of patients who present with frank stroke would have experienced many episodes of transient ischemic attacks in last 24 hours. They might have gone through 5-6 episodes of TIA, and then finally they develop stroke. So TIA is a strong risk factor for stroke. And in the exam, they will ask you, can we assess the stroke risk in a TIA patient? Yes, we can assess the stroke risk in a TIA patient using ABCD2 score. Now, ABCD2 score in itself is a mnemonic. In itself, it is a mnemonic where A stands for age more than 60 years or equal to 60 years, we give 1 point to the patient. B stands for blood pressure more than or equal to 140/80, we give 1 point to the patient. If there are clinical features of unilateral weakness, C for clinical features, unilateral weakness, monoplegia or hemiplegia, 2 points. But if there is no weakness, you only have speech impairment, then we give 1 point. And then we also look at the duration of symptoms. So there are 2 D's here. One is duration of symptoms and the second one is diabetes. How long the symptoms lasted for the TIA. If they lasted for more than 60 minutes, 2 points. And if they lasted anywhere between 10 to 59 minutes, means symptoms resolved quickly, then 1 point. If they resolved within 10 minutes, 0 points. And if patient is diabetic, 1 point. So cumulatively, maximum possible points are 7. And there are 2 areas where we have given 2 points. One is duration of symptoms lasting for unilateral weakness, that is 2 points, and duration of symptoms lasting for more than 60 minutes, 2 points. There are 2 D's in the score. One is duration, the other one is diabetes. Okay. Now, if the score is 6 or 7, they have very high risk of developing stroke in the near future. Okay. Almost close to 10% patients develop stroke within next 3 months. While if I had TIA, but my ABCD2 score is 3 or less than 3, 1, 2 or 3 or 0. In that case, I have very low risk of developing stroke in the near future. Next 2 days, low risk. Overall, in next 3 months, only 1% of such patients develop stroke. We can use ABCD2 score to predict the risk of stroke in patients who had TIA. What questions they will ask? They will ask you the components of the ABCD2 score and when do you consider it as high risk for stroke. Okay, so having said that, let's talk about the early recognition of stroke, because in neurology we always say time is brain, because when you are especially going through ischemic stroke, every passing time leads to every passing minute you are losing more and more number of neurons to ischemia, and the lost neurons cannot be recovered. So all you can do is halt the progression of ischemia and save the neurons which are not dead yet, and that's why time becomes crucial. Time is brain, so early recognition is important. How do I recognize a stroke early? There are 2 things. The first one, you can recognize the stroke, like me as a doctor might recognize stroke in 1 minute, but it is the patient or the patient family members who have to recognize stroke early. If they present 24 hours after the onset of stroke, there's nothing that the doctor can do even if he recognizes it in 30 seconds. So early recognition for laymen, that is patients and patient attenders, and for clinicians, for both of us it is important. Laymen can recognize the stroke early with the help of an algorithm called as B fast. You should instruct all the patients who are having diabetes, hypertension, dyslipidemia, atrial fibrillation, who are all at risk of stroke, to be aware of B fast algorithm, where B stands for balance issues, E stands for eyesight issues, F stands for facial weakness, facial drooping or weakness of the face. Then A stands for arm weakness. S stands for speech impairment. If the patient notices any of these changes, balance issues, eyesight issues, facial drooping or arm weakness or speech issues, without wasting time, T stands for time, they should rush to the hospital. Okay. Once the patient comes to the hospital, instead of spending 1 hour trying to examine which all muscles, which all nerves are showing the evidence of weakness, we can subject them for something called as Barry's sign or pronator drift sign. Barry's sign is also called as pronator drift sign. It is the earliest sign of stroke. Of course, if there is no motor involvement, this sign will not be there. But most of the strokes are motor strokes. And in that case, you will be able to detect this pronator drift sign. This is the earliest sign of stroke, also called as the subtle sign of motor stroke. All you have to do is ask the patient to hold his hands outstretched like this in supine position. If one side is weak, that side starts drifting down. He will have difficulty to keep it elevated, and then it starts pronating. That is why we call it as drift and pronate. Pronator drift sign. Both of them can be image based questions, right? So they can give this picture and ask what is this algorithm used for. It is for early detection of stroke by patients and their family members. And they can give an image where patient is having outstretched hands like this, or one side is already pronated and drifting. That is Barry's sign or pronator drift sign. It is used for early recognition of motor stroke by clinicians. Once you have recognized, you know you have stroke, but you don't know whether it is ischemic or hemorrhagic, and the management is going to be poles apart. If I treat a hemorrhagic stroke with the ischemic stroke protocol, I will worsen the hemorrhage and literally kill the patient. So I need to know now whether I am having ischemic stroke or hemorrhagic stroke. So what investigation I can do to identify whether I have ischemic or hemorrhagic stroke? Well, the investigation that we will be preferring is CT scan of the brain, non-contrast. Truth is, CT scan does not detect infarct before 6 hours. It takes more than 6 hours for the infarct to be evident on the CT scan. Sometimes the blocked blood vessel may be visible on the CT scan before 6 hours as dense artery sign, but then that's a rare occurrence. Then why are we using CT scan when we know it's not going to show any change within 6 hours? Because we have one question. We want to know whether it is ischemic stroke or hemorrhagic. As long as the investigation gives me the answer, I'm content. I don't have an itch to see an infarct. If it tells that it is ischemic or hemorrhagic, it's more than enough. And non-contrast CT can do the job. So whenever you are having a suspected stroke, we go for non-contrast CT. Non-contrast CT is highly sensitive for detection of bleed. It doesn't miss the bleed easily. So if non-contrast CT shows that there is bleed, then you are having hemorrhagic stroke. Hemorrhagic stroke. But if the non-contrast CT says that there is no bleed, if there is no bleed, then it rules out hemorrhagic stroke and you're left with ischemic stroke. It's as simple as that. Ischemic stroke. But because today we have more advanced treatments available for the stroke, in most centers, along with non-contrast CT, if feasible, you also get a CT angio done. CT angio done. That will help us managing the cases better later. For initial recognition, whether it is ischemic or hemorrhagic, I don't need to do a CT angio. But if you have the facility, get it done in the same sitting. Okay. Once we know that it is ischemic stroke, let's see how are we going to manage an ischemic stroke. Management of ischemic stroke. The point to note here is whenever a particular blood vessel gets blocked, some part of the brain gets affected by it, right? So there will be an area that might become infarcted. Okay. The core is generally infarct, and the surrounding area, the neurons are not dead, but they are also not getting sufficient blood supply, so they have stopped functioning. This area is called as penumbra, ischemic penumbra or simply penumbra. So when you see a patient of stroke, the clinical features you see are combination of both, because infarcted area is not working, penumbra area is also not working. So let us just to give you an example, let us say he has developed infarct involving the motor area, okay, and the Broca's area is in penumbra. Broca's area is still getting some blood supply, so it is alive but not working. The patient's symptoms will be hemiplegia plus Broca's aphasia. Now if I relieve this block, the blood flow will be re-established, but infarct cannot be recovered because it's already gone. But this penumbra can be recovered. Once I re-establish the blood flow, penumbra will start functioning again. So the outcome is patient will continue to be hemiplegic, but the Broca's aphasia will resolve. So can I say the goal of treatment is mainly to save the penumbra. And what we know so far is that once the blood vessel is blocked, slowly infarct core starts expanding. And by the time 24 hours are over, the entire penumbra also becomes infarcted. So after 24 hours, you don't have much hope because nothing is there, no penumbra is there. So even if I open this blood vessel and re-establish the blood flow, I don't get any functional improvement. A patient came with Broca's aphasia and hemiplegia, he will go home with Broca's aphasia and hemiplegia. That's why the ideal time for treatment is within 24 hours of the onset of symptoms, right? So that's why when I get an ischemic stroke patient, what really matters is time since onset of stroke. If it is after 24 hours, then everything is infarct, no penumbra, so you can't do much about this stroke. All you can do is offer them secondary prevention. Like further episodes of stroke can be prevented by giving you aspirin plus statins, so that we are trying to minimize another risk of another episode of stroke from occurring, but this stroke cannot be treated. Okay, but if they present within 24 hours, you may have some penumbra, so I have a choice of offering the treatment. Okay, so now within 24 hours, let us divide that within 24 hours into 3 segments. If they present within 4.5 hours of onset, okay, 4.5 to 9 hours of onset and 9 hours to 24 hours of onset. Okay, after 24 hours, anyway, nothing to do. If they present within 24 hours, there is a window of opportunity to treat. A blocked blood vessel can be opened by 2 ways. One, you can give a medication to dissolve it. In that case, you call it as thrombolysis or intravascular thrombolysis, right? IV thrombolysis, intravenous thrombolysis. Or you can put a guide wire, catch hold of the clot and retrieve it, pull it out. In that case, you call it as endovascular therapy. You are literally getting into the blood vessel to retrieve the clot. So we call it as endovascular therapy. It can also be called as thrombectomy because you are removing the thrombus. Okay. Now what we know so far, your IV thrombolysis is suitable for up to 9 hours of the onset of stroke, while the thrombectomy or endovascular thrombectomy can be done up to 24 hours. Now what should I do for a patient who has presented within 4.5 hours? Should I go for IV thrombolysis or should I go for EVT? The current guidelines recommend to do both. Do whatever the patient is eligible for. If they're eligible for both, do both. If they're eligible for only one, do whichever they're eligible. Like if the patient presents after 9 hours, he's not eligible for IV thrombolysis, only EVT, so do only EVT. Okay. If they present before 9 hours, they are eligible for both EVT as well as IVT, so do both. Okay. Now traditionally, if they have presented within 4.5 hours, right, just be aware of the current protocol. If they have presented within 4.5 hours, we are very sure that there will be a small infarct core and a large penumbra. So directly jumping into the thrombolysis makes huge sense, right? If they are presented within 4.5 hours, you will directly jump into thrombolysis. You will go ahead with IV thrombolysis. And if they present between 4.5 to 9 hours, it is called as an extended window for thrombolysis. This less than 4.5 hours is the standard window for thrombolysis. Standard window for IV thrombolysis. This 4.5 to 9 hours is considered as extended window. Means you can consider thrombolysis here only under certain circumstances. Now, what are those circumstances? If you have the evidence that there is still a salvageable penumbra present, then you go for thrombolysis. If you don't have the evidence of the penumbra being present, then there is no need for thrombolysis, because if there is no penumbra, then why should I open the blocked blood vessel? But how will I get to know the penumbra present or not? I have to go for CT or MR perfusion imaging. Perfusion imaging. So if the CT or MR perfusion imaging shows that there is penumbra present, then you go for IV thrombolysis. Then you do IV thrombolysis. If there is no penumbra, then patient is not eligible for IV thrombolysis, so you are not doing IV thrombolysis. Not eligible for IV thrombolysis. Okay. Then so I have to also address, I told you that if they are eligible for both IV thrombolysis and EVT, will do both, right? So then I should know the eligibility for EVT as well. Eligibility for IV thrombolysis was simple. If they present within 4.5 hours of ischemic stroke, they are definitely eligible. Between 4.5 to 9 hours, they are eligible for IV thrombolysis if the CT or MR perfusion imaging shows that there is a penumbra present. No penumbra, no eligibility. After 9 hours, they are definitely not eligible. Okay, so eligibility for EVT is basically having ischemic stroke presenting within 24 hours. Second, there should be a large vessel occlusion, because we can't put the wire into small blood vessels and retrieve the clot from there. So only larger vessel clots can be removed through EVT. So what can be considered as large vessel occlusion? The M1 segment of MCA occlusion. Nowadays M2 is also being done, but as an undergraduate student, just remember M1 segment, proximal ACA and proximal basilar artery. If these are occluded, then EVT is possible. Okay. Then within 24 hours also, remember, if the patient has presented within 6 hours, okay, then you directly go ahead with EVT. But if they are presented anywhere between 6 to 24 hours, you need the evidence of presence of penumbra. So only if CT perfusion or MR perfusion imaging shows penumbra present, they become eligible. They become eligible. Okay. So now when you get a question, how will I decide what should I do? First, think for IV thrombolysis. Is the patient eligible? What makes him eligible? If they are presented within 4.5 hours, they are definitely eligible. If they are presented after 4.5 hours, up to 9 hours, they are still eligible, provided CT or MR perfusion imaging shows there is a penumbra present. After 9 hours, they are not eligible. So first decide about IV thrombolysis. Eligible? We are going ahead with that. After that, decide about the EVT, whether they are eligible or not. If they are presented after 24 hours, they are not certainly eligible. But if they are presented within 24 hours, they are eligible. Within that 24 hours, if they are presented within 6 hours time frame, they are eligible directly without proof of penumbra, provided the block is there in a large blood vessel. If they present after 6 hours up to 24 hours, they may be considered eligible, provided there is a penumbra present for saving. No penumbra, no need for doing any intervention. Right? So on that basis, you can decide whether a particular patient is fit or not. Okay. So now let me give you a question, and we'll see how do we judge such questions. So we had a 68-year-old male patient presenting with right hemiplegia and Broca's aphasia 6 hours after onset of symptoms. So CT brain non-contrast, no bleed. So we know it is not a hemorrhagic stroke, it is certainly an ischemic stroke. Second, we have done CT angio, which shows M1 segment of MCA occlusion. Okay, I forgot to mention, in the proximal vessels, we have also included the internal carotid artery. Of course, that is easy to reach, right? Easily we can retrieve a clot from internal carotid artery. Here we are seeing an occlusion in the M1 segment of MCA. Okay. And the CT perfusion imaging shows there is presence of large penumbra. So now tell me what all management will do for this patient. Is he eligible for IV thrombolysis? Is he eligible for EVT? If they are eligible for both, we are going for both. If eligible for only one, we are going for only one. Okay, first let's talk about IV thrombolysis. Patient is presented 6 hours after the onset of symptoms. He is outside the standard window, but still within the extended window. But in the extended window, we decide the eligibility for IV thrombolysis based on CT or MR perfusion imaging. And here in this question, the CT perfusion imaging is showing that there is a large penumbra present. That means he is still eligible for IV thrombolysis. So we are definitely going ahead with IV thrombolysis. The first thing I will do for this patient is do IV thrombolysis. Because IV thrombolysis today with the Denic triplets is just one push, right? Just push it, done. After that, I will also decide about EV thrombolysis, endovascular thrombectomy. Is he eligible for it? What makes him eligible for the endovascular thrombectomy? He should have presented within 24 hours. There should be a large vessel occlusion. So he has certainly presented within 24 hours. And there is a M1 segment MCA occlusion, so large vessel occlusion is present, right? So in that case, he seems to be eligible for endovascular thrombectomy as well. With respect to time, he has presented 6 hours after the onset of symptoms. If he had presented within 6 hours, I don't need evidence of penumbra. We know some penumbra will be there and we directly go ahead with EVT. But 6 hours or later, we might need the evidence for penumbra, which is there here, right? Because large penumbra evidence is there. That makes him eligible for EVT as well. So he is eligible for both EVT as well as IV thrombolysis. So in that case, my treatment will be administer IV thrombolytic agent followed by taking the patient to the cath lab for endovascular thrombectomy. If your IV thrombolysis was highly effective, then nothing will be left to retrieve during the EVT. If it was not highly effective, there will be some clot that you can retrieve in the EVT, right? So this is how we are going to manage cases of stroke. Few extra point about the thrombolysis. Okay. So what are the extra points about thrombolysis? So if we are dealing with wake up stroke, because we don't know when the stroke occurred. One way we can deal with wake up stroke is like patient goes to sleep, he was normal, and then he wakes up in the morning with stroke. One less known hack is to believe that the stroke happened somewhere in the middle of him going to sleep and then morning someone recognizing him as having stroke. But that's a crude method. The best method is, if you're having a wake up stroke, do a diffusion weighted imaging and flare sequence. If you're dealing with wake up stroke, do a diffusion weighted imaging and flare sequence. And if there is a mismatch present, now what do you mean by mismatch? Diffusion weighted image shows infarct is there, okay, but flare changes are not there yet. Flare changes usually appear 6 hours or little more after the onset of infarct. So if you're seeing an infarct but flare changes are not there, that means you can presume that this is suggestive of stroke of less than 6 hours duration. So in that case, the patient is well within the window period, extended window period for the thrombolysis. So you can consider for thrombolysis these patients. But if there is no mismatch, that means the stroke is reasonably more than 6 hours in duration. So probably they are outside the window period for thrombolysis, most likely. So in that case, you can avoid thinking about thrombolysis, rather evaluate for EVT alone. But if there is a mismatch, you can confidently go ahead and do thrombolysis. Okay, so that's about the stroke. Now let's talk about the agents used for IV thrombolysis, because they are asking the dose questions related to the dose. So there are two agents which are approved by the US FDA for IV thrombolysis. The first one, something that we know from long time, that is Altiplase, and the new one is Tenecteplase. Altiplase, the advantage is it is less costlier than Tenecteplase. The disadvantage is it needs to be administered in a multi-stage process. First, we have to calculate the total dose. The total dose is going to be 0.9 milligrams per kg, and the maximum dose, even if your weight based dose calculation says it is more than 100, the max we give is only 100 milligrams. And out of the total dose, 10% is given as IV bolus, just push 10%, and then remaining 90% is given as infusion over 1 hour. Infusion over 1 hour. Okay. While the Tenecteplase, the advantage is, disadvantage is, yes, of course it is costly, but the advantage is it can be given as one IV push. You don't have to create this 10% loading and then infusion. No, just push whatever is the total dose, give one IV push, done. The total dose here is 0.25 milligrams per kg. The max dose we are going to use is going to be 25 mg, and it is administered as total dose given as single IV bolus. And that makes it much more easier for handling the IVT plus EVT. So if the patient is eligible for both, all I have to do is, once I know that he is eligible for IV thrombolysis, Tenecteplase, push, provided there are no contraindications. Once the total dose of Tenecteplase is delivered, IV thrombolysis is done. Now I can prepare the patient for the EVT. But if I'm following this Altiplase, I'm literally wasting 1 hour to 1.5 hours before I can take the patient for EVT, right? So that's why today doctors prefer Tenecteplase over Altiplase. What is the stroke guidelines recommending? They say both are equivalent. They are not saying Tenecteplase is superior to Altiplase. But we prefer Tenecteplase over Altiplase because of the convenience or ease of administration, right? So that's about the stroke. Okay, now they can also ask you about the contraindications for stroke. So I'll just take another 2 minutes for the contraindications for stroke, and then we'll go for a 40 minutes break before we start the nephrology and rheumatology. The major contraindications for the thrombolysis: number one, the BP more than or equal to 185 by 110 despite treatment. So that means if the patient is within the window period and BP is more than 185 by 110, you can still try to lower it and then go ahead with thrombolysis. Only when your treatment fails, you're not able to lower it, or patient's window period get expired, then it becomes contraindication. Okay. Second is recent major surgery. Recent major surgery, right? These are the two major contraindications I want you to remember. Also, a large infarct occupying more than 1/3 of the territory of MCA was once upon a time considered as a major contraindication. Today's decisions are mainly focused on not looking at the size of the infarct, but rather at the size of the penumbra, what we can save, right? So these two contraindications, please remember. And also coagulopathy, of course. If there is any increased risk of bleeding tendency, then you have to avoid thrombolysis. Mostly MCQs are about the BP management in the stroke itself. So if it is more than 185 by 110 despite treatment, then it is a contraindication. If it is less than that, it is not a contraindication. Okay, so that's it about the neurology. We'll take a 40 minutes break and then we will reconnect again. So meanwhile, I'll also finish my lunch and join you back. Then we'll talk about the nephrology and rheumatology. Okay, so all right guys, we'll continue the discussion. We have already covered cardio and neuro. Now we'll be talking about some topics from the nephrology. Now what are important topics from nephrology? Number one, we're expecting questions in nephrology from, just give me a few seconds, from the ABG. That's a standard template. Almost every exam has a question. We're expecting questions on either AKI or CKD, mainly complications of CKD. Beyond that, you do get questions about the glomerulonephritis, but mostly questions are from pathology. You often have images embedded in the question. So I will not touch the glomerular disorders, but we'll certainly talk about AKI, CKD and ABG. And then we'll talk about rheumatology and respiratory disorders. Okay, so first let's start with ABG. We'll learn the approach to ABG by taking an example. So let us say we have some basics. Let us revise. So basically in our body there is constant production of acids, mainly because of cellular metabolism. So when cells utilize glucose or free fatty acids or even amino acids, as a byproduct of cellular metabolism, there will be production of CO2, and CO2 is the major acid in the body. Now why that is an acid? Because CO2 when dissolved in water becomes H2CO3, and this H2CO3 is acid. It is called as carbonic acid. So cell metabolism is constantly producing carbonic acid. Now this acid, why is it acid? Because H2CO3 is capable of splitting into H plus and HCO3 minus, and anything which is capable of actually donating an H plus is proton. A proton donator is an acid, and because H2CO3 can donate a proton, it is acid. And when we are constantly producing acid molecules, we need a buffer system to make sure that the pH in the blood is maintained in the healthy normal range. And our main buffer system, if acid is increasing, the buffer has to be a base. So bicarbonate is the main buffering system in our body. Okay, so H plus is the main acid, which is mainly coming from carbon dioxide, and HCO3 minus can combine with H plus to produce H2CO3. Thus anything which is capable of taking a proton will be called as base, and HCO3 minus, because it is capable of taking proton, it is a base. So I think the things are clear. Carbon dioxide is acid and bicarbonate is our main base in the body. Now when they are in balance, we have normal pH maintained. What is a normal pH? The normal pH is going to be 7.35 to 7.45. This is necessary because whenever we have to do any cellular reactions or metabolic activities happening, the pH should be in this normal range. When pH goes beyond this range, the cellular metabolism gets disturbed. So maintenance is necessary. Real challenge is constant production of acids, and bicarbonate is taking care of it. Now anytime there is, let us say, excess acid production, that is carbon dioxide is increased in the blood, so you have now tendency to pH go towards acidosis. So in that case, first tell me what should happen to my bicarbonate value. So you have a kind of balance between your acid, which is carbon dioxide, okay, and base, which is HCO3 minus. But if the acid starts increasing, then pH starts falling below 7.35. So imagine that we have one weighing scale here, and we are maintaining the pH between 7.35 to 7.45. Okay, so this is the weighing scale, and in this scale, on one side I have acid, which is mainly carbon dioxide, and on the other side I have base, which is mainly bicarbonate. Okay, so I had perfect balance of bicarbonate and carbon dioxide. Because of that, my pH was maintained in normal range. But now that I have added more acid, the pH is now going to tilt towards acid. It becomes less than 7.35. So I have to now correct it. How do I correct it? Should I decrease bicarbonate or should I actually increase bicarbonate? That's the first question. Okay. Now here I have added more carbon dioxide. So let me call that as the primary abnormality. Acid buildup is the primary abnormality in this particular case. So there should be a mechanism which is compensating for this change. What should be that? Yes, if carbon dioxide is increasing, bicarbonate also has to increase so that the balance is struck again. If acid increases, increase the base so that you maintain the pH in the normal range. So what we learn from this? Whatever is the primary abnormality, whatever is the primary abnormality, the compensatory change, whatever is going to be the compensatory change, both follow same direction. Both follow same direction. Means if, let us say, on the other hand, if I decreased bicarbonate, then pH starts again pointing towards the acidosis. If I decrease the bicarbonate, again pH starts going towards acidosis. So in that case, I have to reduce the acid. Primary abnormality here is decreased base, so acid also has to be reduced. If I increase the bicarbonate, then the pH starts tilting towards alkalosis. So to compensate for that, I have to increase the carbon dioxide, right? So first thing is clear, primary abnormality and compensatory change follow the same direction. If one is increasing, the other increases to get the pH balanced. Okay, that is first point. Second point to understand ABG is, if you have primary abnormality mainly targeting carbon dioxide, then you have respiratory pathology, because carbon dioxide excretion can be increased or decreased by respiratory system. Kidneys can't do anything about it. But if the primary abnormality is bicarbonate excess or bicarbonate deficiency, then your problem is with respect to kidneys, then you can call it as a metabolic abnormality, right? So whenever you think about carbon dioxide as a primary pathology, think about respiratory. And whenever you think of bicarbonate as a primary abnormality, think of metabolic. Okay, clear? Now that we know this much, let us say I had increased carbon dioxide. So to compensate for that, bicarbonate increased. And because of this effort by the bicarbonate, the pH is now back to normal range. Does that mean I have no acid-base disorder now? pH is in the normal range. But when I look at the scale, I notice carbon dioxide is heavy, bicarbonate is also high. So carbon dioxide increased, bicarbonate compensated by increasing itself, and that is why you got the pH normal. But both of these are higher than normal now. So I still have an acid-base disorder. In that case, what should I call this? We will call it as fully compensated acid-base disorder. Whenever the compensatory change brings the pH back to normal, such acid-base disorder will be called as fully compensated. But if carbon dioxide increases and bicarbonate increases to compensate for it, compensatory change is occurring, pH gets better but it does not get fully normalized, then you will call it as partially compensated acid-base disorder. You get the pH fully normalized, fully compensated. You fail to get it fully normalized, then it is partially compensated, but no change occurring at all. Like carbon dioxide is increasing, but bicarbonate is not taking the name of increasing, it remains normal. In that case, you have uncompensated respiratory or metabolic abnormality. Okay, clear? Now let us take some examples and see if we can get the things right. So the first example is here. The pH of this person is 7.32. Partial pressure of carbon dioxide is 80 millimeters of mercury, and partial pressure of oxygen is 50 millimeters of mercury, and bicarbonate is, let us say, 35 millimoles per liter. This is the ABG abnormality. Now tell me, what is the diagnosis? I'll give you a minute time. Come out with a diagnosis. I want a full-fledged diagnosis, because nowadays slight playing with the words is very common when it comes to ABG based questions. So they might say there is no compensatory change, partially compensated, fully compensated. So we have to go beyond the diagnosis of acid-base disorder. So in this case, we have an approach to ABG, right? What is the first thing we should see? First thing we should see is the pH, right? And if the pH is Remember, in any ABG question, the first thing we should see is pH. Okay, and if the pH is abnormal, less than 7.35, whatever pathology you have is acidosis. Okay, and if pH is again abnormal but more than 7.45, more than 7.45, that is clearly alkalosis. But when pH is in the normal range, 7.35 to 7.45, there are two possibilities. Either there is no acid-base disorder, or there is every possibility that the compensatory mechanism might have pushed the pH back to normal, but underlying acid-base disorder may be there. That's why if I get this pH in the normal range, 7.35 to 7.45, I should see what is happening to partial pressure of carbon dioxide and bicarbonate values. If they are also normal, then certainly there is no acid-base disorder. There is no acid-base disorder because everything is normal. pH is in the normal range, bicarb is normal, carbon dioxide is normal, so there is no acid-base disorder. But if you notice that they are abnormal, either increased or decreased, then there is an acid-base disorder, and such an acid-base disorder I will call it as fully compensated acid-base disorder. And if pH is more than 7.45 or less than 7.35, whatever it is either partially or uncompensated it is. Because if there was a full compensation, then pH will be normalized. So either there is partial compensation going on or there is no compensation at all. Partially or uncompensated acid-base disorder if the pH is clearly abnormal. Now the next question is, how will I get to know whether I am having acidosis or alkalosis if the pH is normalized? If the pH is normalized, we guys are going to use 7.4 as the cutoff to differentiate. If the pH is more than 7.35 but less than 7.4, this side of 7.4 will be called as having acidosis. And that side of the 7.4, 7.41, 42, 43, you will be counting it as alkalosis. So you can make a note here. Use 7.4 as cutoff to differentiate between acidosis and alkalosis if it is fully compensated. Okay, so this is going to be our first step. ABG analysis, first step is to assign whether we have acidosis or alkalosis and whether it is fully compensated acidosis or alkalosis. Now in this example, pH is clearly less than 7.35, so there is certainly acidosis. We have acidosis, and whatever it is certainly not going to be fully compensated because pH is not normalized. Now after deciding that there is acidosis here, I have to decide whether it is metabolic or respiratory. That is going to be my second step. So for that we are going to follow the ROMS approach. So what ROMS approach says, ROMS approach to decide whether we are having respiratory versus metabolic abnormality. So ROMS says you have to assign the direction to pH and partial pressure of carbon dioxide. How are we assigning the direction? By looking at whether the pH is increased or decreased, carbon dioxide is increased or decreased. Okay, if both are following the same direction, like pH is increased, carbon dioxide is increased, or pH is decreased, carbon dioxide is decreased. If they are following the same direction, the abnormality is metabolic. Metabolic, same side. Respiratory, opposite. That's what ROMS stands for. Respiratory, opposite. Metabolic, same side. So if pH and PCO2 going in opposite direction, then it is respiratory pathology. And if PaCO2 and pH are going in the same direction, then it is going to be metabolic abnormality. So if I look at this example now, what is happening to the pH? It is less than 7.35, so it is decreased. What is happening to the carbon dioxide? Carbon dioxide is normally 35 to 45. So here it is clearly more than that. So it is increased. Means they are in opposite direction. So because they are in opposite direction, now I should call it as respiratory. Remember ROMS, respiratory opposite, metabolic same side. So once you have identified what kind of abnormality it is, next is to identify what is the primary abnormality and what is the compensatory change in this case. That is my third step. Step number 3 is to identify primary and compensatory change. Now, how do I identify primary and compensatory change? See, lungs can play with carbon dioxide, kidneys can play with bicarbonate, right? So if you have decided that the primary abnormality is respiratory using the ROMS criteria, then carbon dioxide abnormality is going to be the primary abnormality, right? So if respiratory pathology, then primary abnormality will be carbon dioxide, increase or decrease, that's the primary abnormality. And then whatever happens with the bicarbonate in that case, so in case of respiratory, carbon dioxide is going to be primary, and whatever is happening to bicarbonate, that is basically kidney's response to your primary abnormality. So that will be considered as compensatory change. But if I'm having metabolic acidosis or alkalosis, in that case the primary abnormality is bicarbonate. If bicarbonate is increased, that's the primary abnormality. If it is decreased, that's the primary abnormality. And whatever change you get on the carbon dioxide, that will be your compensatory change. Okay, so can we identify what is the primary abnormality in this question? We have already agreed that we are dealing with respiratory acidosis. So whatever is happening with the carbon dioxide, that is going to be my primary abnormality. So here carbon dioxide is increased, that becomes my primary abnormality. So in response, bicarbonate should increase, right? And as we see here, we see bicarbonate increasing. Normal is 22 to 26, here it is 35. So bicarbonate is increased. Those who are not aware of the normal values, let me write down. 22 to 26 is normal bicarbonate, and normal carbon dioxide is 35 to 45. Normal pH we already know, 7.35 to 7.45. So bicarbonate is increasing here, and this increasing bicarbonate is the secondary or compensatory change. So what does that mean? Compensation is definitely occurring, but not sufficient enough to get the pH normalized. If this increase in bicarbonate could get the pH normalized, I would have called it as fully compensated respiratory acidosis. But because pH is not normalized, I will not call it as fully compensated. I will call it as partially compensated respiratory acidosis. So our diagnosis becomes partially compensated respiratory acidosis. What is the compensation? Respiratory acidosis gets compensated by retention of the bicarbonate by the kidneys. So you can say compensatory change here is developing metabolic alkalosis, so that the acidosis gets normalized. Okay, so this is one example we took. This is how we are arriving at the diagnosis. We'll take one more, or in fact two more examples, and then we will go to the next topic. The second example is here. We have a pH of 7.38, PaCO2 of 22 millimeters of mercury, PaO2 of 110 millimeters of mercury, and bicarbonate of 10 millimoles per liter. I am adding some extra information here. The chloride values are also given, which is 110 millimoles per liter. So now tell me, what is your diagnosis? So first thing I should see according to our protocol is the pH, and I notice that pH is in the normal value, 7.35 to 7.45. So there are two possibilities now. Either there is no acid base disorder at all, or there is a fully compensated acid base disorder. So I should see what is happening to bicarb and PaCO2. PaCO2 is decreased here. PaCO2 is decreased here because normal PaCO2 is 35 to 45. It is decreased here, so it is abnormal. And when I see bicarbonate, that is also decreased. Normal is 22 to 26. Here it is 10. So internal values of the ABG are not normal. So according to our protocol, it becomes a fully compensated acid-base disorder, right? So my first diagnosis is whatever it is fully compensated. It is fully compensated. Okay. Next, now I have to identify what kind of abnormality is. Is it alkalosis or acidosis? And in fully compensated cases, we are using 7.4 as the cutoff. Less than 7.4, you are calling it as acidosis. And more than 7.4, you are calling it as alkalosis. So here it is 7.38. So in that case, it becomes acidosis. So I am dealing with fully compensated acidosis. So step 1 done. Now I have to identify whether this is respiratory or metabolic. For that same thing, I will assign a direction to the pH and PaCO2. So here remember, in fully compensated, our cutoff is 7.4, not 7.35 to 7.45 range. So in comparison to 7.4, pH is going down, PaCO2 is also going down. So both are in the same direction. If they are in the same direction, the diagnosis becomes metabolic abnormality. So here we are dealing with fully compensated metabolic acidosis. So if it is fully compensated metabolic acidosis, what is going to be my primary abnormality? In metabolic, primary abnormality is with respect to bicarbonate. So this decreased bicarbonate is the primary abnormality, and because base is decreasing, your respiratory system is responding by washing out carbon dioxide. This is what we call as alkalotic breathing, right? Sorry, acidotic breathing, right? So whenever you develop acidosis, you want to wash out the carbon dioxide. So this PaCO2 decrease is the compensatory change. Okay, so we identified that we are dealing with fully compensated metabolic acidosis. Primary abnormality is decreased bicarbonate. To compensate for that, PaCO2 is also decreased. And because the compensatory change was efficient enough to get the pH back to the normal range, we are going to call it as fully compensated metabolic acidosis. Okay, now whenever we have metabolic acidosis as our diagnosis, there are further steps involved. Most importantly, identifying the anion gap. So if you have metabolic acidosis, if I have any respiratory pathology or metabolic alkalosis, there is no further step involved with respect to calculation of anion gap and all. But if you are having metabolic acidosis, you have to classify them into high anion gap metabolic acidosis and non-anion gap metabolic acidosis. So next step, if metabolic acidosis, you have to calculate anion gap. Now how do I calculate anion gap? Basically, you are looking at the difference between measured anions and measured cations. So delta anion or anion gap is nothing but the difference between measured cations minus measured anions. What are the measured cations? It is mainly going to be sodium. So you will check the serum sodium level and subtract that with the commonly measured anions. What are the commonly measured anions? Bicarbonate and fluoride. Okay. In a normal physiological state, the number of anions and number of cations will be equal in human body. Because if one is more than the other, then you are literally having potential difference. So you have become a battery, not a human body. And we are not a battery. We have a perfect balance of anions and cations. Then from where this difference is coming? Because we are not measuring all the cations and all the anions. So this difference is what we actually see in the measured anions and measured cations. Okay. This difference normal anion gap is usually less than 12. Okay, and if the anion gap is more than 12, we call that patient as having high anion gap metabolic acidosis. And if the anion gap is normal, then such patients are said to have non-anion gap or normal anion gap metabolic acidosis, NAGMA and AGMA. Now, why this is important? Let me give you an example. Let us say I'm adding an extra acid to human body from outside source. If I have to give an example, salicylic acid. A lot of patients of salicylic acid poisoning are encountered in our practice day in and out. Okay, so let us say there are positively charged ions in the body which are perfectly in same number as the negatively charged ions in that person's body. Okay, but when I measure, let us say this is sodium, 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 right? While this is bicarbonate, this is bicarbonate, this is chloride, this is chloride. The other anions are different ones like albumin and other anions, so which are not usually measured. So that creates a difference in the measurement. So basically the gap that we see accounts for unmeasured anions. Okay, now if I add salicylic acid to this patient's body, tell me salicylic acid will be considered as an anion or cation. So salicylic acid when dissolved in water becomes salicylate, and all these ates are negatively charged. So when I add a negatively charged extra acid to this patient's body, the balance is disturbed. Okay, so to compensate for that, one of the existing negatively charged ion has to shift inside the cell so that you have got the balance again. And let us say this was chloride, this was chloride, and this was bicarbonate, this was bicarbonate. So to accommodate this extraneous anion acid, the existing anion has to shift into the cell. So when I measure the anion gap, of course I'm not measuring the salicylate, but I'm definitely measuring chloride, and I will notice that the chloride molecules are decreased. So it creates the widening of the anion gap, right? So indirectly I can say that whenever you notice high anion gap, that means an extra acid, an extraneous acid is being added to the patient's body, and to accommodate for those acid anions, the existing measured anions are shifted into the intracellular compartment, and that's why your anion gap appears to widen. So the moment you see high anion gap, you should think about an extra acid being added to the body. That's the way to remember the causes for high anion gap metabolic acidosis. So here let's try to calculate the anion gap. For that I need the serum sodium values as well. So let us say serum sodium is 140 millimoles or milliequivalents per liter. So in that case, what will be my anion gap? Sodium is 140. The formula for anion gap is sodium, that is the measured cation, minus bicarbonate plus chloride. So in that case 140 minus bicarbonate is 10 and chloride is 110, right? So 10 plus 110 becomes 120 minus 120. So anion gap here is 20. Normal is less than 12. So it is clearly more than 12, right? So with anion gap of 20, making my final diagnosis as fully compensated high anion gap metabolic acidosis. Fully compensated high anion gap metabolic acidosis. So that's going to be my final diagnosis here. Now I have to think about the cause. Whenever I get high anion gap, I should always think that one extra anionic acid ion is added to the patient's body. It could be salicylic acid, it could be methanol, right? There's a formula or the mnemonic to remember the causes for high anion gap metabolic acidosis, which is mud piles. So if I add methanol to patient's body, I'm adding an extraneous acid. Okay. Then if I have diabetic ketoacidosis, we have beta hydroxy butyric acid or other ketone bodies. They are all anions, they are being added to body extra in comparison to whatever normal acids and bases we have. Extra acids are being added in the form of keto acids. That's why I'm getting this high anion gap. Okay. Metformin leads to metformin toxicity. Fenformin, and not just fenformin, but even metformin toxicity leads to lactic acidosis. So extra lactic acid is being added to body. So those lactate molecules account for the anion gap that we see here. Okay, then paraaldehyde, INH, ion therapy, lactic acidosis, I was just talking about it. Then when you add ethanol or ethylene glycol to body, or salicylate is the example that we took. So easiest way to remember all these causes is, if something is added extra to the body, you think about high anion gap metabolic acidosis. You want to remember, you can remember it as mud piles. So uremia here refers to either having acute kidney injury or CKD. Okay. But if I had encountered a non-anion gap metabolic acidosis, anion gap being less than 12, in that case, we are not thinking about an extra acid being added. Either you have lost the base, that is bicarbonate loss, or you have gained the normal carbon dioxide itself. You have gained the normal acids in the body. You have not added an extra acid in the body. The mnemonic to remember the non-ion gap metabolic acidosis is used part: urinary diversion or ureoenterostomy, small bowel fistula, extra chloride being added, diarrhea, pancreatic fistula, Addison's disease or acetazolamide, and renal tubular acidosis. Drugs like tenofovir and topiramate. The mnemonic is used part. Why am I stressing on renal tubular acidosis? Because when you have CKD or AKI, you get hagma. While if you develop renal tubular acidosis, you end up developing non-anion gap metabolic acidosis. So remember, AKI or CKD leads to high anion gap metabolic acidosis. While if you have renal tubular acidosis, you have non-anion gap metabolic acidosis. So let's try to understand why in AKI or CKD there is an anion gap, but there is no anion gap in case of renal tubular acidosis. So what is the pathology in case of renal tubular acidosis? Name only tells, right? There is a problem in renal tubules. If you look at the anatomy of a nephron, you have a Bowman's capsule, then you have proximal convoluted tubule. Proximal convoluted tubule will lead to descending limb of loop of Henle, then ascending limb of loop of Henle, that too with thick ascending limb of loop of Henle, eventually developing into distal convoluted tubule, finally terminating in collecting ducts, right? So this is going to be your Bowman's capsule. This is going to be your proximal convoluted tubule. This is your loop of Henle. This is your distal convoluted tubule, and this is your collecting duct. Normally what happens, we bring the blood into this capillary loops in the Bowman space called as glomeruli through an afferent arteriole. We bring the blood through an afferent arteriole and the blood leaves through an efferent arteriole. But during this process, there is a filtration barrier in the glomerular basement membrane and the Bowman's capsule put together. You create a filtration barrier through which you filter the blood, right? And once you filter the blood, the filtrate is what we call as glomerular filtrate, which is now going to pass through the tubules, right? Now when it is passing through the tubules, in the proximal convoluted tubule, we tend to reabsorb bicarbonate because our body's problem is constant production of carbon dioxide by metabolism, which is contributing to acid environment, and to counter that I need bicarbonate. So I can't afford to lose this filtered bicarbonate in urine. I want to reabsorb it. The site of reabsorption is proximal convoluted tubule, and the H plus ions are acids. I want to get rid of them. So we generally tend to secrete H plus ions in distal convoluted tubule and in collecting ducts. So actively I can secrete H plus in the DCT and reabsorb bicarbonate in the DCT. So if I have impairment in bicarbonate reabsorption, so I will lose base in urine, I will develop acidosis because bicarbonate is decreasing. Or if I have impairment in H plus secretion in the DCT, then I am not able to excrete the acids, and because I have impairment in acid ion excretion, acid ions or H plus will stay in the blood, again I end up developing acidosis. So these conditions we call it as renal tubular acidosis because the pathology is in renal tubules. So if there is impaired bicarbonate excretion, impaired HCO3 excretion in proximal convoluted tubule, we will call that type of renal tubular acidosis as proximal renal tubular acidosis. It will be called as proximal renal tubular acidosis because PCT is where the pathology is. We will call it as proximal RTA. But if there is impaired H plus excretion in DCT, then you will call that as distal RTA because in DCT we have difficulty in excreting the H plus. If I have CKD, there will be damage to tubules as well. So I will have impairment in bicarbonate secretion as well as H plus excretion. Okay. So then essentially renal tubular acidosis and AK and CKD should result in same kind of metabolic acidosis. That should be non-anion gap because nothing extra is being added here, right? Then why am I getting anion gap in patients with AKI and CKD while I don't have anion gap here? Here, see, either you are not able to get the bicarb back or you are not able to excrete H plus. So that impairment is there. There is no extra acid being added to create anion gap. But what happens in CKD is we have other substances accumulating in the patient's body which kidneys are failing to excrete. Example, sulfates, phosphates, they are all acids, right? So accumulation of, so in case of AKI or CKD, you have both. You have impaired HCO3 reabsorption plus you have impaired H plus excretion, but on top of that you also have impairment in sulfate and phosphate molecule excretion, and these molecules are accumulating, and these are the extra acids which are responsible for the high anion gap that we see in AKI or CKD. In renal tubular acidosis we don't have the problem with elimination of sulfates and phosphates, so that's why we don't get the high anion gap. So who is responsible for anion gap in case of AKI or CKD? It is the other molecules like sulfates and phosphate molecules which are responsible for the high anion gap, right? So please remember that. Okay, so this is about our ABG. Approach is pretty simple. First, look at the pH to decide acidosis or versus alkalosis. Even when pH says normal, you don't have normalcy, you may still have an underlying fully compensated acid-base disorder. So in that case, look at the PaCO2 and bicarb. If they are abnormal, you know you have a fully compensated acid-base disorder. In such cases, to decide between acidosis or alkalosis, you will use 7.4 as the cutoff. Okay. Once we have decided whether we are having acidosis or alkalosis, next is to identify whether we have respiratory or metabolic abnormality. For that, we are following the ROMS approach. We have to assign a direction to pH and PaCO2, like whether they are increasing or decreasing. If both are following the same direction, you have respiratory abnormality, metabolic abnormality, and if they are following the opposite direction, you have respiratory. Once that is done, we can identify what is a primary abnormality and what is compensatory change. In respiratory, primary abnormality is always carbon dioxide, and in case of metabolic, the primary abnormality is bicarbonate. So whatever is happening to the other component is the compensatory change. And we know the compensatory change follows the same direction as the primary abnormality. If carbon dioxide is increasing, bicarb is supposed to increase to compensate. If carbon dioxide is decreasing, bicarbonate is supposed to decrease to compensate. So if you don't see the changes in the compensatory arm, then you can say there is no compensation occurring. But you see some change, then there is compensation present. But pH is not normalized, then you will label it as partially compensated. pH is normalized, then it is fully compensated. Okay. And once you have made a diagnosis with this approach, if you're dealing with metabolic acidosis, they might ask you to measure the anion gap, right? The formula you need to remember. And once you identify whether you're dealing with high anion gap or non-anion gap metabolic acidosis, they may ask you which of the following is the most likely cause for this situation. Like we got here a high anion gap metabolic acidosis. So they may give 4 options, and one of them is a known cause for HAGMA. The other ones are the known causes for non-anion gap metabolic acidosis. So if I know the mnemonic to remember it, I'll be able to identify. Even if I don't know the mnemonic, all you have to think of it is in this condition, is there any extra acid being produced in the body or added to the body? So one of the option I see salicylate poisoning, then I know extra acid is being added. So it is supposed to be high anion gap metabolic acidosis. But if the question is talking about renal tubular acidosis where there is no extra acid accumulating in the body, you only have abnormality of either bicarbonate reabsorption or H+ secretion, then the answer should be non-ion gap metabolic acidosis. Okay, so that's about the ABG part. Now let's go to the next chapter on nephrology, which is going to be acute kidney injury. Acute kidney injury. Okay, so what is acute kidney injury? When there is abnormal renal function tests evolving in a very short span of time, we can call it as acute kidney injury. But there is a technical definition for AKI. The first one is if serum creatinine increases by more than or equal to 0.3 milligrams per deciliter over baseline, whatever was the previous value. Over the baseline, if the creatinine jumps by 0.3 milligrams per deciliter or more within a span of 48 hours. Like, okay, today morning I got the creatinine done, it was 1, and tomorrow morning, that's just 24 hours, I got it done, and now it is 1.4. So how much jump occurred? 0.4 jump occurred. That is definitely more than 0.3 jump that is required. So in that case, I can label this patient's creatinine jump is sufficient to say he has got acute kidney injury. That's first criteria. If this is not satisfied, you can also look at the second criteria. What is second criteria? If the serum creatinine increases by more than or equal to 1.5 times baseline within a period of 7 days or 1 week. Means let us say I got it done on day 1 and the creat was, on day 1 the creat was 1 milligram per deciliter. Okay, and I got it done on day 5 and it is 1.6 milligram per deciliter. That did not satisfy my first criteria. Within a span of 48 hours, probably there was no 0.3 jump. But over 5 days period, 1 milligram has become 1.6. So it has increased by 1.6 times the baseline value. That is definitely more than 1.5 times. So this can also be called as a case of acute kidney injury. Then third, if the urine output decreases, urine output less than 0.5 ml per kg per hour for a period of more than or equal to 6 hours. So sometimes when we don't drink water, we are slightly dehydrated. For 2-3 hours, our urine output may be low, but after that you drink, it gets normalized. But sustainably for a period of 6 hours, the urine output is less than 0.5 ml per kg per hour. That means if I am dealing with a 50 kg person, 0.5 ml per kg becomes like half of it. That is 25 ml per hour is the expected urine output for him, minimum. But if his urine output is less than 25 ml per hour for 6 hours, like on first hour it was 10 ml, second hour it is 15 ml, then again 10 ml, next it is 12 ml, then again 10 ml, then again 20 ml. So when I look at it, for a period of 6 hours, definitely the urine output is less than 25 ml per hour. So in that case, this fellow can also be called as having acute kidney injury. So once you recognize that a patient is having acute kidney injury, we should also know how to stage it. There is a KDIGO staging of acute kidney injury, which takes into account both the serum creatinine as well as urine output. Okay, stage 1 is where the creatinine has increased from the baseline by 1.5 to 1.9 times. Like for the definition itself, we have already used that creatinine increased by 1.5 times the baseline becomes AKI. So from 1.5 times the baseline to 1.9 times, like on day 1 it was 1 milligram per deciliter, it became 1.8 milligram per deciliter. So it is definitely more than 1.5 times the original value. So it becomes AKI. And in terms of stage, up to 1.9 times the baseline, it will be considered as stage 1. So it has not crossed 1.9 times. So I will count it as stage 1. Okay. Stage 2 is where your serum creatinine has increased by 2 to 2.9 times the baseline. Let us say later this patient's creatinine becomes 2.3 milligrams per deciliter. So now it is 2.3 times the baseline. So now I can say his AKI has progressed from stage 1 to stage 2. Okay. And when the creatinine becomes more than 3 times the baseline, let us say next day it becomes 3.1 milligrams per deciliter. So it is certainly more than 3 times the baseline. So now his AKI has progressed to stage 3. So 1.5 to 1.9 times the baseline is stage 1. 1.9 means 2 to 3 times the baseline is stage 2. And more than 3 times the baseline is stage 3. This is with respect to creatinine. But in AKI definition, we have also used urine output. So I can also use urine output for staging the acute kidney injury. Okay. So if urine output is less than 0.5 ml per kg per hour for 6 hours, I call it as AKI. From 6 hours up to 12 hours, I will count it as stage 1. But if urine output remains this low for a period of more than or equal to 12 hours, I will call it as stage 2. Stage 2. And if the urine output drops to less than 0.3 ml, which is lower than the defining criteria for AKI, and it remains so low for 24 hours or more, or a patient is not producing urine, anuric, for 12 hours, you will call it as stage 3. An extra point to note here is, in the staging, any patient who is started on dialysis, renal replacement therapy in the form of dialysis or even kidney transplantation. If I started someone on dialysis, regardless of the creatinine values, we will be considering it as stage 3. Regardless of the urine output, we will be considering it as stage 3. Okay. So you should be aware about the AKI diagnostic criteria and staging of AKI according to KDIGO. Now when you have AKI, they will ask you causes for AKI and how do you actually differentiate between pre-renal AKI and acute tubular necrosis, which is a renal form of AKI. Acute kidney injury can occur because of decreased blood delivery to the kidneys. If blood is only not coming to kidney, how will it filter the blood, right? How will it clear the creatinine? How will it clear the urea? So urea creatinine starts increasing. In that case, we call it as pre-renal AKI. Pre-renal AKI. The problem may be in the kidney itself. So in that case, you can call it as intrinsic renal AKI. Okay. Sometimes blood delivery to kidney is fine. Kidneys are filtering fine. They are making the urine, but then urine is not able to leave the kidney properly because there is obstruction to the urine outflow. In that case, you call it as post-renal AKI. Post-renal AKI. Pre-renal AKI is usually due to decreased renal perfusion. Renal perfusion. For the blood to get filtered, first it has to reach kidney. If it is not reaching kidney, how will it get filtered? Decreased renal perfusion can occur in patients with shock, in patients with hypotension, right? And then in patients with hepatorenal syndrome, where there is ascites, increased pressure buildup in the abdomen, which is compressing the renal vessels and reducing the blood delivery to the kidneys. These are some examples for pre-renal AKI. When your kidney tests become abnormal after loose stools, most likely it is pre-renal AKI because you are dehydrated, your circulating blood volume is decreased, you might have gotten into shock or hypotension, your renal perfusion is decreased, and you're ending up with pre-renal AKI. If I have to point out the problems within the kidney, what you call as intrinsic renal AKI, you can have glomerular disorders. Glomerular disorders. You can also have tubular disorders, mainly we'll call it as acute tubular necrosis. And the third one, acute interstitial nephritis. Now, what are all these terms? So, if I look at the nephron, this is going to be my Bowman's capsule. This is going to be my proximal convoluted tubule. This is going to be my loop of Henle. And then this is going to be my DCT. This is going to be my collecting duct. Okay. This is going to be an afferent arteriole bringing the blood into the glomeruli. This is going to be an efferent arteriole. So, if there is decreased perfusion of the kidneys, then it is pre-renal AKI. But if the perfusion is adequate, but if the glomeruli are damaged, example post-streptococcal glomerulonephritis, IgA nephropathy, and because of that you are not able to properly filter the blood and you are not able to clear urea and creatinine, then it is glomerular disorder. Problem is within the kidney, so it becomes intrinsic renal pathology, right? So examples for the glomerular disorders, I can quote post-streptococcal glomerulonephritis. It can also occur in subacute bacterial endocarditis, which is similar to post-streptococcal glomerulonephritis. Then IgA nephropathy. These are all glomerular disorders. Okay. Second, if the tubules get damaged, it can be damaged by drugs like acyclovir. Acyclovir can precipitate in the renal tubules and cause damage. Or if there is vascular injury and the tubules go into necrosis, and because of that your renal functions are getting altered, glomeruli are fine, then we will call it as acute tubular necrosis. Okay, acute tubular necrosis. So ATN can be caused by pre-renal AKI itself. Pre-renal AKI is the most common cause for acute tubular necrosis, because you're not bringing sufficient blood to the glomeruli, you're not bringing sufficient blood to the kidney. Tubules also, for their survival, they will require blood supply, they are not getting it, so they become necrosed. Second, drugs is something that comes to my mind. An example right now I'm quoting is acyclovir, but there are long list of drugs which can cause acute tubular necrosis. But sometimes you can have kidney dysfunction where renal perfusion is fine, glomeruli are fine, tubules are also fine, but then the connective tissue that is surrounding all these tubules, what you call as interstitium, that is being affected. In that case, we'll call it as acute interstitial nephritis. Acute interstitial nephritis. Acute interstitial nephritis most commonly is caused by drug allergy. Drug allergy. Okay. And the most common class of drugs responsible for acute interstitial nephritis are basically your beta-lactam group of antibiotics. The allergy to beta-lactam antibiotics like penicillin, as a part of allergy, even the interstitium of the kidney gets inflamed by eosinophils, producing acute interstitial nephritis. So all these are going to be your intrinsic renal AKI. Post-renal is where kidneys, like if this is a kidney we're looking at, if kidneys produce urine, and from the kidney this urine has to flow down through ureter to bladder and then eventually through urethra out. But if there is obstruction to the urine outflow, then even after creating the urine, you are not able to expel it, nitrogenous waste accumulates and you have AKI. We will call in that case as post-renal AKI. Post-renal AKI is usually caused by bilateral ureteric calculi or bladder outlet obstruction. So when bladder outlet is obstructed because of maybe prostatic cancer or even benign prostatomegaly, right, or any other cancer, or bladder outlet obstruction. Now, if I have to diagnose a case of AKI for the cause, AKI is detected by looking at the creatinine. Creatinine has jumped by 0.3 milligrams from baseline, or 1.5 times the baseline, or urine output is less than 0.5 ml per kg per hour for 6 hours, then I know I have AKI. Once I know it is acute kidney injury, I have to identify the cause. So how will I identify? Number one, it is pretty easy to identify your post-renal AKI because the ultrasound or any other imaging like CT scan can easily detect the ureteric calculi or a cancer obstructing the bladder outflow. Okay, so any case of AKI, we definitely consider going ahead with imaging for the outlet obstruction. Okay, once that is ruled out, you don't see any stones or anything causing the urine outflow, then I'm left with either intrinsic renal AKI or pre-renal AKI. Many a times history itself makes it apparent. Like if I tell you that this patient had acute gastroenteritis, after that his creatinine has jumped, then you know he has lost the fluid from the body, and because of the dehydration there was decreased renal perfusion. That's why probably he has ended up with pre-renal AKI. If I tell you that this patient was brought in a state of shock after road traffic accident, that means I know he has lost blood, he went into shock, decreased renal perfusion. So if I'm seeing abnormal creatinine or abnormal urine output, it is because of pre-renal AKI. And then in case of glomerular disorders, intrinsic renal AKI, patients will generally have glomerular type of hematuria, means hematuria with dysmorphic RBCs, RBC casts. So if they are there in the question, then I know it is a glomerular disorder. Acute interstitial nephritis, they will generally mention the history of exposure to drugs plus eosinophils in the urine. So that way I can recognize. My real challenge will be in differentiating between prerenal AKI and acute tubular necrosis, because prerenal AKI itself is the most common cause for acute tubular necrosis. If you tell me the history of acyclovir, I know, okay, that is responsible. But otherwise, I need to learn to differentiate between prerenal AKI versus acute tubular necrosis. Next, we'll learn how to differentiate between prerenal AKI and acute tubular necrosis. Before that, let's quickly write down localizing the lesions in case of renal disorders. Okay, so first thing, if I have glomerular disorders, if you have glomerular disorders, they can either present with nephritic syndrome or they can present with nephrotic syndrome. Nephrotic syndrome patients are unlikely to present with AKI. They will only present with typical nephrotic syndrome features. But nephritic syndrome patients, they present with acute kidney injury. Their creatinine, blood urea nitrogen can be raised, urine output can be reduced. But on top of that, they will also have hematuria. Right? You talk about post-streptococcal glomerulonephritis, IgA nephropathy, all of them have hematuria. And this hematuria is characterized by presence of dysmorphic RBCs. Dysmorphic RBCs indicate that these RBCs are coming from the injured glomeruli and they are not coming from the tubules, or they are not coming from the ureter or urethra or bladder, right? If you see dysmorphic RBCs, you know you are dealing with glomerular pathology. Okay. On top of that, there will be activation of RAS resulting in hypertension. These patients might have periorbital edema. So if I have an AKI patient with these features, then I know it is nephritic syndrome, and in that case I should be thinking about diseases like post-streptococcal glomerulonephritis or IgA nephropathy or post-infectious glomerulonephritis. But instead, if patient presents with nephrotic syndrome, here also you will have proteinuria. I forgot to mention. In nephritic syndrome, the proteinuria will be subnephrotic, means proteinuria less than 3.5 grams per day. But nephrotic syndrome patients will have proteinuria of more than 3.5 grams per day. And when I have such amount of proteinuria, I'm losing a lot of protein, more than the rate at which I'm able to create protein. So because of that, I will end up with hypoalbuminemia. My blood albumin levels will decrease. And once the albumin levels decrease, oncotic pressure decreased. And once the oncotic pressure decreases, I will end up with edema. Here, the edema in case of nephritic syndrome is mainly periorbital, but in nephrotic syndrome, it becomes generalized or anasarca. So here we are going to get proteinuria, hypoalbuminemia, generalized edema or anasarca, and along with that, nephrotic syndrome is also associated with you're losing a lot of other important proteins. Okay, and when you're losing proteins, to compensate for that, your liver increases the protein production. But what protein production is increased by the liver? Lipoproteins. And increased lipoprotein production by the liver leads to dyslipidemia. Because you're losing albumin and other proteins, liver wants to increase the protein production, but it produces a lot of lipoproteins, so you end up with dyslipidemia. Liver also produces a lot of procoagulant proteins in increased number, increasing the risk of thrombus formation or procoagulant state. So these are the features we are going to get in nephrotic syndrome. Nephrotic syndrome patients generally do not present with AKI. These are the symptoms that they present with. Now, which diseases actually present with nephrotic syndrome? PSG and IgA nephropathy, post-infectious glomerulonephritis, they present with nephritic syndrome. Here, it is the minimal change disease, which is the most common cause for nephrotic syndrome in children. Then, membranous nephropathy and membranoproliferative glomerulonephritis, and some patients with lupus nephritis can present with nephrotic syndrome. Okay. So looking at the clinical picture, you may be able to recognize whether it is nephritic or nephrotic, and on that basis, with the context added, you may be able to diagnose which glomerular disorder the particular patient is suffering from. Okay. Now the second syndrome is if the patient has drug exposure. That's a typical picture of acute interstitial nephritis, where patients will have history of drug exposure, either doctor prescribed, patient took by themselves, followed by development of rash and fever, and they have eosinophils in urine. Normally urine routine does not show eosinophils, but you are getting eosinophils in the urine and you have acute kidney injury, your creatinine is increased or urine output is low, then you know you are dealing with acute interstitial nephritis. Okay. Then third is you have AKI, you have acute kidney injury, plus you have colicky abdominal pain. Then you are mostly thinking about post renal AKI. There is something obstructing the urine outflow, that's why you are getting this colicky abdominal pain, most likely bilateral or unilateral ureteric calculi, right? So in that case, it's a typical description of post renal AKI. Now, as I have already told you, I am only left with how to differentiate between pre-renal AKI and acute tubular necrosis. The point to understand here is if I have pre-renal AKI, means there is decreased delivery of blood to the glomeruli. Don't you think the kidneys should have some compensatory mechanism to get more blood flow to the glomeruli? You are dehydrated, you are not able to provide blood flow to the kidneys, but kidneys should be able to do some auto-regulation, right? Yes, kidneys have an auto-regulatory mechanism. What is the auto-regulatory mechanism? It's mainly your angiotensin 2. So what angiotensin 2 will do? Angiotensin 2 will cause the constriction of efferent arteriole. So if I narrow the efferent arterioles, if I make it narrow, then whatever little blood that is getting into the glomeruli will have no easy escape out from the glomeruli. So intraglomerular pressure increases and then you'll still be able to carry out filtration with this help of increased intraglomerular pressure. The point to learn here is whenever you have pre-renal AKI, you will have activation of RAS. Okay. Pre-renal AKI is associated with RAS activation. That's a point to note. So now tell me, if I have pre-renal AKI, what will happen to my urine concentration? It is associated with RAS activation. What will happen to my urine concentration? So under the influence of RAS, the ENaC channels, right? ENaC channels in the collecting ducts will be overactive because aldosterone is stimulating it. So then from the ENaC channels, I will be absorbing a lot of sodium out, and along with sodium, I will also be absorbing water. So the urine that is flowing out would have less sodium than usual and less water than usual. Simple, right? I had dehydration, so I had less sodium and water. So aldosterone came, reabsorbed more sodium and water so that I can get that sodium and water back to my circulation, but the urine sodium and urine water will decrease. So this will result in excretion of concentrated urine low in sodium. Water absorption is making the urine concentrated. You're not absorbing urea or other electrolytes, only water and sodium. So you're absorbing water, making the remaining urine concentrated, plus the sodium is also being reabsorbed. So urine sodium levels are going to be low. Okay. But if I have acute tubular necrosis, ATN, what is the change I get? In case of acute tubular necrosis, remember, first we filter, and after the filtration is done, we reabsorb the substances. Like in the proximal convoluted tubule, we reabsorb glucose with the help of SGLT2. We reabsorb amino acids with the help of sodium amino acid co-transport. We reabsorb bicarbonate here, right? We reabsorb a lot of water as well in case of proximal convoluted tubule. So proximal convoluted tubule is a site of major reabsorption, right? After that also reabsorption continues beyond that. Like we are reabsorbing water through ENaC channels and also with the help of the aquaporin 2 under the influence of ADH in the collecting ducts. So can I say that reabsorption occurs in tubules, filtration occurs in glomeruli? So if I damage the tubules, first thing I notice is I will not be able to reabsorb. So I start losing water, resulting in polyuria. So tubular injury can lead to polyuria instead of anuria. Second, I start losing the substances that are supposed to be reabsorbed. Like I lose glucose in urine, I can lose amino acid, I can lose bicarbonate. I can also lose sodium because sodium absorption is occurring in the tubules. And if I'm having tubular injury, wherever we are supposed to have sodium absorption, it is all impaired. So I start losing more sodium in urine. So whenever you have acute tubular necrosis, it is associated with increased water and sodium loss, because absorption is primarily occurring in the tubules and you're not able to absorb now because tubules are damaged, resulting in relatively dilute urine because a lot of water is being lost, but with relatively higher sodium content, higher sodium in urine. This is the basic that we need to be aware. So shall we put a table and differentiate? So in case of pre-renal AKI, if I look at the urine specific gravity and urine osmolality, because in pre-renal we are reabsorbing most of the water, leaving behind concentrated urine, the urine specific gravity and urine osmolality will be increased. In acute tubular necrosis, you are not able to reabsorb sodium, you are not able to reabsorb water, you are excreting dilute urine. So urine specific gravity will be less and your urine osmolality will be less. Okay. Then the best investigation to differentiate between pre-renal AKI and acute tubular necrosis is FeNA, fractional excretion of sodium. Now, what is fractional excretion of sodium? In simple words, the amount of sodium that is delivered to the kidneys versus the amount of sodium excreted. If I deliver 100 molecules of sodium to the kidneys, they get filtered, right? All 100 molecules of sodium are filtered in the glomerular filtrate, but then at regular locations, I reabsorb sodium. Generally, how much I excrete out? Generally, we excrete 1 to 2% of sodium. Most of the other sodium is reabsorbed. But if I have pre-renal AKI, I will increase the reabsorption of sodium and the amount of sodium excreted becomes less than 1%. And in case of tubular necrosis, normally 1 to 2% we are reabsorbing. I will not be able to reabsorb even that much. So I lose more than 2%. So if the fractional excretion of sodium is less than 1%, that means you are reabsorbing most of the sodium. In that case, your ENaC is overactive and you think about pre-renal AKI. But if the FeNA is more than 2%, then you're not able to reabsorb the normal amount of sodium, you're losing it in urine, and then you think about acute tubular necrosis. Okay. Beyond that, we can also look at the casts in urine. Pre-renal AKI will have the normal casts, which are hyaline casts. But in case of acute tubular necrosis, you will have renal tubular epithelial cell casts and muddy brown casts. Muddy brown cast. For example, there's a patient who had shock. After that, he was brought to the hospital. In the hospital, his creatinine was 2.4 milligrams per deciliter. Previous value is 1. So clearly there is a jump. So you know it is AKI. And then when urine routine is checked, because from the history point of view, I would think about pre-renal AKI because patient was in shock. But when urine routine report arrived, we see renal tubular epithelial cell cast and muddy brown cast. So then in that case, my diagnosis becomes acute tubular necrosis. So probably she had pre-renal AKI, and because of the reduced renal perfusion, eventually tubules are necrosed. What started as pre-renal AKI has now ended up with acute tubular necrosis. If they're asking you single most important investigation to differentiate between pre-renal AKI versus acute tubular necrosis, your answer is going to be fractional excretion of sodium. Normally 1 to 2% of sodium is only excreted, remaining sodium is reabsorbed. But whenever ENaC is overactive, aldosterone is more, we absorb even more than 99%, leaving behind less than 1% for excretion. But if tubules are damaged, we are excreting more than 2%. Okay. So that's about the pre-renal versus renal AKI. Now the next topic we are addressing is chronic kidney disease or CKD. What is CKD? CKD is defined as abnormal renal function test in the form of elevated creatinine or in the form of decreased urine output persisting for more than or equal to 3 months. More than or equal to 3 months. Some books, instead of blandly saying abnormal RFT, they mention the estimated GFR less than 60 ml per minute per 1.73 meter square body surface area. Persisting for a period of 3 months or more, we'll call it as CKD. Now, what can cause the CKD? Worldwide, the most common cause for CKD is diabetic nephropathy. India also, the most common cause for CKD is diabetic nephropathy. Now, how common it is? It accounts for more than 2/3 of all cases of CKD. So if you go to a nephrology ward today and see how many patients are going through dialysis, you will find that almost close to all of them, like 80-90% of them have landed up on dialysis table because of diabetic nephropathy. Okay. The second most common cause for CKD is going to be hypertensive nephropathy. So please remember, even CKD causes hypertension. Hypertension can cause CKD. Hypertensive nephropathy is the second most common cause. The other causes are all your chronic glomerulonephritic disorders, chronic glomerulonephritis, that includes some forms of chronic IgA nephropathy, membranous nephropathy, membranoproliferative glomerulonephritis, focal segmental glomerulosclerosis, all of them. Okay. Then, apart from that, the patients with polycystic kidney disease and some other inherited renal disorders, they account for a very tiny number of patients developing CKD. Otherwise, majority of them have CKD either because of diabetic nephropathy or hypertensive nephropathy. Now, what happens in CKD? In patients with CKD, there is number of nephrons decreasing because functional nephrons, some of them are getting damaged, so they are becoming dysfunctional. So with the progression of time, the number of functional nephrons decreasing, and because of that, the GFR is progressively decreasing. Second, the underlying pathophysiology might also lead to damage to the glomerular filtration barrier, and you start losing proteins in the urine. So two things are happening in CKD. One, there is decrease in GFR resulting in accumulation of all the nitrogenous waste like urea, creatinine, and there is development of loss of protein in urine or albuminuria. So these are the major changes we are seeing in patients with CKD. That's why for staging CKD, we are using the same parameters. What is happening with GFR and what is happening with this urine protein. Based on that, we stage the patients with CKD. And by looking at the GFR, we assign G number to the patient, and by looking at the albuminuria or proteinuria, we assign A number to the patient. And each patient of CKD will get one G and one A number. For example, someone may be labeled as having G2A1. So that means with respect to his GFR, he is at G2 stage. With respect to albuminuria, he is at A1 stage. Blandly, if someone says it is second stage of CKD, then it is mostly addressing the GFR part, not the albuminuria part. Okay. Now, how do I assign the glomerular GFR stage and how do I assign the albuminuria stage? Normal GFR. Can anybody tell me what's the normal GFR? Normal GFR is approximately 120 ml per minute per 1.73 meter square body surface area at age 20 to 30 years of age. But with age itself, progressively GFR declines. GFR decreases with age. That's a natural phenomenon. But patients with diabetic nephropathy or hypertensive nephropathy or chronic glomerulonephritis, they have more faster decline in GFR. Okay. So as long as your GFR is close to the normal, which is 90 or above, we'll say that patient has got G1 stage of GFR. Okay, and if it is between 60 to 89, then it is G2. There is mild decrease in GFR. Less than 60, there is a significant drop in GFR, and less than 60, the G3 stage is further divided into G3A and G3B. So 45 to 59, it is G3A, and 30 to 44, it is G3B. And then when it is less than 30, means 29 to as low as 15, we will call it as G4. Okay, and if it is less than 15 ml per minute per 1.73 meter square body area, then we will call it as G5. And also remember, any patient started on dialysis, just like AKI, any patient you start on dialysis for AKI, you will call it as stage 3. Similarly, while staging the CKD also, any patient on dialysis will be considered as stage 5, irrespective of estimated GFR. If he required dialysis, he is stage 5. This is GFR wise. Then albuminuria, if the patient is excreting less than 30 milligrams per day of albumin in urine, then it will be called as A1. If it is 30 to 300 milligrams per day, then A2. And if it is more than 300 milligrams per day, then we will call it as A3. So let's do an exercise and see if we can assign the GFR stage to a patient. Okay, so let's take an example. The person's GFR is estimated GFR using the CKD EPI equation is going to be 70 ml per minute per 1.73 meter square body surface area. And though I could not get the 24-hour urine albumin measured, I have measured the urine albumin creat ratio, which shows that patient is excreting 150 milligrams of albumin per gram. So now tell me which stage of CKD this patient belongs to. First, you have to assign a G category. For G category, I have to look at the GFR. 90 or more than 90, it is G1. 60 to 89, it is G2. And this patient is in that range, 60 to 89. So that means GFR wise, he is G2 or stage 2 of CKD in common terminology. But when I look at the albuminuria, less than 30 milligrams per gram, then it is going to be A1. 30 to 300 A2, and that is what this patient is at. So albuminuria wise also he is stage A2. So this patient's CKD stage will be reported as G2A2. The moment you see you say G2A2, other consultant will get to know, oh, GFR will be in the range of 60 to 89 and proteinuria will be in the range of 30 to 300 milligrams per day. So that clearly tells what is the patient's current situation to another consultant or fellow doctors. This is our KDIGO staging of CKD. Now we know the common causes. The most common cause is diabetic nephropathy followed by hypertensive nephropathy. Staging, because in CKD there is GFR decline and albuminuria, we are taking both into account for staging. Now what complications CKD can lead to and how do we manage them? Kidneys play an essentially important role in elimination of nitrogenous waste like urea, creatinine. They start accumulating in the body. So we call that phenomenon as azotemia, right, or uremia. So increased blood urea nitrogen, increased blood urea nitrogen. The second problem is kidneys are playing an important role in acid-base regulation, base reabsorption, that is bicarbonate reabsorption in proximal convoluted tubule, and H+ excretion in distal convoluted tubule is the function of kidney. And when they are damaged, will not be able to get this done. So in that case, I will end up with metabolic acidosis. Problem is in kidney, and main problem is acid I am not able to excrete, base I am not able to reabsorb. So I am losing base but retaining acid. So I am developing metabolic acidosis. The second problem we can get is metabolic acidosis. Then the third problem I can get is kidneys play an extremely important role in regulating the potassium values. Whatever excess potassium that comes to our body through the diet is excreted by the kidneys. But if I have dysfunction, I will not be able to excrete excess potassium. I start retaining potassium and I end up developing what we call as hyperkalemia. So we can also have hyperkalemia. Fourth, whatever excess fluid that gets into human body either by drinking or whatever other mechanism has to be eliminated by kidneys. But if kidneys are dysfunctional, we will start retaining the fluid, so we'll have fluid overload. Okay. Kidneys also play an extremely important role in regulation of calcium homeostasis and bone and mineral metabolism, and they will be affected, resulting in what you call as CKD related mineral bone disease. Okay. And last but not the least, kidneys also play an important role. Okay. Uremia, metabolic acidosis, hyperkalemia, fluid overload, CKD related mineral bone disease. What other complications we can expect in CKD patients? One of the very, very common complications. Yes, the erythropoietin production is a function of kidneys, and if they are dysfunctional, erythropoietin production decreases, resulting in what you call as anemia of CKD, anemia of chronic kidney disease. Okay. Now, uremia itself can lead to various complications. Uremia is an osmotically active substance. It can lead to dehydration of the brain tissue, resulting in what you call as uremic encephalopathy. Because when the blood urea level is high, blood is having more osmotically active substances. So it drags the water from the tissues, including the water from the neurons, making the neurons get dehydrated, dysfunctional, and end up with uremic encephalopathy. High urea levels can also cause uremic pericarditis. Uremic pericarditis. And high urea levels can also cause hemolysis. You might be aware about hemolytic uremic syndrome. Okay. Then high urea levels can also cause what is called as uremic gastropathy. Now, what happens in uremic gastropathy? Patients will have severe intractable nausea and vomiting. So much so that there will be development of aversion to food. They literally start hating the food because they know they try to eat, they'll have intense nausea, vomiting, they will puke, and that is a very uncomfortable experience. Okay. Then metabolic acidosis, we already know it is going to be high anion gap metabolic acidosis. Why is this occurring? Because there is decreased bicarbonate absorption in PCT. There is decreased H plus excretion in DCT, plus there is also accumulation of other substances. What are the other substances we are talking about? Like sulfates and phosphates. And these sulfates and phosphates are responsible for the high anion gap that we see here. High anion gap we see in patients with CKD. Okay. Hyperkalemia, we know why we are getting into it. Fluid overload, we know why we are getting into it. Anemia of CKD is mainly due to erythropoietin deficiency. That is the main cause. There are other contributory pathophysiological changes occurring here, but the main cause is erythropoietin deficiency. Theoretically, anemia of CKD should be normocytic normochromic. But in reality, we don't get to see normocytic normochromic that often because anemia in CKD gets complicated by iron deficiency. Why are they developing iron deficiency? Number one, CKD is a chronic inflammatory state. They will have increased interleukin 1, interleukin 6 production, and these inhibit iron absorption. Okay, that is first. Second, the uremia leads to severe reduction in appetite, so their food consumption and thus iron consumption, nutrients consumption all decreases, so that also contributes to iron deficiency. So in reality, what we see is erythropoietin deficiency plus iron deficiency. Theoretically, it's mainly erythropoietin deficiency. That's why whenever we have to treat anemia in CKD, first we have to fill the iron deficiency, and after that we have to start with the erythropoietin therapy. So now we are aware of the main complications. Let's talk about the management of CKD. So if I have uremia, how can I manage uremic symptoms? How do I manage fluid overload? If I have fluid overload, that can be managed by diuretics. Mainly, we will require high ceiling or loop diuretics. and we can also put the patient on fluid restriction, tell them not to drink too much of fluids. Okay, then if I have hyperkalemia, how do we treat? We can treat them by dietary potassium restriction, and then we can give potassium binders, potassium binding resins like kyaxalate, which binds to whatever potassium that is coming from the food in the intestine and takes it away in stool, prevents it from getting absorbed. Okay, then to protect heart from the hyperkalemic impact, we can give IV calcium gluconate, and then we can give IV dextrose plus insulin, which actually shifts the potassium from extracellular compartment to intracellular compartment. So we have ways to manage hyperkalemia in a patient with CKD. Okay, then when it comes to metabolic acidosis, if I'm developing metabolic acidosis because of CKD, my first line treatment is by giving bicarbonate, right? We can give sodium bicarbonate supplementation to get the pH normalized. Okay, and if I'm developing anemia of CKD, my initial step is first iron replacement if there is deficiency, followed by erythropoietin therapy. Either you can use the regular recombinant erythropoietin or a new modified erythropoietin called darbepoetin alpha, which is relatively longer acting, allowing less frequent dosing. Okay, now the question is, what about uremia? If uremia is symptomatic, there is no way you can manage them conservatively. If uremia is symptomatic, the urea can come out from the body only through dialysis. There is no drug which reduces the urea levels. So if the urea is symptomatic, you have to go ahead with dialysis. So all these fluid overload, hyperkalemia, metabolic acidosis and anemia, these all are considered as relative indications for dialysis. You first try with conventional non-dialysis measures, like you restrict the fluid, you give diuretics, still not able to get the fluid load normalized, then you go for dialysis. You restrict the dietary potassium, you give potassium binders, calcium gluconate, dextrose, still you are not able to normalize potassium, then you go for dialysis. But if the uremic symptoms are there, you have to go ahead with dialysis. Uremic pericarditis, uremic encephalopathy, no choice. Dialysis is the only choice. That's why we consider uremic symptoms as the absolute. Uremic symptoms are the absolute indications for dialysis. Okay, so if there's an MCQ asking you what's an absolute indication for dialysis, anything that is complicated by uremia. Everything else is a relative indication. Okay, so that completes our CKD as well. Now let's progress to some important rheumatology topics. In the rheumatology, what are the important topics? Majority of the questions actually come from SLE. Some questions also come from rheumatoid arthritis, which is more or less image-based questions from your orthopedics. All those deformities, just deformity, swan neck deformity, ulnar deviation, those are the kind of questions you get. SLE, mostly what kind of questions you are getting? Antibodies and their clinical correlation, or lupus nephritis management, or some image-based questions about the lupus rashes, or sometimes clinical vignettes asking you to identify that this patient is having SLE. Beyond that, recent trends, there are questions appearing from Sjogren's syndrome, mixed connective tissue disorder, some questions asking you to recognize Bessay syndrome. Those are the standard templates. But if they are asking two questions from rheumatology, one will be from SLE. Right? That's why we'll focus more on the SLE. Okay. Now in SLE, we know it is an autoimmune disorder, and it is mainly an antibody mediated autoimmune disorder. The antibodies form complexes with antigen, and those immune complexes are getting deposited in the tissues, triggering the tissue inflammation. So whatever manifestations we see in SLE are because of immune complex deposition. What is the composition of immune complex? Our body's own antigen, antibody produced by our own body against that antigen. They form the complex, they get deposited in the tissues, and when they get deposited in the tissues, there will also be complement deposition. complement plus antigen antibody complexes are getting deposited in the tissues. Okay, now the tissue inflammation that we see here is primarily mediated by interferon 1. The main cytokine responsible for triggering the tissue inflammation is going to be interferon 1, more precisely interferon 1 gamma. This is a principal cytokine. In case of rheumatoid arthritis, the principal cytokine is going to be TNF alpha. In case of systemic sclerosis, or what you call as scleroderma, in case of systemic sclerosis or scleroderma, the main cytokine responsible for all the organ inflammation and scarring and fibrosis is going to be transforming growth factor beta. So later, when you learn about the management of these rheumatological disorders, you will come across drugs targeting these inflammatory cytokines. Like in case of rheumatoid arthritis, because TNF alpha is playing a major role, we use anti-TNF alpha drugs like infliximab, adalimumab, golimumab. And in case of SLE, we can use drugs targeting interferon 1. We do have drugs targeting interferon 1. We'll talk about it later. Now, what are the most common organ manifestations that I can get because of immune complex deposition, complement activation, and production of interferon gamma? Okay, the overall most common manifestation is going to be malar rash. Malar rash is the overall most common manifestation, right? And that is also the most common dermatological manifestation. But SLE is a multi-system disorder. Skin is only one of the targeted organ, right? What other manifestation I can expect? If I talk about the cardiovascular system, the most common manifestation of serious involvement is going to be pericarditis. Pericarditis is the most common manifestation. Okay. Apart from pericarditis, these patients can have endocarditis, and endocarditis caused by SLE is sterile. There is no infection. It is the inflammatory cascade which is activated is responsible for the endocardial inflammation without infection. This kind of endocarditis is called as Liebman-Sachs endocarditis. Liebman-Sachs endocarditis. Okay. This can also cause myocarditis. So can I say that SLE causes pancarditis? Yes, SLE can cause pancarditis. What is most common manifestation? It is pericarditis. In fact, you can say most common organ manifestations of SLE are related to serositis, means these serosal layers, pleural layer, peritoneal layer, the pericardial layer, they are being targeted by the inflammatory cytokines. So pericarditis is the most common cardiovascular manifestation. Pleuritis is the most common respiratory manifestation. Okay. Then with respect to CNS, you know what is the most common manifestation? It can lead to brain fog. Brain fog is basically a form of cognitive dysfunction. What is brain fog? Suddenly getting a blank sensation, right? You're not able to progress the thought process. You're thinking something and then you're totally out of thought. You're not able to think at all. That's what we call as brain fog. And that's very common in SLE patients because all these inflammatory cytokines that are produced in SLE, they also cause neuronal damage. Okay, so they can present with brain fog. That's the most common CNS manifestation. Apart from that, they can also develop depression and even psychosis. Depression and psychosis. If we talk about the musculoskeletal manifestations, then SLE can cause polyarthritis, which is very similar to rheumatoid arthritis, means it produces inflammatory polyarthritis. Inflammatory polyarthritis. Poly means of course more than 4 joints being affected, and it is inflammatory. It will be associated with involvement of small joints more than large joints. Same as rheumatoid arthritis. Okay. It will be affecting upper limb joints more than lower limb joints, same as rheumatoid arthritis. So then what is the difference between polyarthritis of rheumatoid arthritis and SLE? Both are inflammatory polyarthritis, and being inflammatory, this will also be associated with early morning stiffness. So SLE patients also complain of early morning stiffness lasting for more than or equal to 1 hour. Yes, the inflammatory arthritis of rheumatoid arthritis is erosive. That's why you get the true joint deformities. While in the SLE, it is non-erosive. So you don't get true joint deformities. Thus, there will be no true joint deformities. In case of rheumatoid arthritis, you're certainly aware of all the deformities that we know, right? Here you don't get any true joint deformities. Soft tissue weakness might give rise to some deformities, but they're because of the laxity of the tendons and all. The joints are not eroded, so you can easily reduce those deformities. Such deformities are called as Jacquard's arthropathy. No need to remember that. Okay. Then there can also be renal involvement. And what is the renal manifestation? The renal manifestation is in the form of what you call as lupus nephritis. Lupus nephritis. Now there can be a question asking you, what is the most common cause for death in SLE? The most common cause for death in SLE right now is coronary artery disease, followed by lupus nephritis. Once upon a time, lupus nephritis was the leading cause for death, but now that we have treatment available, we are able to manage a large number of cases of lupus nephritis, and transplantation is also a choice. It is no longer the leading cause for death. But SLE being a chronic autoimmune inflammatory disorder, inflammatory cytokines increase the risk of endothelial injury, thus the chance of forming a clots inside the blood vessel increases. So they are at higher risk of developing ischemic heart disease in comparison to general population, and right now that is the leading cause for death. Okay. So now, if I forgot to mention the epidemiology, right? If you look at the epidemiology of SLE, we know it is more common in females than males. How common it is? With a ratio of almost 9:1, and age wise it typically affects reproductive age group. Means females in their 20s and 30s are the most vulnerable group for developing SLE, reproductive age group. So if there is a question which is saying that a 20-year-old or a 25-year-old female presented with photosensitive malar rash, this malar rash worsens with sun exposure and gets better with sunscreen or avoiding the sun exposure, then it is photosensitive malar rash, which characteristically spares the nasolabial fold. That story, along with organ manifestations like either having chest pain due to pericarditis or proteinuria due to lupus nephritis, or complaining of brain fog due to CNS involvement, then you start thinking about SLE. Okay. Now, when it comes to diagnosis of SLE, you can diagnose a case as having SLE if you have clinical features and antibodies positive. But the classification criteria is different. Classification criteria is used for classifying the cases for recruitment into clinical trial. And for that, we are using American College of Rheumatology and European League Against Rheumatological Disorders, ACR-EULAR criteria for classification of a case as SLE. According to that criteria, will need an entry criteria to be satisfied. And what is that entry criteria? The entry criteria is going to be mainly ANA positivity, right? ANA should be positive with a titer of more than 1:80, more than or equal to 1:80. If you use a titer of 1:40, 5% of the general population will be positive. And the ANA positivity has to be using the standard ANA assay. What is the standard ANA test that we are going to follow here? Which method I should use for estimation of ANA? Any other method used, the numbers are not reliable, so it can't be considered as an entry criteria. Yes, we are using indirect immunofluorescence. Indirect immunofluorescence. And for that, we are using Hep2 cell lines. Hep2 cell lines, using Hep2 cell lines. If the ANA is positive, then we will assess the patient on lab and clinical score, right? So then we will look at the score. And if the score is more than or equal to 10, then you will classify the case as SLE. Classify as SLE. Point to note here, out of the score that we are talking about, at least 1 point, because in the scoring pattern, there are scores given for clinical features like fever, malar rash, arthritis, CNS manifestations, lupus nephritis. There are scores given for clinical manifestations and scores given for laboratory features like anti-DS DNA positivity. So if I get all the 10 points from the lab only, then it is not SLE. At least one of the 10 points should come from, at least 1 point should come from clinical domain. At least 1 point from clinical domain. Now, do I need to remember what all components are there in the clinical domain? Absolutely no. In last 4 or 5 years, there is no direct question asking you which of the components are used in the classification criteria. All they might ask is about what is currently considered as entry criteria, what is the method of assessing ANA for classifying the case, and how much score is required, and out of that how many points should be from clinical domain. So with that, the case can be classified as SLE. Once you diagnose it as SLE, when we talk about the management, we already know that there is a one major cytokine responsible for organ injury, which is going to be interferon 1 gamma. So we can target that, but it's not required for all patients, right? All patients do not have severe organ manifestations. So if there is mild case, our first line therapy is going to be in the form of hydroxychloroquine, HCQS, right? This is considered as the standard therapy, or many books consider it as blanket therapy. Until and unless there is contraindication to hydroxychloroquine, you will give hydroxychloroquine to all patients with SLE, right? If no contraindications for hydroxychloroquine. Now, what are the contraindications for hydroxychloroquine? Number one, hydroxychloroquine itself can cause retinopathy if you already have retinal disorders for whatever reason. Then exposing you to more retinal toxic drugs is not safe, so we will not give. Second, if there is prolonged QT interval, hydroxychloroquine prolongs the QT interval, and if you already have QTC prolongation, then the risk of developing Torsades de Pointes is high, so we avoid. Otherwise, we give hydroxychloroquine for all patients. The second line agents, when hydroxychloroquine is not able to help achieve the disease control, then we think of using corticosteroids, okay, immunosuppressants, okay, and within the immunosuppressants, we have two important drugs to note here. One is called as belimumab. The second one is anifrolumab. Belimumab is a inhibitor of B lymphocyte stimulant. Remember, all the antibodies that we speak about in SLE are coming from B lymphocytes, and B lymphocytes require a factor called BAF or B-Lys for their proliferation and sustenance. If I block it, B lymphocyte activity comes down, active B lymphocyte number comes down, so antibody production also comes down. So belimumab is one such drug. Then anifrolumab is a monoclonal antibody against interferon 1. So this is anti-IFN1 monoclonal antibody. We already know interferon 1 is the principal cytokine involved in pathogenesis of SLE. So if I could block it, I can minimize the organ injury, right? So both of these are potential MCQs. What is the mechanism of action of belimumab, and what is the mechanism of action of anifrolumab? Okay, that's about the basic management of SLE. But as I've already told you, majority of the questions are going to be about antibodies and their correlations in SLE. The first question is going to be, what is the most common antibody in SLE? The most common antibody is also the most sensitive antibody. Most common and most sensitive antibody is going to be ANA. But it is not specific, right? It is lacking the specific, so we only use it as an entry criteria or a screening test, not for the confirmation of SLE. The next question is, what is the second most common antibody and what is the second most sensitive antibody? The answer for both of them is same. The second most common antibody as well as the second most specific antibody is going to be anti-double stranded DNA antibodies. and being highly specific and also quite common. They are the preferred antibodies for diagnostic confirmation of SLE. ANA is not specific, so you can't use it as a confirmatory test, but anti-DS-DNA can be considered as a reasonable test for confirmation. And not just the specificity, another thing is anti-DS-DNA correlates with the disease activity. Like let us say ANA titers when I diagnose SLE was 1:160. Okay. Later I notice its titer has increased. Okay. It has become 1:320. So in that case, is the SLE disease activity worsening or getting better? The answer is we can't say about it, because ANA titers do not correlate with disease activity. So all we do is use ANA for initial screening. Once the diagnosis of SLE is done, we never recheck ANA. There is no point in rechecking the ANA again, right? Because ANA does not correlate with disease activity. But anti-DS-DNA is not only highly specific, quite sensitive, it is also correlating with disease activity. Correlates with disease activity. So if the anti-DS-DNA titer is high, that means your SLE disease is more active. If anti-DS-DNA titer is low, disease is less active. So tomorrow, if I have to prove that this patient of SLE is in remission, I have to prove that the anti-DS-DNA titers are very low. Because lower the titers, lower is the disease activity. Okay. Apart from that, anti-DS-DNA titers also correlate with risk of lupus nephritis. Higher the anti-DS-DNA titers, higher the chance of kidney involvement. Lower the titers, lower the chance of kidney involvement. So if tomorrow suddenly my anti-DS-DNA titers start shooting up, then I know my kidney is getting under threat. So if you ask me, the single most important antibody in SLE is going to be anti-DS-DNA antibody. Okay. Now what is the method used for estimation of anti-DS-DNA titer? For ANA, we followed indirect immunofluorescence, and for that we used Hep2 cell lines. For the anti-DS-DNA estimation, we are following Cryptidia immunofluorescence. Cryptidia immunofluorescence. Okay. Next antibody of relevance is going to be our anti-Smith antibodies. Anti-DS-DNA antibodies are the second most specific. The most specific antibody is going to be anti-Smith antibody. But it is not very common. If it is there, you know it is SLE, but its absence doesn't rule out because it lacks the sensitivity. Okay. And sometimes drugs can induce SLE. Drug-induced SLE is characterized by anti-histone antibodies. Anti-histone antibodies. So if you have anti-histone antibodies and you have SLE features, then you're mostly having drug-induced SLE. And remember, drug-induced SLE is reversible. If you withdraw the drug, SLE resolves in most cases. So if I find anti-histone antibodies in a patient where I have made a clinical diagnosis of SLE, I should be happy, because then I figure out which drug is responsible, withdraw it, then eventually his SLE will resolve. On the other hand, if I don't have anti-histone antibodies, rather I have anti-DS-DNA antibodies, anti-Smith, then it is not drug induced. So in that case, the complete remission may be very challenging. Okay. Then another antibody we have to remember is your anti-SSA antibodies. Anti-SSA antibodies are associated with increased risk of neonatal lupus. Increased risk of neonatal lupus. And at the same time, this antibody presence also correlates with risk of subacute cutaneous lupus. So malar rash is not the only rash we get. We get subacute cutaneous lupus as well as discoid lupus erythematosus in patients with SLE. And the risk of developing subacute cutaneous lupus erythematosus or SCLE is higher if you have anti-SSA or anti-Rho antibodies. Okay. So these are some antibody and correlations that you need to be aware about. Okay, so that completes our SLE. Rheumatoid arthritis, I am leaving it to orthopedics faculty to address. I will take you through next important rheumatology chapter, which is scleroderma. Okay, what is scleroderma? It is also a rheumatological disorder where the principal cytokine is going to be transforming growth factor beta. Principal cytokine is going to be transforming growth factor beta, and transforming growth factor beta has a tendency to trigger inflammation and activate fibroblasts. And because the transforming growth factor beta activates fibroblasts, there will be organ fibrosis and vasculitis. Vasculitis here is primarily small vessel vasculitis. So you will have small vessel vasculitis plus organ fibrosis. And when I say organ fibrosis, that includes skin as well, because you have overactivity of fibroblasts under the influence of transforming growth factor beta. So that will result in skin thickening because of skin fibrosis, plus there is organ fibrosis because of fibroblast activity, and collectively this condition where your skin thickening and organ fibrosis, you call it as systemic sclerosis. Systemic sclerosis. Why are we calling it a systemic sclerosis? Because it's not only about skin thickening, it's also about the fibrosis of organs. So whole systems are getting fibrosed. Principal cytokine we know, so we know it is an autoimmune disorder, and there are two types of scleroderma, and this type classification is actually based on the extent of skin involvement. Okay, so if I have two patients of scleroderma, okay, if I have two patients of scleroderma, in one the skin fibrosis is restricted to elbow or distal to elbow, and in the lower limb it is restricted to the knee joints and distal to it, then we will call it as limited cutaneous. Means skin thickness is elbow and beyond in the upper limb and knee joint and beyond in the lower limb, not proximal to that, then we will call it as limited cutaneous scleroderma. But if the skin thickness extends proximal to elbow joint in the upper limb or extends proximal to the knee joint in the lower limb, then we will call it as diffuse cutaneous scleroderma. In both cases, there will be involvement of face skin. There will be fibrosis of facial skin plus the skin of the upper limb extending max up to elbow, lower limb max up to knee joint. It is limited cutaneous. But if it extends proximal to it, then it is diffuse cutaneous. Now it's not just about the extent of skin involvement. The underlying disease has a totally different behavior, because in limited cutaneous you get this antibody called anti-centromere antibody. That's the typical antibody of limited cutaneous, while in case of diffuse cutaneous you get anti-scleroderma 70 antibody, which is also called as anti-DNA topoisomerase antibody. Okay, now what other differences I get beyond the antibody? I told you that transforming growth factor beta stimulates vasculitis and organ fibrosis. If the organ fibrosis part is more dominant, then it becomes diffuse cutaneous variant, and if the vasculitis part is more dominant, then it becomes limited cutaneous. When you think about limited cutaneous, think about blood vessel. When you think about the diffuse cutaneous, think about organ. So now tell me what manifestations I can get in case of limited cutaneous. So limited cutaneous patients will predominantly have Raynaud's phenomenon. These patients will have Raynaud's phenomenon, profound vasculitis, small muscle vasculitis. So they will have Raynaud's phenomenon. They will also have fingertip ulcers because of the Raynaud's phenomenon. Yes, fingertip ulcers, critical limb ischemia. They will have calcinosis cutis, calcification of the skin. Okay. Then they will have increased risk of pulmonary hypertension. Pulmonary hypertension. This is very, very important, because again, simple thing. If it is limited cutaneous, think about blood vessel. Pulmonary hypertension is more common here. Raynaud's phenomenon is more profound here. Fingertip ulcers or critical digital ischemias are more common here. But when we think about diffuse cutaneous, in diffuse cutaneous variants, you may have Raynaud's phenomenon, but then it is going to be mild. So you don't get to see many of these patients presenting with ulcers of the fingertips. Whatever vasoconstriction is occurring is mild. Here, severe vasoconstriction resulting in ulcers of the fingertips. Okay. Apart from that, these patients will have increased risk of interstitial lung disease, because interstitial lung disease is nothing but lung fibrosis, right? The NSIP type of interstitial lung disease is more common here. And then involvement of kidneys resulting in what you call as scleroderma renal crisis is more common in patients with diffuse cutaneous. So the best way to remember is, you think about organs, you think about diffuse cutaneous. You think about blood vessels, you think about limited cutaneous. And then they will ask you about antibodies. Antibodies are also not very difficult to remember. Remember, the centromere is present in the chromosome, in the center of the chromosome, and it is visible only in selected phases of cell cycle. Centromere is not always visible, and centromere is present only inside the nucleus, not outside. So we can say that centromere has limited presence inside the cell. It's restricted to nucleus. So in limited cutaneous, you get anti-centromere antibody. Centromere has limited presence, while DNA has more diffuse presence in the cell. Because if you talk about the cell, inside the nucleus you will have DNA, but outside also there are mitochondria in which DNA will be there. So DNA has more diffuse presence. So that way, anti-DNA topoisomerase antibodies are seen in diffuse cutaneous. Or you can also think of D for D. In diffuse, you have DNA topoisomerase antibody. Right? In limited, you have anti-centromere antibodies. Sometimes the questions are framed in a way that if you have a patient with scleroderma and he is positive for anti-centromere antibody, which of the following complication is more common in this patient? One option is ILD, second is scleroderma renal crisis, third one is pulmonary hypertension. What should be your answer? Pulmonary hypertension. Similar question, but then patient is positive for anti-SCL70 antibody, then diagnosis becomes diffuse cutaneous. So in that case, these patients are more likely to have ILD or renal crisis, right? So that's it about the basic topics from I am not carrying the images, but if you want, I'll certainly share the immunofluorescence images for all the rheumatological disorders, and maybe if we get time we can discuss it on another schedule. Okay, so now we are just left with few topics from pulmonology. Mainly questions in pulmonology are going to be about PFT interpretation and asthma and COPD. First, let's talk about the PFT interpretation before we talk about asthma and COPD. So PFT is useful because it helps us to differentiate between the obstructive and restrictive disorders. And what am I interested in looking at PFT? I'm interested in looking at FEV1 by FVC ratio. If FEV1 by FVC ratio is more than 0.7, there is no obstruction. There is no obstruction. But if the ratio is less than 0.7, there is clearly airway obstruction. So you are having obstructive disorder. If the ratio is more than 0.7, there is no obstruction. That does not rule out restriction. So if the ratio is more than 0.7, then I should see what is happening to FVC. If FVC is decreased, that means there is restrictive disorder present. There is restrictive disorder present. But if FVC is also normal, that means neither ratio is decreased nor FVC is decreased. In that case, you can say no major respiratory disorder. Okay. And if you're dealing with obstructive disorder, you have three major differential diagnoses. For restrictive disorders, you can have restriction from outside the lungs, restriction from inside the lungs. So you can have intrapulmonary restrictive disorders and extrapulmonary restrictive disorders. In case of the extrapulmonary restriction, what can restrict the lung expansion? Mainly pleural effusion, pneumothorax and chest wall deformities, right? So if you have pneumothorax, the air that is accumulating in the pleural space is not allowing the lungs to expand. It is restricting the lung filling. Or if you have pleural effusion, the fluid is restricting. Or if you have, let us say, severe kyphoscoliosis, the chest wall deformity is restricting. These are extrapulmonary restriction. What can restrict from within the lungs? The lung fibrosis, as in case of ILD. Pneumonia is also a restrictive disorder. Yeah, myasthenia gravis or musculoskeletal weakness. Musculoskeletal weakness including myasthenia gravis or organophosphate poisoning, where you have weakness of the respiratory muscles. Yes, they are all causes for extrapulmonary. ILD, pneumonia, typical examples for intrapulmonary restriction. If you're talking about obstructive disorders, we have COPD, asthma and bronchiectasis. At the very pathophysiology level, there are differences between them. Asthma is characterized by reversible obstruction because it is caused by bronchoconstriction. Dilated obstruction is relieved. In COPD, the airway narrowing is not fully reversible. In bronchiectasis, it is not fully reversible, right? So that's why what I do is, whenever I have obstructive disorder, I try to prove whether it is reversible or not. If I have restrictive disorder, next step is pretty simple. Get an lung or respiratory imaging done and it solves your problem. Because ILD can be detected on X-ray or HRCT. Pneumonia can be detected on X-ray, ultrasound or HRCT. Pneumothorax can be detected on X-ray, ultrasound or CT. Pleural effusion can be detected on X-ray, ultrasound or CT, and same with kyphoscoliosis. Myasthenia gravis, OP poisoning, they are quite apparent from the history itself. So diagnosing the restrictive disorders is not difficult, but differentiating asthma versus COPD is sometimes challenging. So what we do a test called as bronchodilator reversibility test. So in this test, we would already know patient's baseline FEV1, how much is his FEV1, because we have calculated this FEV1 for the calculation of this ratio. We know what is the baseline FEV1, and once we know the baseline FEV1, we will administer a short-acting beta agonist to the patient in the inhaled form, and we will check what is called as post bronchodilator FEV1. And if this post bronchodilator FEV1 increases by more than or equal to 12% from pre-bronchodilator or baseline FEV1 and by more than or equal to 200 ml. If that increase has occurred, that means there is reversible obstruction present, right? It is reversible obstruction, and for all practical purpose, if you have reversible obstruction, you think about asthma as the diagnosis. But if that much increase doesn't occur after administration of SABA, then you have persistent obstruction. And when you have persistent obstruction, you think about COPD or bronchiectasis. You think about COPD or bronchiectasis. So sometimes they've asked MCQs where they just give the baseline FEV1 and post bronchodilator FEV1, then they ask you to interpret whether it is showing reversible obstruction or persistent obstruction. 12% and 200 ml increase, reversible obstruction. Less than that increase, it is persistent obstruction. Okay, clear? Persistent obstruction, think about COPD as the most common cause, bronchiectasis less common. Reversible obstruction is always asthma. Restrictive disorders, image, and you will get to know whether you have pneumonia, pneumothorax or hydrothorax or ILD or other causes. So this is going to be our approach to the interpretation of PFT, right? So with that background, let's get into the first topic from the respiratory medicine, which is asthma. So how do I diagnose asthma? For the diagnosis of asthma, I am relying on FEV1 by FVC ratio that should be less than 0.7, indicating that there is obstructive disorder present. And then on bronchodilator reversibility test, there should be more than or equal to 12% and more than or equal to 200 ml increase in FEV1 after administration of a bronchodilator should occur. That indicates that you have reversible obstruction, and that confirms that you have asthma. Reversible obstruction is equal to asthma. So once the diagnosis of asthma is done, we can also make an attempt to identify whether we have type 2 asthma or non-type 2 asthma. So after the diagnosis is done, we mainly go for fractional exhalation of nitric oxide and absolute eosinophil count. If fractional exhalation of nitric oxide and absolute eosinophil count is increased, then it will be called as case of type 2 asthma. And if it is normal, means neither eosinophil count is increased nor FeNO is increased, then it is non-type 2 asthma. Non-type 2 asthma. So you can diagnose as well as typify it. Once we have diagnosed and typified, there comes the question of management of asthma. So for management of asthma, we are following the GINA guidelines, and right now we are following 2026 GINA guidelines. For all patients with asthma, our initial treatment will focus mainly on inhaled devices, inhaled bronchodilator and anti-inflammatory therapy. Only in difficult cases or advanced cases, we think about injectables or other therapies. But the first question is, which inhaler to start? How frequently to give? Should every patient receive daily inhalers, or selected patients will receive daily inhalers? So for that, we should be aware about the GINA stepwise guideline. And I'll give you the stepwise approach so that you can raise the answer in such questions. Whenever there is a question which is asking you to manage a case of asthma according to current GINA guidelines, first question you should ask is whether patient has daily asthma symptoms, means he is getting asthma attacks on daily basis. When I say daily, almost you can say more than or equal to 5 days a week he is getting asthma symptoms, or he is getting more than or equal to 1 nocturnal asthma symptom. Nocturnal asthma attack means he has to wake up in the night because of cough, shortness of breath per week. This is what I want to know from the patient's history. For both of these questions, if the answer is yes for any one of them, that means those patients require daily inhalers. And if the answer is no, then probably those patients do not require daily inhalers, because they're less frequent attack. Whenever there's an attack, they can take a inhaler. So if you're saying yes, these patients need what we call as MART. Now what is MART? MART stands for maintenance and reliever therapy. Means currently we use a combination of formoterol, which is a long acting beta agonist. So it can act as a preventive therapy when taken morning and evening, and because it is short acting, it is long acting but rapid onset of action. So when I take the inhaler readily, it helps me to relieve an attack also. So same medication can be used for prevention because it is long acting. Same medication can be used to relieve an attack because its onset of action is fast, right? So this is going to be my reliever plus maintenance medication. Along with that, as an anti-inflammatory agent, we are using steroid. So this combination of formoterol plus inhaled corticosteroid is called as MART. Maintenance and reliever both bundled into one drug. And when I say need MART, that means patient needs regular inhaler, plus whenever there's an attack, he will take an extra inhaler. But if the attack frequency is low, in that case there is no need for MART. Means he does not require maintenance therapy. So then how will I treat these patients? These patients will be treated as and when required. Formoterol, which is the preferred reliever medication, and whenever we give a reliever medication, it should always be accompanied by steroid. So same inhaler we are giving for these patients as well, but only when required, whenever they're going through asthma attack. If they don't have asthma attack at that time, on that day, they don't need to take the inhaler because it's less frequent for them. So it is like SOS, or as and when required, for these patients. But for these patients, they need MART, right? MART refers to maintenance, means daily inhaler use. Daily use. So if I'm giving MART, there are two things. Should I start with low dose combination of ICS and formoterol, or medium dose or high dose? We never start with high dose, but we rather start with low or medium. The decision to start with low or medium depends on patient's post bronchodilator FEV1. If after giving the bronchodilator, the FEV1 that we recorded during the initial bronchodilator reversibility test, if that was less than 30% of predicted value for that patient, the lung functions are low. Such cases, I cannot rely on starting with low dose MART. We'll start with medium dose combination of formoterol plus inhaled corticosteroid. Okay, that is going to be my treatment. But if the post bronchodilator FEV1 is more than 30% of the predicted value, the lung functions are, I'm not great, but reasonably okay. So in that case, the treatment will begin with low dose MART. Low dose MART. So the algorithm is simple. If the patient is getting at least 5 days a week, is bothered by asthma, or at least 1 night a week is bothered by asthma, that patient requires daily maintenance therapy. The maintenance therapy is now called MART, because reliever and maintenance inhaler is same. Attack also same treatment, morning, evening also same inhaler. But if less frequent attacks, like once or twice a week attacks, no night attacks, then they do not require a daily inhaler. Whenever there's an attack, they take the formoterol plus ICS 1 puff. But these patients take 1 puff morning, 1 puff evening, and in between, if there's an attack, they take an additional puff. Whether I start with low dose or medium dose is decided by the post bronchodilator FEV1. Once we start these medications, escalation follows a stepwise approach. Okay, so there is a hierarchy given in the GINA. Okay, so there is step 1 and step 2 combined in current GINA in the preferred track, and then we have step 3, we have step 4, and we have step 5. Okay, so what is there in the step 1 and step 2 combined? We basically have SOS, or as and when required, formoterol plus ICS inhaler. Step 3 is where we are starting the patient on low dose MART. Step 4 is where we are switching the patient to medium dose MART. Step 5, you can think of high dose maintenance renal therapy or biologicals. Now you might be confused. Sir, you said if less frequent attacks, we start with as and when required formo-ICS combination, and if frequent attacks, those patients need MART. In some of them, we start with low dose MART. In some of them, we start with medium dose, depending on their post bronchodilator FEV1. Right, that is our starting point. So according to this approach, some patients start their journey here, right? Then some patients start their journey here. Some patients start their treatment journey with the step 4. Nobody starts their treatment with step 5. Either you're starting with step 1, step 2 combined, that is as and when required formo-ICS, or low dose MART or medium dose MART. And whatever is your starting point, if there is no response, we always step to the next level. Like these patients, we have started them on formo-ICS combination and they're not responding now. So then I switch them to daily low dose MART. These patients who are now on daily low dose MART, either they started from here and come here, or directly started here, but they are now not responding. Then I escalate the treatment to step 4. Okay. Now whether I came to step 4 by passing through step 1, 3, then to 4, or I directly started with step 4, I'm not responding now. Then I have to escalate the treatment to step 5. Nobody is directly starting the step 5 treatment. And when we go to the step 5 treatment, One choice is using high dose MART, but then using higher dose of steroid is associated with increased risk of oral candidiasis. So we don't prefer. Instead, biologicals is what we prefer today. These are monoclonal antibodies. So now tell me what all monoclonal antibodies you are aware about. We have one anti-IgE monoclonal antibody which is called as omalizumab. It is called as omalizumab. Okay. Then we have one anti-interleukin 4 receptor antibody which is called as dupilumab. Dupilumab. Then we have anti-interleukin 5 antibodies. That includes mepolizumab, reslizumab, and reslizumab. And then one new antibody called anti-thymic stromal lymphopoietin antibody called tezepelumab. So we think about using these medications if patient is not responding to step 4 therapy. Yes, high dose MART is a choice and biologicals are a choice. Given a choice patient can afford, I will go ahead with biological instead of high dose MART because I'm worried about oral candidiasis with high doses of steroids. Okay, now what questions they will ask you? They will ask you which antibody is targeting which interleukin or target antigen. Like for example, omalizumab is anti-IgE. Now how do I remember them? Few things are easy to remember. The first and the easiest to remember is tezepelumab. It is anti-TSLP. T for T, easy to remember. Anti-TSLP monoclonal antibody is tezepelumab. Okay. The next easy to remember is dupilumab. D is the 4th letter in the alphabet and IL-4 is being targeted by dupilumab. Easy to remember. Omalizumab as anti-IgE is also easy to remember. Why? Because O and E both are vowels. A, E, I, O, U. So vowels are fighting against each other. That's how you remember omalizumab is anti-IgE. Whatever is remaining, they are all targeting interleukin 5. The mechanism of action is sorted. Now if I am starting here, which one to use? So remember, if you are having type 2 asthma, where you have high FeNO and high eosinophil count, you can use any of these. But if you are having non-type 2 asthma, only one is useful, which is tezepelumab. So point to note, all these can be used for type 2. Tezepelumab is the only one approved for non-type 2. So if there is an MCQ asking you which of the following monoclonal antibody can be used for treatment of asthma regardless of the type, what should be our answer? Our answer will be tezepelumab because I can use it for type 2 also. I can use it for non-type 2 also. But otherwise, omalizumab, dupilumab, mepolizumab, reslizumab, they are not to be used in non-type 2. They are only for type 2 asthma. Okay. So that completes our discussion on asthma. What questions we are expecting? Number one question, it's about diagnosis of asthma using the PFT data. Okay. Number two, deciding the initial treatment, whether MART is required or not, and if required, are you starting with low dose or medium dose? For that, just follow this protocol and you will land on the right answer. Third type of question, already on treatment, not responding, what is the next best step? So if they are on SOS Formo ICS, low dose MART is the next best step. If they are on low dose MART, medium dose MART is the next best step. If they are on medium dose MART, then high dose MART versus biologicals is the next best. Okay. So that concludes our asthma. Now let's talk about the COPD. Okay. What is COPD? COPD is the obstructive airway disorder, just like asthma. It's an obstructive airway disorder, just like asthma. But this is characterized by persistent obstruction, unlike your asthma cases. Okay, and it is due to chronic exposure to noxious gases. Noxious means harmful gases. So what are the harmful gases that can lead to COPD? The noxious gases here include tobacco smoke, which is the most common cause, but even biomass fuel, when you burn wood or cow dung for cooking, right? Even biomass fuel can cause COPD. That's the most common cause for COPD in non-smoking females. And now there is evidence to prove that environmental pollution also contributes to COPD, right? So these are common causes. Now COPD, as we know, has two components. One of them is going to be emphysema. The other one is chronic bronchitis. Chronic bronchitis. Emphysema is defined as irreversible dilatation of acini. Irreversible dilatation of acini. What is an acinus? An acinus is basically one respiratory bronchiole, and whatever number of alveolar duct it branches into, and whatever number of alveolar sacs those alveolar sacs branch into, is called as one acinus. So one respiratory bronchiole, let us say this is one respiratory bronchiole. This respiratory bronchiole has two alveolar ducts. It may have 3, it may have 4, whatever number of alveolar ducts that respiratory bronchiole is leading into, and all those alveolar ducts will culminate in alveolar sacs. So one respiratory bronchiole plus whatever respiratory alveolar ducts and alveolar sacs it is carrying, all collectively we call it as one acinus. So when these acini become irreversibly dilated, we call it as emphysema. And the dilatation may affect the respiratory bronchiole without affecting the alveolar ducts and acini. In that case, you call it as centri-acinar emphysema. So if there is dilatation of only respiratory bronchiole, only respiratory bronchioles become dilated, then you call that kind of emphysema as centri-acinar emphysema. Centri-acinar emphysema is typically more common in smokers. But when there is dilatation of entire acinus, means there is dilatation of respiratory bronchiole, alveolar ducts and alveolar sac, everything is dilated, then we call it as pan-acinar. The pan-acinar emphysema usually occurs in patients with alpha-1 antitrypsin deficiency. Pan-acinar in alpha-1 antitrypsin deficiency, centri-acinar in patients with smoking. Okay. Now, regardless of whether it is pan-acinar or centri-acinar, once a segment of acini becomes dilated, dilatation means volume increased, pressure decreased. So air from the upper airway easily gets into the dilated acini, but they are irreversibly dilated. Generally, we exhale the air by recoil of the acini, but because they are irreversibly dilated, they are not able to recoil. So air comes in easily but can't go out easily. So they start developing air trapping in the lungs. So this emphysema is associated with air trapping. It leads to air trapping, and air trapping in the lungs results in various changes. One of them is, you see the changes on the spirometry. You will start noticing increased residual volume, increased total lung capacity. Okay. And on the other hand, the lung volume is increasing, resulting in, to accommodate this expanding lung, right, I have to increase the chest size. I can't increase the chest size horizontally, so anteroposteriorly chest size increases, making the chest look like barrel shaped. So you get barrel shaped chest. What other changes I can get? Air is coming into my lungs easily because acini are dilated. By dilating, their volume is more, pressure is less. So from high pressure atmosphere to low pressure acini, air comes in easily. But then I am not able to recoil to push the air out, so it gets trapped. So I struggle to exhale, and I try to make some physical adaptations to make my exhalation easier. One of such physical adaptation is pursing the lips. When I purse the lips, pressure in the airway increases, and that may help me to breathe out easily. So pursed lip breathing is one of the adaptation to air trapping. These patients will have pursed lip breathing. Second, when I take a tripod position, when I lean forward while sitting or standing, my diaphragm gets pushed up, right, when I'm leaning forward. So that squeezes the lung, and the acini which are not naturally able to recoil, this act squeezes and pushes the air out from those acini. So that makes it little more easy for me to exhale. So that's why all these COPD patients, you see, they're never lying down flat like this in the bed. They're sitting, leaning forward and breathing with the pursed lip, right? So this is what we call as tripod position. So these patients will have tripod position. So these are the changes that we are seeing in emphysema patients. And remember, patients of emphysema are called as pink puffers because their lungs are getting puffed by the air trapping that is going on. It's just like you take an egg and wrap it with maida and put it into a oven. It comes out as egg puff, right? It traps air to become puffed. Similarly, lungs are getting air trapped and they are becoming puffed. That's why we call them as pink puffers. The second one is chronic bronchitis. In chronic bronchitis, patients with chronic bronchitis are also called as blue bloaters. Blue bloaters. So what happens in chronic bronchitis? In chronic bronchitis, there is inflammation of the bronchi, resulting in fibrosis of the bronchi and narrowing of the bronchi, resulting in the obstruction to airflow. Okay. So there will be development of hypoxia because there is bronchial narrowing by inflammation and fibrosis. And this hypoxia leads to pulmonary vasoconstriction because less oxygen coming to the alveoli, then why should I deliver blood to that alveoli which is not getting the oxygen? I constrict its capillaries. Pulmonary vasoconstriction leads to pulmonary hypertension. Pulmonary hypertension can lead to concentric right ventricular hypertrophy, right atrial pressure increasing, and thus eventually you will have right heart failure. Eventually you will have right heart failure. And once you develop right heart failure, you become bloated because right heart failure leads to edema and ascites. Okay. So hypoxia is causing cyanosis. That is where the word blue comes from. And once you develop right heart failure, you develop edema and ascites, and that is where the word bloaters comes from, right? They're bloated with fluid. That's why they are called as blue bloaters. Okay. And this heart failure is one of the leading causes for death in COPD. And when heart failure occurs because of the COPD, we call this heart failure as cor pulmonale because this heart failed because of the lung disease. So who is more prone to develop cor pulmonale? It is the patients with chronic bronchitis who are more prone to develop cor pulmonale, not the patients with emphysema. Emphysema patients are merely struggling to exhale the air out. So they make all these physical adaptations. Life is hell for them, but these patients tend to die because of cor pulmonale. Cor pulmonale to be remembered as the second most common cause of death in COPD. Second most common cause of death in COPD. To note, the most common cause for death in COPD is going to be coronary artery disease. And that's why I tell you, most of the smokers are worried about developing COPD, and I tell them that you don't have to worry about developing COPD because majority of them will not live long enough to develop COPD. Before that, the smoking induced atherosclerosis will take you down with the coronary artery disease. So you have to be really lucky to live long enough with bad smoking to develop COPD. Unfortunately, that's not the case for most of the people. That's why whatever COPD cases you see in the wards, right, they're all in their 70s or 80s. They have lived long enough with smoking to develop it. Most others die in 50s or 60s with coronary artery disease. Okay, so this is about the clinical features of COPD. Now, if I have to diagnose COPD, how will I diagnose COPD? Well, current gold guidelines say all you have to do is post bronchodilator FEV1 by FVC ratio. So they say don't follow the traditional method of first do the FEV1 by FVC ratio less than 0.7, there is obstruction. Then give a bronchodilator and repeat the FEV1. And if FEV1 shows 12% or higher increase or 200 ml or higher increase, then it is reversible, so you call it as asthma. But if you get less than 12% improvement, then you call it as COPD. But current gold guidelines say that mess is not required. Measure the ratio itself after administration of bronchodilator. And after bronchodilator, if the ratio is less than 0.7, that means you did not reverse the obstruction. So it clearly proves that it is persistent obstruction, and you will take it as a case of COPD in the right context. Patients having symptoms of COPD, and if the ratio is less than 0.7 after bronchodilator, that itself is enough. So traditional mess is not to be followed. Okay, once you have diagnosed the COPD, for management of COPD, we have to categorize the patients into 3 categories. That is going to be A, B or E category. Now, how are we going to categorize the patient? If patient had more than or equal to 1 moderate exacerbation or any hospitalization in last 1 year because of COPD, any hospitalization in last 1 year because of COPD, that patient will be directly put in category E. Earlier, 1 hospitalization or 2 or more than 2 moderate exacerbations used to place the patient in category E. Today, 1 or more than 1, not 2. 1 or more than 1 moderate exacerbation or 1 hospitalization. So in last 1 year, either patient had 1 moderate exacerbation or he was admitted because of COPD. If the answer is yes for any of these questions, the patient directly goes into category E. E here stands for exacerbation, because when you look at the question, our focus is on whether COPD is getting exacerbated badly. If exacerbation is really a problem, then we will put them in exacerbation category, category E. But if the answer is no, there was no moderate exacerbation in last 1 year, there was no hospitalization in last 1 year, maybe mild exacerbations would have occurred or no exacerbation at all, then certainly patient is not going to category E. Either he has to go into category A or category B. Now, what is the basis for dividing the patient into A and B? We will now assess the dyspnea severity. Yes, E for exacerbation. So we will now assess the dyspnea severity for all those patients who do not belong to category E. Dyspnea severity will be assessed. Now, how do I assess it? Either I can use a tool called as MMRC, Modified Medical Research Council Grading of Dyspnea, or COPD Assessment Tool, or CAT tool as we call it as. So if the MMRC grade of dyspnea is out of 0 to 4, if MMRC grade of dyspnea is 0 to 1, or COPD assessment tool score is less than 10, less than 10 means anything between 0 to 9, those patients will be put in category A. You will place them in category A. And if the MMRC scale is more than or equal to 2, 3 or 4 grade, or the CAT score the patient gets is more than or equal to 10, then the patient will be put in category B. So we have 3 major categories, A, B and E. And from the story, what we understand is category E is exacerbation predominant category. And when you see category A and B, exacerbation is not their main problem. But is dyspnea a problem? If dyspnea is a problem, you have higher grades of shortness of breath, then you go into category B patients. So you can say category B patients are dyspnea predominant cases. Dyspnea predominant. But when you see category A patients, one thing is clear. Neither they have frequent exacerbations nor they have severe dyspnea. So they are on the milder end, right? So these are the milder cases of COPD. Nor exacerbation is frequent, nor dyspnea is very severe. So if I have to treat a category A patient, I will try to treat them with any one bronchodilator, either use a LAMA or a LABA. Any one bronchodilator. That can be either LAMA or LABA. But for category B and E patients, for B, dyspnea is problematic, and for E, exacerbation is problematic. So I cannot rely on only one inhaler. So we start treatment for them with two agents, LAMA plus LABA. Same for the category E patients also. We will start them with LAMA plus LABA. And for category E patients, selected patients, you might consider adding a inhaled steroid also. Only selected patients to start with. We will call that as triple therapy, that is LAMA plus LABA plus ICS. It is used if you have a category E patient whose eosinophil count is high. If there is no high eosinophil count, then there's no point in adding steroids to start with. If eosinophil count is more than or equal to 300 per cubic millimeter, then you will start with triple therapy. Otherwise, for category E also, you are starting with LAMA and LABA. Okay, so this is the initial management of COPD. Now these managements, the inhalers, are not going to help reduce the mortality in COPD. They will only make their quality of life better. With LAMA and LABA, exacerbation can come down, their dyspnea can come down, so they can feel little better, but still their death risk will remain high. So what can decrease the COPD mortality? COPD mortality, when we talk about it, the most common cause for COPD mortality is coronary artery disease, and that can come down by using statins, antiplatelets, and most importantly, smoking cessation. Smoking cessation. You continue to smoke, then nothing helps. You will die soon for sure. The second most common cause for mortality is going to be cor pulmonale, and this is something that we can try to do something for. Why? I just told you that cor pulmonale is all triggered by chronic bronchitis. Chronic bronchitis leads to hypoxia. Hypoxia leads to pulmonary vasoconstriction. That leads to pulmonary hypertension. That leads to right heart failure. If I resolve hypoxia, then pulmonary vasoconstriction won't occur. Pulmonary hypertension won't develop. Right heart won't fail. So I will not get cor pulmonale. But how will I resolve hypoxia? By giving oxygen. Because the narrowed bronchi cannot be reversed. There is persistent obstruction. But by giving oxygen, I can improve the oxygen status. So this can be managed by giving long-term oxygen therapy or LTOT. It's called as LTOT because if I use only for half an hour, it's not going to help. I have to use it for years together or maybe till the death of the patient. We call it as long-term oxygen therapy. So they may ask you questions. When is it indicated? It is indicated for any COPD patients with SpO2 less than 88%. That means there is clear hypoxia, and giving oxygen reduces the risk of pulmonary hypertension and cor pulmonale. At a slightly higher SpO2 in the range of less than 89%, you may consider, if along with the SpO2 of 89%, patient also has evidence of right heart involvement. What is the evidence of right heart involvement? Either echocardiography shows that there is right ventricular hypertrophy, or there is pulmonary hypertension, or if there is increased erythropoietin levels, indicating that hypoxia started taking toll on the patient's physiology. Sometimes questions may mention PaO2 instead of SpO2. So remember, PaO2 of less than 55 millimeters of mercury. And if I'm talking about SpO2 less than 89, that refers to PaO2 of 55 to 60 millimeters of mercury. Between 55 to 60, you will start if RVH, pulmonary hypertension, or hypererythropoietinemia is there. But less than 55, irrespective of any of these changes, you will start them on oxygen, right? So this is about the long-term oxygen therapy, and this is the only direct COPD intervention that is associated with mortality reduction. Only direct COPD intervention that decreases mortality. Okay, so that completes the basics that we need to know about COPD. Two questions are expected: interpretation of PFT to diagnose COPD, current shift in the diagnostic criteria, that instead of following the pre-bronchodilator FEV1 by FVC ratio, then seeing how much FEV1 increase after bronchodilator, right now the diagnosis is simplified. Post bronchodilator FEV1 by FVC ratio less than 0.7 is directly persistent obstruction, and if there is smoking history or other contributory factors, you label it as COPD. Second MCQ is going to be about categorization and choosing initial treatment. Which patient goes to category E, which patient goes to category A, and which patient goes to category B, and what is going to be initial treatment. Okay. Another MCQ: which treatment is associated with mortality reduction and what are the indications? Okay. So that completes the major topics from COPD. Okay. So there are few quick images to look into before we wind up for today, or I will hand over the baton to my radiology faculty. So, okay, I'll just take 5 minutes to give you a quick overview. So, can anybody tell me what is the major change that you notice in this first ECG? What is the major change that you notice in the first ECG? So, if you're asking me about the drugs for COPD, so there are a few things to know about COPD. We'll skip the images. You can try to solve them, and if you're not getting the answers for these images, just ping me on the Instagram. I will annotate and share the annotated notes with you. Let us address a little more about COPD and drugs, because I'm expecting one potential question from there as well. Okay. So patients who are refractory to inhalers, if it is a COPD patient who is refractory to inhalers, what I can think of? So one of the drugs you can think of is going to be roflumilast. Roflumilast. Another you can think of is using azithromycin. Azithromycin. So what is roflumilast? It is a phosphodiesterase 4 inhibitor. It is not your Viagra, which is phosphodiesterase 5 inhibitor. This is phosphodiesterase 4 inhibitor, which increases the nitric oxide in the bronchial epithelium and help you achieve a slight higher bronchodilation. So it can be used in selected COPD patients. Azithromycin reduces the infection rate, reduces the exacerbation rate, and in itself it is an anti-inflammatory agent. So we can use it in selected patients as weekly pulse therapy, or like 3 days a week, or 1 gram once a week for a maximum period of 1 year, right? So these are the two drugs you need to be aware about when it comes to COPD. Another thing I want you to know about COPD is vaccines recommended for COPD patients, because exacerbation is a real problem in COPD. That's why we had created an exacerbation or E category. But why exacerbations are so common in COPD? The reason is, in COPD, especially chronic bronchitis patients are more prone for exacerbation, because in chronic bronchitis, another important change occurs, that is increase in submucosal glands. This increased submucosal glands makes the submucosal gland layer become thickened, and that is responsible for high Reed index that you get in COPD. And because of this increased submucosal gland activity, there will be increased mucus production, and mucus becomes a reason for bacterial infection, because mucus provides the environment for the bacteria to flourish and grow. So this mucus is associated with increased infection risk, and infection is the most common cause for COPD exacerbation. Yes, there is, apart from the submucosal gland hyperplasia, there is also hyperplasia of goblet cells, which produce mucin, to be more precise. So which are the common infections that we encounter? Do we have vaccines preventing them? So common infections responsible for COPD exacerbation are mainly the most common infection. The most common infection responsible for COPD exacerbation is pneumococcal infection. Do we have vaccine against pneumococcus? Pneumococcus in the sense Streptococcus pneumoniae. Streptococcus pneumoniae is the most common cause for pneumonia overall. In COPD also, that's the most common cause. This is also the most common cause for the bacterial meningitis. Do we have vaccine against it? Streptococcus pneumonia, we have pneumococcal vaccine. So first vaccine recommended in COPD is going to be pneumococcal vaccine. Pneumococcal vaccine. Okay. Apart from Streptococcus pneumonia, another organism responsible for COPD exacerbation is Moraxella catarrhalis. Moraxella catarrhalis. Do we have vaccine against it? No, unfortunately, no. Right. The next one is influenza virus. Influenza virus. Do we have vaccine against influenza virus? Yes, your H1N1, H5N1, these are influenza viruses. Right now in India, there are a lot of cases of H1N1 being reported. Those who are vaccinated are probably protected. Most of my COPD patients are vaccinated. So they are less likely to get infected by this current ongoing run of influenza virus, right? Do we have vaccine? Yes, we have vaccine. So it is recommended. Influenza vaccine is recommended. Okay. Then recent times, the pertussis is becoming an increasing concern in COPD patients because the vaccine coverage for pertussis is decreasing and the herd immunity is decreasing, and that is contributing for pertussis as a cause for COPD exacerbation. Do we have vaccine? Yes, we have in the form of diphtheria, tetanus, pertussis. So we can give them diphtheria, tetanus, pertussis vaccine. And as I've already told you, you need to be really lucky enough to develop COPD by smoking because most people don't live that long enough. By the time COPD actually gets diagnosed in patients, they are mostly 65 plus. And after 65, whether you have COPD or not, you are at increased risk of developing herpes reactivation or shingles. And that's why the shingles vaccine is also recommended. Shingles vaccine, yes, the pertussis vaccine here will be acellular. So shingles vaccine is also recommended. So these are the 4 important vaccines recommended for COPD patients. So this can also be a potential MCQ. So please remember that as well. And they may also ask you what is the most common cause for COPD exacerbation. That is going to be Streptococcus pneumonia. So remember that as well. Okay, so that kind of completes the quick revision of medicine. Images you can go through. If you don't find an answer, you just ping me and I will share the answers with the annotations on the Instagram, because Dr. Natisha is waiting on the other side for the radiology. So I will hand over the baton to her and she will take over from me. If there are any doubts pending, ping me on the Instagram whenever you find time, and whenever I find time, I'll give you a quick answer on that. That's it from me today. I'll see you in the next class. Hopefully you will do well in the exam and we will connect after the exam. Till then, have a
So, hi students, welcome to the radiology class. I'm sure that everyone had an amazing session with medicine, and so now we are going to start with radiology. Only 5 days left for the examination. I'm sure that it will be a peak of anxiety right now, and I would just suggest that the most of the preparation is already over, and this last 4-5 days of preparation is really not going to decide your rank. The main part, the toughest part, is completely over, right? So just stay patient, just be calm before the examination on the examination day, and that would really help. So what we are going to do is we are going to start with general radiology. We will be dealing with some basic investigations and to identify them, and then we'll start covering the systemic radiology. A quick session, lot of images will cover. If you have any doubts, do write in the chat box and I'll try my level best to answer all your questions, right? So let's start with the first question. Which of the following structures has the lowest Hounsfield unit? So just a little refresher type of a question, an easy one. So just give me a thumbs up if everything is right, if I'm audible, if I'm visible. So then we can just start with the session. Okay, yes, Vayu, good evening. Just can you confirm that the audio is okay, everything is fine, then we'll just start. So how's the preparation going, everyone? Yeah, okay. Yeah, so which of the following structures has the lowest Hounsfield unit? Of course, everyone is correct. The answer is air. So let's just quickly revise about the CT Hounsfield unit. So when I'm talking about CT Hounsfield, the baseline will be always water. This was previously tested, that has an HU of around 0. Right now, if I'm talking about air, it will be the minimum, that is minus 1000, and that is why anything that will be having the least Hounsfield, the negative Hounsfield unit, that will appear as jet black. Right, and if I'm talking about the on the opposite side of the spectrum, that is plus 1000, that will be appearing very hyperdense. Right, so what will come in the plus 1000 category? It will be cortical bone, like for an example your skull bone, the calvarium, that will appear very dense, and that will be 1000. If I'm talking about cancellous bone, like for an example the central part of the vertebrae, they will be having a relatively lesser HU, and that will be around 400. If I'm talking about calcium, it will be again somewhere around 200 to 250. It will be somewhere around 200 to 250. If I'm talking about soft tissue, almost all your organs, they will come somewhere in the category of 50 to 60. Right, now what about acute bleed? Again, this was previously tested. Acute bleed has an HU of around 60 to 80 HU. Okay, now what about metal? So it will be somewhere around 1000 to 3000. Now why I am emphasizing for the metal, it has got such a high HU. What will happen? It will give lot of artifact. What artifact will appear? If there will be metal on a CT image, it will appear as a streak artifact. You will get a metallic streak artifact. Okay, you will get lot of streaks of hypo attenuation, because of course it's so hyperdense that the machine is not able to register such sort of hyper attenuation. The most important one is your fat. Okay, because many questions can come from fat. They can show you various fat density lesions. Okay, I'm talking density. When I talk about CT, almost my nomenclature will include the term density. If I'm talking about MRI, it will be intensity. If I talk about ultrasound, my word will be echogenicity, right? So this is how you need to remember. So I'll be using density whenever anything pertaining to CT has to be described. So for fat, it will be again hypodense. It is somewhere around minus 100 or somewhere between minus 40 to minus 60. That will be negative. It will be not as jet black as that of air, but of course it will be having this dirty black type of an appearance. And there are many lesions which can be tested with the fat containing lesions, right? So let's start discussing our first image. Now I'm telling you that there is a lesion that is present in the brain. Okay, I'm also giving you a hint. The exam may not be so lenient, they will not give you this hint, but I'm telling you that the hint that this lesion is having an HU of minus 80. Okay, that means that it is a fat containing lesion. Now what lesion? Containing fat present in the central part. What is the diagnosis? Please write down in the chat box. So fat containing lesion that is centered in the corpus callosum. We are talking about corpus callosum lipoma. Okay, you can just write, maybe there is a lag when I'm asking. There is a lag of yeah. So Dhanush, yes, right. It is corpus callosum lipoma. Okay, now what else are you seeing over here? Can you see this this calcifications that are present? Again, calcification, as I told you, it will appear as hyper. So this particular typical calcifications of corpus callosum lipoma, particularly in this tuberonodular variant, it's a nodular lesion that is present in corpus callosum. So this is nothing but your bracket calcification. This is your bracket calcification. Now what other lesions which they can test in your examination? So it can be a dermoid cystoteratoma. They can show you a pelvis image. They can show you an MRI pelvis image, and then they can show you this fat intensity lesion, right? They can either show you a CT or an MRI. How will fat appear on MRI? It will appear hyper intense. It will appear hyper intense because fat has the tendency to shorten the T1. Anything that will shorten the T1, it will appear as bright. What about the other fat containing lesions? Lipoma, they can show you a skin or a subcutaneous lipoma. Then of course they can show you kidneys with multiple hypodense lesions, so they can show you an angiomyolipoma. And what about the last one? In the adrenals, they can show you a lipid rich adrenal adenoma. Okay, so these are the various fat density lesions which they can test you. And they can show you the HU. Either they will not show you the image, they will just tell you that there is a lesion with this negative HU, and you have to start thinking that yes, it is a fat containing lesion. Okay, now let's move towards again the similar lesion I'm showing you. I'm already told you that this is a similar lesion, so the diagnosis is straightforward. You are seeing again, see, this is, first of all, you need to identify that this is a T1 weighted image. Okay, how am I identifying? Look at the CSF. Okay, the CSF over here is, of course, the CSF is appearing black. So of course, this is not T2 weighted image. This is a T1 weighted image. Look at the subcutaneous fat over here, how hyper intense it is appearing. So fat is very hyper intense on T1 weighted image. Again, you can see that there is a lesion that is centered in the corpus callosum. It is again appearing bright, right? So what I am talking about, again, this is the corpus callosum lipoma, but this is the curvy linear variant of corpus callosum lipoma, just parallel along the corpus callosum. Okay, now what are the other T1 hyperintense lesion? Anything that is going to shorten your T1 time, that will be appearing as hyperintense, right? So what are the various other lesions which you can see? So it can be fat, as I have already shown you in this image. You can see that fat in the subcutaneous plain, how hyper it is appearing, right? Now what about the other lesions? So it can be a posterior pituitary bright spot. So you can see in this lesion, in this particular image only, you can see that this is the normal pituitary. This particular bright part in the posterior part of the pituitary, that is your normal posterior pituitary bright spot. It's absolutely normal, right? Because it has a shorter T1, that is why it will be appearing as bright. Right, now what about the other things? So you can also have melanin. Okay, so remember two M's are there. We have got melanin as well as mineral like calcification, some small basal ganglia calcifications, they will also appear hyper on T1 weighted images. Most important is GADO. Okay, again, if you want to remember, you can remember one more M, that is magnavist. Okay, that is the name of the gadolinium contrast. And again, gadolinium has a tendency to what? To shorten the T1. So if they are shortening the T1, they are going to appear as bright. Now what about blood? So again, there is one more M over here, that is methemoglobin. So most probably in the subacute stage, blood will be also appearing hyperintense on T1 weighted images, right? So it's very easy to remember. All the M's will be there, and of course you have to remember fat and posterior pituitary bright spot. These are all the lesions that will appear hyper on T1 weighted images, right? Now let's just quickly revise about the various MRI sequences. So the first image, as you can know, the very obedient one, I would say, that is your T1 weighted image. White matter is white. It's the most obedient sequence. You can see that the white matter, it is appearing very white. So this is your T1 weighted image, right? And what about the CSF? It will be appearing dark. So this is nothing but your T1 weighted image. If you see the second image, you can see, you can remember the mnemonic, that is World War II. So white, okay? So on the T2 weighted images, your water, your CSF, it will appear as bright, right? So this is again your T2 weighted image, but it is not that obedient. So the white matter over here will appear dark. White matter will appear dark over here, right? So the white matter is dark. Now, if I'm talking about the third image, everything is dark over here, right? You can see that the white matter is also dark. The CSF is also dark. So this is nothing but your flare sequence. This is your flare sequence. We have suppressed the CSF signal. So it is exactly like T2. It's just that the CSF signal is suppressed, where flare is used. So almost in all the brain pathologies, if I want to see the edema, if I want to see the inflammation, especially if I want to see demyelination, if I want to see demyelinating pathologies, in that condition, flare will always be my investigation of choice. Like for an example, if I talk about multiple sclerosis, if I talk about ADEM, right? In all these particular pathologies, your investigation of choice is flare, because we are suppressing the signal. If I suppress the signal from the CSF, I will be able to see this hyperintensities more conspicuously, more nicely on the flare images. Okay, now tell me, what is this particular sequence? Okay, if you see this particular sequence, the last one, what are you seeing over here? The first image, if I'm talking about, you can see that this is again a T1 weighted image, but you are able to see that there is an enhancing lesion. So I'm using the word enhancing. So this is definitely my post contrast T1 weighted image. This is my post contrast T1 weighted image. Now, as I have already said you, what is contrast going to do? It is going to shorten my T1 time, right? So it will be appearing as bright. The lesions will appear as bright. The vessels, they will be, wherever the contrast is there, it will appear as bright because of the shortening of the T1. So this is a post contrast. You need to identify to a post contrast T1 weighted image. Now tell me the lesion, tell me the diagnosis. Yes, Dhanush, very good. It's dural tail which you are seeing. So this is our most favorite meningioma. Of course, we'll discuss all the brain tumors in today's class, but just to give a gist of this is a meningioma. You are able to see a very beautiful dural tail, plus this is also an extra-axial mass. It is not present in the brain, it is present along the falx, right? The second image which is there, you can see that the CSF over here, it's bright. It's a T2 weighted sequence. Okay, so the diagnosis is meningioma in this particular patient. Now I'm going to discuss about another important sequence of MRI. So this everyone knows, it's a DWIC. Most of the things I have written so that we can cover most of the images in today's class. That is my main motto. So most of the things I have written for you so that I don't waste my time in writing, right? So if you see the DWI sequence, the second image over here, if you see the ADC, what is happening? There is a drop in the signal. Yeah, there is a drop in the signal that you are seeing on the ADC. So this means that this is true diffusion restriction. Now, if I'm talking about a pseudo diffusion restriction, what will happen? It will also appear bright on ADC. To have true diffusion restriction, the signal on ADC has to definitely reduce. Otherwise, it is not true diffusion restriction. Then it will be what? It will be T2 shine through. That is, the intrinsic T2 signal is so much that it is appearing bright on DWI and on ADC, and it's not true diffusion restriction. So to mark your answer that yes, exactly this is true diffusion restriction, it should appear black on ADC, right? Just on one DWI, you cannot say that this lesion is showing diffusion restriction. What is the main concept? The main concept is what? Restriction of the Brownian molecules, Brownian motion. That is the main concept. Now, if I'm talking about the mnemonics, the mnemonic for diffusion restriction is SEAL. I have told this many times. So, CS will be your stroke. So particularly it is your acute stroke I am talking about. Stroke ke bhi we have got multiple phases, so we are talking about acute stroke. Now what is the concept? Why in stroke you are having this diffusion restriction? It is mainly because we get cytotoxic edema. Okay, so when we talk about the cytotoxic edema, what happens? There is basically disruption of the sodium potassium pumps, and that will be cytotoxic edema. So Hussein ma'am, if possible, cover the topics with clinical signs and symptoms. Sure, we are going, this is just the introduction. We are going to cover all the systems, systemic wise we will be covering with all the clinical hints. So don't worry, just be with me, and we are going to cover the entire systemic radiology very nicely. Right? So if I'm talking about the cytotoxic edema, that is something which you see in stroke because the sodium potassium pumps which are there, they are damaged. That is why you will always see diffusion restriction in cytotoxic edema. But if I'm talking about vasogenic edema, what happens? Vasogenic edema will be seen if there is any particular tumor. Okay, suppose there is a tumor that is present, okay, or any particular pathology is present that is going to disrupt the permeability, the blood-brain barrier. The permeability is going to be affected. That will lead to the leakage, and that will lead to vasogenic edema. Will it show diffusion restriction? Never. Vasogenic edema will not show diffusion restriction. If I talk about one more important pathology that will not show diffusion restriction because of this vasogenic edema, it is your PRES. Okay, so PRES, okay, that you see in this postpartum patients in eclampsia, you will not see vasogenic edema over there. Right, now what about the other lesions? So all these are potential questions that can show you diffusion restriction. The second E which is there, it is your epidermoid cyst. Okay, if I'm talking about A, it is your abscess. Okay, I'm going to show you all the images in CNS. Okay, and what about L? So it is basically your lymphoma or your medulloblastoma. So anything that will be highly cellular, anything that will be highly cellular, that will be showing diffusion restriction. Because see what happens in abscess, there is lot of pus, so the Brownian motion is going to affect. What happens in highly cellular, highly malignant tumors like lymphoma, medulloblastoma, it's highly cellular, so the Brownian motion of the molecules will not occur. Similarly in epidermoid cyst also lot of sebaceous contents will be present. Okay, so because of cholesterol and all, you will not be showing the diffusion restriction again because the Brownian motion is going to be affected. Right, now let's move towards the next question. Please answer this in the chat box. A 24-year-old male is brought after a high-speed road traffic accident. CT brain is normal. MRI shows multiple tiny blooming foci at the gray-white matter junction and corpus callosum. Which MRI sequence for detecting this particular lesions? So please answer this in the chat box. Yes, Vayu, perfect. It is SWI. So this has been asked many times. This is a potential question, could be tested in many forms. So you will always be shown a trauma history. You will be shown that the patient is having definitely some problem. There is some neurological deficit is present, but CT is absolutely normal. What next investigation? I have already shown you, I have already given you the MRI findings. Sometimes they will not give you, they will just ask you what will you do next. You'll do an MRI. Which sequence will you do? You will always do an SWI, because what pathology I'm talking about? I'm talking about diffuse axonal injury. I'm talking about diffuse axonal injury that mainly occurs because of the shearing and the stretching forces, especially in the acceleration deceleration. Remember that SWI, so two options can be given, SWI, GRE. What will you pick? You will always pick SWI if both the options are there. If both options are not there, you can either pick SWI, GRE or T2 star, whatever the option is there. The concept is same. These are microbleeds. So microbleeds will always show what? They will always show blooming. Okay, what happens? These are going to disturb the local magnetic field, and that particular concept we are using in this gradient imaging or the susceptibility weighted imaging. And because they are going to interfere with the magnetic field, they will appear as hypo-intense or this jet black foci. Yes, Dhanush, rotational also can be done. So that is why you can also see such type of injuries in battered baby syndrome also, right? So blood products are there, or calcium is there, or any iron, metal, air, all this will be producing this signal voids, and they will be appearing as black. The most important thing, again in trauma I'll be covering this diffuse axonal injury, but the classical location is at the white matter gray white matter junction. Then you can also see them at the brainstem, you can see it along the corpus callosum. Remember that the sequence of choice is definitely SWI. Okay, so yes, Shashi, very good. Shearing torsion of the axons that you will see, right? Now, next question is, which structure is damaged in the dashboard injury? But before you solve this particular question, tell me that which of the following is an MRI and which of the following is CT. I know it's very easy, but students tend to make mistakes in such simple questions, and I really don't want that. And so I'm revising this. The first is either which one of them is an MRI, whether it is A or whether it is B. Okay, please answer this in your chat box. Which of the following is an MRI, A or B? I'm waiting. Yeah, so MRI is first. I got this answer from Dhanush. Very good. So you can see that, see how to identify. See, always look at the cortex. If the cortex is appearing so white, okay, even in the CT brain, if you're seeing this particular cortex appearing bright, then that is your CT. I don't want you to get confused between CT and MRI. Just look at the bone. Bone on the another hand on MRI will appear black. So you can see how nicely the cortex, I'm talking about in MSK, we look at the cortex is appearing black over here. So that is basically your MRI sequence, MRI image. Now, if you see another important thing, the easy one is you can see the ligaments. Can you see such ligaments so beautifully? You can see ACL, you can see PCL. ACL is inserting. They will not label this, right? So you need to know the structure inserting anteriorly. What is the anterior part? The patella, right? So anteriorly inserting structure is your ACL. Posteriorly inserting structure is your PCL. So this is definitely the MRI image. This is the CT image. Look at the cortex. Look at the ligaments. If you're able to see the ligaments, if you're able to see the menisci, the beautiful bow tie, these are all your clinches for an MRI image. For almost all the MSK pathologies, investigation of choice, especially if I want to see ligament injury, if I want to see the meniscal tears, it will be always MRI. And particularly if they will be giving you subsequences like say PD sequence, like the proton density sequence or the stir sequence, most probably your answer will be that, because these are the best sequences to see the ligaments. They will appear jet black, and you can also see the bone marrow edema, especially with the stir sequences. Right now, which structure is damaged in the dashboard injury? So the answer will be what? Answer is PCL. That can be inserted in the dashboard injury. Okay, so this is just an orthopedic reminder. I'm just trying to tell you that they can give you this clinical hint. They will merge with the clinical hint from your orthopedic section, and then they can show you the image. Okay, I'm sure that you have covered everything in orthopedics, but just a type of example of question how they can test you. Right now, let's move towards our next pathology. So what are you seeing over here? This is a very classical spotter image, could be tested. So that is why I've included here in the general radiology itself. We'll cover MSK separately. This is your, you are able to see that there are two posterior cruciate ligaments. So what is this? Yes, Dhanush, very correct. This is the, can someone please write in which particular tier will you see this particular sign? So this is basically your double PCL sign, not double handle. So this is double PCL sign, and what happens here, there is a tear that you will see in the posterior horn of the medial meniscus. It's a bucket handle tear, and because of this, the torn fragment which is there, it is going to flip and it will lie anteriorly just in front of the posterior cruciate ligament. Right now, let's move towards some of the important ultrasound images. First image which you're seeing is in what type of an image? So I'm just quickly telling, this is an abdominal imaging which we are doing. My probe is in the right upper quadrant, and you are able to see the liver. Okay, you are able to see the right kidney over here. Right now, what is this particular mode? The mode is B mode ultrasound, which we are doing over here. Now, another important thing is, then when I'm doing an abdominal ultrasound, what frequency of the probe is usually used, whether you use a high frequency or whether you are going to use a low frequency probe. So remember, we always use a low frequency probe. Okay, please, before I answer, try to think about these answers. We cannot have a big question and answer type of a session. It will take too long. We have to cover a lot. Just remember that the low frequency probe is used. When I'm talking about the low frequency probe, it will be somewhere around 2 to 5 megahertz probe which we are using. Now, if I talk about the probe, whether it will be curvy linear or whether it will be a linear, what will be the type of probe? When I'm talking about a low frequency probe which we use in obstetrics, which we use in abdominal imaging, if I want to see all my organs at depth, I will be using a curvy linear probe. I will be using a curvy linear probe. Okay, now if I'm talking about the high frequency, I would say that somewhere around 10 to 18 megahertz, if I'm using this type of a probe, this is mainly used if I want to see the superficial structures, because what happens, higher will be the frequency in the ultrasound, more will be the resolution. Although I would say that the depth which is there, it will tremendously decrease. Ulta will be for the low frequency. Low frequency mein what you will see relatively lesser resolution, but you will see all the organs at relatively more depth. Right, now let's talk about the high frequency probes. So it is used in breast imaging, thyroid imaging, MSK, scrotum. So whenever these particular questions are given, this particular hints are given in your question, your answer will be high frequency probe, because these are all superficial structures. Right, now let's move towards the next image. Can you tell me that what is this an image? Can you tell what advance I have used over here in ultrasound image? Oh, it's written on the image only, but try to answer. Try to answer what you are seeing. You are seeing a lot of orange color over here. If you are seeing this lot of orange color, we are talking about a contrast enhanced ultrasound. Very good Gaurav. This is a contrast enhanced ultrasound. They can definitely show you to identify. And what is the contrast agent which we are using? We are going to discuss the contrast as well. We are talking about SonoView. If I'm talking about SonoView, that is the most commonly used agent. The main component over here which is there, it is sulfur hexafluoride. These are the gas molecules, 1 to 10 micrometer, very small micro bubbles, and these micro bubbles, this is definitely injected IV, right, and it is covered by that of a phospholipid or an albumin layer. The main thing is that this particular gas will be excreted in the lungs, and if I talk about the albumin, or if I talk about the phospholipid layer, which I'm talking about, the layer of this particular contrast, this will be eliminated by that of the liver. So definitely we can say that this is safe in renal failure. Okay, this is absolutely safe in renal failure. Okay, this is a very important point which can be tested. Now let's move towards our next advance which I'm talking about, the ultrasound. Can you just identify? You are able to see all the layers over here, right, of the bowel wall. So this is, or of the esophagus or of the rectum. So this is nothing but your endoscopic ultrasound. This is your endoscopic ultrasound. Remember that it will be, again we are using a high frequency probe over here. It will be mounted on that of an endoscope probe, and mounted on an endoscope, and you can just directly in the proximity of the bowel, or either in the pancreas, near to that of the pancreatic head, you can see all these lesions which are present in the pancreas, or either the bowel wall can be seen. Remember that it will be also having a very high resolution. So it is used in the local staging, or I would say whenever in your question the question is regarding the T staging, almost every time your investigation of choice will be endoscopic ultrasound if it is given in the options. What about the other pancreatic tumors like the neuroendocrine tumor? If I want to see the characterization of the cyst, in all that particular conditions, again, I can use this endoscopic ultrasound. I can also do the interventions like I can do fluid aspirations, I can do biopsy with the endoscopic ultrasound. Right, now let's move towards the next image. What you are seeing, lot of green color, blue color, red color. What is this particular investigation? So this is nothing but your elastography. This is your elastography. Okay, sometimes in the liver they can also use the term fibroscan, so don't get confused, one and the same thing. The main concept is that we are going to measure the tissue stiffness using this ultrasound. We are using what? We are using shear waves. If I'm using the concept of the shear waves, I can basically measure the stiffness of the tissue. Very novel technique, very nice technique if I want to see liver fibrosis, liver cirrhosis, because of course the liver, the parenchyma which is there, it will become more stiffer and harder. If I want to differentiate between malignant and benign lesions, again, like for an example, if I talk about a benign lesion like a cyst, it will definitely have lesser stiffness. If I talk about malignant lesion, it will be definitely having more hardness, right? So that is about this. Yes, of course, Gaurav, right? Red is hard, green is somewhere intermediate, and blue which is there, it is a relatively softer part. Okay, what is this particular organ shown over here? So this is your thyroid which we have shown over here, right? So it can be used in thyroid lesions, it can be used in breast lesions, it can be also used in the liver lesions. Now let's move towards our next pathology, next investigation. So what are you seeing over here? So can you see the first, can you just tell me what is this? Okay, so what you are seeing over here is a color Doppler sequence. What is this particular sequence? This is a spectral Doppler, not the sequence, sorry. This investigation is spectral Doppler. This is your color Doppler. And what is going to happen with this color Doppler? You're able to see this red-blue color. So don't get confused. You can get colors in elastography also. You can get colors in the contrast enhanced ultrasound, but the pattern of colors is different. So just identify what sequence we are talking about. Now, if I'm talking about the color Doppler, remember that blue away, red is towards. That is the basic thing which you need need to know, it's not that the venous blood will be appearing blue or the arterial blood will be appearing red. It's not like that. It is depending upon the flow of the blood, whether it is towards the transducer or whether it is away. If it's away, then it will appear blue. If it is towards, it will appear red. So you'll get an idea about the flow as well as the direction. Right, Sunny? It's triphasic wave. So this particular spectral Doppler they can show you and they will help you to identify. They can ask you to identify. So this is basically seen in your peripheral arteries. It is seen in your peripheral arteries, and this is basically your normal triphasic pattern which you see in the peripheral arteries. Now, can you tell me, see what happens? You will get an idea about flow and direction. With spectral Doppler, you will get an idea of the waveform. You can get an idea about the waveform. If I want to know the velocities, if I want to basically measure the resistive index, if I want to measure the PSV, if I want to see the end diastolic volume or flow, everything can be measured. This graphical terms can be done with spectral Doppler. Now, if I'm talking about the third image over here, you are seeing that there are a lot of red colors, right? There are a lot of red colors which you are basically seeing. So this is nothing but your power Doppler. This is nothing but your power Doppler. Just a minute. So on the power Doppler, you will not get an idea about the direction of the blood flow. But remember that power Doppler is the most sensitive Doppler modality. And you will basically pick up even some small flows. Okay. If supposing there is a stenosis, okay, you're not able to see the flow on a normal color Doppler. In that particular condition, I might use a power Doppler in order to pick up this small flow. Just if I want to see this trickled off flow. So that is the beauty of power Doppler. Just remember, if you're seeing this jet red color, this is a power Doppler modality. Now let's identify what is this particular sequence over here. What is this investigation which I'm showing over here on the first one. So again, very important to differentiate between the two. The first image which is there, it is your MRCP image. Okay, you can see that how beautifully everything is appearing very hyper intense. All your biliary structures, your gallbladder, it is appearing very hyper intense. So that is basically your magnetic resonance cholangiopancreatography. What can happen? They can basically show you some small signal voids either in the gallbladder. Okay, they can show you in the gallbladder. They can show you along the CBD. So that can be cholelithiasis or that can be choledocholithiasis. Right now, the investigation of choice for almost all your biliary pathologies, I would say the non-invasive investigation, it would be MRCP. Mark your answer as MRCP if there is any biliary pathology. Except for one, that is biliary leak. Remember, in biliary leak, your investigation of choice, you will mark your answer as HIDA scan. Okay, now if I'm talking about the second image, what is this particular modality? You're able to see endoscope, you're able to see the contrast, it is appearing black. So this is basically your endoscopic retrograde cholangiopancreatography. Right, perfect, Vaishak, right. Second is an ERCP. Now, if I'm talking about the gold standard, this almost for all your biliary pathologies, if they ask you gold standard, your answer will be ERCP. Why gold standard? Because of course it has got the highest spatial resolution, and the another point is that you can do the management. You can do the intervention in the same setting. So that is why it becomes your gold standard, right? Highest spatial resolution will be definitely for an ERCP image. But what are the drawbacks? It is definitely an invasive procedure. You will also have to give the contrast over here. You can have a risk of iatrogenic pancreatitis or iatrogenic biliary injuries can occur. So that is why we say that ERCP is not the investigation of choice. Or investigation of choice is MRCP. Remember, in MRCP, we do not give any contrast. Okay, what is the main principle of MRCP? It is basically using the intrinsic high T2 signal which is present in this biliary structures. You can also do an MR urography, right? If you want to pick up the signal from the urine, okay, how will the fluid appear? It will appear hyper. Anything which is fluid, any cyst, they will all appear very hyper on these MRI images on a T2 weighted image. So these are heavily T2 weighted images. Right, so that is about the beauty of MRCP. We do not give any contrast. It is absolutely non-invasive. So that is why it becomes your investigation of choice for all the biliary pathologies. Right, now next we are going to cover what investigation. We are coming to the breast. So what is this investigation? Everyone knows this is a mammogram. Okay, now tell me the views. Which of them is a craniocaudal view? Which is the MLO view? Tell me A is craniocaudal or whether it is MLO. Vaco, we will cover nuclear also. Let me just first cover the general and we'll start with systemic fast. Yeah, everyone knows this is mammogram. Tell me the view. What is this particular view? The first view which is there, it is craniocaudal view. The second view which is there, it is your MLO view. Okay, that is your MLO view. Now, if I'm talking about the craniocaudal view, remember if I draw a line in the midline through the nipple, this is my outer quadrant. Okay, and this is my inner quadrant. If I draw a line over here through the nipple in the mediolateral, this will be your upper part, and this will be the lower part of the breast. Now if you see this particular structure in the MLO view, this is nothing but your axillary tail. So if they ask you a question that on which particular view will you be able to see the axillary tail, if I want to see the lymph nodes, then mark your answer as MLO view. Now if I'm talking about the screening modality for less than that of 30 years, what will you mark? Okay, for less than 30 years, what you will mark? Screening modality for breast cancer I'm talking about. So remember, for less than 30 years, you will always mark your answer as ultrasound. For more than that of 30 years, you will mark your answer as mammo. If they do not give you the age, then still pick up the answer as mammo. Okay, so mammo is definitely very sensitive in picking up these particular small conspicuous masses on the mammography. Now, why in less than 30 years we are going to use an ultrasound image? We are going to use an ultrasound because what happens is, in the less than 30 years, the breast tissue is very hyperdense. It is very hyperdense, and you will not be able to differentiate between the lesion and between this hyperdense breast tissue. So that is why you will be always marking your answer as ultrasound for less than that of 30 years of age. On mammo, you will not be able to differentiate from the dense breast tissue. Right. So, Sunny, yes, if the question gives you pregnancy, in the pregnancy, if any breast pathology will come, okay, or either they can give you lactating mother, always and always mark your answer as ultrasound for the breast pathologies. Okay. 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 Now, let's move towards the next lesion over here. So high risk screening. So if the question tells you high risk screening, now what is this particular image? This particular image over here is a MRI. Okay, and you can see how hyper intense the fat is looking. So this is basically a T1 weighted MRI. I have asked the patient to lie prone. Okay, and the breast will be present in the breast coil. This is how we are doing this imaging of the breast tissue. So whenever the question says that if I want to do a high risk screening, like for an example, BRCA1 or 2 mutations history, or there is a family history of cancer, Lee-Fraumeni syndrome, Cowden syndrome, P53 mutations, if there is any previous radiation history, or if there is any particular history of implants, then in that particular case, I will be marking my answer as MRI. I will be marking my answer as MRI always, right? Because MRI is definitely more sensitive than even the mammography in picking up these tumors, and we do not want any missing in this particular high-risk patients. Now, one thing which they can ask you from breast MRI is your dynamic contrast enhancement curves. So remember that when I talk about the curves, there are 3 types of curves. This is when I am giving gadolinium, and I am basically doing the kinetic analysis of this contrast which passes through the lesion. So you can get 3 different type of curves. Type 1 is you will get a persistent plateau. You will get a persistent type of a graph. Type 2, you will get a plateau, and number 3, which is there, it is washout. Now, can you tell me, out of this type 1, 2 as well as 3, which of the following will be malignant? Okay, that could be tested. So, can you tell me type 1, 2 or 3, which of the following would be malignant? Please answer this particular question. Which will be malignant, type 1, 2 or 3? Okay, so I remember that type 3 which is there, it is the malignant one. Okay, type 1 is usually the persistent one which is there, it is usually benign. Rest, yes, of course, yes. So everyone has got this particular answer correct. Okay, that is washout, you will have this malignant. Okay, now you are seeing the 3 important next 3 important images. I am showing you 3 different modalities over here. I'm showing you 3 different modalities. Can you tell me which of the following is which? Okay, so the first image, you can see this blackish type of the contrast over here. The bones are also appearing black. The first investigation which is there, it is your DSA. Okay, it is your DSA, digital subtraction angiography, which we have done for the renal arteries. If you see the third image over here, you can see this bones. As I've already told you, if you are seeing on your image, the bones that will be appearing very hyperdense, okay, the cortical bones that will be appearing very hyperdense. What are we talking about? We are talking about the CT angio. Okay, we are talking about CT angio. Again, this is CT angio of the renal arteries. The middle image which is there, you are able to see what? Again, you are able to see that there is the renal arteries you are seeing. You are also seeing that there is a pathology over here, and that is present in the proximal part. So we are talking about renal artery stenosis, and this is your MRI angio. Okay, this is your MRI angio. Okay, so it's very difficult to differentiate ideally between both MRI as well as the CT. The only way is if you are able to see the bones. That is how you can basically differentiate. In MRI, you will not be able to see this white bones. Now, another important thing I would like to stress is that if the patient is having renal failure, suppose if the patient is having renal failure, and if I want to do any angio, then in that particular condition, always mark your answer as MRI TOF angio. You will mark your answer as MRI TOF angio. Okay, so TOF angio is the method of doing an angio that is called as time of flight angiography, in which I will not be needing any contrast. Okay, I will not be needing even the gadolinium over here, and again it will be picking up this intrinsic signal, and it's that again the physics is beyond the scope, but you just need to remember that if the question says renal failure, you can mark your answer easily as TOF angio over there. Okay, but if they ask you the question regarding gold standard modality for any vascular pathology in the body, be a brain aneurysm, okay, or any vascular pathology, my gold standard again is DSA, as I've already said that in ERCP. Similarly, DSA which is there, it will be also having a very high spatial resolution, plus you can do the intervention also in the same setting. If I'm talking about the CT angio, again, if the options are given to you as investigation of choice, okay, investigation of choice for any vascular pathology, in that particular condition, I will mark my answer as CT angio. Again, it has got a good resolution and it is also not invasive like that of the DSA. Right? Okay, so moving towards our next table. So this is just a synopsis of what we have seen. We have seen all the investigations. This is the most important table. Okay, we're just going to quickly revise. One question could definitely come from this particular table. And even if you have not got time enough to read the systemic, just go through this particular chart, because that will solve most of the concepts. If anywhere in the body fluid is present, cyst, ascites, pleural effusion, and they ask you the investigation of choice, mark your answer as ultrasound. Remember, ultrasound is the friend of the fluid. Anywhere the fluid will be present, ultrasound will be the best modality, and it is the enemy of air. So if anywhere air is present, pneumo is there, emphysematous polycystitis, emphysematous pyelonephritis, in that particular condition, my answer will be NCCT, right? If I talk about calcifications, renal calcifications, any granulomas I want to see, again my answer will be NCCT, except only one particular calcifications, that is gallstones. See, gallstones are made up of cholesterol, so my answer over here for gallstones will be ultrasound. It will be ultrasound. Okay, now if I'm talking about, yes, even HRCT can be marked, okay, for pneumo. Now, if I'm talking about the soft tissue, if I want to see the soft tissue component anywhere in the body, if I want to see any soft tissue pathologies, if I want to see tumors, if I want to see infections, the modality that will be giving me the highest soft tissue contrast, it would be MRI. It would be MRI. If I want to see the bony cortex, if I want to see the fractures, if I want to see osteoid, osteoma particularly, my answer will be NCCT. My answer will be NCCT. Okay, now if I talk about the bone marrow, if I want to see the edema as well as the AVN, in that particular condition, remember M for bone marrow, always my answer will be MRI. Now, if they ask you acute hemorrhage, as we have already discussed in the Hounsfield section, the acute hemorrhage will have an HE of 60 to 80. Again, the best modality to see acute bleed will be NCCT. Now, if I want to see chronic hemorrhages, if I want to see micro hemorrhages like diffuse axonal injury or hypertensive encephalopathy or vasculitis that will show me this small blooming foci, my answer will be SWI, or my answer will be GRE or T2 star on an MRI. Okay, so we have already discussed DAI. Now, if I talk about the vascular pathologies, like for an example stenosis, this also I've already covered. So always mark your answer as CT angio as an investigation of choice I'm talking about. But if they ask you gold standard, then I will be marking my answer as DSA. If they tell you the first thing which you will do whenever a patient says you're suspecting renal artery stenosis, and if a patient comes to you in that particular condition, I will always go for an ultrasound Doppler. I will always go for an ultrasound Doppler. Okay, hope this entire table is clear to you. One more thing, if they ask you anything neurogenic, pancreas tumors, brain tumors, anything pertaining to spine, my answer will be, most of the time my answers will be MRI. My answer will be MRI because of its highest soft tissue contrast. Okay, so I hope this entire chart is clear. Again, pregnancy, remember that if the options are given in the form, this is the way you will select. For pregnancy, my first modality will be always ultrasound. It's the safest modality. You don't have to worry about it. If I'm talking about the next modality which I will choose, it would be MRI. It would be MRI. See, it depends upon what pathology they have asked also, but usually it would be MRI. That would be a safer modality, followed by that of your CT or X-rays. Again, CT or X-rays which are there, they will be done only and only when they will be done? If you are basically able to justify if the for what the patient has come. Like for an example, if a patient is coming to you with a road traffic accident, you're suspecting a splenic injury, will you wait that no, we cannot do a CT? You will not do that. Okay, you will immediately do a CT. So it again depends if you are able to do justification, okay, from the GOD principle, that is justification, optimization and dose limitation, okay, from the principles of the radiation protection. If you are able to justify this, and if you use the ALARA principle, that is as low as reasonably achievable, you can do the CT. What about the contrasts? Again, CECT and CEMRI. Again, if you are able to justify that particular thing, you can do. Traces of gadolinium can pass through that of the placenta. They can also pass through a lactating mother in the breast. But there is no perfect answer to this question. Okay, this is the sequence which you will see, and of course it depends upon the clinical scenario which has been given. Okay. Now let's move towards our next question. Sunny Singh is asking, is PET-CT is only for meds? No, it's not only for meds. You can see many infections as well, and we will cover that in the nuclear radiology as well. Okay, now let's move towards our respiratory radiology. Quick spotters which we are going to cover now. Almost all the systems I have included, and we are going to have a very rapid, really it's a marathon, and we are going to cover many important spotter images. Okay, now the first image which you are seeing over here, what you are seeing over here is a Ellis curve. Okay, you are able to see that there is a beautiful Ellis curve over here. Okay, or you can also see what you are seeing. This is a homogeneous opacity that you are seeing in the left lower lung node. So what is this? This is your pleural effusion. This is your pleural effusion. Now the thing is, okay, this is very easy. Everyone knows you're not able to see the CP angle. It is also blunted. But even for the blunting of CP angle, I will require at least 200 ml of fluid. For this Ellis curve appearance, this beautiful curve, if I this concavity which I am seeing, again that is rising up along the left lateral wall, you require at least 300 to 500 ml of fluid. But I want an investigation that can pick up 5 to 10 ml of fluid, and I've already said that anywhere in the body my fluid is there. My best investigation will be always an ultrasound. Right now, if they ask you what is the best X-ray that will pick up this particular pleural effusion, so my best investigation or best X-ray will be a lateral decubitus view. It will be a lateral decubitus view, because again that will be able to pick around 10 to 50 ml of the fluid. So look at the question where they have asking whether they have asked you a best investigation, whether they have asked you a best X-ray. Okay, now in the lateral decubitus position also, again, if I'm suspecting my pleural effusion on the left side, I will ask my patient to lie down on the left side. That is left lateral decubitus if I'm suspecting on left side. But if I'm suspecting pneumothorax, it will be opposite, right? If I'm suspecting a left pneumothorax, I will ask my patient to lie down on the right side, okay, so that the air can rise. Okay, so I hope that is clear to you. Now let's move towards our next pathology. What you are seeing, you are able to see that there is a fluid level that is present over here, plus there is a lucency and there is no bronchovascular marking also. So quick spotter, this is hydropneumothorax. See, before I write, please write down in the chat box, so it will actually test you also, and it would be really fun. Okay, so let's talk about the third image. The hint which they will give you is that the patient is having either foul smelling sputum, okay, or putrid sputum, or there is a risk of, there is some risk of aspiration, like there is alcoholism, something like that will be given to you with this type of an image. What is this? What you are able to see over here, you are able to see a lesion that is having this air fluid level. This is your nothing but lung abscess. See why the history is important, because this cavitary mass can be hydrated cyst, it can be a squamous cell carcinoma. We cannot tell that on an X-ray, right? There are so many differentials for a cavitary lesion. It can be vaginal also. So there are so many differentials. So always look for the clinical hint, because that is very important. See, it's not aspergilloma. Yes, it could be an aspergilloma, but my hint was that the patient is having this foul smelling sputum plus there is an aspiration risk. So this is a lung abscess. Right, now what about the Silhouette sign? Okay, so just quick revisions. What is the Silhouette sign? So Silhouette sign is that if there are two structures of similar radiographic density, if they come in contact with one another, it is going to obscure the margin. It is going to obscure the margin, and that is the definition of the Silhouette sign. Okay, now if I talk about the first pathology over here, what happens if there will be a Silhouetting of this particular line, which is called as your right paratracheal stripe, which is my right paratracheal stripe. If that will be Silhouetted, suppose there is a pathology over here and it Silhouettes this right paratracheal border, that means my pathology is present in the right upper lung lobe. Okay, for the left upper lung lobe, the pathology will obscure my aortic knob. It will obscure my aortic knob. Okay, now what about the number 3, right middle lung lobe? I will see that my pathology will obscure the right cardiac border. Okay, if the pathology is present in the lingula, it will be obscuring my left cardiac border. If the pathology is present in the right lower lung lobe, it will obscure the right dome of the diaphragm. And if my pathology is present in the left lower lung lobe, it will obscure the left dome of diaphragm. Okay, so that is about this. Aspergilloma, it's not aspergilloma. I will be covering aspergilloma just in a moment. Okay, now let's, what if I'm using my cell house sign principle, can you tell me that what particular lobe this pathology is? See, I'll tell you that this is consolidation. This is the homogeneous opacity that is present in the right middle lung lobe. Can you tell me that which particular lobe is involved over here? Which lobe is involved? Okay, using the principle of the Silhouette sign, what is the principle? Again, you can see that the obscuring of the right cardiac border. Okay, so which lobe is involved over here? Yes, so this pathology which is there, very good Gaurav, this is present in the right middle lung lobe. So anyway, they can show you the pathology, and using the Silhouette sign, using the 6 important localizers, you can localize where exactly it is present on a lung X-ray. Right, now let's move towards your favorite aspergilloma. So I'll give you a hint. The first lesion which you are seeing over here, you are able to see that there is a solid lesion that is present, plus you are able to see this crescent of air in a cavitary lesion. I will give you the hint that the patient is having normal immunity. I will also might give you a hint that the patient has got previous tuberculosis, or there was an emphysematous bulla that was present. So what happens in a pre-existing cavity, the localization by aspergillus can occur, and that will lead to what? That can lead to your very favorite aspergilloma, right? So this is your classical monod sign which you will get. Right, now another important thing in aspergilloma monod sign is that this particular ball, this fungal ball or aspergilloma, this is mobile. Okay, so for checking this particular mobility, I will ask my patient to turn prone. Okay, prone and supine, I can basically change the position, and you will be able to see that the ball also moves with that. Now in the second image, okay, in the second and the third image, I will give you the hint that my patient is hyperimmune. The patient is either having asthma history, or there is a elevated IgE, there is a history of A2P, there is some elevated eosinophil count. So all this history will be given to you with such classical X-ray or bronchiectasis. What is this? This is my classical finger in glove appearance, and that you will see with allergic bronchopulmonary aspergillosis. So this is my classical finger in glove appearance. Why do you see this finger in glove? Because your dilated bronchi, they will be filled with lot of mucus. Now this mucus, if I want to see on a CT image, what you are able to see? You are able to see this hyperdense type of mucus, right? So the question they can ask you is that this is a HAM, or I would say high attenuating mucus. This is a high attenuating. See, this is very chronically present, and anything that is chronically present either in the sinus, either in the bronchus, they will have a tendency to have a increased attenuation. So this will be high attenuating mucus, and that is again a hallmark of ABPA. That is again a hallmark of ABPA. Right, now let's move towards the next history, the next question category, again in aspergilloma. Now I am giving you a history that the patient is having neutropenia, the patient is having HIV, or the patient is on steroids, and you are giving this classical sign over here, that is there is a central consolidation surrounded by ground glass thing. What is this particular sign? Can someone tell me? No, this is not tree in bud appearance. The first image which is there on your image screen is your CT halo sign. This is your CT halo sign. Now, if I talk about the CT halo sign, this is not specific to that of invasive. See, this is classically seen with invasive aspergillosis. Right, now if I talk about the differentials, similar lesions can also occur if there is hemorrhage. Okay, if anything that will be invading through the vessels, or if there is a bleeding present, like for an example hemorrhagic metastasis, like vasculitis, like for an example vaginous granulomatosis, they will all present with this CT halo sign. Okay, now if you see the third image on your screen, the third image over here, you are seeing that there is completely opposite. There is a central ground glassing that is surrounded by consolidation. So this is my reverse halo sign, and this reverse halo sign is also called as the atoll sign. That is also called as the atoll sign. So very good, Dhanush. It is, yes, it is seen with that of the cryptogenic organizing pneumonia, but it can also be seen with mucormycosis. It can be seen with COVID pneumonias, and it can be also seen with chronic eosinophilic pneumonia. So look for the question hint what they are giving to you. With mucormycosis, they might give you some classical history of diabetes, right? With cryptogenic organizing pneumonias, again the cause which is there, it is idiopathic. They may present with that of shortness of breath. Okay, and of course, if I talk about the chronic eosinophilic pneumonias, they will have this high eosinophil count. Another important imaging finding which you can get with chronic eosinophilic pneumonias is the reverse bat wing. Okay, normal bat wing you get with pulmonary edema. With chronic eosinophilic pneumonia, you can get a reverse bat-wing appearance. Right. Now, if I talk about the middle image, again, this is an image from invasive aspergillosis, and it is a, I would say, a very close differential to monod sign, but this is not monod sign. This is your air crescent sign. If I will be asking my patient to move, will this air move over here? It will not move. So what happens is that in an invasive aspergillosis, when I'll start with the treatment, if I start antifungal, what happens? There will be resorption of the consolidation. If the consolidation will now start to retract, it will leave an air crescent. So this is nothing but my air crescent sign, and this is air crescent sign of invasive pulmonary aspergillosis. And remember that this is a sign of recovery. This is the sign of recovery and not of poor prognosis. That means that the treatment is responding and the consolidation or the cavitation which is there, it is now retracting, and that is why it is leaving this air crescent sign. Okay. Mayank, how much duration? So the class will continue till 10:30. Okay, because we have to cover all the systems. So that is why. Okay, second is okay, fine. Now let's talk about the type of calcifications which you can come across in the lungs. So when I talk about the first image over here, they can either give you an X-ray or CT, and you are able to see this classical calcification pattern which is seen in pulmonary hematoma. That is your popcorn calcifications. So this is your popcorn calcification. You can also show some fat that is present in this lesion because it's a hematoma, okay, disorganized tissue. Now when I talk about the other popcorn lesions which are present in radiology, so there are many popcorns. One can be in the fibroid, especially if I talk about an involuting fibroid. They can be seen in a hematoma, I've already told you. Popcorn appearance can be also seen in a brain cavernoma because of the multiple aging of the different blood products which you see. Then you can also see this in the chondroid matrix. Now where will you see the chondroid matrix? Wherever there is a cartilaginous matrix, or wherever, like for an example, if I talk about enchondromas, okay, just an example, in enchondromas you will get this chondroid matrix. In chondrosarcomas you can get, right? So you will get this chondroid matrix that will be either in a form of ring and arc, or you will get this stippled type of calcification pattern, but you can also use the term popcorn calcification pattern in the chondroid matrix. Now if they ask you eggshell calcifications, where you will see eggshell, you will see that in silicosis, and you can also see with sarcoidosis. This was a question that was asked, you should know. Eggshell calcification, I'm talking about the lymph node that you can get with silicosis and sarcoidosis. Now there are two important terminologies I want to stress, that is Carney's triad and Carney complex. I'm sure you must have learned this in medicine and surgery, but a quick revision, because many students get confused with pulmonary hematomas and Carney's triad. It is CGG. This is my most favorite mnemonic. I've told this in many classes. So CGG, which is there, it will be your pulmonary chondroma and not hematoma. Okay, G which is there, it is your GIST, and another G which is there, it is your extra-adrenal paraganglioma. This is my extra-adrenal paraganglioma. Okay, right. Okay. Sunny, you will get this PDF. You will get it immediately after the class. Okay. Okay. Okay, now let's talk about the Carney's complex. So Carney's complex, remember that the mnemonic is a mess. So remember that the patient is in a complete mess over here. You will get multiple myxomas. Okay, you can get multiple myxomas over here. You can get endocrine hyperactivity. Okay, okay, so myxomas can be again cardiac or they can be cutaneous. They can be cutaneous. You will get endocrine hyperactivity, either adrenal lesions or either testicular lesions can be also there. And SNS is for your spotty skin pigmentation. That is for my spotty skin pigmentation that you get with Carney's complex. Okay, so that is about this particular thing. Now let's move towards our next important spotter image. I will give you the hint that the patient is having ptosis, meiosis, and ophthalmos shoulder arm pain that is radiating to the arm. So this is classically, I'm talking about what? I'm talking about the Pancoast tumor. This is the Horner syndrome that is classically associated with Pancoast tumor. Everyone knows this. You have to closely look for the lung apex. They can show you either an MRI, either a CT or an X-ray with such apical lesion, okay, in the lungs. So the most common is which particular lung cancer? It is the squamous cell carcinoma of the lung. Right now, if I'm talking about the investigation of choice, always mark your answer. I've already covered this, but my investigation of choice again, it is MRI. If it's contrast enhanced MRI is given, then you can mark your answer as that again, because I want to see the involvement of sympathetic chain. I want to see the involvement of the brachial plexus. All that could be seen only on an MRI. If I'm talking about the gold standard modality, if they ask you something regarding the gold standard, you have to, again this was asked, so you have to mark your answer as CT guided biopsy. Okay, or if even biopsy is given in the question, in the options, you can mark your answer as biopsy. Okay, so that is about the Pancoast tumors. Now again, some spotter images. The first image, I am giving you the hint that the patient is having an elevated ACE levels, or the calcium levels are also elevated, plus you are seeing this multiple potato nodes. Okay, so these are nothing but your sarcoidosis. Okay, you are able to see that there is an enlargement of right paratracheal lymph nodes, plus there is also enlargement of bilateral hilar lymph nodes. This is also called as my 1, 2, 3 sign, or potato sign, or pawnbroker sign, all one and the same. This is classically seen with sarcoidosis. What staging which we are using over here? We are using the scadding staging. Right, so if I talk about the scadding staging, the stage 1 is hilar lymphadenopathy, that as you're seeing on your screens. Then the stage 2 is that there will be also pulmonary infiltrates. Okay, third will be pulmonary infiltration, but there is no lymph nodes. And the fourth, which is also very rare, and that will be in the end stage, that will be fibrosis. One thing in the CT, again, we have covered this in the main classes, but remember that on CT you will get what type of nodules could be tested. So you will get this peri-lymphatic distribution of the nodules. It could be tested in sarcoidosis. Peri-lymphatic means that it will be present along the subpleural location, or peribronchovascular distribution, or subperiphyseal distribution. That is the classical nodular distribution which you get in sarcoidosis. Now, what about this nodular pattern? This nodular pattern type, what is this classical nodular pattern? This is my tree in bud pattern of the opacity. Again, this will be indicating what? This is indicating that there is a endobronchial spread. There is a endobronchial spread of the infection that you will see in the tuberculosis. But if you see the third image over here, you are seeing that there is a miliary pattern. Now, if I'm talking about miliary pattern in tuberculosis, remember that miliary pattern which is there, it also indicates that there is a hematogenous spread. There is a hematogenous spread of infection. So both are different. Miliary, you will always get this classical history of immunocompromised patient, and you will get this diffuse spread throughout the lung parenchyma. Tree in bud can be also limited to just a single lobe. Okay, so this two you have to remember. Now let's move towards our next image, spotter. I am giving you the history that the patient is having recurrent chest infections, plus there is also sinusitis that is present. Look at the heart over here, you can see it is towards the right. There is also dextrocardia that is present. I would also say that the liver is also present on the left and spleen is present on the right. So there is a situs inversus. We are talking about the characteristic Carter-Jenard syndrome. So look for the clinical hints with such bronchiectasis picture. Either they can show you this cystic bronchiectasis, this bunch of grapes appearance they can show you, or they may show you this tram track appearance on the x-rays. Both your answers, you have to look for situs inversus, sinusitis. This triad is classically seen with Carter-Jenard syndrome or with that of primary ciliary dyskinesia. But if you talk about the second image, I will give you the hint that the patient is having pancreatic insufficiency. There is an elevated sweat chloride, recurrent chest infections, the relatively younger patient. Okay, in that condition, again, you are seeing this classical tram track appearance, upper lobe predominance is there. There is bronchiectasis that is happening. So in that particular condition, my answer will be cystic fibrosis. Okay, so don't get confused between these two pathologies. The situs is absolutely normal in cystic fibrosis. Okay, no confusing between these two important pathologies, very frequently tested. Okay, now another classical spotter image, I've just written it because you know everyone knows this. These are the very favorite cannonball meds. Okay, everyone knows this cannonball meds. The mnemonic is crack. So remember, it's choriocarcinoma, RCC, adenocarcinomas, or the GIT, childhood cancers like Wilms and osteosarcomas, and you can also see this with the Kaposi sarcoma. Okay, now if I'm talking about the osteosarcoma, remember that in osteosarcoma you can also get metastasis that can cause pneumothorax. Okay, so this is only one particular pathology where you can get this metastasis causing pneumothorax with osteosarcoma. Also remember, with osteosarcoma you can also get calcified metastasis. You can also get calcified metastasis. So just an extra point which I remembered, seeing this metastasis. Okay, now again classical spotter image, you will get a history, a newborn having a severe respiratory distress. Two important spotters, no confusing, both are different pathologies. I will like you to concentrate on the second image. In the second image, you are able to see that right dome of diaphragm is intact, but the left dome of diaphragm is not seen. Right, you are seeing that there are multiple cystic areas that are present in the left lung lobe, creating a significant mass effect, pushing the heart towards the right side. What we are talking about? We are talking about congenital diaphragmatic hernia. Okay, remember that they can also give you an Ryle's tube that is present in the chest. Okay, and that would be, I would say, the most specific or most diagnostic of congenital diaphragmatic hernia. Okay, now another thing is that they will also have a significant mass effect. It will also have a significant mass effect. If I am talking about the first image, Okay, again you are able to see a similar lesion, multiple cystic lucencies, similar history is present, but you can see that the dome of the diaphragm is completely intact over here. What I am talking about? I am talking about CPAM over here. Okay, congenital pulmonary airway malformation. It's a malformation that is present within the lung parenchyma. Overall, the relative mass effect which is there, it will be left. You will not see any Ryle's tube over here. The mass effect is also relatively less, and the diaphragm which is there, it will be absolutely intact. So there should be no confusion between these two important pathologies, right? Now let's move towards our next pathology, and I think this is the last from the chest section. So again, the classical history of excessive salivation, choking during the feeds. What you are able to see is, you are able to see the classical coiling of the Ryle's tube. Okay, so everyone knows this particular thing, that this is a tracheoesophageal fistula. But my extra edge question for you is, what is the type of this tracheoesophageal fistula? Okay, I'll give you a hint that I'm able to see the gastric bubble. I'm able to see a distal gas over here. So tell me, everyone knows this is a TEF. Can you tell me what is the type of this particular T? There is definitely a component of esophageal atresia because there is coiling is present, but also there is distal hair. So yes, Dhanush, perfect. This is type C. Now why this is type C? If you see this image closely, there is an esophageal atresia in type C, but there is a distal communication of the esophagus with the trachea. Because of this, you are able to see this air or the gastric bubble. But if I'm talking about proximal fistulas, like for an example type B, it will not have this gastric shadow. Pure esophageal atresia, only coiling, and again you are not able to see a distal gas. That will be what? That will be your type A. That will be my type A. Okay, so they can ask you the type. That is a little extra edge which they can test you on the radiology. Right? Now let's move to some important spotter images from the CVS section. Okay, so first thing what you are seeing on your screen is, I'm really sorry if the speed is too much. We have to cover a lot of systems. So if any doubt is there, please write it down in the chat box and I'll answer them. Right? Now the first image which you are seeing over here is a pacemaker. You are able to see that there is an RA pacing wire, there is a RV pacing wire, and both the leads which are there, they are present in, one is present in the right atrium. Okay, this is present in the right ventricle. The base of the heart, remember, it's formed by the right ventricle. If you are able to see the lateral X-ray, you can see that the anteriorly placed lip, anterior and superiorly, that is the RA pacing wire. The inferiorly along the base is always the RV pacing wire. So why I have shown you, because they can ask you the best X-ray to see the positioning of this pacemaker and its positional wires. The best investigation which is there, it is an X-ray or a radiograph. Okay, now if I'm talking about a better X-ray view which they can test you, so the better X-ray view is always lateral. Okay, lateral is much more better than that of a PA or an AP view, because you can see the positioning of the leads more accurately on a lateral X-ray. But if they tell you absolute contraindication for this pacemakers, remember that absolute contraindication, everyone knows that it is an MRI. You will never do an MRI with a patient who is having a cardiac pacemaker. Okay, now if I'm talking about an ICD device will have shockable coils. Okay, you will be able to see that thicker shockable coils. If you remember from the class, you will be able to see this thicker shock coils, whereas in the pacemaker, you will have relatively thinner leads. Now, this is an important X-ray, and I'll be covering some important pointers in this particular X-ray. So you can see that, of course, that the cardiothoracic ratio over here is increased. It is definitely more than that of 0.5. So there is a cardiomegaly is present. There is a fissural component of the pleural effusion that you can see that is present. Now you are also able to see that there are a lot of sternal sutures that are present, right? So this indicates that the patient has also, the patient which is there, it will be also having what? The patient has also undergone what? Some surgery has undergone. Now the surgery, you can see there are two valves over here. There are two valves. I have drawn a line over here from the right cardiophrenic space. Okay, this is the cardiophrenic space. I hope you know this is the cardiophrenic space. And this is my left atrial appendage over here. If I draw a line, anything that is above it, okay, the valve which is above it, that will be my aortic valve. The valve that will be below this particular line, that will be my mitral valve. That will be my mitral valve. Right? Now, if I'm talking about this particular lines, can you see this prominent peribronchial cuffing? So this also indicates that there is also some component of pulmonary edema that is present, because you are seeing that there is a lot of this reticulations, and also there is a lot of peribronchial cuffing. So this patient has cardiomegaly. This is a fissural component of pleural effusion, indicating that there is some fluid overload. This patient has undergone what? He has undergone some surgery. There are sternal sutures. This is how you will identify. You know aortic valve, you know mitral valve, you know the positioning of the pacemaker and the leads that are present in the right atrium and the right ventricle. right? So here it is little above, okay, should be somewhere near the base, that is the right ventricle. So lot of pointers I have covered on this particular X-ray which you should identify, right? Now let's move towards the important heart border. So I've already covered this. So if you see, this is the right atrium, this particular part which is there, it is the right ventricle, this part which is there, it is my left ventricle, a little bit part is formed by left atrial appendage. So what is left? Okay, so remember that left atrium which is there, it will come somewhere in the middle. So left atrium which is there, it is not contributing to the any border on the chest X-ray. Okay, so whenever there will be an enlargement of the left atrium, what will happen? It will lead to what? Splaying of the carina. The angle which is 90 degree will now increase if there will be enlargement of the left atrium. Right, now what about these two valves? You can also see that there is presence of an aortic arch. Then you can also see that there is some prominence over here of the pulmonary artery. So either left pulmonary artery or main pulmonary artery, I would say, will be present just below the aortic arch, and the space between this aortic arch and the pulmonary artery, that will be my AP window. Okay, what will be contributing here to the right paratracheal stripe? That will be contributed by superior vena cava. Right, so these are the important heart borders which you should know. Okay, now the most favorite, everyone knows this, so quickly answer all the important congenital heart diseases. I will give you some hints. The first hint is that the patient, the first image, okay, patient is cyanotic, he is few months old, not a newborn, patient is having an ejection systolic murmur. Okay, please answer the first one. Also you can see that the lung fields, there is a relative pulmonary oligemia that is present. What is this classical X-ray appearance? Pulmonary oligemia, cyanotic, few months, ejection systolic murmur is present. Can someone please tell me? Yes, TOF. Yes. So everyone knows this. This is the boot-shaped heart, core and sabot, and of course this is your TOF. Now the second image which is there, again you are able to say that this is the cyanotic, and you are able to see this widened mediastinum. This is almost looking like that of what? It is looking, please write down the pathologies as I am describing. We don't have time, but just write it down so that you can quickly revise. You are able to see this classical snowman or the figure of 8 appearance. So this is your total anomalous pulmonary venous connection or the return. Right, now if I'm talking about the investigation of choice, if I want to see the TAPVC, I want to see all these pulmonary veins. Okay, what happens? The pulmonary veins will form this vertical vein. If I want to see the entire vascular structure over here, my investigation of choice will be definitely CT angio. It will be CT angio. Okay, I'm not sure whether it's called Christmas tree, but it is definitely called snowman or the figure of 8 appearance. And the investigation of choice, if I want to see anything vascular, will be CT angio. Otherwise, for almost all your congenital heart diseases, investigation is echo, investigation of choice. But if I want to see anything vascular, my investigation of choice will be CT angio. Okay, now the third image, I am giving you a hint that the patient has taken antenatally, the mother has taken lithium. Okay, what are you seeing over here? You are seeing that the heart which is there, it is massively enlarged, right? This is also called as wall-to-wall heart, or it is also called as the box-shaped heart seen with Epstein's anomaly. Now, why do you see this Epstein anomaly? You can see that there is, what happens over here? There is a displacement of the tricuspid valve inferiorly towards the apex, right? What leaflet? The septal leaflet and the posterior leaflet which is there, it will be displaced apically. Because of this, this leads to atrialization of the right ventricle. So it's the massive enlargement of the right atrium that will lead to this classical wall-to-wall heart or a box-shaped heart, right? Now, fourth image, what are you seeing over here? Again, I'm telling you a history that the patient is cyanotic, but this time I'm telling you that the patient is a newborn. Also, look at the lung fields over here. There is a relative pulmonary blood flow plethora. There is an increased pulmonary blood flow. What pathology I'm covering over here? You are seeing this classical appearance. So you can see that the mediastinum over here, it is relatively narrow over here. So this is nothing but my egg on side or egg on string appearance. Egg on side or egg on string appearance that you will see with transposition of great arteries. And of course, you will see this because what is the pathology over here? There is the absence of spiraling of the aortopulmonary septum that leads to this great transposition. Right, so these are the 4 important pathologies. Now the next one is you are able to see this classical vascular structure paralleling the right heart border. So what you are seeing over here, you are able to see a Schmitar sign. Okay, this is also called as the Schmitar vein. This is nothing but my partial anomalous pulmonary venous connection. Remember that when I'm talking about the Schmitar sign, this is looking like that of a Turkish sword, right? Now if I talk about the this PAPVC, it is not completely cyanotic, it's a mixed circulation. So I'll classify it in the acyanotic category. That is how you differentiate it from TAPVC clinically. And if I talk about the syndrome, The syndrome is Schmidt syndrome. Okay, so what happens? What four things will come in the Schmidt syndrome? So remember, there is an absent or hypoplastic pulmonary artery that leads to increased or unilateral translucency in the lung. That will also lead, there will be also an associated dextro position. Okay, the heart will be shifted towards the right, plus there is a pulmonary anomalous connection, right? Pulmonary venous connection, anomalous pulmonary venous connection that you will see. So that is the four things that you will see with this Schmidt syndrome. Now, if I'm talking about this particular image, okay, everyone knows this already. The sign is also given to you. Turner syndrome, radiofemoral delay, hypertension, young patient, probably female patient, more likely they will give you. This figure of 3 sign will be classically tested you on what? On the X-ray. It's very subtle. Already I've drawn the 3, so it's easy to identify. But if you look very closely for this figure of 3 with such clinical hints, so we are talking about aortic coarctation. We are talking about aortic coarctation. Now, my investigation of choice which you need to know for both the pathologies, PAPVC, TAPVC or aortic coarctation, as I said, if I want to see all these vascular structures, my investigation of choice will be CT angio. Okay, now can you tell me what is this Rosler sign? So, Gaurav, sunflower, yes, please tell me what is Rosler sign that you will see with aortic coarctation. So in the coarctation, you will see this lot of collaterals, okay, intercostal collaterals, and especially if you see it along the 2/8 ribs on the posterior aspect, this inferior rib notching, that will be your inferior rib notching that will be classically seen with this aortic coarctation. Okay, so these are some important radiology signs which we are covering. Now let's move towards this particular thing. So just label what is 1, 2, 3, 4 and 5 and 6 for me. So first we'll tell. So 1 which is there, what is the structure number 1? See, if you remember this particular sequence, remember SAP. So 6 which is there, it will be my SVC. Okay, 6 will be my SVC. Okay, if I talk about number 1, that will be my aorta. Okay, particularly I'm talking about ascending aorta. Number 2 will be my main pulmonary artery. If I talk about 3 and 4, so 3 is my right pulmonary artery, 4 is my left pulmonary artery, and 5 is descending aorta, just adjacent to the vertebra posteriorly. That will be my descending aorta. Okay, now let's talk about. So this is my CT angio which I have talked about, and these are some important important structures which they can ask you to annotate. So this is a very important image per se for your examination. Okay, remember this particular sequence of SAP on the CT chest angio, right? Okay. Okay, Prem, which X-ray is looking normal to you? Okay, it's aortic coarctation. You can see this classical figure of 3 sign, because at the point of the coarctation you are seeing this particular indentation, right? So you can see that. Now let's talk about the next important structure. So just inferiorly, if I'm coming in the heart, what you are seeing in the heart chambers, this is right atrium, this is right ventricle, this is left atrium, this is left ventricle. What structures will drain over here? These are my pulmonary veins that will drain in the left atrium. This is again my descending aorta. Now what structure will come between the right atrium and the right ventricle? So remember, that is my right coronary artery which will come in this particular groove, okay, between the right atrioventricular groove. Now what structure or which artery will come in the anterior interventricular groove? Between the two ventricles, that will be my left anterior descending artery, that is the coronary artery. Okay, I really think that this could be tested. So if I'm talking about this particular talking about the LAD, this is not normal. You can see that it is dilated, plus you can also see that there is a filling defect that is present. So there is also presence of thrombus that is present over here. Okay, now I am giving you a history that the patient is having fever for more than that of 5 days. No other cause has been diagnosed. This is pyrexia of unknown origin. Plus, there are symptoms pertaining to either of the following can be given, like conjunctivitis, which is bilateral, non-purulent. Plus, there is rash, adenopathy, strawberry tongue, hand-foot changes like edema and deformation. So what I am talking about? This classical medium vessel vasculitis. This is my Kawasaki's disease. Okay, medium vessel vasculitis, and this could be really tested. I really hope that this is tested, because we have covered this very nicely in the class as well. Can show you a coronary artery with thrombus, with aneurysms. Okay, that is the only pathology in the pediatric patient for coronary arteries which could be tested. Right, now let's talk about the next pathology. So everyone's favorite, with classical history of tearing, pain and hypertension, you are able to see that there is an intimal tear. You are able to see there are two lumens, one having a relatively delayed flow or a relatively fainter opacification. So this is my false lumen, this is my true lumen, which is relatively smaller. which is relatively smaller also, plus it is showing this adequate contrast enhancement. So that is basically we're talking about aortic dissection. Remember, ascending aorta is involved. So this is my Stanford A. This is my Stanford type A. Yes, Dhanush, ball, tennis ball appearance. This is my Stanford A. Remember that the false lumen which is there, it is relatively larger. It will be showing relatively delayed or a fainter contrast enhancement. True lumen will be relatively smaller. It will be of course showing the main continuity with the main lumen, and it will also show it will also show a significant contrast enhancement. Right now, if I'm talking about the Stanford A, remember that the management which is their surgery, so they can ask you what is the next best step. So next best step for type A will be surgery, whereas for descending aorta or Stanford type B, you can medically manage this particular patient. If I'm talking about investigation of choice, so for unstable patient, if the question says unstable, my answer will be transesophageal echocardiogram to see this aortic dissection. Right? If I'm talking about the stable patient, then you will mark your answer as CT angio. You will mark your answer as CT angio. No sunflower, no, it is never MRI. Okay, for stable MRI takes a lot of time. Okay, you will never do that in an unstable patient. Right? Esmolol for B, yes, I am sure esmolol is the answer for type B. Okay, but of course the medicine faculty would have told you very nicely about the dissection treatment. Okay, now let's talk about the other pathologies over here. So what you are seeing over here, again a barium image, you are able to see a smooth posterior indentation, and I'm telling you that the patient is having this dysphagia. Sometimes these patients are also asymptomatic if the indentation is not that great. I'm clubbing this with the CT image. You are able to see that there is a vessel that is arising from the left side and it is going towards the right side. So what is this particular pathology I'm talking about? This is nothing but my dysphagia lusoria. Where will you see this dysphagia lusoria? This will be seen classically with my aberrant right subclavian artery. Aberrant right subclavian artery, that is my dysphagia lusoria. A classical spotter, either a barium can be given or a CT can be given to test you for dysphagia lusoria. Investigation of choice to confirm this will be definitely CT angio. Okay, now nextly, again a similar image, you can see that there is a mitral valve. Okay, we know that we draw a line from the right cardiophrenic space to left atrial appendage, valve below that line, that will be my mitral valve. You are able to see that there are two heart borders over here. You are also able to see a relatively straightened left heart border. So what is this particular pathology? We are talking about left atrial enlargement in a mitral stenosis. So classical signs, you will get straightening of left heart border. Why do I see the straightening? Because my left atrial appendage is enlarged over here, and that is why that will contribute to this straightened border. You will see the double density sign. You can see this LA which is there. Normally it will not contribute to any border, but now you are seeing this enlarged left atrium border, so you will get this double density sign. Then of course you can get this playing of the carina because of the enlargement of the left atrium. And then lastly, of course, the spleen will be indicating more than 90 degree of angle because of the enlarged left atrium. Right, so these are all my mitral stenosis sign. One more thing I wanted to stress on the signs, I have not included the image because everyone knows about pulmonary edema, okay, or heart failure. So if I'm talking about the pulmonary capillary wedge pressures between 12 to 17, then you will start seeing the cephalization. Okay, you will see the cephalization or the diversion of the blood flow in the upper low pulmonary veins. With 17 to 25 mmHg pressures, you will start seeing curly B lines that will be seen along the bases, that are the prominent interstitial lines. If I talk about the pressures more than that of 25, I will now start seeing alveolar edema because now the fluid has come from the interstitium into the alveolar spaces, that will give rise to my bat wing appearance. Right? So that is one thing which I wanted to touch. Now, important cardiac MRI images. I am giving you the hint that the patient is having a young athlete who has got a sudden cardiac death, and with this particular image, with this clinical hint, they are giving you an MRI image. You are able to see that there is a septal hypertrophy that is present. I would use the term that this is the asymmetrical septal hypertrophy. The septal thickness is more than that of 15 mm. So what I am talking about, which particular pathology I am talking about? Can someone please answer? This is one of the most easiest cardiac MRI and could be really tested at NEET PG level. So this could be really tested in this examination also. It's a very important topic. So this is basically your HOCM. This is my hypertrophic cardiomyopathy. Yes, yes, Sunflower, right? Perfect. It is HOCM. Now, if I'm talking about the investigation of choice, I want to see the morphology. See, initially I'll do an echo. Okay, on the echo, I will see SAM, that is classically seen with this HOCM, that is systolic interior motion of the mitral leaflet, that is classically seen with HOCM. Now, if I'm talking about the investigation of choice to see the morphology, then you will mark your answer as MRI. You will mark your answer as MRI. Now, again, because we were covering echo, I'm sure you have covered in medicine, but two important signs I wanted to touch. See, SAM you will see with HOCM. If I'm talking about the McConnell sign, where you will see McConnell sign in which there is, I'll just tell you the sign and you tell me the pathology. There is a right ventricular mid-wall akinesia or hypokinesia, and there is a spared apex. Okay, the apex of the right ventricle which is there, it is spared or it is normally contracting. Where will you see this McConnell sign? Can someone please answer this? McConnell sign you will see with acute pulmonary embolism. Acute pulmonary embolism, right? If I'm talking about the septal bounce, where you will see the septal bounce, so I'm giving you a hint on X-ray, you are getting egg in cup appearance, or you are getting a heart and that will be having calcifications. That is having a calcification around it, or I would say that there is a calcification that is present in the pericardium. In the pericardium. Okay, so this calcified pericardium that I'm talking about is constrictive pericarditis. That will be seen with constrictive pericarditis. And what you will get on echo, you will get this septal bounce. Why you will get septal bounce? Because during inspiration, when the blood will enter into the right ventricle, it has nowhere to go. It will not distend the pericardium because it's very thick. So it will now create the pressure on the septum, which will be now bounced back towards the left side. It will go towards the left side. Then when the blood will again fill in the left ventricle, the septum will again be pushed back towards the right side. So that is the septal bounce motion that you will see with constrictive pericarditis. Right. Okay. So meniscal tear. Where is meniscal tear? I'm not talking about the meniscal tear right now. Okay. Now let's move towards our next cardiac MRI image. A 65-year-old postmenopausal woman develops acute chest pain. There is ECG changes that will be mimicking MI. There are elevated troponins. Okay, so everything is looking like that of MI, but there are clinical hint of recent emotional stress, okay, or physical stress. Coronary angiography has shown completely normal coronary arteries. What I am dealing with, a very classical X-ray, a very classical MRI image which I have shown to you is of what particular pathology? Everyone, please answer this particular thing. This is a very high potential question, could be tested for the cardiac MRI, because I feel cardiac MRI is really developing in our country and it could be really tested in your NEET PG examination. Very good, Shashi. This is Takatsubo cardiomyopathy. Okay, this is Takatsubo cardiomyopathy. This is also resembling that of a Japanese octopus. You can see that how the neck which is there, it is narrow. The base of the ventricle which is there, it is ballooned. So this is my Takatsubo cardiomyopathy. Now one more echo finding I will cover over here. That is, here the patient will be having a apical hypokinesia. The apex which is there, it will be hypokinesia, means it will be contracting relatively less. But the basal part of the heart or of the left ventricle, it will be having hyperkinesia. It will be having hyperkinesia. Okay, so many echo findings we have covered with this particular pathology with the heart. Now again, a classical spotter image, inguinal swelling after catheter angiography. So this is the clinical hint we are going to give you. Catheter angiography. In the femoral artery, you are putting the probe. There is a pulsatile swelling. You are able to see this classical Pepsi sign, or it is also called as my yin-yang sign. Okay, what has happened over here? There is a pseudo-aneurysm that has formed, right? There is a pseudo-aneurysm because the adventitia of the artery is damaged, because I have done some catheterization. The adventitia is damaged, and because of this, okay. Okay, so if I'm talking about this particular thing, what you are able to see that the adventitia, see, adventitia which is there, it will be damaged, and you will see this particular outpouching over here. Now what happens is that the blood which is there, it is going to move like this. Now in this particular situation, if I'm putting my probe over here, what is happening? It will be detecting the blood flow that is moving towards the probe, and it will be also detecting the blood flow that is moving away from the probe, right? So two blood flows it is detecting, and that is why you will get this to and fro motion in the spectral Doppler, and you will also get this classical pseudo-aneurysm or Pepsi sign, or the yin-yang sign that you will get with pseudo-aneurysm. Okay, Ajanya Chandakar is asking what will be the clinical question buzzwords for each image. So we are trying to cover almost all the clinical hints. If you see the previous part of the lecture, in this, like for an example, in this question, they will give you this clinical hint of catheter angiography that is done with the inguinal swelling. Okay, so they will give you all these clinical hints which I have covered in this questions, right? Now let's move towards our breast imaging. Okay, so classical spotter images, we have already discussed the views when we were discussing about the imaging investigations. So quickly we are going to discuss about the breast spotter images. The first image on your screen is what you are seeing, this classical popcorn. So popcorn calcification that you will see with fibroadenoma. Remember that this is my Biret's 2. Okay, this is an involuting fibroadenoma, so this will be definitely my Biret's 2. This is your classical popcorn calcification that you are seeing on the mammogram. Okay, now what about this particular image? I'm zooming this image. You're seeing, able to see the small calcifications. Okay, you're able to see small calcifications. So these are your micro calcifications, or they can also use the term fine pleomorphic type of calcifications, right? Fine pleomorphic, or varying sizes or varying shapes. These are, the thing is that if they are showing you this micro calcifications which are fine, which are pleomorphic, or they will show you along the duct, or these are linear calcifications. If you are seeing anything on this image, apart from this, can you see there is also some spiculated mass that is present over here, right? You can see that there is also some architectural distortion over here. So this is all pointing towards some malignant process going in the breast. So remember that this will always be either my Biret's 4C or it will be Biret's 5. Okay, 5 is given in your option, mark answer as 5 only. This is highly malignant, highly suspicious, and you definitely have to do a biopsy for this particular patient. Right, now what about this particular imaging appearance? You are seeing that it is looking like a breast within a breast appearance. So this is my classical breast and breast appearance, because what happens, there is a lesion that is present, that is having fat and fibroglandular tissue just like that of the breast. So this is again my Biret's 2, and what we are talking about, we are talking about a hamartoma. Okay, this is the breast hamartoma. Now what you are seeing over here, again you are seeing a radiodense lesion. This is a spiculated mass which you are seeing. You are able to see a very beautiful radiodense spiculated mass. This is again breast malignancy, and remember this is again my Biret's 5. Okay, so remember, you can see, you can make out there are speculations that are present in this particular breast cancer, right? Now let's move towards our next important breast imaging spotters. Okay, first I'll cover this pathology. So you can see that there is an eggshell calcification. Okay, around the boundary it is present. So we are talking about what? We are talking about oil cyst. Okay, we are talking about oil cyst. Okay, okay. Yes, for Biret's 5 we will always do biopsy. Not only 5, even for 4 we will do a biopsy. Okay, now oil cyst is nothing but fat necrosis. Fat necrosis, when it will be evolving, there will be a dystrophic calcification that will develop, and that is my oil cyst. And again, because it's absolutely benign, this will again come in the category of Biret's 2. Okay, now let's move towards the first image over here. You are able to see that there are implants. Again, implants, silicone or saline, they will appear hyper intense on T2. They will appear hyperintense. Now let's quickly revise about the signs of implant rupture. I'm talking about intracapsular rupture within the breast implant itself. The first sign over here, what you are seeing is, this is my teardrop sign. This is the teardrop sign, or it is also called as the nose sign, because it is folding on itself. Now if you are able to see this multiple hypointense lines that are present within the implant itself, this is my linguini sign. Okay, already written, this is my linguini sign that you will see. Okay, these are the two important signs which you need to remember for the MRI, right? Or for the intracapsular rupture. For the intracapsular rupture. Same thing, if I see on an ultrasound, this linguini sign, it will look like that hyperechoic lines. Okay, so this hyperechoic lines which is there, it will be giving rise to your step ladder appearance on an ultrasound for IC rupture. Okay, now for the extracapsular rupture, there is only one sign which you need to remember. In the ultrasound, what happens? Silicone has now gone into the axilla. If I put my probe in the axilla, you will see this lot of shadowing and reflection because of this hyperechoic silicone that is present. So on the ultrasound, what you will get is, you will get my classical snowstorm sign. You will get classical snowstorm sign. Where else do you see the snowstorm sign? We have not covered OBS in the rapid revision, but snowstorm sign is seen in complete H mole. Okay, it is seen in the complete hydatiform mole. Okay, in the uterus. Right. Now let's start with some important spotters of MSK radiology. Okay. Any questions? If you have any questions, we can just answer and then we can just proceed. Okay. So in the MSK, again, a lot of the MSK radiology which is there, it will be already covered in the orthopedic section. But again, we will be just covering some important radiological images, and most favorite, I will definitely cover the bone tumors for you for a quick revision before your exam. Right? So I know that you will be having a peak of anxiety right now, but what I'm suggesting, only 5 days are left. Nothing is going to change. You are not going to add anything right now to your main topics, right? Whatever you have learned, it's quite enough. You just have to revise. if you are not able to revise as per your planned revision plan. Okay, if you are not able to do that, I would really suggest that go through these videos. Okay, go through these marathon videos. They would really help for the last moment, rather than just I mean, you are not able to read actively, then just go for passive learning through the form of these videos. That would really help before the examination day. Just don't give up hope. Only 5 days are left, everything is done. You just have to wait patiently for your exam day, and you are definitely going to crack it. Just keep on learning passively if you're not able to do an active reading right now. Okay, that is my advice. Okay, fine. So let's see the first image over here. So again, I'm giving you a hint over here that the patient is having, say, RCC or a choriocarcinoma. You are able to see this multiple lesions of the varying sizes over here. Okay, multiple lesions, varying sizes. This is lytic metastasis. Okay, this is lytic metastasis that you can see. Okay, so first skull image. I'm first covering all the important skull spotters. The second image is, I will give you a hint that the patient is having chronic renal failure. You are able to see this classical salt and pepper appearance. Okay, where will you see this classical salt and pepper appearance, and what happens exactly? I'm talking about a pathology in which there is a lot of resorption happening. Now, because there is a lot of trabecular resorption, there is a lot of trabecular resorption that is happening over here, and this particular resorption which is there, it will be giving rise to this black areas that are present into the skull. So the most classical pattern that you will see with this secondary hyperparathyroidism. Okay, this will be seen classically with the secondary parathyroidism. The most specific, okay, X-ray, if I want to see this particular resorption, okay, or the subperiosteal resorption, the most specific and the most earliest sign that will appear on radiology is on the hand X-ray. Okay, that will be on the second and the third phalanges. You will see this resorption on the middle finger, and on the index finger you will be able to see the resorption, subperiosteal resorption, that will be classically seen with this hyperparathyroidism. Okay, yes, renal osteodystrophy, perfect, yes. Now let's move towards this particular image. You are able to see this multiple, again, lytic lesions, multiple punched out lytic lesions, giving you the hint in the question might be of M spike or anemia or recurrent infections or renal failure. What are we talking about? We are talking about this raindrop skull. Again, this is classically seen with your multiple myeloma. This is seen classically with multiple myeloma. Okay, now the fourth image is, I am giving you a hint that the patient is a pediatric patient. You are able to see the single lytic lesion. There is resorption of the outer table more than that of the inner table. Okay, more than that of the inner table. You are getting this classical hole in hole appearance or beveled edges. You might also get a button sequestrum. Yes, Dhanush, perfect. This is Langerhans cell histiocytosis, or this is the eosinophilic granuloma. Okay, so these are the classical skull spotters which could be tested. Few more to go. Again, a classical hint in an elderly patient, elevated ALP, you are able to see the skull, hyperosteotic skull. There is widening of the diploic spaces. Okay, the skull size, the cortex which is there, it is extremely thickened over here. You will get this classical Tam O'Shanter skull, or because of course the skull or the hat size which is there, it is increased. So you can get this cotton wool or this multiple sclerotic fluffy opacities. This is classically seen with what? This is classically seen with your Paget's disease. This is classically seen with the Paget's disease. Okay, now what about the vertebra appearance in the Paget's disease? What type of vertebra? You will get a sclerotic vertebral body that might be also expanded. So that is called as the ivory vertebra that you will get with this Paget's disease. Okay, I hope you remember the image. We have also covered this image. So you will get this completely white single vertebra in an elderly patient with elevated ALP. That is my ivory vertebra. Okay, now what about this hair on end appearance? So again, the classical hint that they will give you for hair on end is extramedullary hematopoiesis that you will see with sickle cell disease, or you will see it with thalassemia. You will see with thalassemia. That is seen. Yes, Dhanush, you can also get banana fractures in the Paget's disease. Right, now let's move towards this classical spotter image. Again, you can see that there is a radiolucency, plus also there is a central sequestration that is present over here. So this is nothing but the cockade sign, also called as the target sign. This is nothing but a fat density lesion that is present in the calcaneum, particularly in the anteroinferior part of the Watts triangle. This is nothing but a calcaneal lipoma. This is a calcanean lipoma. Now, if I want to do the investigation of choice for this, it is always MRI. You can confirm the presence of the fat by doing a fat separation sequence, and that is how you can confirm that there is presence of a lipoma. Will you do anything for this? You will do nothing. These are do not touch lesions. So, calcanean lipoma will fall in this category. Apart from this, the vertebral hemangiomas, simple bone cysts, enchondromas, fibrous dysplasias, or no. Okay, all this will be do not touch lesions. You do not do anything for these particular lesions. Okay, now one more thing I wanted to mention is that this hair on end appearance which you are seeing, you can also get a focal type of hair on end appearance. If a focal or single lesion with hair on end appearance in skull appears, think about neuroblastoma metastasis. Okay, think about neuroblastoma metastasis. Right, now let's move towards our next image. I know everyone knows this particular image, just a quick revision. Okay, we are talking about chronic osteomyelitis. So in the chronic osteomyelitis, if you see this particular bony dead tissue, okay, this dense tissue, that the radiodense part which you are seeing in this bony lesion, that is nothing but my dead bone, or it is also called as a sequestrum. If you are seeing an opening or a sinus that is going through the cortex, that is my cloaca. If you are able to see this particular solid periosteal response, that is my involucrum. That is all about these three important pathologies, that is sequestrum, cloaca, involucrum, that you see in chronic osteomyelitis. Okay, now let's talk about, okay, Shashikaran, chronic osteomyelitis. Yes. NOF is do not touch. Yes, it is do not touch lesion. NOF, chondromyxoid fibroma, enchondromas, particularly, especially when there is no fracture or there is no any complication, these are absolutely do not touch lesions. Okay. Now, what about this particular pathology over here? This is the classical, again, do not touch lesion, incidentally diagnosed. We see these cases on routine basis. This is nothing but a vertebral hemangioma. Okay. Now, if you see on a sagittal image, what you are seeing this corduroy appearance, okay, like that of a cloth. You remember, you have known that cloth that is called as the corduroy, okay, that has this stripe pattern. If I do, this can be similarly seen on an X-ray sagittal also, on a lateral X-ray. If I am doing an axial cut through this particular pathology, you will get this classical polka dot appearance. Okay, so this is my vertebral hemangioma. This occurs because there is a resorption of the horizontal trabecula. Okay, so again, this is hemangioma. You do not do anything of these lesions unless it is a atypical hemangioma. We see atypical also, that will have a relatively larger soft tissue mass and that can compress the spinal canal. Right? Yes, Shashi, it is also called as jail bar appearance or corduroy cloth appearance. Okay, now let's talk about some important vertebra findings. So first vertebra, I've already written the name. This is called as the codfish vertebra. You can see that there is a compression that you will see along the superior end plate. You can see that it is depressed. So this is the codfish fracture, and this mainly occurs when the bone density has decreased, the bone mass has decreased. This is particularly seen with osteoporosis. Okay, also called as the codfish vertebra. Now, to diagnose the osteoporosis, what I am going to use? I am going to use T-score. Okay, don't get confused. It is always T-score. Remember the T-score. Remember for T, remember typical. So here I am going to we are basically using a DEXA scan, and I am going to compare the bone density of this particular patient through the DEXA with that of a typical young age patient. Okay, typical young age, maybe say 30-year-old patient, male patient. I'm going to compare it. That is my T-score. Based on the T-score, what is the definition? If the score is less than that of minus 2.5, that is osteoporosis. For severe osteoporosis, you will have a score of minus 2.5 plus there is also fracture. Normal will be more than minus 1 and osteopenia will be somewhere between minus 1 to minus 2.5. That is my T-score. Now, what about the Z-score? So, Z-score is used when I am suspecting osteoporosis in an atypical patient. Like for an example, if the patient is premenopausal, okay, or if I'm talking about a male patient, say a young male patient is having osteoporosis, like he is having rheumatoid arthritis, or if I'm talking about a pediatric patient, okay, in that particular condition, I will use the Z-score, because here, remember Z, say you can remember zoom. You can remember zoom, so I'm zooming it for the same age and the same sex. I'm going to compare the bone density with the same age and the same sex person. Right? So that is my Z-score. So don't get confused. For your normal osteoporosis, which we commonly use for postmenopausal women, we use a T-score. Okay, now what about this vertebra image? You are able to see that a vertebra which is completely compressed. So you can see this with osteoporosis also. This is also called as vertebra plana. But if they are giving you a pediatric patient with this Potter image, this is classically seen with what? Vertebra plana you will see with eosinophilic granuloma, or you see it with Langerhans cell histiocytosis. Right. Now next vertebra, again classical vertebra images. We have seen the skull. Now classical vertebra images, you are able to see that there is a bullet shaped vertebra over here. This you will say so it's very confusing. If you see the second image, this is also looking like that of a bullet. Okay, so this is actually more of a bullet. And if you see this particular image over here, this is actually beaking of the vertebra. So there is no difference per se. Both will look similar, but see what is the question that is being given to you. So if they are asking for beaking of the vertebra, okay, or if the options are pertaining to mucopolysaccharidosis, it is particularly they are testing for beaking, and here the mnemonic which is there, it is high ma. This is how you will remember. So if I'm talking about inferior beaking, you will mark your answer as Hurler. Okay, if I'm talking about the anterior beaking, it is what? It is Morqueo's disease. It is Morqueo's disease. Okay, so that is something important. Now the second image is the bullet shaped vertebra. Here again you will get this classically with achondroplasia. You will see this with achondroplasia. See, they will give you this classical clinical hints also. Maybe some dwarfism is given, rhizomelic dwarfism, or they will give you this champagne glass pelvis. Some sort of history will be given if they are testing you for achondroplasia. Okay. Now, if I am talking about another vertebra, which is H-shaped vertebra, that you will see classically with sickle cell disease, already written. What are the pathology? What are the findings you will see? So, you will see it with splenomegaly. You can see splenomegaly in the early stages. In the later stages, what happens? The spleen which is there, it will go into infarction, and you will get the calcium. You can get the calcifications also. You can get an autosplenectomy stage. You can get H-shaped vertebral bodies. In the bones, you can see avascular necrosis also. You can get patchy bone sclerosis, right? All these findings you will see with sickle cell. What happens in the hand, foot? In the hand and foot, you can also get what? Dactylitis. You can get dactylitis, and that will also, patient will present with severe pain. Similarly, ribs can be involved, that can give rise to acute chest syndrome in the sickle cell disease. Right. Okay. So Ajinkya Chandekar is asking, what is the difference between sequestration and cloaca? So when I'm talking about the chronic osteomyelitis, if you are able to, I'll show you the image again. So when I talk about the sequestrum, this is the dead tissue. Anything which is dead, anything, the vascular supply, when it will be gone. Okay, what happens in chronic osteomyelitis? There will be a dead tissue. So that will appear very radiodense. Similarly, like for an example, avascular necrosis. Okay, if you remember the X-ray image of the AVN, it will appear very dense. Whenever the blood supply will go, that particular area which is there, it will appear relatively radiodense. Whenever the blood flow is intact or it is increased, that the radio density is going to decrease. So this is the sequestrum that you are seeing with chronic osteomyelitis. What is cloaca? So cloaca is the sinus or a fistula opening that you will see with chronic osteomyelitis. So it is the body's way in order to drain that pus. That is my cloaca. And what is involucrum? It is associated with chronic osteomyelitis. In this, you will have this solid or a thick periosteal response, again indicating the chronicity of this bone infection. Okay, that is about this particular thing. Okay. Okay, now let's move towards the next set of pathologies, and that is my bone tumors. Okay, so we are going to quickly cover the bone tumors. Okay, it would be very quick. If any doubt, you can ask. Dhanush, I'm not getting your question. SCA versus sacral insufficiency. SCA, are you talking about sickle cell anemia? Honda sign. Okay, we'll cover Honda sign also. We'll cover that in the nuclear radiology. So in the sacral insufficiency fractures, what is going to happen? You will get this Honda sign because there will be fracture. See, that is also commonly associated with osteomalacia, plus there will be stress fracture. See, I'll cover that in nuclear also. There is nothing to do with SCA per se and sacral insufficiency. I mean, what is the confusion regarding that? I'll show you the sacral insufficiency image also. See, sickle cell, they will show you an AVN. Okay, or either they will show you this H-shaped vertebral body. They will not test you for sacral insufficiency in SCA. Okay, now let's talk about the bone tumors. So when I talk about bone tumors, three important parts: epiphyseal, diaphyseal, and metaphyseal. Epiphyseal, you all know, ECG. So epiphyseal, only two lesions, anything in the epiphysis of the bone, chondroblastoma, GCT. Okay, you are not going to remember metaphyseal. You are going to remember just diaphyseal, and that is the mnemonic, that is female O. Anything apart from these two, epiphyseal and diaphyseal, will come in the metaphyseal category. So just remember epiphyseal, diaphyseal. Remember female O. F is FD, E is Ewing sarcoma, M is multiple myeloma and metastasis, A is adamantinoma, particularly adamantinoma, where you will see that in tibia. L is for your lymphoma. You can also see with Langerhans cell histiocytosis, and of course E is for your enchondroma, that is again a diaphyseal lesion, and osteoid osteoma. Okay, now osteoid osteoma, which is there, again, this is a cortex based tumor. It is the only tumor, I would say, where a NCCT, which is there, it is a better investigation than that of MRI. Otherwise, if I'm talking about bone tumors, always remember my investigation of choice or best investigation to see the bone tumors is always and always MRI. If I talk about an initial investigation, it is always an X-ray. It is always an X-ray for a bone tumor. So see what is given to you in the question. Before I start discussing the bone tumors, some important pointers and differentiation between the benign and the malignant categories. So benign lesions will be relatively smaller, right? There will be no soft tissue. They have a very narrow zone of transition. Narrow zone means if I'm having a lesion, say in the bone, if you are able to draw a line with that of a sketch pen, if you are able to draw that sclerotic border, okay, if you are able to draw this with your pen very nicely, the border that can differentiate it from the rest of the bone, then I would say that it has got a narrow zone of transition that is classically seen with benign lesions. Okay, these lesions are also geographic per se. That means that it is quite localized and it is something which can be traced on your bone. Okay, geographic, it will come in the category of a lytic lesion. Okay, now if I'm talking about the periosteal response, you will get a very solid and a thick type of periosteal response. Now if I'm talking about malignant, they will be ill-defined, all the bad things. Okay, you can say that if there is a bone, if there is a large aggressive soft tissue mass that is present, that is ill-defined, you are not even able to draw a line with that of a sketch pen, you are not able to trace and separate it from the rest of the zone, that is wide zone of transition. You will have this soft tissue, you will have this permeative or moth-eaten appearance, right, rather than a geographical pattern which you see in normal bone tumors. And what about the bone response? Here you get a solid periosteal response like involucrum I showed you in chronic osteomyelitis, but here you will get either spiculated or a hair on end or a sunburst type of a response or a Codman's triangle like you see in osteosarcoma. Right? So that is some general pointers. Now let's start dealing with all the pathologies. Most of the things I have written, but just tell me the diagnosis. What is the first lesion? Please try to be quick and answer these particular questions. What you are seeing a lesion over here. Again, it is lytic, it is unilocular, it is well defined. I am telling you that the patient's age is 15 years. That means he is in the less than 20-year category. The lesion is in the epiphysis, in the apophysis. Okay, you can see that it has got a narrow zone of transition. You can separate it from the rest of the bone. What is the diagnosis over here? Please write down fast. This is less than 20 years. So this will be an epiphyseal lesion. This is my chondroblastoma. This is the chondroblastoma. Yes, Ash, perfect. This is chondroblastoma. Now the second lesion is 35-year-old female. You are able to see again a lesion. No, Shashi, it's not ABC. The first lesion is not ABC. See, it is in the epiphysis. Can you see this is the epiphysis? Okay, this is the epiphysis. This is the apophysis that is present. If any lesion that is present in the epiphysis or the apophysis, then it is your either chondroblastoma or GCT. Less than 20, chondroblastoma. More than that of 20 years, okay, more than that of 20 years, again you can see that the epiphysis is involved. Also you can see that there is a spread, that is subarticular spread, or there is also a metaphyseal spread which you are seeing over here, right? So what is the diagnosis? Yes, perfect, everyone has answering. This is the giant cell tumor, no mistakes over here. Very commonly tested pathology. Okay, again it can be unilocular or it can be multilocular. Usually you do not see a sclerotic rim. You will get this honeycomb type of an appearance or a soap bubble type of an appearance. Again, it has got a narrow zone of transition. Now, if you see the third lesion, I'm giving you the age. The patient is 10 to 20 years old. And of course, this lesion which is there, it is occupying most of the diaphysis. It is spreading and extending into the metaphysis. If you talk about the matrix per se, it is particularly, I would say, a ground glass type of matrix. So this classically is what particular pathology? Please answer this. Diaphyseal lesion with ground glass matrix with bowing deformity, especially in the femur, you will get this classical shepherd crooked deformity. We are talking about fibrous dysplasia. We are talking about fibrous dysplasia. Very good. Ash, Gaurav, perfect. If I talk about the syndromes, they can be McCune-Albright or Mazabrod syndrome. McCune-Albright, you will get this classical triad of polyostotic FD, Caffey-Lewis spots, and precocious puberty. In Mazabrod syndrome, you will again get polyostotic FD, but here you will get multiple soft tissue myxomas. Okay, this is two important syndromes could be tested. They can show you an image. They can also show you an image of polyostotic FD and soft tissue myxomas. Then mark your answer as Mazabrod syndrome. Okay, so these are the clinical hints that can be given to you in the question along with this image. Okay, now if I talk about the fourth image, again the patient's age is less than 20 years. Now look carefully at this lesion. This is my epiphysis. It is absolutely spared. Okay, you can see that the lesion is not spreading into the epiphysis, and of course this is a skeletally immature patient. Okay, there is no fusion happening over here, less than 20 years. Location is predominantly in metaphysis. You are seeing a multilocular expansile lesion. What has happened? The cortex which is there, it is thinned out, also called as endosteal scalloping has occurred with this expansile lesion. What I am talking about, this is the classical ABC. Vayu, Ash, perfect. This is ABC, very good. So this is ABC. You will get this classical soap bubble appearance on an MRI. They can give you an MRI image. What you will see multiple blood fluid levels. Okay, multiple blood fluid levels. Okay, you can get this multiple hypointensity and hyperintense levels in the MRI image, right? So that is about this particular pathology. Now what about this classical pathology? Again, less than 20 years, skeletally immature metaphyseal lesion. This time you are able to see a bone fragment that is present. So this means that there is some fracture also present. This is the most common way of presentation. The patient will present with fracture, otherwise the patient is asymptomatic for this lesion. What we are talking about? We are talking about a simple bone cyst, and this classical sign, can you tell me the sign? Simple bone cyst presenting with that of a fracture, a central unilocular lesion. Usually there are no septa. What will you get? Yes, you will get this trap door appearance, okay, or a fallen leaf or a fallen fragment sign. All these are the various names that have been given to this particular pathology. Okay, so that is about simple bone cyst. Now the next pathology, again the patient's age group is 20 to 30 years, typically a hand x-ray. You are able to see that there is a diaphyseal lytic lesion, there is an endosteal scalloping happening over here, right? What you are seeing over here, if you zoom it, you can also see some stippling over here. There is some stippling that is present over here. So stippled type of cartilaginous matrix in a diaphyseal lesion, in a diaphyseal lytic lesion that is also having a very narrow zone of transition. This is the classical enchondroma that you will see in this patient. Okay, so this is enchondroma. This is classically diaphyseal with chondroid matrix, ring and arc, popcorn type of calcification. That is enchondroma. Syndromes, again Ollier syndrome, multiple enchondromas, Maffucci. They can give you a soft tissue that will be also having the small calcifications or this phleboliths. Okay, so they can also give you a hemangioma in the soft tissue of the hand. What we are talking about? We are talking about Maffucci's. So remember, in the Maffucci, the chances of the malignant transformation is definitely more than that of the Ollier's disease. Okay, so if both the options are there, then mark your answer as Maffucci because that has got a higher chance of malignant transformation. Okay, now if I talk about this particular pathology, again this is a very classical lesion. You are able to see that there is a central nidus over here plus a lot of cortical response, and for any particular bone tumor, they are showing you a CT image with such a type of periosteal response with central nidus. You can see here also a lot of periosteal solid response. This is my classical osteoid osteoma. Osteoid osteoma. Okay, now what about the investigation of choice? So investigation of choice will be NCCT. The age will be 10 to 25 years. Again, this is a cortical based tumor. This is a diaphyseal lesion. Remember that if I talk about the complaints over here, the patient will typically present with night pain, severe leg pain that is relieved with NSAIDs. This can also be present in the posterior elements of the spine. So remember the mnemonic OOA. So these are the three important pathologies in which they will test you with the posterior vertebral spinous component of the spine, and they can test you for osteoid osteoma, osteoblastoma, or an ABC. Okay, remember that to differentiate from an osteoblastoma, see, osteoblastoma will also present with pain, but that pain will not get relieved with NSAIDs. In osteoid osteoma, this pain is getting relieved with NSAIDs because there is a prostaglandin. There is an excess of the prostaglandin that is secreted. Now, if I talk about the treatment of choice, it is radio frequency ablation, right? Of course, that is the treatment of choice. Otherwise, initially, so you will manage it with NSAIDs. Okay, we are going to ablate the nidus with the radio frequency ablation. The nidus size is less than that of 2 centimeter, and there is also a solid periosteal response that you will get. Okay, so I hope this is clear to you. Now let's move towards our next classical thing, the most common benign bone tumor. Everyone knows this classical appearance. This is also called as exostosis. Okay, this is exostosis. Okay, so this is also, if see there are multiple, then it is called as hereditary multiple exostosis, or it is also called as diaphyseal eclasis. So age is usually 10 to 20 years of age. If I talk about the location, it is in the metaphysis. It is always directed away from the joint. Most commonly it is present around the knee. It can be also present in the rib. Classically on MRI, remember that you will get this classical, see, X-ray with you can identify on MRI if you are showing a lesion that has bony projection, plus there is also this presence of a cartilage cap. Now how will the cartilage appear? Remember, anywhere in the body, if cartilage is present, this will always appear as T2 hyper. So your cartilage cap which is there, it will be appearing as a T2 hyperintensity, right? Now if I am talking about the chances of malignancy, when you will start thinking that it's the most benign pathology, but when you will start thinking that yes, it can convert into malignancy, per se, which malignancy and chondromas and osteochondromas will get converted? Chondrosarcomas, okay? So if there is a growth after skeletal maturity, if this lesion is painful, or if the cartilaginous cap is more than that of 1.5 centimeter on an MRI, then I will say that yes, this is chondro. This can be getting converted into the chondrosarcoma. Okay, so that is all about your osteochondroma. Okay, now Shashi, yes, MRI cap thickness more than 2 centimeters. So there are a lot of resources which also say 1.5 centimeter. So it's always a confusion whether to mark 1.5 or 2 centimeter. For me, I think more than 1.5 centimeter as a radiologist, we will consider more than 1.5 centimeter as a little suspicious, and we will definitely investigate. And also if the size of the cap has increased from a previous interval MRI you are doing, and the size of the cap is increasing, plus the symptomatically also the patient is becoming painful, then you will start thinking that yes, there is a chance of it getting converted into a malignancy, right? Now let's move towards the malignant pathology. So very few examples. The first one, you will get this classical spiculated or sunburst appearance. You will get this elevated periosteum, also called as my Codman's triangle, classically seen in the long bones around the knee. Again, metaphyseal in the location. Now if I talk about the age, it is in the first decade, both Ewing sarcoma, osteosarcoma, 10 to 20 years of age. But if I'm talking about a history, they can confuse you. They can maybe they can give you a patient who is 65 years of age. They may show you a pelvis that is expanded, like in the Paget's disease. Okay, or there is a previous history of radiation, and in that, if you are seeing such a type of lesion, don't get confused that osteosarcoma is only seen in pediatrics. This can be a case of secondary osteosarcoma in a Paget's disease or with a radiation history. Okay, again, periosteal response, you will see sunburst or the Codman's triangle, right? Now let's talk about the 10th pathology over here. So again, here the classical hint which is there, here the age will play a very important role, more than 40 years, a pathology that you are seeing particularly in the axial skeleton, okay, like in the pelvic bones, okay, or you can also see it around the shoulder, okay, or it can be also seen in the long bones like femur and humerus, but more commonly it is seen in the pelvic bones or in the shoulder. Then in that particular condition, you will start marking or thinking about chondrosarcoma. You will start thinking about chondrosarcoma. Okay. Now, if I'm talking about chondrosarcoma, we have already talked about the cartilaginous matrix, that is ring and arc type of calcification, or you can get this cloudy appearance also with this classical chondrosarcoma. Can you see this large soft tissue that you are seeing with this type of a lesion? Then you will start thinking about this ring or arc popcorn or cloud pattern of appearance. Again, this is a very lytic lesion, a very aggressive type of lesion. One more important differential when it comes to chondrosarcoma, it can be metastasis, but metastasis is usually multiple, plus they will give you some hint that the patient is having some primary. Plus, if you're seeing this cartilaginous matrix, start thinking about chondrosarcoma particularly, right? Any doubt on bone tumors, you can just put it down. Another important thing is that you can also get this chondrosarcomas in a younger age group, like in osteosarcoma in an older age group. Here you can get in a younger age group if it is a secondary lesion. Like for an example, if the patient is having enchondroma, or if the patient is having an osteochondroma, if they can get converted into a chondrosarcoma, they can present relatively earlier, right? So that is all about the bone tumors and the MSK section. Now we will take a quick dinner break. We will resume in exactly 15 minutes. It's 8:45. We'll start at 9 again. So just take a quick dinner break and we will start at 9. We will be covering next sessions. If you want to know, we will cover the Neuro-Radiology, we'll cover GIT, Hepatobiliary, and we also have to cover GUT, lot of images in GUT. Lastly, we'll touch on radiation protection and safety, nuclear medicine and radiotherapy. So more than half of the session is still left. I'm expecting the session will continue till 10:30 or quarter to 11. So because we started late. So take a quick dinner break and we'll meet you in 15 minutes. Okay, so Ajinkya is asking me that diaphyseal level where you will see. So I don't have an image per se, but See, if you are seeing anything which is present completely in the central part of the shaft of the bone, okay, in the mid part of the bone, then that is particularly they are testing you for diaphyseal lesion. Then they are testing you for diaphyseal. Metaphysis, which is there, it will be just beneath the epiphysis. This entire region which is there, that will be metaphysis. Okay, I hope this is clear. Anything that will be present in the mid part, that will be your diaphysis. Okay. Ash, thank you so much. Ma'am, you're awesome. Thank you so much. So let's take a quick break and I will meet you at 9 o'clock. Okay. I hope you all had your dinner. We still have 2 minutes and I'll start at 9 o'clock. Okay, fine, we'll start. Okay, so let's start with neuroradiology. We have got a couple of important spotter images. Again, we will be covering just the high yield CT and MRI images. Of course, I will be also covering your brain tumors. We have covered bone tumors, so it's very important that we also cover brain tumors. Okay, so let's start with the various infections. The first image, very classical, you are seeing this multiple T2 hyperintense lesions. Okay, just give me a thumbs up if everything is okay. If you are able to hear me, if the audio is okay, just give a thumbs up if you can, and I will continue. Okay, so first thing what you are seeing over here is the classical cystic lesion, but if you look very carefully over here, you are also able to see that there is a small T2 hypointense, right? What I am talking about, we are talking about a classical scolex, and this is also called as a dot in hole sign. What pathology we are talking about? We are talking about NCC or neurocysticercosis. Okay, try to be more interactive and please write down the spotter answers in the chat box, and that would really make the session much more fruitful for you as well. Okay, so if I talk about the first pathology, first stage, we have got 4 stages of NCC. We've got a vesicular stage, we have got the colloidal stage or the colloid vesicular stage. Also, we have got the granular nodular stage and calcified stage. So 4 stages, and all the 4 stages are important from imaging point of view. When I'm talking about the first one, that is the vesicular stage, that will be a dot in hole. You will not get any edema. You will just get the cystic lesions. If I'm talking about the colloidal stage, that will become much more symptomatic type of patient because here there will be maximum edema. Okay, so if you are seeing a lesion that shows a peripheral enhancement, you will also get a ring enhancement over here. Okay, you will also get a ring enhancement over here. You will also get a ring enhancement over here. So when I'm talking about the neurocysticercosis, a ring enhancing lesion, also there are multiple, they will be less than 2 centimeters usually. But if you are seeing a lesion that is showing a lot of edema plus patient is symptomatic, that means that the patient is also having seizures. Start thinking about the stage which is the colloidal stage. See, they can ask you in a little extra, especially they can ask you with the symptoms. If the patient is having a symptomatic stage and lot of edema in the brain, then mark your answer as a colloidal stage. If I'm talking about granular nodular stage, the edema will start decreasing. Okay, what about the calcified stage? Here the lesion which is there, it will become starry sky. Okay, in the calcified lesion, what happens is in the starry sky pattern that is on the CT, what happens, you will see this multiple calcifications on NCCT that will appear as hyperdense foci, and the lesions over here will be called as, this appearance is called as starry sky appearance. So that is the first pathology. The second pathology is you are able to see, this is a post-contrast image, and you are seeing a lot of enhancement that is present along the basal cisterns. So this is particularly because of the basal exudates that are present. Plus there is also basal enhancement that will be present. If I do a flare image, what you will see? You will see a hyper intense signal on the flare along the basal cisterns. So what are we talking about? We are talking about classically TB meningitis. Okay, we are talking about TB meningitis. Okay, they can also show you a tuberculoma. Again, that will be a ring enhancing lesion. Remember that on a tuberculoma, it is usually the central part, the T2 part. On T2, that central part which is there, it appears relatively hypointense because of the caseous necrosis. Okay, and of course, as compared to NCC, again, they can be also multiple, but they are relatively, I would say, larger. Plus the classical scolex appearance that will be classically tested on NCC. Okay. Now the third lesion which you are seeing over here, what you are seeing in the third lesion is again a ring enhancing lesion. They will also basically show you that this lesion is also showing diffusion restriction, as we have already discussed in the general investigations. So if you are seeing a lot of pus, okay, because there is a diffusion restriction, what will happen? Because of the pus, it will be showing diffusion restriction. If you are seeing all these classical findings, start thinking about pyogenic abscess. Okay, start thinking about pyogenic abscess. Whereas now I'm talking about a pediatric infection. I'm talking about an pediatric just born patient who has been shown such a type of a CT image. You are seeing this large periventricular calcifications over here. So this classical periventricular calcifications, they can also show you polymicrogyria. Particularly, they will show for polymicrogyria, they will show you an MRI image. What happens in the polymicrogyria? You can see this convoluted or folding pattern of the gyri that can be shown for polymicrogyria. So this classical white matter migration abnormalities along with microcephaly, clinically there will be microcephaly. What we are talking about? Yes, Gaurav, perfect. That is your CMV infection. That is my CMV infection we are talking about. For toxoplasmosis, if I'm talking about toxoplasmosis in a pediatric patient, again you will have lot of calcifications, but they are not periventricular. They would be rather diffuse type of calcifications. Plus, there is a hallmark that there will be hydrocephalus. And also microcephaly is particularly per se associated with CMV, and also it is associated with Zika and not with toxoplasmosis. May you remember, bigger will be the name, the ventricles are bigger, and there is hydrocephalus that is present in toxoplasmosis. Okay, CMV and Zika both small names, so there will be a microcephaly that is present. Plus, you will also have calcifications that will have cortical as well as subcortical calcifications that you will see with Zika virus. Right? So, I hope these 4 important pathologies are clear. Now, again, coming towards the next infection. Again, I'm giving you a history that the patient is presenting with fever and altered sensorium. Please tell me the answer. You are seeing that there is involvement of bilateral temporal lobes. And you can see this is asymmetric. This is not symmetric. Right is involved more. This is the right side. Right part is more involved. There is definitely a flare hyperintensity which you are seeing. They can also show you a post-contrast image. You can see that there is enhancement in these particular lobes. These are my basifrontal lobes. Okay. So this particular pattern is characteristically seen with what? Very important, a potential question could be tested. This is my HSV1 or herpes simplex encephalitis. Okay. Now the hallmark feature is that this will be asymmetric. Usually it is asymmetric. More importantly, it is also hemorrhagic necrotizing encephalitis. If anything is hemorrhagic, what will I show? You can also be shown SWI sequence. On SWI, you may also be shown blooming foci. We have discussed about the SWI sequence in detail in the beginning part of the class. So that they can show you. Okay. And of course, if I want you to tell the lobes, so medial temporal lobes or inferior frontal lobes are classically involved when I talk about the HSV1 encephalitis. Now, if I talk about the treatment, see if a patient is coming to me, you are suspecting HSV encephalitis. On MRI, it is equivocal. You're not sure that it is HSV. You're still waiting for the PCR reports. Okay, most sensitive, you have to definitely do a PCR. And of course, that is done with the help of CSF analysis. You have to do lumbar puncture. But if on the MRI there is this appearance, you are suspecting HSV encephalitis, you are still not sure. Okay, you are still not sure. The PCR results are still awaited. In that particular condition, you will immediately start your treatment with acyclovir. You will not wait. Okay, as soon as there is a clinical suspicion of HSV encephalitis, immediately you will start the patient on acyclovir, because it's very important that of course the hemorrhage which is there, it should not extend, right? So that is about this particular pathology. Now, again, 2 important pathologies I'm going to cover. The first image, what you are seeing is, okay, the classical history which you will get is of rapid dementia. Okay, you will get a classical history of rapid dementia. Plus, there is bilateral. See, what is this particular structure on the axial image just adjacent to the third ventricle? Thalamus. Thalamus may, if you are seeing this hyper intensity, okay, you will get this classical history of rapid dementia. What are we talking about? We are talking about a variant CJD, or we are talking about the prions disease. Okay, we are talking about variant CJD, or we are talking about the prion disease. This is very classically seen with this. Okay, you can also be shown this particular sign. What is this sign called as? This is also called as the pulvinar sign, or this is also called as the hockey stick appearance. Okay, this is also called as the hockey stick appearance. Just a minute. So this is also called as hockey stick appearance. So why this is called as pulvinar sign? See, pulvinar is if there will be involvement of these particular nuclei, okay, of the thalamus, the pulvinar nuclei, that is called as pulvinar sign. But if it is extending to involve the dorsomedial side of the nucleus of the thalamus also, then that becomes, and it resembles like that of a hockey stick. So this is called as hockey stick. Now, why I have covered this pathology? Because there is a potential confusion with another pathology. In the first image, you will get a classical history of what? Rapid dementia. In the second image, I will tell you that a young patient has come in the month of monsoon. There is a mosquito bite, there is altered sensorium, and then there is presence of fever. If you are getting this classical history, okay, then you will start thinking again there is similar imaging finding. Bilateral thalamic hyperintensity. Two images, bilateral thalamic hyperintensity. So here your answer which is there, it is Japanese encephalitis. Okay, this is particularly a flavivirus caused by the bite of Culex mosquitoes. So again, two images, two different clinical scenarios. So please look at the clinical, this type of questions will always come with clinical vignettes. Okay, such bilateral thalamic involvement is also seen with PCA infarct, with posterior cerebral artery infarcts or the artery of Percheron infarcts. They can be also seen. Okay, so again, you have to start thinking about with the help of the clinical symptoms only. Yes, Dhanush, it is hockey stick sign or the pulvinar sign. Okay, now let's quickly revise about the ring enhancing lesions. So I'll just tell you all these are ring enhancing lesions, but what are the classical pointers that will help you to shorten your diagnosis? If I talk about pyogenic abscess, you will characteristically get what? You will characteristically get diffusion restriction. You will get diffusion restriction. That is how they will basically test you. T1 pe it will be a hypointense, T2 pe hyperintense, and again you will show this diffusion restriction again because of lot of pus that is present. That is very classical. Plus you will get clinical hinders of say maybe automastoiditis is present in a pediatric patient. So some sort of history will be given to you pertaining to that. If I'm talking about GBM, okay, you will get, I'll show you an image just in a moment, but you will get this lot of central necrosis. Okay, there is a central necrosis plus there is a irregular periphery. Okay, the periphery which is there, it will be very irregular. So the ring which is there, it is sort of a very irregular type of a ring, and you will get again this peripheral ring enhancement in the GBM, but the central part will not enhance, only the peripheral solid part which is there, it will be enhancing. If I talk about NCC, you will classically, they will test you with this Colex, okay, or we can say dot in the hole sign. Again, lot of edema will be seen. Now if I want to differentiate between NCC and between tuberculomas, the size of the lesion is not a rule, but usually more is less than 2 cm. Tuberculomas is more than 2 cm. NCCs are usually multiple. Tuberculomas can also be multiple, but they can also show you a single solitary lesion for tuberculoma. Remember that it is usually hypointense on T2 in contrast to NCC brain abscesses. They are all T2 hyper. Tuberculoma is particularly T2 hypo, and that is mainly because of the caseous material that is present. Okay, caseous, lot of debris of caseous material that will appear as hypointense on T2 weighted images. If I talk about demyelination, what you will get, what type of ring you get in demyelination? In acute, you will always get it in acute demyelination, not in chronic stages or subacute stages. You usually get in an acute stage, and you will get an open ring pattern. Okay, you will get an open or a half ring type of a ring enhancement. It's not a complete ring. Okay, and if I talk about metastasis, okay, again they will be multiple. You will have this ring enhancement, but remember the classical location for metastasis is you will get them at gray matter, white matter junction. You will classically get them at gray matter, white matter junction. Okay, I hope this is an important slide for you to differentiate between this important ring enhancing lesions. Right now, another ring enhancing lesion doesn't end. If they will give you a clinical hint of say patient having an HIV, this was recently tested in the FMG examination, and again this is a potential question. This can be tested in NEET PG also. Again, if you are shown a lesion, okay, a single lesion, they will give you the hint that the patient is HIV or patient is immunocompromised, some solid organ transplant or some steroids, and they are giving you a single lesion that is showing this ring enhancement. Again, the central part you can see this is not enhancing. This is, you are talking about what particular pathology? We are talking about a malignancy which is called as lymphoma. Now if I'm talking about lymphoma, remember that lymphoma will always show diffusion restriction because it's highly cellular. Okay, apart from this, not only diffusion restriction, it will be also positive on thallium, and it will be very hot uptake on FDG PET scan also because of its hypermetabolic status. If I talk about the second image, I will be giving you again a hint that the patient CD4 count is less than that of 200. You are seeing multiple ring enhancing lesions that are particularly seen around the basal ganglia. around the basal ganglia. What I am talking about? I am talking about this classical toxoplasmosis. Okay, remember toxoplasmosis usually do not show diffusion restriction. They will be usually multiple. Lymphoma is usually single. Typical location of lymphoma is periventricular white matter, whereas typical location of toxoplasmosis is in the basal ganglia, right? And of course, when I talk about FDG PET or thallium, they will be also negative for toxoplasmosis. It's always positive for FDG PET. Many differences between the two important pathologies I have covered. Okay, now let's move towards the neurocutaneous syndromes. These are classical spotter image. Again, very high potential, can be tested from your medicine or surgery section also. So the first image, you are seeing this classical subependymal nodules. I'll give you history that the patient is having epilepsy, ash leaf macules, mental retardation. All this history with subependymal nodules, this calcification along the ventricle. What I'm talking about, I'm classically talking about your tuberous sclerosis. Okay, if they are showing you an enhancing mass, okay, if there is an enhancing mass, that will be somewhere here. If it is present over here, okay, just at the foramen of Monro, an enhancing mass is present. What I'm talking about SEGA, which is a sign, which is what? Which is a ependymal giant cell astrocytoma, subependymal giant cell astrocytoma, that can be present and shown with tuberous sclerosis. What are the clinical hints they can give you? They can give you this question in a long clinical vignette type of a question format. They can tell you that the patient is either having angiomyolipomas in bilateral kidneys, or they can show you an image of angiomyolipomas. Of course, they can show you cardiac rhabdomyomas, or they can show you lung with multiple cysts, that is lymphangioliomyomatosis. So what are we talking about? This entire spectrum is seen with tuberous sclerosis. Okay. Now the second image, very classical bilateral acoustic schwannomas or neuromas, that is classically seen with what? With neurofibromatosis type 2. In NF2, you will get this MIS-ME lesions, that is multiple inherited schwannomas, meningiomas and ependymomas. They can also show you the spinal involvement. Okay, what about neurofibromatosis 1? They can show you an image with bilateral optic nerves that are enlarged and enhancing, that is NF1, that you will see with optic gliomas. The third image, what you are seeing over here is what? You are seeing the Stram-Tag calcifications that are present into the skull bone. Okay, you can also show a CT image with this gyral calcification pattern. This is also called a Stram-Tag calcification or gyriform calcifications. Do you want to guess? I am also telling that the patient, a young patient having the port wine stain on the face or a capillary hemangioma. So what I am talking about? Which pathology? Which neurocutaneous syndrome? Please answer. Danush, Muskan, Gaurav, please answer. Which is this neurocutaneous syndrome which I am talking about? Come on fast. We are talking about Sturge-Weaver syndrome. Okay, so we are talking about Sturge-Weaver syndrome, in which you will have the port wine stain or leptomeningeal angiomas. Okay, now let's quickly describe about some important brain tumors. The first one, you are able to see what? You are able to see a very beautiful butterfly. Again, in the central part along the corpus callosum, we are talking about GBM, glioblastoma multiforme, that is present along the corpus callosum, crossing the midline, highly malignant tumor, irregular ring enhancement that you will see. Okay, so I'm getting all the answers relatively late. There is a lag of few seconds. So very good, everyone who have answered Sturge-Weaver syndrome. So when I am talking about this butterfly GBM, corpus callosum, what other lesion can also cross corpus callosum? Write down in the comments. Corpus callosum crossing lesion is your lymphoma. Another lesion which can cross the corpus callosum is lymphoma. Okay, now what about this particular image? You are able to see a lesion that is showing a lot of cortical calcifications. That is showing a lot of cortical, it's a cortical lesion showing calcification. Only one differential will come for this particular region, cortical calcification, most common location in frontal lobe. What are we talking about? We are talking about oligodendroglioma. We are talking about oligodendroglioma. Histopathology, what you will see this classical fried egg appearance. Okay, so this is my oligodendroglioma. Remember that it's cortical and calcifying. Both CC will be seen with oligodendroglioma. Okay, now let's move towards our third image. The third tumor. You will get a classical history of soap bubble appearance. You can get this soap bubble appearance in the, again, this is a cortical tumor that you will see. Plus, I would say that the patient is young. Patient is also having this medically refractory epilepsy. So this is nothing but my classical soap bubble appearance with a DNET tumor. Okay, this is my DNET tumor that you will see. Okay, now what about this particular lesion over here? So again, I am telling you that this is the most common pediatric malignant tumor. You are able to see a hyperdense mass This is seen in the roof of the fourth ventricle. This is seen in the mid part along the cerebellar vermis. Okay, a hyperdense mass that will show diffusion, restriction. What are we talking about? Classically, we are talking about medulloblastoma. Today only I saw a case of medulloblastoma. These patients, because the fourth ventricle is compressed, that will lead to what? That will lead to obstructive hydrocephalus also. One important point regarding this about this medulloblastoma is that they will have this drop metastasis. Okay, that will be in the form of lymphoma as well as again lymphoma and germinoma. They will also show this drop metastasis. So the next best step, if they ask you in the imaging, the next best step is that you will be doing the entire spine imaging to rule out that there is no drop metastasis or sugar coating that can be seen along the spinal cord, because this particular mets have a tendency to spread along the spine. Okay, in the form of leptomeningeal metastasis. Okay, now what about this lesion? The second lesion, what you are seeing, anyone wants to guess? This classical tigroid pattern appearance, you are seeing this tiger stripe appearance. So this will be classically seen with what? This is dysplastic cerebellar gangliocytoma. Again, it's a hematoma. It's not actually a brain tumor. It will be classified as WHO grade 1. And this is again associated with what? Lermite-Dickler syndrome. And also it is associated with this Cowden syndrome. Okay, so together this is also called as cold, which is Cowden syndrome, plus there is Lermite-Dickler syndrome. So together it is called as cold. Okay, then apart from this, they can give you the clinical hints that the patient is having this multiple GIT polyps, there are mucocutaneous lesions, plus there is increased chances of what cancers? Breast cancer, thyroid cancer, and endometrial cancers in the Cowden syndrome or the P10 mutations. Okay, most important thing, what is the pathological part? The hyperintense part, that is the cerebellar folia that are enlarged, and the spared part which is there, it will be the normal cerebellar folia that will appear black. Okay, you can see that how the cerebellum has enlarged over here. Right, now what about this particular lesion? You are seeing a lesion that is in the suprasellar region. Either they will give you this or they will give you a sagittal image, and you can see that there is again calcification that is present, plus this is a hypodense mass. Okay, if I do an histopathology, what you will see, this cholesterol pattern of appearance and this calcifications which you are seeing, this is classically seen with what? This is the wet keratin or cholesterol that you will see with the adamantinomous type of craniopharyngioma. Okay, so this is a craniopharyngioma, but what category? This is adamantinomatous type, which is cystic and calcified, and of course this is seen in a relatively younger age group. Now if I talk about the another variant of craniopharyngioma, that is papillary variant, and that is more of solid appearing. There is hardly any calcification, and they will show this good contrast enhancement also, a smooth homogeneous contrast enhancement, that is papillary, but that will be seen in relatively older age group. Okay, a little extra edge point, I don't think so this would be tested, but just for your knowledge. Okay, now let's talk about this particular image. Again, a very important pituitary tumor. I am telling that the patient is presenting with bitemporal hemianopia. Again, you are getting this classical snowman appearance. What is this particular pathology? This is my pituitary macroadenoma. This is my pituitary macroadenoma. Now, if I'm talking about the size of the pituitary macroadenoma, what is the size category or the size cutoff? It is more than that of 10 mm or more than that of 1 centimeter. You will get this classical snowman appearance because there is the constriction at the level of what? At the level of diaphragmatic cella. Okay, in the skull. So this is the classical history of bitemporal hemianopia that you will get with pituitary macroadenomas. Most of the macroadenomas are not functional. Microadenomas, on the other hand, they will be less than that of 10 mm. Okay, they will also show this delayed enhancing small foci in the pituitary, and the most common microadenoma which is there, it is prolactinoma. That is prolactinoma. But size category for microadenoma which is there, remember it is less than that of 10 mm. Okay. Madhurendra, yes, of course, we will make sure, I will make sure today itself that all the notes are uploaded. I will definitely talk to the team if they are not yet uploaded. Don't worry about that. You will definitely get the PDFs. Okay, now let's talk about the next important brain tumor. This was tested when I gave NEET PG, and this is classical history of gelastic seizures plus, so I have already written the diagnosis, I'm sorry, but you will have this gelastic seizures, plus you will get this classical history of precocious puberty. In my exam, I think they had not even given the clinical hint, and they had just shown this image. So it is very important that you identify hypothalamus. Okay, so if you are seeing this particular part, see, identify on the T2 this particular part. This is pons. Okay, pons has a belly. If you see this particular part over here, this will be my midbrain. This will be my midbrain. Okay, now this particular part which is there, it will be my medulla. Okay, now what about this part? This particular part which is there, it is the pituitary gland. So just anterior to the midbrain, this particular structure which is there, it is hypothalamus, and you will see this smooth type of mass that is present in the hypothalamic area with this classical history of hypothalamic hamartoma. Now, why I am stressing this enough is because you need to know other pathologies also. See, if there is a pathology that is present somewhere over here, this is in the area of pineal gland. Okay, this will be present in the area of the pineal gland, and with pineal gland, they will give you classical history of perinode syndrome, that is upward gaze palsy. Okay, so with pineal gland tumors, you will get the classical history of perinode syndrome. What is this particular structure? They can ask you to annotate this particular structure over here. This is my optic chiasma. Okay, this is the optic chiasma, this smooth area which you are seeing over here, that is my optic chiasma. Right, this is cerebellum. Everyone knows this is the cerebellum. This particular part which is there, it is the corpus callosum. This is the part of lateral ventricle, and this particular structure which is there, it is my massa intermedia, or that is my thalamus. Okay, so some important structures which you should definitely know on a sagittal MRI image. Okay, now let's talk about the next important question. Okay, so again, pineal gland tumors I have already told you, upward gaze palsy because of the involvement of superior colliculus, and that is the syndrome which is your perinode syndrome. That is the perinode syndrome. Now let's talk about this particular lesion. Again, when we were discussing about the general radiology, I have shown you this particular image, so everyone knows this. This is the extra-axial lesion. Again, you can see that you can get a classical dural tail sign over here, an extra-axial lesion that is showing this avid post-contrast enhancement. This is the most common benign tumor. I am talking about meningioma. I am talking about meningioma. The most common location for a meningioma is what? Parasagittal region. Along the falx, if you are seeing this, that is your parasagittal location. Okay, now what about the syndrome? Which syndrome? I already talked about the neurocutaneous syndrome. This is classically seen with NF2. Again, on the angio, what you will see a very classical sign with meningioma, and that is mother-in-law sign. That is mother-in-law sign. Okay, that is early to come, late to go. That is the type of contrast enhancement that you will see with meningioma. On MRS, what peak you will see? Very good, Dhanush. Alanine peak. You will get the alanine peak in meningioma, and that is classically seen at 1.48 ppm. Okay, now let's talk about Samoma bodies. I'm sure everyone knows this, but it is something which is very important from NEET PG. So I've covered PSM2, that is the mnemonic. So papillary carcinoma of the thyroid, serous carcinoma of the ovary, meningioma and mesothelioma. These are the Samoma bodies. These are nothing but onion skin concentric dystrophic calcifications that you can get. Okay, now CP angle, maybe you can get the meningiomas, but the most important, the most common tumor that is present in the CP angle. See, this is the CP angle. If you are showing an extra-axial mass in the CP angle between the cerebellum and the pons, sorry, this is not the CP angle. This is a little bit lower section, little bit up. If I will go, you will get the CP angle over here. So if I'm talking about the lesions over here, you will get a schwannoma. Okay, that is the most common, followed by meningioma, and followed by that of epidermoid cyst. Followed by epidermoid cyst. That is the order of the most common lesions that are present in the CP angle. I wanted to cover that with meningiomas. Okay, now because we touched upon epidermoid cyst, again, as I've told you many times, this epidermoid cyst will always show diffusion restriction. What is the closed differential which will appear similar like this only? So this is the CT. You are seeing that this is looking like that of CSF. It is appearing hypodense. Even arachnoid cyst will look like that, but arachnoid cyst will not show diffusion restriction. Okay, I don't want you to make any mistake in this one. This is very easy. Arachnoid cyst will always follow CSF. Anything that will be following CSF, it will also show suppression on flare, completely suppressed on flare. That is arachnoid cyst with no diffusion restriction. Right, now let's move towards our next pathology. So again, some classical spotter image. You will get this classical eye of tiger sign. I will not waste your time asking, because everyone knows eye of tiger sign is classically seen with what? It is seen with PCAN, or it is seen with NBI, that is neurodegeneration with brain iron accumulation, also called as a Haloverden-Spatz disease. So you can see the central area of necrosis over here. This central area of necrosis is because of the gliosis, that is seen because of the iron, which is getting deposited over here. So that is the classical sign that you will see with this PCAN or Haloverden-Spatz disease. Right, now what about the second image? The second image which is there, it is Wilson's disease. So you will get this classical face of the panda sign. So in the face of the panda sign, what you are going to get? You will get this classical Can you see this hyperintensity that is present in the midbrain? So this is because of the striatal hyperintensity that you are seeing this, that is the abnormal part, the hyperintense, the whiter part which is there, that is abnormal, that you can see on T2 or flare, that will be hyperintense, that is along the striatum. Okay, this is the red nucleus that will be forming the eyes, that is normal. Okay, the ears are formed by substantia nigra, that is black, again that will be normal. And this particular part, again the black part over here forming the mouth, that is the superior colliculus, that is all normal. The white part in the background which is there, the face which is there, that will be abnormal in the Wilson's disease. Right, so I hope this is clear. A quick revision on the MRS also. So if you see about this MRS, you have to know some important markers. So NAA which is there, it will have a peak at around 2. If I talk about creatinine, so remember E which is there, it comes before O. So creatinine will be having 3. Choline will be seeing a peak at around 3.2. Okay, so these are the 3 important peaks, at least this too you should know. If I'm talking about other peaks, so amino acids you will see at around 0.9 ppm. Where will you see this amino acid peak? You will see this classically with bacterial abscesses. Bacterial abscesses. If I talk about 0.9 to 1.4, the range you will get in lipid as well as the lactate. Again, these are products of vein destruction, anaerobic glycolysis. So if anywhere there is a necrosis that is present, you will get this thing. Yes, Dhanush, very good. Canavan's disease may you will get NAA peak. Okay, so NAA usually decreases in all the pathologies, all the brain tumors, inflammation. NAA which is there, it's a neuronal marker, so it will decrease. But only one pathology in which NAA is going to increase, that will be my Canavan's disease. That will be my Canavan's disease. Now, if I talk about 2.2 to 2.4, that will be around glutamine and glutamate peak. It's a neurotransmitter and it will be elevated with hepatic encephalopathy. Now 3 and 3.2. So 3.3, as I already said, it's creatinine, and 3.2 is choline. So choline is again a cell membrane marker. So anything which is hypercellular, any tumor per se, we can say will have a choline peak. So tumors mein choline will be elevated. What happens? NAA will decrease, and then there is a lipid lactate peak. Okay, what about 3.5? So 3.5, which is there, it is myoinositol, and it stands for glial cell marker or an osmolyte. So of course it will be affected in the osmotic demyelination syndrome. Okay, so that is about this MRS. Now 2 important pathologies, last pathologies from the CNS section. You are seeing this classical puff of smoke appearance on a DSA image. Okay, so where will you see? This will be seen when there will be large amount of lenticulostriate collaterals. When will you see this lenticulostriate collaterals? This is particularly seen if there is a ICA narrowing. If there is a ICA narrowing. So what I'm talking about? I'm talking about, please comment down. We are talking about Moya disease. Okay, we are talking about the primary Moya. It's idiopathic. There will be a narrowing that can be seen in this, especially in the supraclinoid ICA bilaterally, and you will get this puff of smoke appearance on DSA. You can also see the secondary type of Moya, when there is a secondary narrowing, and that will be seen with neurofibromatosis 1. You can get it with secondary to radiation, or you can also see them associated with Down syndrome. Right? Now another, so these are the classical associations which they can test you for NF1. For your Moya disease. Okay, now let's talk about this image. So again, this is a classical image which they can test you for vein of Galen malformation. Yes, Dhanush, perfect. This is what is the pathology over here. What particular vein is going to be persistent? So it is persistent of the median prosencephalic vein. There is persistence of median prosencephalic vein. Okay, and that you will see with the vein of Galen malformation. Now, what is the cause of this? So you can see that how aneurysmally there is a dilatation that you will see of the vein of Galen that is ultimately draining into the straight sinus. Okay, but the most important, the most common cause of death over here is a high output cardiac failure. Okay, that is high output cardiac failure, because of the presence of the AV shunt that is present. Okay, these are very high flow fistulous connections that are formed between the arteries and the veins, and that will lead to this high output cardiac failure. Right, now let's talk about some important pediatric neck pathologies. I'm sure you have covered this in ENT, but that's what my subject is. Everyone covers everything. We are just going to have a quick revision of the so important imaging pathologies. So first question I'm giving you, that the patient is having a muffled hot potato voice. There is a patient who is coming to you with a tripod positioning. There is drooling of the saliva. So what you are getting over here, you are getting that there is a classical enlarged epiglottis, and that is basically compressing your airway is compromised over here. So we are talking about acute epiglottitis. Okay, acute epiglottitis is classically seen with what? Associated with H influenza B virus. Most important thing, the next best step over here, you have to do what? You have to do an airway stabilization in these particular patients. That is very, very important. Okay, again, this is very detrimental. The patient is in severe distress and you have to stabilize the airway first. That is your next best step. In the second image, I'm giving you the history that the patient is having barking cough. Okay, so barking cough, but the patient is not unstable. The patient is relatively stable over here. You can see that how narrow over here my airway is. Okay, my airway over here is very narrow over here. So this is classically seen with what? Classically seen with, this is called as a steeple sign. And this is again, the steeple which is there, it basically means that there is a narrowing. This mainly occurs because there is lot of edema in the subglottic mucosa, and that leads to this narrowing of the airway. This is classically seen with croup or laryngotracheobronchitis, and that is again classically seen with para-influenza. Yes, Dhanush, right? Never do laryngoscopy in those particular patients, right? For epiglottitis, right? So, perfect. These are the two important pathologies which are commonly tested. Another pathology, I have not shown you the image, but they can show you an image in which this prevertebral tissue which is there, it is enlarged. Okay, so the prevertebral tissue, particularly at C2, is more than that of 7 mm. And if at C7, it is more than 22 mm. Okay, so 2 say 7, 7 say 22. This is how you will remember. This is basically a marker of prevertebral space widening, and this is classically seen with retropharyngeal abscess, right? Yeah. So this is seen classically with retropharyngeal abscess or a retropharyngeal hematoma if it is present. They can show you an X-ray with the prevertebral tissue widening, right? Now let's talk about this image, and this was again tested previously in one of the examinations, giving you classical history of diabetes mellitus, facial plane, black nasal discharge. You are seeing this post-contrast image, and there is non-enhancing mucosa that is present along the maxillary sinuses. What I am talking about, we are talking about a very classical sign which is called as black turbinate sign, and this is seen with mucormycosis, very classically seen with mucormycosis, because there is a lot of necrosis of the tissue that is happening, right? There is a, because this is angio-invasive, anything which is angio-invasive, it is going to devitalize the tissue, and that is why it will not show any enhancement. Can you see, this is the normal mucosa, this is how it should enhance, but if you are seeing this devitalization, non-enhancing tissue or mucosa, we are talking about the black turbinate sign in mucormycosis. Okay, so that was all about CNS and head and neck. Now let's move towards our favorite, GIT radiology. Lot of surgical overlap will be seen, so let's quickly see all the images. Okay, the first image, first of all, I'm talking about barium. So for barium, remember that it's a positive contrast. Remember that it is water insoluble. Because it is water insoluble, will you ever give it IV? You will never give barium IV. And remember that this is absolutely contraindicated in if you are suspecting perforation. Okay, this is also tested. If you are suspecting perforation, if you are suspecting any bowel leaks, you will never give barium because of the risk of barium peritonitis. Okay, you will either give it in the form of oral or enema, but never ever you will give this IV. Okay, the second image, if you are seeing over here, this is my classical barium swallow. This is my classical barium swallow in which you will see the esophagus, and it can extend up to the GE junction. The third image which you are seeing on your screen, that is the classical barium enema. Okay, you are seeing the entire rectum and the entire colon up to the level of the cecum. Right now, if I am talking about the first image over here, you are seeing all the small bowel loops, plus you are able to see the stomach as well. So we are talking about barium meal follow through. We are talking about barium meal follow through. If they are only showing you the stomach, then that is your barium meal. Okay, so this is the three important investigations which can be tested. Now let's talk about the first image. I am giving a clinical hint to you, and then you just tell me the diagnosis. So the first image, you write it down in the chat box. We will not be able to do a Q&A, but I will definitely appreciate if you will answer. So the first question, I am telling you the hint that the patient is having halitosis, and you are seeing this outpouching arising from the posterior part of the esophagus. Okay, what is this? This is classically seen in along the Killian's dehiscence and outpouching a diverticulum. We are talking about the classical Zenker's diverticulum, right? Perfect. Someone, so yeah, answer. Yeah, really, someone is answering. That is the Zenker's. Gaurav, yes, it is Zenker's diverticulum. Okay. Now, if I talk about the another one, which is Killian-Jamieson diverticulum, not included the image, there you will get a lateral outpouching. So they can show you a esophagus that will be having a lateral outpouching, that is Killian-Jamieson diverticulum. Right now, this another important, I would say, a clinical hint which I'm giving you, that dysphagia is there more for liquids and for solids, and you are seeing this smooth narrowing over here. What is this classical appearance? The second image, achalasia, perfect. It is achalasia. You will see this classical what appearance? This is my bird beak appearance that you will see with achalasia. Okay, now again, I'm not going into the details of it. This is a classical bird beak appearance. Lot of points on Achilles, I'm sure you have covered this in surgery. We're just covering the images fatafat. If you see the third image, what you are seeing over here, in the third image, you are seeing again a narrowing, but this time it's very irregular. Okay, it is looking like that of, I would say it also looks like that of an apple core, or the classical name which has been given to is your rat tail appearance because of the irregularity. This is my esophageal carcinoma. Okay, now if I talk about the fourth image, you are getting a history of chest pain or intermittent chest pain, plus there is dysphagia to both liquids and solids, and you're getting this classical corkscrew appearance or a beaded appearance of the esophagus. What I'm talking about my characteristic diffuse esophageal spasm. Okay, remember that for these motility disorders like diffuse esophageal spasm or achalasia, my gold standard, okay, I'm talking about the gold standard for my motility disorders. It is always and always what? It is always manometry. It is always manometry. Okay. Now one extra edge, where will you get a patulous G junction? The G junction is widened. Okay. Which particular pathology? Remember, think about a pathology in which we are saying that the muscle is affected. It's not able to contract. It is rather dilated. And they can show you an HRCT image with a dilated esophagus as well. Where will you get? This is characteristically seen with scleroderma. Okay, you will see this characteristically seen with the scleroderma. Okay, okay, fine. So everyone is writing some important, I think, pressure parameters, but I think the surgery faculty will be more in a good position to answer all those questions for you, right? So if I talk about a patulous G junction scleroderma, they can particularly give you an HRCT image in which there is a ILD pattern of NSIP, and they will give you this dilated esophagus with the patulous G junction, that is scleroderma. Okay, now if I'm talking about this particular image, what you are seeing over here, identify the investigation. See, this is the CT image. Again, you are seeing that there is a contrast also present in the vessels, but look at the bowel. You are able to see that the bowel over here is distended with what? It is distended with water. Okay, it is distended with polyethylene glycol or mannitol. I am talking about a neutral contrast agent which is resembling that of water. Anything which is neutral, what will be the HU? HU will be 0. So neutral contrast agent you will get classically with mannitol, okay, or polyethylene glycol, okay. So these are the classical examples, and this investigation no one has answered yet. The investigation which I am showing over here is CT enterography. Remember, it is an investigation of choice which we do for ulceroconstrictive diseases. Like if I want to see the TB, or if I want to see the Crohn's disease, okay, if I want to see the ulcerative colitis, in that particular conditions, I'll do a CT enterography. Dhanush, perfect. NSIP mein you will see ground glass opacities. Okay, some important one-liners. I know everyone knows the single bubble sign. You can show an X-ray or an ultrasound image with a single gastric bubble. Mark your answer as congenital hypertrophic pyloric stenosis. For double bubble, there are three differentials: duodenal atresia, annular pancreas, and lad bands also. Lad bands you will see particularly with what? With mid-gut volvulus and malrotation. Okay, with mid-gut volvulus and malrotation. Triple bubble sign, multiple bubbles you will see with more distal obstruction, that is jejunal atresia. Yeah. Okay. Now, if I talk about the another important pathologies, another important signs over here, so barium enema image, and you are seeing this classical obstruction you are seeing, okay, an abrupt cutoff you are seeing at this particular level. What are we talking about? We are talking about this claw sign or the meniscus sign that you will see with intussusception. Okay, remember that the intussusception, what happening? There is a telescoping of the bowel fragment, and that will be creating this abrupt cutoff of the barium, and that is why you will get this classical claw or the meniscus sign. Now, if you see this particular image, again this is intussusception, again the telescoping which is there, it will be producing what? This classical coiled spring type of an appearance. Now, if I am talking about ultrasound, because of this again telescoping, you are getting this multiple alternate layers of hyperechoic and hypoechoic mucosa. See, remember, mucosa is always hyper. Anything with this muscular in the bowel wall, that will appear hypo. So you will get this classical target sign when I am talking about intussusception as well. Three important signs we have covered regarding intussusception. Okay, the most favorite one, that is your volvulus, again very commonly tested, so I'm covering this. So if I'm giving, see, always look for the clinical hint which they have given to in the question. There are this very vague terminologies. I would say that they are using the term coffee bean appearance, and then they are using embryo and coma sign, but these are all non-specific appearance. I have seen a case where a cecal volvulus also looks like that of a coffee bean. So these are all signs which are theoretical. Look for the clinical hint. I would say that the exam pattern which they are testing right now, they are focusing more on the clinical aspect also. So if they are giving you a history of, say, an old chronic constipation patient who is having, say, dementia, nursing home history, okay, little bit of a USMLE style question, they are basically testing Parkinson's disease, old age home history, then think about this sigmoid volvulus. Okay, think your answer as sigmoid volvulus. But if a patient is relatively young patient, okay, the main cause in cecal volvulus is that you will get this mobile cecal mesentery, right? So this will be your cecal volvulus. Again, the classical signs are, as I have told you, you will get this classical embryo sign, also called as the coma sign, or you can get this coffee bean sign because of the opposition of the two bowel walls. So that is my coffee bean sign that you will get with sigmoid volvulus. Most importantly, what is the next best step for coffee bean or for sigmoid? See, here you can see that it is the sigmoid volvulus usually faces the right upper quadrant, whereas the cecal volvulus will face the left upper quadrant. Again, vague and non-specific. I do not support this, but this is theoretical, and it, when they test you, they can test you with this particular pointers, right? But next step, if I talk about the next best step for coffee bean appearance is for the sigmoid volvulus, it is basically your decompression sigmoidoscopy. It is decompression sigmoidoscopy. Okay, that means that it is non-surgical. But if I talk about cecal volvulus, my next best step, which is there, you have to do a surgery, right? Now, next important colon pathology, patient admitted in ICU for sepsis, and what you are seeing over here, you are seeing that there is a contrast that is entrapped between the thickened Hostra. This is producing a characteristic accordion sign. Now, if the patient is in ICU for sepsis, that means that, of course, when patients are receiving a lot of antibiotics, okay? Remember the antibiotics, like for an example, they can be given the question of Cipro. They might not give you the question of antibiotic, but it's understood in ICU, sepsis, okay, or a pneumonia, this patient must be with this broad spectrum antibiotics, and of course, you can have this ciprofloxacin in the question, or you can also have fluoroquininols, okay, or you can also have cephalexin, like these agents, okay. So this can be given to you in the question, and that means broad spectrum antibiotics, that is basically associated with which particular pathology? Yes, perfect, it is pseudomembranous colitis, okay, because of the overgrowth of what? Of the Clostridium difficile, right? Now let's talk about the another important pathologies when I'm talking about the hepatobiliary signs, okay. So again, remember that we have also got the Gerby classification, WHO classification. What I feel and important for you to remember is WHO, because that is the latest and which we follow, right? Now if I talk about this particular signs, so remember we have got CE1, 2, 3A, 3B, 4 and 5. So when I talk about CE1, that's simple unilocular. Can you see this ultrasound? They can give you an ultrasound image. Ultrasound pe cyst will appear black. MRI pe ultrasound, the cyst will appear white. T2 hyperintense. On C2 it will, on CT it will appear hypodense, like that of fluid. Okay, so remember how a cyst looks on all the modalities, and this imaging, the staging could be asked on any of the modalities. I have shown you ultrasound, that is more likely to be tested. So first image CE1 completely unilocular. The second, that is CE2, you will get this honeycomb or rosette appearance or a multi-septated appearance. That is my CE2. Okay, CE3A may what you will get a cyst with that of detached membranes, also called as floating membranes, also giving rise to what is called as my water lily sign, that you will see with CE3A. C3B may you will get this multiple daughter cyst that will be also present in around a relatively solid matrix, okay, that you will see around a solid matrix, that is my CE3B. CE4, that is about my CE3B. Now, if I talk about the CE4, it will be again cyst that will be having a more of heterogeneous and hypoechoic. You can see that hardly any fluid is there. It's all solid component that is completely present. That is my CE4. And lastly, CE5, which is there, that will show you calcification. That is my CE5. Now, why the stages I have mentioned? So, stages is mentioned because the treatment is different. If I talk about CE1, which is a simple cyst, and 3A, that is my water lily sign of floating membranes, in that I will do pair, okay. That is my puncture, aspiration, instillation of hypertonic saline or ethanol, and then I'll do re-aspiration. That is my CE1 and 3A, please remember this. But for CE2, that is my multi-septated or a honeycomb cyst, or CE3B, that is my cyst with daughter cyst in a solid matrix, I will do surgery. Okay, so these are the two important steps which you need to remember. If I talk about again some classical pointers and revision, honeycomb sign you will see with CE2, water lily sign you will see with CE3A. If I talk about the hydrated sand, you will get CE1. Okay, here in this cyst, if you see this small dependent densities, hyperechoic areas, that is my hydrated sand that you will get with CE1, and finally the calcified which is there, it is CE5. Okay, so that is all about the hydrated cyst. Okay, now some important classical spotters on ultrasound of the hepatobiliary system. The first image, classically you are seeing this multiple hyperechoic foci that are showing posterior acoustic shadowing. We are talking about cholelithiasis. If you are seeing a wall that is absolutely thickened or it is more than that of 3 mm, we are talking about what? Acute cholecystitis. So this per se was an acute calculus cholecystitis. You can also get the sonographic Murphy sign, in which the patient will be having pain when you will be putting the ultrasound probe in the right upper quadrant. Okay, now if I talk about the most accurate HIDA scan, okay, the most accurate for the diagnosis of the cholecystitis is HIDA scan, in which there is presence of non-visualization of the gallbladder on the HIDA scan after 4 hours. Okay, non-visualization of the gallbladder on the 4 hours, that will be basically associated with what? That is associated with acute cholecystitis. Now the second image you are seeing over here is a lot of air foci that are present along the abdominal x-ray or either on the CT, as I have already shown you, emphysematous cholecystitis. Remember, for emphysematous cholecystitis, my investigation of choice, any ectopic air, my investigation of choice which is there, it is NC-City. Okay, now what about the third image? In the third image, you are again seeing a lot of hyperechoic foci that are present, again giving rise to this comet tail artifact. This is classically seen with GB adenomyomatosis. Okay, this is seen with GB adenomyomatosis. Okay, now let's talk about the another important pathology over here. Here you are seeing that there is a calcification that is present along the wall. If you are seeing a calcification that is present along the wall, this is classically seen with porcelain gallbladder. This is seen with porcelain gallbladder, and remember, whenever you see porcelain gallbladder, my ideal next step which is there, it is an elective cholecystectomy, because of the presence of what? Because of the risk of carcinomatous malignant transformation that can occur. Okay, so that are the 4 important gallbladder pathologies which is covered. Remember, for cholesterol calculi, the best investigation even for acute cholecystitis for that matter, it is always ultrasound. Okay, that's the only place in our body where calcifications we are using ultrasound as an investigation. Right, now this is a very nice image, and that is why I have included. You are able to see a very linear hypointense structure that is present in the CBD. What is this classical spotter image? Okay, so this is a classical ascariasis. Okay, this is a worm, a long worm as a hypointense worm you are seeing on the MRCP image. This is my ascariasis. They can also show you an image in which there will be this. I will show you the next image only. So next image you can see over here that there is a hypointense foci that is present in the CBD, that is my choledocholithiasis. Similarly, on ERCP image, okay, I've already discussed ERCP and MRCP in detail in the initial part of the lectures. I'm not repeating this. You are seeing the spilling defects, right, in the ERCP. So this is my choledocholithiasis that you can see, right? So I hope this is clear. Now, if I talk about biliary leak, the best or the most sensitive investigation, again, we have covered this. It is HIDA scan. It is HIDA scan. Right, now where will you see this type of an appearance, which is also called as a beaded appearance or a pruned tree appearance? You are seeing this multifocal strictures, alternating areas of strictures and dilatations. This is classically seen with beaded or a pruned tree appearance associated with what? With that of PSC, that is also associated with ulcerative colitis. Okay, so sclerosing cholangitis is also commonly associated with what? It is associated with ulcerative colitis, right? Perfect, Dhanush, it is ascariasis, CBD stones, and Gaurav, right, it is PSC, right? So these are some important biliary pathologies which we have covered. Now some important triphasic or triple phase abdomen images. I hope that you know what is triple phase. Plain CT, arterial phase, portal venous phase, and delayed phase. Arterial phase 20 to 30 seconds. Okay, then we will do a portal venous phase at around 60 to 70 seconds, and then finally at 3 to 5 minutes we will be doing a delayed image, that is the triphasic abdomen. Of course, you have to do a plane to see if there is any calcification, the baseline attenuation to get an idea. Okay, if a lesion is shown to you like this, that is showing this peripheral, can you see this peripheral arterial nodular enhancement, and then there is also progressive centripetal filling. Okay, if you see the third image, there is a complete filling of the lesion. What we are talking about? We are talking about a characteristic cavernous hemangioma. Okay, so this is my characteristic cavernous hemangioma. The second, no, it's not HCC, Dhanush. Please look at the image. You are able to see that there is a progressive puddling of the contrast as you are going towards the delayed. It is centripetally progressing inside towards the lesion. That is my cavernous hemangioma, right? Now, the second image which I am showing over here, again, you are seeing that this is an MRI. So they can show you either an MRI or a triple phase CT. The concept is same. In the arterial, you can see that the lesion is completely enhancing, but then there is also a central non-enhancing part that is present. What is the central non-enhancing part? If you see the delayed image, the central non-enhancing part now is enhancing on a delayed image. So what I'm talking about? I'm talking about FNH. Okay, this is the characteristic scar that you are seeing in an FNH that will show a delayed enhancement. Okay, now if I talk about the scar, where else will you see the scar? So you can see with fibrolamellar HCC, you can see with oncocytomas, and you can also see oncocytoma where? In the kidneys. And of course, you can also see it with serous cystadenomas which are present in the pancreas. Okay, now the HCC will come now. You will get classical history of liver cirrhosis, alcoholic patient or HCC. Again, you can see that this particular lesion, can you see how well it is enhancing on arterial phase, but almost it is completely washed out and become hypodense by the end, by the delayed phase. So complete washout even only on the portal venous phase. Early enhancement on the arterial, washout on portal venous and delayed phase. This is characteristically seen with HCC or your hepatocellular carcinoma. Okay, so these are the three important images which I wanted to cover regarding liver. Again, they can give you this particular type of a lesion in which you will have this double target appearance. Can you see this hyperdense rim, enhancing rim, plus then there is also this hypodensity that is present around the lesion. Okay, so this is nothing but your liver abscess. Okay, classical history, they will give you a right upper quadrant pain or fever, or they can also show you a lesion that has got relatively, I would say, shaggy margins. Okay, especially when they become large, that shaggy margins and this lot of edema around the liver, that is classically seen with liver abscess. But remember that you get a double target sign over here. Sometimes you can also get the small abscesses, and they will ultimately coalesce to form a relatively larger abscess. This is also called as clustered sign, and that is again classically seen with the pyogenic liver abscess. Okay, so I hope this is clear to you. Now, if I'm talking about double target, how can I miss target sign? So target sign will be seen with liver metastasis. So you will see this multiple peripherally enhancing lesions again in the liver. And again, if I'm talking about an ultrasound also, you will get this multiple hypoechoic black lesions. Okay, and they might also show this hyperdense, hyperechoic rim around that you will see with the liver lesions. Okay, so this is basically metastasis. Multiple target signs, that will be metastasis. Double target you will get with what? You will get with liver abscess. Okay. Okay, now if I talk about, so for Shashi liver abscess amoebic, so again you will get this classical, again I have not included the image, but you will get this shaggy type of margins for this amoebic liver abscess, right? Okay, now next important X-ray, again very important from pancreas section, only few pathologies which I feel could be tested. Although we have covered pancreas in quite detail in the main sessions. If you have seen my lectures, I have covered pancreas in a quite a detailed session on the app. So if you see this particular pathology, this is a classical spotter image in which you are seeing multiple calcifications along the pancreatic body. This is chronic calcific pancreatitis. Okay, this is chronic calcific pancreatitis. Okay, so this is how they can basically give you a hint maybe of cystic fibrosis in the clinical question, and then they can show you this particular X-ray. Okay, now just one point regarding pancreatitis. I have not included the images of pancreatitis again because of the time constraint, but of course revise Atlanta is important. Remember to see the pancreatic necrosis. If there is no necrosis less than 4-week duration, it is an acute peripancreatic fluid collection. More than 4 weeks, then it will be classified as pseudocyst for no necrosis. Again, if the necrosis is present, how will you see necrosis? Non-enhancing component on the CECT. Less than 4 weeks, it will be acute necrotic collection. More than 4 weeks, it will be a vault of necrosis. Yes, Dhanush, right. Chain of lakes appearance, MPD and the dilated branches, classically seen with that of ERCP images also. You will get the chain of lake appearance, right? Okay. Now let's move towards the genito-radiology. I'll just have water because we have a lot of images in genito-urinary radiology as well. Yes, on you can get it on ERCP, chain of lakes, as well as in secretin MRCP. You can get it on both. The main concept is you will get this dilated MPD and the secondary branches of the pancreas because of the chronic inflammation. Okay, so let's start with a lot of IVB images we are going to cover and some CT images also of the important pathologies. Okay, so first image what you are seeing is, you are seeing that both the calyces are coming in the midline. Try to answer what is image number 1. Both the calyces meeting in the midline. Okay, the isthmus which is there, it is relatively low lying. These are hand holding calyces, also called as your shaking hand or flower vase type of calyces seen with horseshoe kidney. What will happen here? The isthmus which is there, it will be low lying. The ascent which is there, it will be prevented by the IMA. Inferior mesenteric artery, and it will be seen at that of L3 to L5 level. Okay, what about the second image? Yes, Preeti, Gaurav, right? It's horseshoe kidney. The second image, what you are seeing over here, you are seeing that there is a dilated, ballooned out renal pelvis. Okay, so this is classically seen with PUJ obstruction. This is classically seen with PUJ obstruction. The third image is, you are seeing a classical image. You can see the left side is normal. Okay, but you are seeing on the right side. On the right side, you are seeing that there is a calyceal system that is drooped down. There is actually an upper calyx over here which is hydronephrotic, and it is creating a mass effect on the second meiote. We are talking about a duplex kidney, or it is also called as what? It is also called as my drooping lily sign. With this duplex kidney system, always remember the Wiegert-Meyer law. So for Wiegert-Meyer law, remember that the upper meiote which is there, it will be having an inferior and a medial insertion. Okay, and if I talk about the lower meiote, it will be having a superior or a lateral insertion. So upper meiote which is there, it will be ectopic. It will be ectopic and associated with uretroceles, whereas lower meiote which is there, it is associated with VUR. Okay, so I hope this is very clear to you. Wiegert-Meyer law commonly tested, and they can show you this drooping lily sign appearance. Okay, so this is a, what happens, there is a hydronephrotic upper meiote creating a mass effect on the lower meiote. Okay, so these are the three important signs. Now next, let's cover the next set of images. What you are seeing over here, you are seeing, can you focus over here? You are able to see that there is this dilatation in the distalmost part of the ureter, and that will be at the VUJ. What you are seeing, this is classical my cobra head appearance. Also it is called as what? Also it is called as what? It is adder head appearance that will be seen with uretrocele. Okay, next image what you are seeing is, can you see that there is a medial deviation of the ureters over here? So this is classically seen with retroperitoneal fibrosis, also called as the maiden waist deformity. Okay, also called as the Ormond's disease. It's an IgG4 related disease that will be encasing this tissue in the midline around the retroperitoneum, around the ureters, and that will give rise to this medial deviation and lead to obstructive uropathy as well. Excellent response to steroids, because it's an IgG4 related diseases. Where you will see or IgG4 related, you will also see in orbital pseudotumors. Remember, in orbital pseudotumors, there will be what? There is a tendon involvement. In thyroid ophthalmopathy, there will be a tendon sparing. Sorry for jumping on the orbit, but we have not covered orbit, so I felt important with IgG4 related disease, you should know orbital pseudotumor as well. Now, what about this particular image? Here you are able to see that you are able to see the urethra over here. Okay, now if you are seeing the urethra, okay, this is not an IVP. Okay, this is basically a maturating cystourethrogram I have done in this patient, and after I have done the maturating cystourethrogram, normally should it go up to the level of the kidneys? It should not go to the level of the kidneys, but here you are able to see that it is going up to the level of the kidneys, and it is dilated pelvic ileal system. So what I am talking about? I am talking about grade 5 UR that is diagnosed on an MCU, or that is diagnosed in an MCU. Don't make this mistake of marking this as an IVP image, right? You can see the urethra over here very nicely. So this is basically an MCU image that has been shown over here, right? Dhanush, right? Yes, it's keyhole appearance. The next image which I am showing on the MCU, you are seeing dilated posterior urethra plus dilated bladder. Can give you an antenatal image also. So this is my keyhole appearance for a posterior urethric valve on an MCU image. Okay, now let's move towards our next image. What you are seeing over here, you can see that in this image there is what? There is a fish hook appearance, or there is a J-shaped ureter. There is a J-shaped ureter. You can see that there is a twisting, there is a abrupt turning of the proximal ureter. So what is the pathology over here? Whether the ureter is abnormal or whether IVC is abnormal. So it's IVC that is abnormal, and because of the persistence of this posterior cardinal vein, what happens? The ureter which is there, it is actually going posterior to that of the IVC, that will give rise to this fish hook or the J-shaped type of the ureter. So this is again a circumcaval ureter or retrocaval ureter, because it's going behind the IVC. And what about this particular thing? Okay, so next So this is basically a circumcaval ureter, and that is the pathology that will be related to the ureter. Now next image over here, can you see again there are two kidneys that are seen one above the another, but on the left side you are not able to see any kidney. So don't make this mistake of marking this as duplex collecting system. This is what? This is a cross-fused ectopic that you will see in the IVP image. This is the cross-fused ectopic that you will see. Okay. Yes, someone persistent posterior subcardinal vein. That's perfectly right. Okay. Now let's move towards our next image. So first image again. First of all, look very carefully over here. Look very carefully whether this is an IVP image. Okay, so look carefully, this is not an IVP image. Okay, can you see there is no bladder? You're not able to see the ureters over here. You are seeing just these two hyperdensities that are present, this radiographic hyperdensities. So these are bilateral staghorn calculus. Look very carefully, right? If you are seeing this particular investigation of choice, if I talk about the calculi, always remember it is always NCCT, and this was also tested. The investigation of choice is NCCT. The investigation of choice is NCCT. Initial investigation, see both the options are given to you. I will mark my answer as ultrasound more than that of the X-ray, because in the modern terms, modern days, we are preferring ultrasound, non-radiation modality. Again, excellent for viewing this particular stones. You can also look for hydronephrosis. So initial investigation, ultrasound better than that of X-ray. Okay, so these are your staghorn calculi that are basically your associated with E. coli infections, repeated UTI and MAP. Okay, now if I talk about the second image over here, again this is a normal plain X-ray. You are able to see a putty kidney or a cement kidney, and this is classically seen with what? This is seen with the TB of the kidney. Okay, so they can give you this type of an image, and with the entire cortex is also calcified. This is not a stone. Now, if you see this NCT. Yes, someone, yes, NCCT is investigation of choice for all the kidney stones. Okay, no doubt in that. NCCT is always the investigation of choice, whether it is a kidney stone, whether it is a ureteric stone. Now, in the third image, you are seeing that there is a lot of calcification in a triangular format. So, what you are seeing that there is medullary nephrocalcinosis. This is medullary nephrocalcinosis that you are seeing, and this is again classically seen with what? This is seen with FAM. Remember the mnemonic FAM. Primary hyperparathyroidism, hypervitaminosis D, renal tubular acidosis type 1, which is distal, and M, which is there, it is your medullary sponge kidney. Medullary sponge kidney, what happens? There is ectasia of the collecting ducts because of this retention of the urine, and ultimately calcium, which is there, it will segregate, and that will lead to this calcifications. Okay, so that is about this particular pathology. Let's move towards our next set of images. The first image you are seeing over here is what? You are seeing a very beaded type of ureter, such beaded, irregular type of ureter, kinked ureter. Okay, this is classically seen with that of what? It is seen with TB. Okay. Kshitij, it's not off the topic. It's a good question. GB stone, I have covered this twice before. You might have not seen the first part of the lecture. Investigation of choice for GB stone, it is always ultrasound. Acute cholecystitis, always ultrasound. That's the only place in our body where calcium is there. I mean, we are talking about cholesterol stones. So cholesterol stones, it is the only place where NCCT will not be the answer. Your answer will be ultrasound for gallbladder stones. Okay, for ureteric stones, kidney stone, NCCT will be the answer. Okay, so first image over here is your beaded ureter that you will again see classically with tuberculosis. What are the other signs you will see with tuberculosis? You can get thimble bladder, which is basically a small capacity bladder. The first sign which you get on this is moth-eaten calyx, the skeletal irregularity that you will classically seen with IVP image. Of course, you can also get phantom calyx, you can get papillary necrosis. Okay, papillary necrosis you also get with NSAIDs. You also get with NSAIDs. You can also get that with diabetes mellitus. Okay, so you can also get that with sickle cell disease. So that are the important signs regarding your tuberculosis, like moth-eaten calyx. And remember, this is the first sign that you will see. Thimble bladder you can get, and phantom calyx or amputated calyx you will see. Okay. Preeti, yes, in MCU we normally do not see kidneys. It's only bladder and urethra which we see. Okay. Now the second image, you are seeing a calcification that is present like that of a fetal skull. It's actually present in the bladder wall. So what are we talking about? We are talking about fetal skull appearance. This is also seen with schistosomiasis, and of course. Okay, so in this particular thing, fetal skull schistosomiasis, and the malignancy that you will see with schistosomiasis, remember that it is squamous cell carcinoma. Okay, not transitional cell carcinoma. Remember S for S, schistosomiasis and SCC. Okay, now the third image you are able to see is a jackstone type of a calculus. Okay, you can see this multiple projections. This is the classical jackstone calculus which you are seeing in the pelvis. Remember that the composition is COD, which is calcium oxalate dihydrate for these stones. Again, they can also show you a calcification like this in the pelvis. Don't get confused. If you're looking like that of a popcorn, can you see it is looking like that of a popcorn, right? So this is the fibroid. So we have already discussed all the popcorns in the radiology in the complete session. This is the fibroid that you can see. So remember to differentiate between fetal skull appearance, jackstone calculus and a pelvic fibroid. Okay, so I hope that this is clear. We have covered many important spotter images and definitely it can be tested. Now identify the first image which you are seeing on your screen. What you are seeing that there are two metallic stents that are passing from the kidney up to the bladder. What you are seeing, this is, it's just something that you should not get this wrong, right? So this is basically your DJ stents. These are your DJ stents. Okay, no investigation. This is just a plain X-ray. This is just a plain X-ray which I have shown you with bilateral DJ stents. And of course, you can also see that there are some calculi that are present in the left kidney. Okay, so just identify this is not contrast. This is DJ stent. Right now, if you see this particular image over here, what you are seeing is, can you see that there is a tube over here? We have basically injected the contrast from outside, and over here what happens that the contrast has entered into the pelvic ileal system. Of course, that's dilated. The ureter is also dilated up to the distal end. So this is nothing but my antegrade pyelogram. This is my antegrade pyelogram which I have done. Okay, so this is basically an investigation. You should not get confused and you should be able to identify this, right? Now let's talk about this particular image, what you are seeing over here. Okay, identify what is this particular thing. I am giving you a hint. This is used particularly when it is used to prevent pulmonary embolism. It is used to prevent the thrombus to basically migrate into the lungs. So what is this I am showing you over here? This is what I am waiting for the answers. Okay, so we don't have time. I cannot wait so long. So we have got Gunther tulip, this Gunther tulip IVC filter. Okay, so they can show you this particular. Yes, I'm getting answers now. So this is IVC filter. It's a Gunther tulip filter which we are using. The normal level which is there, it is L1 to L3 infrarenal. That is the normal level that you will see. Again, remember IVC is present on the right side, aorta on the left side. So you will see it in the right paravertebral location. Right, so that is the position that you need to know. Some important CT images, let's cover this. So you can see that there are multiple cysts that are present in the liver and bilateral kidneys which are enlarged. We are talking about autosomal dominant polycystic kidney disease, and in this case it is also autosomal dominant polycystic kidney disease with the polycystic liver disease. Okay, you will get this classical Swiss cheese pattern appearance. If I talk about the IVP appearance over here, you will get this spider leg type of callisis. You will get spider leg callisis. Why? On the IVP, I have not shown the image. You will see this mainly because the cysts which are there, they will be causing a mass effect on the pelvic ileal system that will be stretching this particular callisis. Now, the most common cause of death which is there, it is berry aneurysm rupture that you will see with AD PKD. Some important one-liners I wanted to cover. Now, I am giving you a history of newborn that is presenting with that of a flank pass and a kidney. You are able to see this multiple varying size cyst. The entire kidney which is there, it is non-functional. Yes, Afreen, right? The chromosomes you have written are right. 16 and 4. So this is basically my multicystic dysplastic kidney. Okay, now the third image what you are seeing over here is the lesion that is seen in the kidney, and look at the post contrast image. You are seeing an enhancing solid nodule. Can you tell me what is the Bosniak grade for this particular lesion? There is a lesion that is present which is enhancing. It's present again. It's a multi-cystic lesion with a solid nodular lesion. Can you tell me the Bosniak grade? This could be really tested, a potential question this year. I could suspect this question could be asked. So please tell me what is the Bosniak grade. Waiting for the answers. Okay, so this is basically my Bosniak grade 4. Yes, very good. So I'm getting some answers. Afreen, Shashi, yes, it's Bosniak grade 4. The next important step which is there, you have to do a surgery over here. There is no doubt in that. You have to basically refer this patient to the surgeon. That is next best step. So quick revision, Bosniak 1, you will have no septa. If I talk about Bosniak grade 2, you will get 1 to 3 septa. That will be less than that of 2 mm. If I talk about 2F, you will get more than 1 septa. That will be 3 mm. If I talk about Bosniak my grade 3, you will get more than that of 4 septa, that will be more than 1 septa. So remember, in 2F, I will do a follow-up after 6 months in stage number 3. And stage number 4, see 4 you will get nodules, which I have already shown you. In both stage 3 and 4, I will basically refer my patient to do a surgery, either a partial or a complete nephrectomy, depending upon the surgeon and depending upon the lesion, right? So that is about this particular Bosniak classification. Now I am giving you a hint, again a lesion that you can see in the lower pole, exophytic lesion coming out of the kidney, showing a significant heterogeneous enhancement. There is central area of necrosis. I am giving you the hint, patient is having history of smoking. There is hematuria that is present. Classical smoking history you will get with these patients. This is classically seen with what? This is classically seen with renal cell carcinomas. Okay, enhancing mass, smoking history, hematuria. Mark your answer as RCC. They can also show you a patient with skull metastasis or with liver with various vertebral lytic bone metastasis, right? Now let's move towards some another important spotter from the CT section. Again, you are seeing a very big pancake type of a kidney. Okay, I've already told you the diagnosis. Both the kidneys are fused. There is no isthmus. The complete kidneys are fused, and it is present in the pelvic region. What I'm talking about a pancake kidney. Yes, Afreen, very good. I've not covered von Hippel-Lindau's disease, and yes, multiple RCC or clear cell RCCs can be seen with VHP. Okay, now you are able to see over here. I'll give you a hint that the right kidney is present, but the left kidney was not present in the left renal fossa. It's present in the pelvis. This is my simple ectopic kidney present in the pelvis. Okay, now next. Again, I've already shown you the IVP image, 2 kidneys that are fused on one side. Okay, the upper pole of the left kidney is fused to the lower pole of the right kidney. What we are talking about? We are talking about a cross-fused ectopic kidney, right? So these are again 3 important spotter images from the CT section. Now next, again, so many spotter images we are covering. So here you are able to see that there are multiple hypodense fat density lesions that are present in bilateral kidneys. So what are these fat-containing lesions? These are angiomyolipomas that you will see with tuberous sclerosis. Okay, now what about the second image? In the second image, imagine that this kidney is looking like that of a bear paw. You are able to see that there is a large staghorn obstructing calculus. There is significant hydronephrosis. There is a non-functioning kidney. This typical triad you will get with xanthogranulomatous pyelonephritis or the bear paw appearance, right? Now the third image, again very classical, air around the kidneys within the renal pelvic ileal system. What I'm talking about emphysematous pyelonephritis. I hope all the 3 important pathologies are clear to you. All are appearing hypodense, right? Even fat, look at the difference. See, this is the fat. It will look like this, AML, as well defined dirty black appearance. Emphysematous pyelonephritis, again you can see best investigation if I want to see air. Okay, if I want to see air, as I've already told you multiple times, my investigation of choice which is there, it will be always NCCT. Remember that the next best step is you have to go for an urgent percutaneous drainage for them. Okay, now lastly we are going to cover some important RGO. So first of all, identify this is a normal RGO, retrograde urethrophy. Retrogradely, the contrast is basically injected over here in order to see the urethra. RGO is mainly to see the anterior urethra. If I talk about MCU, that was mainly to see the posterior urethra and the bladder pathologies. So here you can see that this is the anterior part, which is bulbar and the penile urethra. The posterior part, that is the prostatic urethra, and the membranous urethra. Remember that the membranous urethra is the shortest segment. Okay, and of course you can also see this filling defect over here. This is nothing but verumontanum, and it is normal. It is normal. Okay, so this is a normal RGO image, you should know. Okay, this is a normal retrograde urethrogram. If you talk about this particular image, you can see that there are multifocal strictures. I will give you a hint that the patient is having sexually transmitted diseases. So this is basically multifocal strictures which can be seen with gonococcal infection. Okay, so multifocal stricture of RGO, this is the classical spotter image which you can get. Then of course they can show you an image of urethral trauma in which there will be extravasation of the contrast outside it. So that will be basically your urethral trauma. I've not included the image, but remember for urethral trauma, investigation of choice for urethral trauma or for stricture, it is always RGU. Okay, now let's move towards our next important vascular pathologies. So this you can see that multiple beaded appearance or string of bead appearance that you are seeing on a DSC image. This is classical fibromuscular dysplasia. You will get the string of bead appearance. Now if I am talking about the investigation of choice, okay, remember that it is CT angio that would be as an investigation of choice. Gold standard gold standard, as I've already told you in the general radiology section. Okay, the most important section is the first one, because we have got a glimpse of all the investigations, how and when to use it. So if I'm talking about the gold standard, it will be DSA. And if there is a renal failure in the patient, if they give you some history of elevated creatinine or renal failure, mark your answer as TOF MRI angio. Okay, the second image on your on your screen is the TOF MRI angio. You can see that there is a proximal renal artery stenosis. So this is nothing but my renal artery stenosis that you are seeing in the second image. Okay, now let's move towards the trauma and emergency radiology. Again, one question is really expected from trauma and emergency section. Okay, lot of overlap with the surgery class, but yes, we will definitely see some important imaging findings. The first image, the diagnosis already written. You are able to see that there is translucency with no bronchovascular markings on an X-ray, that is pneumothorax. The best X-ray, remember, it is chest X-ray, PA view, expiratory phase. Okay, because if I want to see air trapping, I will always do an expiratory phase in investigation. Best investigation, as I said, any ectopic air, pneumoperitoneum, pneumomediastinum, emphysematous pyelonephritis. My best investigation is always NCCT, because it is most sensitive in picking up this ectopic air. Right now, if I'm talking about the classical hint of tension pneumothorax, in which there will be a clinical triangle of hypotension, tachycardia, distended neck veins. Okay, that you will get with classical tension pneumothorax. If they are giving you this history, plus they can show you an X-ray in which there will be also contralateral mediastinal shift. Okay, that will be my what? That will be my characteristic tension pneumothorax. So remember that the management guidelines will be different. If you are being given a history of patient who is relatively stable, I will do an ICD in the triangle of safety. But if my patient is unstable, if my patient is having tension pneumothorax, I will do a needle thoracostomy. And remember that the current guidelines which are there, current ATLS guidelines, that say that I will be putting this needle decompression. Where will I do it? Earlier it was in the second intercostal space in the mid-clavicular line, but now they say you do it in the 4th to 5th intercostal space anterior to the mid-axillary line. Okay, so basically you need to remember, for tension pneumothorax, I have to do a, first of all, needle decompression. Okay, now next is EDH, SDH, and SDH. I have already written the diagnosis, so there is no wasting of time, because we all know that this question is almost tested every year, either in INI-CT, FMG, or NEET PG. EDH, remember, it's convex in shape, associated with fractures, rupture of middle meningeal artery, and it is not going to cross the sutures. SDH में, oh yeah, so sorry Shashi, right, you just made me remember, I forgot the M mode. So on M mode, again on pneumothorax, if I'm talking about the M mode imaging, okay, you will be basically seeing what sign? You will see barcode or the stethoscope sign. See, normally the lungs which is there, it will be moving, right? The lungs will be moving, so you will get this classical seashore sign, that is a normal M mode. But whenever there will be pneumothorax, there will be absence of the lung sliding, and you will get this classical barcode or the stratosphere sign when it comes to your pneumothorax. Right now, if I'm talking about, yeah, so SDH, as I was already saying, that it was mainly because of the rupture of the bridging veins, and it will also cross the sutures. Classically, this will be seen in old age. Okay, classically seen with old age. Now, subarachnoid hemorrhage, can you see this hyperdensity that you will see along the sulcal spaces, along the basal systems? That is my subarachnoid hemorrhage. Remember that the most common cause is trauma, but the most common non-traumatic cause is berry aneurysm rupture. Okay, now let's move towards the DAI, already discussed many times, but again, RTA history, CT is normal. Next best step is definitely my SWI MRI sequence. Okay, in order to pick the small microbleeds. Can you see this microbleeds at the gray white matter junction? So the classification which we are using is Adams classification. Okay, Adams classification says that grade 1, which is there, it will be at gray white matter junction. It will be at gray matter and white matter junction. The grade 2, which is there, it will be grade 1, plus there will be involvement of what? Involvement of corpus callosum. And grade 3, which is there, it will be 1 plus 2, plus there will be also involvement of brain stem. That is the Adams classification which we use when it comes to what? Diffuse axonal injury. Now let's talk about this particular pathology. Again, lot of air. Okay, you can see that this particular air which is present in the bone, that is in the frontal sinus. But here the air which is there, it is present within the brain. So what we are talking about? We are talking about pneumocephalus extending along the falx. Can you see it is extending along the falx, resembling that what? This is basically your tension pneumocephalus, and this is classically called as your Mount Fuji sign. This is called as my Mount Fuji sign. Again, a surgical emergency, you need to drain it, indicating that there are high pressures in the brain. Okay, after trauma, classically associated with trauma and multiple fractures, even the sinus air which is there, it is entering into the brain. Okay, now let's move towards the next pathology. So here you can see that there is again ectopic air that is present. If you look very closely, you will see that the air which is there, it is present just beneath the heart surface. So this is giving rise to what is called as my continuous diaphragm sign, and that will be seen with pneumomediastinum. If you see this particular image, again there is pneumomediastinum. You can see that the air will be present in the mediastinum, but most importantly, air is also present into this particular soft tissue. Okay, and this is particularly, can you see, it is looking that it is along the muscles. So this is nothing but my, what particular sign we are talking about? This particular sign is my ginkgo leaf sign. Ginkgo leaf sign indicates that the air is present in the subcutaneous and intermuscular plane, and this will be seen with the subcutaneous emphysema, again classically seen with trauma and multiple rib and clavicle fractures. Right, now let's talk about the other signs. Just quickly revising, on the CT or on the X-ray you can get these particular signs. So you can get this ring around the artery sign, that is air around the artery, or again tubular artery, especially if you are seeing the coronal images. Then in the pediatric you can get thymus that will be floating in the air, called as the thymic sail sign. You can get double bronchial wall sign and Niclarios V sign. Okay, you will get some air that will be classically present over here in the form of a triangle. This is classically seen with what? Bohr-Haave syndrome. You will see with esophageal rupture, that is Bohr-Haave sign, that is Niclario V sign. So these are the classical signs that you will see with pneumomediastinum. Okay, so quick revision of all the signs of pneumomediastinum. Now, how can we forget pneumoperitoneum? See, most sensitive investigation, always NCCT to pick up any ectopic air, repeating it again and again so that you don't make any mistake. Again, you can see that the best X-ray initially when the patient will come and you're suspecting this bowel perforation, my best X-ray which is there, it will be always chest X-ray. Okay, it will be chest X-ray, that will be my best X-ray that you are going to do. But if suppose my patient cannot stand, patient cannot even move, okay, then in that particular condition, I will do a cross table X-ray. I will do a cross table lateral view. I will do a cross table lateral view. What happens in the cross table? Patient will be lying supine. I will be moving the X-ray tube to the lateral aspect, and then with the help of this horizontal X-ray beam, as the air is going to rise up, you will be able to see the free air present, right? So that is the cross table lateral view. Where else do we use this cross table lateral view? You do it in the cervical spine fracture, because I do not want to move the spine. So in that case, I will do a cross table lateral view, right? Now, what about this particular X-ray? The patient is supine. Okay, this is the portable X-ray, and this is an AP radiograph. The patient is supine. You are seeing massive collection of free air, like that of a football. So this is football, and this is also called as the football sign of massive pneumoperitoneum. Okay, now what about this sign? Here you are able to see that you are able to locate the falciform ligament. So this is my falciform ligament sign of the pneumoperitoneum. Similarly, what is the regular sign? So the regular sign which is there, you will see it where, when the bowel wall, the air will be defining the bowel wall. At that particular condition, that is called as the regular sign. Okay, now what about this particular clinical vignette? So a 6-month-old infant is brought with excessive crying. Parents give a vague history of fall from bed. Classical history pattern which is not matching the patient's injury, indicating deliberate injury, and classically you are seeing this metaphyseal fractures. This is very classically seen with battered baby syndrome. Again, a very high yield topic, non-accidental injury or battered baby syndrome. You will get this classical metaphyseal corner fractures which are pathognomic because of the twisting and the shearing forces when the parent will be deliberately twisting the child's arm. Okay, so you will get this. Apart from this, you can get green stick fractures. So in green stick fractures, what will happen? Only the outer cortex will be broken, and the inner cortex which is there, it will be bent because the bones are relatively more elastic. Okay, you can also get this because of the vigorous shaking. You can get posterior rib fractures. You can get multiple fractures in the body in different stages of healing. Plus, you can get spiral fractures in the tibia, and the patient is non-ambulatory. Like for an example, the patient is only 6 months, and you will get a classical history that the patient was walking, and that is why he got a tibia fracture. But that is absolutely vague. So spiral fractures in non-ambulatory patients, and of course you can get SDH and retinal bleeds with a diffuse axonal injury. So these are all the classical signs that you will get with battered baby syndrome. Okay, how can we forget FAST when we are discussing about trauma? FAST is what focused assessment with sonography in trauma. Remember, E-FAST, we are now using extended FAST, probe in right upper quadrant to see the Morrison's pouch, left upper quadrant, splenorenal pouch, in the pelvis region, in the subxiphoid region, in the chest, right upper and the left anterior chest in order to see hemothorax, or if I want to see pneumoperitoneum. That is about the E-FAST that you will do as a first investigation if a patient is coming to you in the ER with a trauma patient. Okay, if a patient is coming to me with major trauma, okay, this is very important. If I talk about the patient coming with major abdominal trauma, patient is unstable. First thing, the question options are given resuscitation. First will be resuscitation and volume replacement that you will do. Only then you will do imaging once your patient is stabilized. Still my patient is unstable, I will do first investigation always an E-FAST in order to see if there is any free fluid that is present or if there is presence of any hemoperitoneum, right? Now, afterwards, if the patient is E-FAST positive, means fluid is present, that is E-FAST positive, I will do an exploratory laparotomy, that is my next best step. But suppose my patient has E-FAST is negative. Okay, my patient is E-FAST negative. After stabilizing the patient, I can do a CECT abdomen. Okay, so this is about the basic approach that you will use if a patient is coming to you with blunt abdominal trauma in an imaging approach. Right, now let's talk about stroke imaging. Remember, when I am suspecting a patient with stroke, my first investigation is always NCCT. It is always NCCT head because I want to rule out hemorrhage. Okay, before I will start thrombolysis, I need to rule out that there is not hemorrhage present in my stroke, right? So, okay, now let's okay, so Hanan, you are asking me drawbacks of FAST. Okay, so drawbacks of FAST is that you need at least 50 to 100 ml of fluid for it to be positive. It's definitely not the best investigation, but what happens is you do not have time for the patient to get into a CT, right? So that is why you are basically doing a first investigation as that of an ultrasound. It's definitely not as sensitive, but of course, because the patient, you need to do something in a portable setup, you need something very quick. That is why you are doing this fast imaging. Okay, now let's talk about this particular sign over here. What you are seeing over here, you are seeing that there is a classical sign associated with stroke. You will get this classical stroke history and you might be shown this image. So this is my very good Dhanush. It is hyperdense MCA sign. Hyperdense MCA sign. See, this is not just limited to MCA. You can get a hyperdense ACA, you can get a hyperdense PCA, you can get a hyperdense basilar artery. This means that there is thrombus that is present. Whenever there is presence of thrombus, that will appear hyperdense on the NCCT. Now, the most sensitive investigation, if they ask for stroke, okay, if they ask for stroke over here, okay, so if they ask for this particular stroke, what you are going to talk about, most sensitive investigation is definitely MRI, and particularly if I talk about the sequence, that will be my DWI. That will be my DWI. Okay, so let's talk about the DWI. If I talk about a hyperacute stroke, if I want to talk about hyperacute, which is less than that of 6 hours, it is only DWI that will be able to pick the pathology or pick the stroke. It will not be picked up by what? It will not be picked up by NCCT. NCCT may be normal in this hyperacute stage. So most sensitive investigation is definitely DWI. Right, now next important point is regarding your cerebral perfusion. So CT perfusion or MR perfusion imaging, the concept of penumbra and infarct is very important. So if I talk about how to differentiate the infarct which is there, if I talk about any infarct, there will be always a central area, a core dead tissue that is completely infarcted. If anything that is completely infarcted, of course the cerebral blood flow will decrease, the mean transition time will increase, the time to peak is also going to increase. That is, what is mean transit time, time to peak? The amount, the time that will be taken for the blood to reach that particular tissue, that is going to definitely increase, right? The cerebral blood flow, and of course the volume which is there, it will also decrease. But if I am taking into consideration penumbra, this means that this particular part of the brain or of the infarct which is there, it is still salvageable. It is still salvageable. The blood flow which is there, it has decreased over here. So in penumbra also the blood flow will decrease. Okay, this is infarct, this is penumbra. So penumbra also the blood flow will decrease, the mean transit time will increase, the time to peak will increase. But if I'm talking about the cerebral blood volume, that will increase or it will be normal. It will be increased or it will be normal. This is because there is still some collateral supply that is happening and it is trying to basically preserve that particular area. Okay. So the salvageable part, so the main difference, if they ask you a question, how will you differentiate between penumbra and infarct? It is cerebral blood flow. Remember, for the penumbra, the cerebral blood flow will be increased or it will be normal, whereas the blood volume which is there, it will be completely decreased in the area of infarct. I hope that you remember cerebral blood volume and flow concept. Okay. So let's talk about the next important part over here. So here this image, okay, this image over here, this is of the ischemic penumbra. Okay, you can see that this is the affected area. The TTP which is there, it is increased. The mean transit time has also increased. The cerebral blood flow which is there, it has also decreased. But if I talk about the cerebral blood volume, because of the collaterals, it is normal or it is trying to be increased, right? So that is about the CT perfusion imaging. Now, next important, already we have discussed about DWI, hyperacute stroke. What happens? What type of edema? You will get cytotoxic edema and not vasogenic edema. Cytotoxic edema may you will get diffusion restriction. You will always get black on ADC. That indicates that it's true diffusion restriction. Now, another important concept I want to say is that if you are seeing a DWI flare mismatch, if you are seeing a DWI flare mismatch, now what is the DWI flare mismatch? If you are seeing an abnormality only on DWI, okay, I'm telling that my DWI is abnormal, but I'm telling that my flare which is there, it is absolutely normal. This means that there is a mismatch, and this indicates that my infarct is less than 6 hours or it is in the hyperacute stage. Okay, if there is DWI flare match, okay, means that the flare hyperintensity has also now appeared. That means that my stroke will be more than that of 6 hours if there is signal positive on the flare image. This DWI flare mismatch is also a marker of wake up stroke. This is also called as my wake up stroke because it's an early stroke, right? Now, talking about the investigation of choice, again, as I've already told you, large vessel occlusion, investigation of choice will be CT angio, better than MRI angio for its spatial resolution. If I don't want to do the contrast, actually in MRI brain stroke protocol, we always do TOF MRI brain angio, in which I do not have to give any additional contrast. Right? Now, let's move towards our next pathology. I'm talking about hematuria after an RTA. Again, we are talking about trauma. So this is our classical, what you are getting, molar tooth appearance. Okay, so this is basically, if I talk about hematuria after RTA, you are suspecting bladder injury. My best investigation will be CT cystogram. It will be CT cystogram. I am retrogrately injecting the contrast in the bladder and seeing where it is going. Here it is going in the perivesical space. Okay, this is my bladder. Okay, this is the bladder, and I am seeing that my contrast which is there, it is extravasated outside. This is giving rise to my molar tooth appearance, and this is classically seen with what? Extraperitoneal rupture. Remember that extraperitoneal rupture, you have to manage it with SPC, or I would say it is managed conservatively. It is managed conservatively. Another important pointers on extraperitoneal bladder rupture is you will see it classically associated with pelvic fractures. It is more commonly seen with blunt trauma. Okay, these are the classical pointers that you can get with this. Also, urethral injuries are also more commonly seen with the with this particular extraperitoneal rupture. Now, if I'm talking about the second image, what you are seeing that there is a pear-shaped bladder. This is also called pear. Some also say it as inverted pear, or it is also called as teardrop appearance. Okay, so this is classically seen with what? Again, if there is external pelvic hematoma, or if there is a lipomatosis. Okay, if there is a lipomatosis, you will get this classical appearance. You will get this classical appearance. Okay, now let's talk about the another important pathology. Again same concept. You are seeing that the contrast which is there, it is now seeing around the bowel loop. So this is classically seen with intraperitoneal rupture. This is classically seen with intraperitoneal rupture of the urinary bladder. Again, what is the management over here? Again, you have to do surgery. Here, what is the intraperitoneal component? That is dome of the urinary bladder. This is classically seen with penetrating trauma of the urinary bladder. Okay, that is seen with penetrating trauma. I hope this is clear. IP rupture versus EP rupture of the bladder, very commonly tested. Now, another important pointer I wanted to just emphasize, if the clinical question is blood at meatus or a high riding or a floating prostate you are getting, never ever do Foley's, because you are suspecting what? You are suspecting urethral injury. Okay, whenever you are suspecting urethral injury, you will never do Foley's because of the chances of iatrogenic injury. So always next best step, as I've already said, for for the urethra, it is always RGU, that will be followed by suprapubic cystostomy. Okay, so this is again very commonly associated with extraperitoneal or blunt trauma injuries. But first step, you will always do RGU if you are giving such clinical hints in the question. Okay, now next important points on trauma is foreign body. I'm showing you 5 X-rays on foreign bodies. High yield, very important topic. Okay, yes, urethra injury. Okay. Okay, let's move towards our next set of questions. Okay, let's talk about the foreign body. So when I'm talking about the foreign body, the first image you are getting over here, first identify what foreign body is used. I'm zooming this image. You are able to see a single radio opacity over here, a single radio opacity in the midline. So you are seeing over here a coin that is present. Okay, so Ajanya, I might take half an hour more for completing the complete radiology marathon. So first thing you are able to see over here is the radio opaque structure. This is a coin. But if you are seeing an image over here, that will be having this double density. Okay, this double type of density. What we are talking about? We are talking about a battery or a button battery. We're talking about a button battery. Remember that button battery which is there, it is more alkaline, it has more chances of perforation. So definitely this is more hazardous as compared to that of a coin, and you have to remove it immediately if it is present in the esophagus, rigid esophagoscopy. If in the trachea, you have to do a what? Yeah, so I'm not asking you where exactly it is present. I'm asking you to differentiate. I will show you the esophageal and tracheal bodies as well. Okay, now if you see this particular laterally, you will get this type of a step deformity if I'm talking about a button battery. Now let's talk about this particular image over here. So now your question will come whether this is present in the esophagus or whether it is present in the trachea. So the first image you can see again a radio density that is present. Again, I'm showing you a coin. You can see that the tracheal shadow is also seen separately. So it's very obvious that it's present in the esophagus. Laterally, if you can see that, of course, if it is seen end face on the AP image or on a PA image, you will see it as a slit like on the lateral image. Okay, now why? The question is why. See, esophagus which is there, it can stretch sideways. It's more distensible, more collapsible, and that is why you will be able to see it as a end face on the coronal images. Now the next is that if the patient is asymptomatic, okay, for a coin, what you will do, I will observe for 24 hours. I will do an observation for 24 hours and then I will do a repeat X-ray. And after doing a repeat X-ray, if again it will be getting stuck, if it gets stuck, then I will be doing a rigid endoscopy. I will do a rigid endoscopy to remove this. Okay, so that is the basic concept. Now, another important thing is if it is present in the trachea, you can see that the coin's edge, you can see that in the trachea which is there, because of the cartilaginous ring, it's rigid, and that is why the coin which is there, it is adjusted on edge and it appears like that of a slit. Right, so that is about this particular appearance. Again, the classical history you will get of stridor or wheezing of respiratory distress. Again, because it's in the trachea, it's more hazardous. You have to immediately do and treat this particular patient with a rigid bronchoscopy. Right, now let's move towards our next question. A 2-year-old child who is presenting with sudden respiratory distress. If this is the classical history that they will give you, 2-year patient who is presenting with severe respiratory distress. Okay, here you are able to see that there is, if you look very closely, you are able to see that there is a unilateral translucent lung. Okay, and also there is a foreign body that is present over here. So I'll just show you, this is a foreign body. Can you see this? This is a foreign body and there is a unilateral translucent lung. So this basically indicates that there is an obstructive air trapping that is happening. The best X-ray to see this particular air trapping, that will be your chest X-ray PA view, and you have to basically go for an expiratory view if I want to see the air trapping. See what happens over here, there is a ball valve mechanism. This foreign body which is there, it has not completely obstructed the bronchus, so air is going inside but not able to come out. That gives rise to this ball valve type of a mechanism, and that is how you will be able to see this unilateral translucent lung. Whereas if I talk about the second X-ray over here, you can see that there is a complete collapse because the foreign body is completely obstructing the bronchus, so you will get a white out lung. Okay, white out lung mein you are seeing complete collapse. There is an ipsilateral mediastinal pull and mediastinal shift that you are getting. So that is why here again this both the questions, both the X-rays are a foreign body. One is incomplete obstruction, one is the complete obstruction. Okay, now if you see again a 54-year-old who is presenting with sudden respiratory distress in ICU. Here you are seeing the position of the endotracheal tube. You can see that it is aerating the right bronchus. Ideal position for the endotracheal tube which is there, it is 5 centimeter above the carina. It is 5 centimeters above the carina. Okay, but if you are seeing that there is a preferential aeration of the right bronchus, what happens? There is a collapse of the left lung, and that has led to this ipsilateral mediastinal shift. Okay, now next question is that there is a sudden onset respiratory distress again in a child. Again, you are seeing that there is a relatively unilateral translucent lung. You are not able to see any foreign body. This is mainly because the patient has ingested a peanut. So they can basically give you a question with unilateral translucent lung, but again the foreign body which is there, you will not be able to see it. It's radiolucent, like for an example, a peanut. Right, now let's talk about this particular. Okay, so lastly we will now cover some important nuclear medicine stuff and some points on radiotherapy. We don't have much time, we only have 15 minutes, so it will be a very quick revision. So if I talk about radio tracer, remember that it's made up of radioisotope and ligand. So radioisotope is technetium 99, F18, iodine 131. These are the common radioisotopes which you use, and ligand is something which will be going to the tissue, so it can be MDP or it can be DMSA. Okay, so if I talk about the differences, scintigraphy versus SPECT versus the PET scan. So SPECT is single photon emission computed tomography, it's 3D as compared to scintigraphy, which is 2D. So of course SPECT will have a better resolution as well as it has got a better sensitivity. Now the half-life, if I talk about the most common radiograph which we are using is technetium 99M. M stands for metastable. The half-life is 6 hours. It is going to emit gamma rays, and the detector which we are going to use is gamma camera or the angle camera. If I talk about the SPECT, it will be having a better resolution and sensitivity. And lastly, PET, again the radioisotope is 18F, using deoxyglucose as a ligand that mimics the glucose. And of course we use the principles of Warburg effect, that is also called as aerobic glycolysis. Remember, half-life of F18 which is there, it is 110 minutes. And test before the PET, of course you have to see the glucose not more than that of 200 before you do a FDG PET. PET negative tumors, 3 important tumors: bronchoalveolar carcinoma, carcinoid tumors, and mucinous adenocarcinomas. These are PET negative tumors. Okay, now the novel agents, these are potential questions, could be tested. 11C choline, a type of PET again this will be emitting positrons. 11C choline is used for prostate cancer. 11C methionine is used for brain tumors. 18F dopa, it is used for pheochromocytoma. Remember, dopa, it will go wherever there is adrenergic tissue. So 18F dopa for pheochromocytoma, and 18F sodium fluoride is particularly used for bone metastasis. Okay, so these are some novel theoretical topics you need to know. Okay, next important image regarding this is your technetium 99 bone scan. But can you see normally you should be able to see the kidneys excreting this MDP scan. Here you are not able to see the kidneys because the entire uptake is taken diffusely into the bones. What I am talking about, I am talking about super scan. Okay, so this will be particularly seen if there is a diffuse skeletal involvement, like if there will be presence of severe metastasis or there is Paget's disease. Okay, so diffuse skeletal uptake, no contrast left for the kidneys, no kidneys that will be seen. This is your super scan on a bone scan. This is a normal MDP bone scan which I am showing you. Okay, now second image is your Honda sign. Honda sign again can be tested for sacral insufficiency fractures. You will get this classical Honda sign along the sacrum. Right, now let's move towards this classical sign which is panda sign. Okay, so panda sign and lambda sign you will see with sarcoidosis. So panda sign you will see uptake that will be present where? In the nasopharynx, lacrimal glands and parotid glands. That will be my panda sign. Okay, lambda sign you will again see an uptake that will be seen along bilateral hilar lymphadenopathy and the right paratracheal lymph nodes. Okay, another important point is, see, when I talk about infection or inflammation anywhere in the body, what are the agents I can use? I can use gallium 67 because they have this tendency to go wherever there is lactoferrin, wherever there is infection. Lactoferrin will be there, so gallium 67 is used. More sensitive agents are also indium 1111 WBC or technetium 99 WBC, because what happens is wherever there is infection or inflammation, of course the WBC count which is there, it is going to increase. So you can use these agents whenever there is infection or inflammation. Yes, Afreen, we are talking about sarcoidosis. So keep on answering, whoever is online. Please try to answer so that I also know that you are listening. So this is about this. Now I am giving you a classical history. So please answer this. Elderly smoking history, or given this type of a PET or a SPECT image in which there is uptake that is present in bilateral parotid gland. Okay, this is the technetium 99 per technetiate scan which I have shown to you. Okay, bilateral uptake, we are talking about what? We are talking about Warthin tumors. Remember, Warthin tumors, because of oncocytic epithelium, they will show a hot uptake. But if I talk about pleomorphic adenoma, when the parotid tumor, they are usually unilateral and they will be cold. So pleomorphic adenoma which is there, it will be cold. Okay, so that is some important nuclear from the head and neck section. Okay, so yes, Dr. Aspirin, Okay, so let's talk about this particular iodine tumor. So iodine tumor, see, this is normal. This is how a normal thyroid, which is there, it will be looking on an iodine scan. But if I talk about Graves' disease, there is a diffuse uptake that will be seen in bilateral thyroid. Toxic multinodular goiter, you can see multiple hot uptake in multiple nodules, whereas toxic adenoma, single nodule that will be suppressing rest of the thyroid. Okay, 3 important agents. Iodine 123, remember the half-life is 13 hours. Okay, iodine 125, 12 into 5, 60 days. That is the TF. And iodine 131. Okay, what is the half-life? Anyone wants to comment? Iodine 131 half-life. Okay, just comment. Meanwhile, I'll cover other things. So when I talk about iodine 123, it will be emitting gamma rays. Okay, it is mainly used in the diagnostic imaging. Iodine 125, it is mainly used in brachytherapy. I will show you an image where interstitial seeds are used. So that is where iodine 125 is used. And if I talk about iodine 131, it is used in the treatment of the various thyroid tumors like papillary and follicular cancers. And of course, it is also used in the whole body scan imaging, especially if I want to see any residual tumor or recurrent tumor after the surgery. If I want to see distant metastasis, I will use iodine 131. Okay, yes, Afreen, 8 days. Shashi, Som Prakash and Vikas Raj. Very good. It's 8 days. This gives me a positive boost that people are still here and listening. Okay, now if I'm talking about the non-avid carcinoma, this will be mainly anaplastic and medullary. Very important. So anaplastic and medullary carcinomas, they will not show any uptake on this iodine nuclear studies. Okay, okay. So let's talk about the another important pathologies over here. So this is a very important table. Do you want me to read this table for you, or will you be reading it from the PDF itself? As you say. I will just need 1 to 2 yes, and then I can just start. Otherwise, I will proceed with the rest of the part. We have only 15 minutes. I'm waiting for a minute. No answers? Okay, I'll read then. So if I talk about the renal imaging, we have got 3 important agents, that is DMSA, DTPA as well as the MAC3 agents. Remember, S in the DMSA is for the static imaging. It is mainly used for pyelonephritis or for the scar imaging that is associated with VUR. If I talk about DTPA, it is the agent of choice that we use in perfusion imaging. Remember, radioisotope is technetium-99m for all the agents. Whereas okay, so if I talk about the MAC3 or the tubular function of the drainage, that is used in obstructive uropathy. Okay, if I want to see the tubular function, I will use MAC. Okay, now for the cardiac imaging, the common ones, if I talk about the Muga scan, okay, so again, I'm quickly only going, I don't have an option, I'm going very quickly. So if I talk about the ejection fraction, we talk about the Muga scan, for which we will be using technetium-99 RBC. If I talk about my myocardial viability, this was again a question asked in INICT, and it could be really tested this time. FDG PET we will be used if I want to see whether the tissue is dead or not. That is FDG PET. Remember, the dead tissue will be like a cold spot. Whereas if I talk about the hot spot imaging in myocardial infarction, pyrophosphate scan will be showing a hot uptake, right? Again, for myocardial perfusion in ischemia, we use technetium-99 system maybe or tetrophosphine or N13 ammonia. Okay, now bone scan, as I already said, technetium-99 MDP we are using for METs, infection stress fractures, they will all show a hot uptake. Cold spot will be multiple myeloma in the bone scan. If I talk about biliary tract, we have already discussed about biliary tract, so I'm not repeating. Again, remember, biliary leak, investigation of choice for biliary leak is the HIDA scan. What is the agent we are using? We are using technetium-99M mebrofenin. Thyroid we have already discussed. Parathyroid adenoma mein which agent we are going to use? We are going to use technetium-99 system maybe. That will be showing what? That will be showing a very hot uptake, the parathyroid adenoma. Right now, if I talk about the Meckel's diverticulum, the ectopic gastric mucosa, that will also show a technetium-99 per technetiate scan, that will be showing a hot uptake wherever the Meckel's diverticulum will be present. Okay, so this could be again tested. If I talk about neuroendocrine tumors or carcinoid tumors, okay, earlier we used to use octreotide or somatostatin receptor scintigraphy, but nowadays we are using gallium-68 DOTATOC or DOTANOC. So if your options have gallium-68 DOTATOC, DOTANOC, that is better and more sensitive for neuroendocrine tumors or carcinoid tumor. If I talk about pheochromocytoma, again, if the option says F-DOPA, mark your answer as F-DOPA. It's more sensitive as compared to MIBG. If I talk about prostate cancers, may you remember PSMA PET or 11C choline. As I've already told you, these are the novel imaging modalities which we are using in nuclear. Parkinson's, very important. This is an extra edge point. Iodine 123 ioflupine. Okay, that will be used in DAT scan. That is iodine 123 ioflupine. Where is it taken? It is taken by nigrostriatal dopaminergic neurons. So normally, normal uptake will be present in caudate and putamen, and it will look like that of a coma. But whenever there will be Parkinson's, what happens? There is loss of this dopaminergic neurons. The uptake will decrease. The most first affected area which is there, it is the posterior putamen, and that is why it will look like that of a dot sign. It will look like that of a dot sign. Okay, so this is my caudate and this is my putamen. So what happens, because the uptake which is there, see, normally it looks like that of a coma, but what happens when this particular area which is there, the uptake will decrease, only a dot of the caudate will be left, and that is why it is called as a dot sign. Okay, so that is about this. Radiotherapy, 5 minutes for radiotherapy, not more than that. So if I talk about two types of radiotherapy, teletherapy is there and brachytherapy. Teletherapy means coming from a distance, that is teletherapy. Two important sources, cobalt 60 and LINAC we are using. Cobalt 60 mein we will be using what? We are using gamma rays. LINAC mein we are using X-rays. If I talk about brachytherapy, it's completely placed close to that of the patient's carcinoma. So again, you need to remember two implants. One is permanent implants, that is, remember the mnemonic IPG, which is iodine 125, palladium and gold. These are permanent implants. If I talk about temporary implants, they will be mainly CCI, that is cobalt 60, cesium 137, iridium 192. Remember, this will be emitting beta as well as gamma rays, but the predominant one which is there in the temporary implants in the CCI is gamma rays. Completely theoretical topic, but again this could be tested. If I talk about choice agent for cervical cancer in terms of radiotherapy, brachytherapy only, it is iridium 192. Okay, it is iridium 192, but earlier cesium 137, that was low dose radiotherapy, was used, but now the choice agent is iridium 192. Okay, now purely beta emitters, the mnemonic is YSP, and it's yttrium, strontium as well as phosphorus. Okay, now if I talk about another important concept, that is stereotactic radiosurgery. What is stereotactic radiosurgery? It's something for the accurate localization of this radiotherapy or of these ionizing radiation. So we have got two important options. One is gamma knife and one is cyber knife. So if you see this particular image here, the patient is wearing one. This is an image-based question, could be tested. This is Lexel frame which we are using in gamma knife radiosurgery. We are using cobalt 60 rays. Again, remember, this is classically used in brain AVM, brain tumors, acoustic neuromas. But remember, brain ke liye we always use cobalt 60 as the source, or we use gamma knife. But if I talk about the body, okay, if I talk about body, we use cyber knife for the stereotactic radiosurgery or radiotherapy, where we will be using this LINAC, that will be using X-rays for the body tumor. Okay, two important concepts. One is your Bragg peak. So Bragg peak, what is only how many slides are left? So still 4-5 slides are left, but we will cover only the important topics. Okay, so when I talk about this proton beam radiotherapy, it is classically used with what? It is used in skull-based chordomas and head and neck tumors. So what is this Bragg peak? Okay, so what happens when I talk about the X-rays? Normal X-rays at the entry point. This is the entry point in the tissue. Okay, this is the depth of the tissue. Normally the X-ray intensity will decrease, but for protons, when we are using protons as a source of radiotherapy, you can see that there is an increase. The protons will deposit at the maximum energy at the depth of the tissue. So here there is sparing of the normal tissues in the beginning part, and the maximum energy is deposited at the depth or our target site. That is the Bragg peak with the proton beam radiotherapy used in head and neck tumors or skull-based chordoma. If I talk about the BNCT, which is boron neutron capture therapy, here what I am going to do, I am using an IV boron. So when I talk about the IV boron, it is particularly going very specifically to the brain tumor. Now I will be bombarding my patient with neutrons. So whenever there is boron that is trapped in the brain tumor, along with this I am giving neutrons. So remember, boron and neutrons will give an alpha attack. Whenever there is an alpha attack, what are these alpha particles? These are heavy particles with high linear energy transfer, and that is going to destroy whatever tumor is present in the vicinity. So it is particularly used in the brain tumors, and also it is used in melanoma. It's used in GBM and it is also used in melanoma. Right? So that is about this particular thing. Lastly, we'll discuss about the radiosensitive, radioresistant tumors. So very commonly tested, this entire table is important. Cell cycle phase, G2M more than that of M, that is the radiosensitive table. Radiosensitivity, that is G2M phase. If I talk about radioresistant, that is the S phase. If I talk about the organ. So it is most radiosensitive is gonads like ovaries and testes, whereas the radioresistant will be vagina. If I talk about tissues, most radiosensitive will be bone marrow. This is all as per law of Bergoni. Highly replicative cells will be more radiosensitive, right? Now, if I talk about the tissue, it is nervous tissue that will be radioresistant. Blood cell leukocyte is most radiosensitive, that is your lymphocyte. Okay, that is my lymphocyte. And if I talk about the platelet, that is again most radio resistant, could be tested. Right now, radiation protection, we are using lead apron. So lead apron, you need to remember what is the thickness. It is 0.5 mm lead equivalent. That is the thickness of the lead apron. It is basically protecting from the scattered radiation. That is the main function. What are the lead free alternatives? So see, lead is very heavy, so this apron is heavy. So we will be requiring a lead free alternative also, which are relatively less heavy and more environmental friendly. So this examples is antimony, bismuth, AB, and T, that is tungsten and tin. These are the alternatives which are now available. What about the second device? What is this device? Anyone wants to answer? What is the second device which is shown on your image on your screen? It is basically used to measure the radiation. What is this device? Could be tested. Anyone wants to answer? This is the TLD batch. Okay, this is the TLD batch. Now, what is the crystal which we are using? So, we are using mainly lithium fluoride over here. Okay, basically, we are measuring the total X-ray dose. It is sent to ARV. Remember that it's reusable. Okay, once this particular, every 3 months, it is basically sent to the ARV. It is read, it is then deleted, and then it is sent back again. Okay, so that is something which you need to know. Okay, now of course regarding all this effects we are not going to cover, but I will be covering some important points on image contrast. So if they definitely will get the PDF also. So okay, so if I talk about the image contrast, it is predominantly determined by what? Please answer this question. KVP, MAS, exposure type, or it is determined by that of the tube current. Can someone answer this? I'm talking about the contrast of the image. Okay, so remember that if I talk about the image contrast, it is predominantly determined by photoelectric effect. Okay, this is predominantly determined by photoelectric effect, not going into the details, but remember that higher will be the KVP, lesser will be the photoelectric effect, and lesser will be the contrast. Lesser will be the contrast. Okay, so high KVP, less will be the contrast. Image contrast is predominantly determined by KVP, less will be the KVP, more will be the contrast. So if they are giving you a question, okay, two X-rays, one of 70 kVp, one of 140 kVp, 70 kVp X-ray will be having a better contrast. Okay, they are telling you an obese patient. Suppose they are giving you a question history of an obese patient, what modification you will do in order to increase the image quality. So for obese patient or for the thicker part of the body tissue, you will be having to increase the MAS. So MAS will be increased if I want to improve the overall quality in obese patient or in a thicker patient. Okay, so these are some basic concepts which you should know regarding the general radiology. Okay, let's talk about contrast media. Still 2 minutes. So 2 minutes are enough to cover the contrast. Barium we have already studied. I'm not going to repeat. Okay, if I talk about Magnavist, again, Magnavist, as I've already told you, it is decreasing the T1 time. Anything which decreases the T1 time, this will be appearing as bright. So it will appear bright on a post contrast T1 weighted image. Now, most important complication that can occur is, especially if the patient is having renal failure, if the eGFR is less than that of 30 ml per minute, in that particular condition, it can lead to what? It can lead to nephrogenic systemic fibrosis. Okay, now nephrogenic systemic fibrosis, very debilitating condition. Most importantly, it's not treatable. Okay, even dialysis will not help. So the most effective way of avoiding this is prevention. Okay, never ever do gadolinium contrast image if the patient is having renal failure. So investigation before CECT or CE-MRI is always RFT. Okay, you have to do serum creatinine, and of course if the creatinine is elevated and you want to do a gadolinium contrast, you need to know this eGFR as well. You can never do eGFR less than 30 ml patient. You should never ever do gadolinium contrast imaging because of risk of NSF. Okay, now again in CECT you will do the RFT because there is a risk of contrast induced nephropathy. Two important agents you need to remember. There is an entire classification, but two important just before the exam you can remember. Okay, so if I talk about the ratio, so if I talk about the two important, one is iohexol. So iohexol will come in the low osmolar category. So when I talk about iodinated, they can be high osmolar or they can be low osmolar. Right now, if I talk about the low osmolar agents, that will be like iohexol. This will be 600 to 800 milliosmoles per kg, and this is a non-ionic monomer. Non-ionic means that it is not going to ionize, so the ratio of the particles will be is to 1 because it's not going to ionize. And if I talk about monomer, because it's has a benzene ring, that will have 3 iodine atoms. So it's 3:1. If I talk about iodixanol, this will come in the isoosmolar category because the blood osmolarity is 280 to 300 milliosmoles per kg. That is equal to that of blood, and that is a non-ionic dimer. And remember, because it's a dimer, you will have 6 iodine particles not ionizing, so it is 0.1. So which is the better agent? Better agent is iodixanol. Of course, it's a non-ionic dimer. It's a relatively, I would say, safer patient, and it is also called as VC-pack. It is also called as VC-pack. So if the patient is having some diabetes mellitus, or you're suspecting that the kidney function which is there, it is borderline, I will prefer a VC-pack over iohexol. Most commonly in India, the agents which we are getting is iohexols. Okay, so I think someone is asking me, ma'am, there was a question about what type of probe to use in obese patient, linear or curvilinear. So in obese patient, you will use a curvilinear probe. You will use curvilinear because, as I've already told you in the general radiology when I was discussing about the probes, remember that if I talk about a curvilinear probe, what is curvilinear? It's a low frequency probe. Low frequency means, of course, the resolution will be little less, but the depth that the curvilinear probe or the low frequency will offer, that is good, right? If I talk about a high frequency probe, the rectangular probes, you use it in thyroid and breast, they are used only for superficial structures. So for deeper structures, I will use a curvilinear probe. I hope this is clear to you. Okay. Okay, now let's talk about double contrast. Where will you use this barium double contrast imaging? So this double contrast imaging is particularly, we can say, used where if I want to see mucosal pathologies. If you are using in the mucosal pathologies on the barium, that is double contrast means you're using either air or CO2. Basically, I ask my patient, after barium, you will be basically injecting those eno granules which are present, right? And because of the outer coating of the barium, and of course there is an air now that will be coating, it will give a very beautiful imaging for the mucosal pathologies. That is where I will use a double contrast imaging. Okay, now let's talk about contrast-induced nephropathy. So contrast-induced nephropathy will be seen in 48 hours of the contrast CECT abdomen if you are doing. So creatinine more than 0.5 milligram per deciliter or more than 25% from the baseline. If your creatinine level is elevated, that is my acute, what happens, that will be my contrast induced nephropathy. So this is the definition for contrast induced nephropathy. Sonoview, I have already discussed. So sonoview mein we will be having 1 to 10 micrometer particles, 1 to 10